Hello. Audio. Hello. Hello. Good morning, everyone. This is Dr. Jambukeswaran, PrepLadder's orthopedic faculty for you. Am I audible and visible clearly? Yes, I am seeing Manjuman. Yes, Shreya. Very good. Good morning, sir. Good morning. Okay. Oh, Chaudhary. He's using the word Talaivan. Okay, excellent. Right? Yeah. So, dear friends, today we are going to have a marathon session. The time allotted for me is 50 to 55 minutes. Okay. So, within 1 hour I should finish. Already we have completed the rapid revision RR and last resort revision LRR. This session is just a quick revision in 50 minutes of the essential topics, essential points for FMGE. Okay. So definitely this will be very helpful. Okay. So we'll straight away move on to the first question. Galeazzi fracture is fracture upper third ulna with radial head subluxation, fracture lower third ulna with distal radial ulnar joint subluxation, fracture lower third radius with distal radial ulnar joint subluxation, fracture upper third radius with distal radial ulnar joint subluxation. Okay, so what is the right answer? Hello? Yes? Yes? Yeah. Okay. Yes. So it is fracture. See, Galeazzi is fracture. The question is Galeazzi. Carefully read and answer. Fracture. Many of you are giving an answer. Yes. No. Yes. A.K. Ramkumar Sari has given the right answer. Abhya has given the right answer. Nandini Sharma has given the right answer. Galeazzi's fracture is fracture lower third radius. Okay. With distal radial ulnar joint subluxation. Quickly, in 1 minute, what is Montegia's? Please focus your fullest attention. Chatting is enough. Focus your fullest attention. What is Montegia? What is Galeazzi? Often repeated area in FMGE. Montegia's fracture is fracture upper third ulna with radial head subluxation. Montegia's fracture is fracture upper third ulna with radial head subluxation. This is Montegia. Galeazzi's fracture is ulta. It is fracture lower third radius with distal radial ulnar joint subluxation. This is called Galeazzi's fracture. Okay. And Galeazzi, see, coming to the treatment. Yes, very good. Coming to the treatment, Montegia's fracture can be managed conservatively. Okay, can be managed conservatively with an above elbow POP slab. It can be managed. But Galeazzi fracture 100% needs surgery. 100% it needs surgery. Okay, it needs only surgery. That is why this Galeazzi's fracture is otherwise called fracture of necessity. Fracture of necessity. 100% surgery is necessary. So this is called fracture of necessity. Okay, good. And another important point, Montegia is common in children. Okay, Montegia is common in children. Galeazzi is common in adult. This is another important point. Okay, right? And this, you are in Galeazzi fracture, the classical clinical sign, because there is fracture lower third ulna with the distal radial ulnar joint subluxation, the classical sign, distal radial ulnar joint is unstable, no? So when you press the head, the styloid process of the ulna, it will go down. When you release, it will come up. When you press, it goes down. When you release, it will come up. This is called piano key sign. So far unasked. In Galeazzi, all other things they had asked, all the complications, everything they had asked, treatment, everything. Okay, the only treatment for Galeazzi fracture is open reduction, internal fixation with a long plate and screw. The classical clinical sign is called piano key sign. So far unasked question. Okay, yes, very good. Yes, Abhishek Singh has given The right answer. Marvelous, marvelous. That means you had done your LRR and RR very well. Okay. So this is Monteggia, this is Galeazzi. Shall we move on to the next question? Basic difference between Colles fracture and Barton's fracture is Colles is intra-articular, Barton is extra-articular. Barton is intra-articular, Colles is extra-articular. Any of the above, none of the above. What is the answer? Yes, Abdul Rahim, Darkat side. Okay, yes, Abhishek Singh, Priya Reddy, all of you had given the right answer. The basic difference between Colles and Barton. Focus your fullest attention, dear friends. See, there are few fractures that can happen in the distal radius. The commonest is Colles fracture. The reverse Colles is called Smith fracture. The third thing is Barton fracture. Fourth thing, it can affect only the fracture of the radial styloid, that is called Schaffer's fracture or radial styloid fracture. What are the fractures that are possible in distal radius? A Colles, a reverse Colles, that is called Smith, a Barton, a radial styloid fracture. These are the fractures that are possible in the distal radius. What is the difference? The only difference between Colles and Smith are almost same. Colles, Smith and Barton. What is the basic difference? When it is purely extra-articular, it is called Colles. When it involves the joint line, that is intra-articular, that is called Barton. So, a distal radial fracture which is intra-articular is called Barton. A distal radial fracture which is extra-articular is called Colles. So, the right answer, Barton is intra-articular, Colles is extra-articular. Okay, this is the answer. Okay, so very simple, right? You see here, this is a classical X-ray of Colles fracture. This is a classical X-ray of Wohler-Barton fracture. Barton, see, you see here, in Colles when you see, fracture line is here. Fracture line is here. And on the lateral view, fracture line is here. It is not involving, this is the joint space. I will draw, this is the joint space. I will erase now, you see. So, the fracture is not extending into the joint space. This is called Colles. This is called Colles. Colles means, you see, this big chunk is the proximal fragment. This small chunk, this is the distal fragment. This is the distal fragment. Okay. So, when the distal fragment is dorsally displaced, this is dorsal, this is volar. This is dorsal, this is volar. When the distal chunk, the distal fragment is dorsally displaced, that is called Colles. When the distal fragment is ventrally or volarly displaced, that is called Smith, reverse Colles. That is the difference. Where is the distal fragment? Is it dorsal or volar? When it is dorsal, it is called Colles. But in both in Colles and Smith, it is not involving the joint space. Whereas when you see this Barton fracture, we are able to see this is the proximal fragment, this small chunk, this is the distal fragment. This is the distal fragment. When you see the fracture line is going and is going inside the joint space. It's going inside the joint space. You see the X-ray. So it is intra-articular. Since the small chunk is volar, in volar aspect, this is called volar-Barton. If the small chunk is in dorsal aspect, that's called dorsal Barton. Okay, this is volar Barton, dorsal Barton. Among the two Bartons, this is more common and this is called classical Barton. This is called classical Barton. This is very rare. This is very rare. And Colles fracture, since it is extra-articular, since the Colles fracture is extra-articular, the best treatment is below elbow POP cast. POP cast. This is the treatment of choice. I am going to show you the diagrams. In the next slide it will come. Below elbow POP cast is the treatment of choice. But volar Barton, since it's intra-articular, it is involving the joint space. Best treatment is open reduction and internal fixation with buttress plate, okay, with buttress plating. Okay, so classical Barton, the Barton's fracture treatment is surgery, Coley's fracture treatment is conservative, POP. Okay, now let us revise very quickly. Okay, yes, plaster of Paris, good. Okay, John Chanley's, right, John Chanley's method, excellent man. So you have done very well. Yes, you see, what are the 6 components of Coley's repeatedly asked area? What are the 6 components of Coley's? Number 1, it is dorsal tilt, then dorsal displacement, then comes impaction, okay, then lateral tilt, lateral displacement, finally supination. All these displacements are, and the classical mnemonic which we follow is DILS, DILS. This is the mnemonic which is given in our notes, DILS. Okay, so excellent supination, marvelous Abhishek Singh, excellent man. So see, all these displacements are in relationship with the distal fragment. All in relationship with the distal fragment. Distal fragment is dorsally tilt, dorsally displaced. The distal fragment is impacted to the proximal fragment. Then the distal fragment is lateral tilt, lateral displacement, and the distal fragment is in supination. So these are the 6 components of Coley's. These are the 6 components of Coley's. Okay. Only when we understand these 6 components, we can reduce. So how we are reducing? By John Chanley's method. Abhishek Singh has correctly mentioned that John Chanley's method. Yes. Yes, Smith. Yeah. Ventral displacement in Smith. Okay. Kirtha lifts. Okay. Kirtha lifts. And yeah, Jaffe, Vipul, all of you, Superman, and you have written dinner folk deformity. So that means you have read thoroughly. Excellent. You see here, John Chanley's method, what I am doing is, I am giving traction. When I give traction, impaction, this is neutralized. Okay. The impaction, the third thing, no, this impaction, this is neutralized. When I do traction, impaction is neutralized. After that, after giving traction, I am flexing the hand in palmar aspect. I am palmar flexion. Palmar flexion neutralizes dorsal tilt and dorsal displacement. And I am, after palmar flexion, I am doing ulnar deviation. When I do ulnar deviation like this, ulnar deviation, the lateral tilt and lateral displacement is neutralized. Then I am putting the POP cast in pronation. When I put it in pronation, the supination is neutralized. So all the deformities are neutralized by reducing by John Chanley's method and doing a closed reduction and below elbow POP cast in full pronation with palmar flexion and ulnar deviation. This cast is called Coley's cast. Exactly, this looks like a cotton loader machine. So the position of immobilization with Coley's cast is called cotton loader's position. So far unasked question. Cotton loader's position. Okay, this position is called cotton loaders, unasked question. Okay, so this is palmar flexion, ulnar deviation. The treatment of choice for Coley's fracture is below elbow POP cast in palmar flexion, ulnar deviation in full pronation. Treatment of choice for Barton fracture is open reduction, internal fixation with buttress plating. Okay, yes, just to revise quickly, most common complication of Coley's fracture is stiffness of finger. Second common complication is malunion, and that malunion is called dinner folk deformity. Everything is there in our recording. Okay, we will go on to the next question. Yes, look at this question. A 20-year-old male had fall on outstretched hand. Fall on outstretched hand 6 months back, 6 months before. Okay, Now he complains of pain in his left wrist. On examination, tenderness over the anatomical snuff box. So whenever there is tenderness over the anatomical snuff box, scaphoid is gone. Okay, so we all know, dear friends, this is the anatomical snuff box. When somebody complains of pain in the anatomical snuff box, exactly I am palpating the scaphoid. Okay, so scaphoid is gone. Okay, you see here. So this has happened 6 months back. Now the patient is complaining of pain. It is not a simple scaphoid fracture. It is scaphoid fracture with query avascular necrosis. Query avascular necrosis. That is the diagnosis from the history. Best investigation is, yes, many of you already, okay, Sangchat, Guru, okay, Krishna Prakash, all of you have answered it very well. And you see, yeah, so avascular necrosis is suspicious. So what is the best investigation? Okay, see, X-ray, please focus your full attention. X-ray of the left wrist scaphoid view is very good to diagnose scaphoid fracture. But you are suspecting avascular necrosis. Avascular necrosis in X-ray is seen very late. The best investigation to pick up a suspicious avascular necrosis wherever in the human body is MRI. This is the catch here. See, when you suspect scaphoid fracture, you can go for this. But you are suspecting AVN. This has happened 6 months back. Okay, so you are suspecting AVN. AVN will take few months to develop. So MRI will pick up AVN. It will give you surely this is AVN or not. So the question asked is best investigation. The right answer is MRI. Okay, best is always MRI. Yes, Medico Traveler has answered it. Yes, it is not the next step. Okay, Sharath Reddy, it's not the next step. You are asked a doubt. Is it next step, sir? I am not asking the next step. Best for the suspicion. Clinically, this history gives a suspicion of avascular necrosis of proximal pole of scaphoid. Avascular, please focus your fullest attention. The commonest complication of scaphoid fracture is the non-union and avascular necrosis of the proximal pole of the scaphoid, because blood vessel enters through the distal pole. Common area of fracture of the scaphoid, see, you see here, see, for example, a boat-shaped bone. This is called scaphoid. This is the distal pole. This is the proximal pole. This is called waist of scaphoid. Blood vessel enter through the distal pole, goes proximally. Blood vessel goes like this. Okay. The most common site of scaphoid fracture is this waist. So what happens? Distal pole will have blood supply. The proximal pole will go for AVN. Okay. This is called Preecier's disease. Avascular necrosis of proximal pole of scaphoid is called Preecier's disease. Okay. Preecier's disease. Very, very important MCQ. The commonest complication, Preecier's disease. Okay. So when you suspect, no, MRI is the best investigation. That will give you a clue. Okay. Now you see, this is an asked question many times in NEET PG and in FMGE, several times. Most important clinical sign of scaphoid fracture is fullness and tenderness in anatomical snuff box. When the scaphoid, you see, this is the scaphoid. Scaphoid means boat shaped. The bone is boat shaped. That's why it's called scaphoid bone, like boat shaped. That's why whenever an abdomen is like this, that abdomen is called scaphoid abdomen. Bailey and Love uses the word scaphoid abdomen. Okay, a very flat abdomen is called scaphoid abdomen. You see here, you see this scaphoid, this fracture is displaced. The scaphoid, the bone fracture has happened in this area and it is displaced. It is looking like this now. Is it not looking exactly like a hump? And this is called, the classical deformity of displaced scaphoid fracture is called humpback deformity. Okay, it is called humpback deformity, right? This is called humpback deformity, right? two important clinical tests to diagnose scaphoid. One is called scaphoid lift test. Catch hold of the hand like this, move it dorsally and ventrally like this. There will be pain along the scaphoid. This is not very important. This test is very important. Asked question, Watson test. Whenever the question Watson's test is positive, the diagnosis is scaphoid fracture. Ask the patient to keep his hand over a table like this. From ulnar, ask him to deviate it radially like this. I think you'll be able to. So, for example, this is the table. I had kept my hand over in an ulnar deviated position like this. In an ulnar deviated position like this. I am moving from ulnar deviation to radial deviation like this. Severe pain is produced in this scaphoid. That is called Watson's test. That is called Watson's test. Okay. And you see here, X-ray of the scaphoid. The view is performed with the wrist in ulnar deviation to free the. So you will keep like this. X-ray beam will pass. And classically you can see. You see this scaphoid like a boat-shaped bone here. Scaphoid, a boat-shaped bone, scaphoid bone. When you carefully zoom your app and see, you can see a thin fracture line here. Okay, so this is waist of the scaphoid. This view is called scaphoid view. This is the view of choice. If you clinically suspect, this is the question that has been repeated 3 times. Focus your full attention. Okay, this is last minute preparation. Focus your full attention, dear friends. See, quickly I will finish. You see, clinically, there is strong suspicion of scaphoid fracture. Fall on outstretched hand history is there. Tenderness and fullness of anatomical snuff box is there. You took an X-ray, proper scaphoid view X-ray, but the X-ray is not clearly giving you the fracture line. But clinically, you are suspecting scaphoid fracture. What you should do? Treat it like a scaphoid fracture. Give a below elbow POP cast in tumbler holding position or glass holding position like this. This is called a scaphoid cast. This is called scaphoid cast. You just give a below immobilize in a tumbler holding position, scaphoid cast. Repeat the X-ray after 3 weeks. Repeat the X-ray after 3 weeks. The same scaphoid view you take in the 3 weeks. After 3 weeks, when you see a thin healing fracture line, you continue the cast for 10 weeks. Leave the cast for another 7 weeks, total 10 weeks. Okay. Even after 3 weeks, there is no sign of fracture healing. You are not able to see any fracture. You just remove the POP, set him free. Okay. Over treatment is justified in scaphoid fracture because the main complication is non-union and avascular necrosis. Once a patient develops avascular necrosis, young adult, he is a young adult. Scaphoid fracture is common in young adults. Colis is common in elderly. He is a young adult. Once he has developed avascular necrosis, throughout his life, he will have wrist pain. Okay, wrist pain, very dangerous, right? So, MRI detects scaphoid fracture much earlier than X-ray. So, this is the investigation of choice. Okay, so be very, very clear in your mind. If they ask a question, please focus your full. This is a tricky area. If they ask a question, best investigation, best, not the next line, best investigation, confirmatory investigation in a suspicious scaphoid fracture. In the choice MRI is there, please tick MRI. Please tick. If they ask next step, you can take scaphoid view. Okay. So this is, I want you to be very clear in the last moment. Okay. Yes. Treatment of undisplaced scaphoid fracture is called below elbow POP cast in tumbler holding position, or there is called glass holding position, and this is called Bowler gauntlet cast. Scaphoid cast goes by a name, Bowler gauntlet cast. Displaced scaphoid fracture, you have to give a screw fixation, and that screw is called, this is called Herbert screw fixation. Asked question. We will move on to the next slide. Yes, good. We'll move on to the next thing. Best treatment for fracture clavicle, medial 2/3, lateral 1/3 junction is. Best treatment for fracture clavicle, medial 2/3, lateral 1/3 junction is POP, figure of 8 with arm sling, K-wire, plating. What is the best treatment? Yes, superb, 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 marvelous. Oh, Humpty number of guys are answering and all of you are answering. Okay, excellently, man. You are this time, all of you, sure pass in FMGE. There is no doubt. All of you are answered very sure pass. You see, the best treatment for fracture clavicle, medial 2/3, lateral 1/3 junction is figure of 8 with arm sling. Okay, figure of 8 with arm sling. You see, this is the only thing. You see, this is called figure of 8 bandage. This is your arm sling. Okay, just 10 seconds, I will finish this topic. Medial 2/3, lateral 1/3 junction fracture clavicle has happened. The lateral 1/3, always the fracture will be displaced like this. The medial 2/3 is pulled up by sternocleidomastoid muscle. Lateral 1/3 is pulled down by weight of your upper limb. I have to neutralize these two forces. When I give a figure of 8, that neutralizes the medial 2/3 pull up by sternocleidomastoid. When I give an arm sling, that neutralizes the lateral 1/3 pull down by your weight of your upper limb. So both the things are neutralized. So clavicle will be in contact. And we know clavicle is a membranous bone. Clavicle ossifies membranously. It's a membranous bone. Only long bone to ossify membranously is clavicle. So healing will just like that, it will happen. In 45 days, totally it will be healed with a superb callus. Okay, so 99% of fracture clavicle is managed only like this, figure of 8 with arm sling. Okay, good. We'll move on to, see, yeah, this is a very favorite NEET PG area. In FMGE, I am expecting this as a question. In FMGE, I am expecting this as a question. What are the indications for surgery? Only 1% needs surgery. What are the indications? Just read this once. Displacement more than 2 centimeter, open fracture, that is here a wound is there, you can't apply figure of 8, that will end up in gas gangrene, so some surgery you have to do. Then when the fracture clavicle is associated with neurovascular injury, because you know fracture clavicle, what neurovascular injury? Medial cord of brachial plexus, especially ulnar nerve is injured. Okay, so injury to the neurovascular bundle, you immediately have to open, decompress the neurovascular bundle. Subclavian artery is there, subclavian vein is there, medial cord of brachial plexus is there. Okay, so you have to release, otherwise it will go for permanent damage. When there is fracture clavicle is associated with the same side scapula fracture, same side rib fracture, when you give figure of 8, it will hurt him more, so you have to go for surgery. Non-union of fracture clavicle, wherever there is non-union, the only treatment is open reduction internal fixation with cancellous bone grafting, surgery. Fracture near acromioclavicular joint, very it is not medial 2/3 lateral 1/3 junction, very near to acromioclavicular joint. You can't give figure of 8. You cannot give figure of 8. It won't heal. So it needs surgery. If it is bilateral or it is flat floating shoulder, that is fracture clavicle associated with scapular neck fracture, you cannot give figure of 8. You have to go for surgery. Something tells my mind this year they may ask this question. Please read it twice. The indications for surgery in fracture clavicle. In NEET, how they are asking, all are indications for fracture clavicle except. This is how they are asking. Repeatedly they are asking. So something tells my mind in FMGE, we can expect this as a new question. Yes. Light bulb sign is classically seen in. Light bulb sign. Okay. Dr. Morathi. Okay, sir. Right, good. Yes, doctor. Light bulb sign is classically seen in anterior shoulder dislocation, posterior shoulder dislocation, inferior dislocation, none of the above. Marvelous. Marvelous. Oh, superb, man. Superb. All of you are answering it correctly. So how many? Oh, humpty number of right answers. Light bulb sign is classically seen in. Okay. So yes, Junaid. All of you are answered it correctly. Excellent, man. So see, I am very confident in you. Okay. This time we are all going to rock. There is no doubt. Light bulb sign is in X-ray is classical of posterior shoulder dislocation. Classical of posterior shoulder dislocation. Okay, light bulb sign. Right. You see, please focus your fullest attention. There are 3 types of shoulder dislocation: anterior, posterior, inferior. The most common type, without doubt, it is anterior shoulder dislocation. But in X-ray, there is no named sign for anterior shoulder dislocation. There is no named sign. Okay. Anterior shoulder dislocation means head of the humerus is lying in front of the glenoid. That's called pre-glenoid. Head of the humerus is lying in front of the glenoid. Okay. So there is no named sign. But posterior shoulder dislocation means head of the humerus is lying behind the glenoid, posterior to the glenoid. It has 2 named signs. One is called empty glenoid sign, other is called vacant glenoid sign, another is called light bulb sign. You see here, you see this empty glenoid sign you can see what you can see. This is the glenoid cavity. Totally it is empty, and you are seeing very clearly a glenoid cavity, right? And the radiological criteria says that space between the glenoid rim and humeral head is more than 6 mm. This is a criteria. Okay. If it is anterior shoulder dislocation, this head of humerus is lying in front of the glenoid, so you won't see the glenoid clearly. The glenoid cavity is obscured. You won't see it clearly. In posterior shoulder dislocation, glenoid cavity is seen empty. That's why it's called empty glenoid or vacant glenoid sign. The next important sign is called light bulb sign. Dear friends, if you see our main video or rapid revision, you see the position, the clinical attitude, no? When a patient comes with the, for example, I am having right side shoulder dislocation, arm is extended, abducted, externally rotated. I will come like this. Arm is extended, abducted, externally rotated. Like this I will come. When the head of the humerus is in external rotation, this is anterior shoulder dislocation. When I take an X-ray AP view, when the head of the humerus is externally rotated, I can see GT, LT, greater tuberosity, lesser tuberosity as a prominence. Okay, one round curve will be there, one prominence will be there. In case of posterior shoulder dislocation, what is the attitude we had studied? Arm is adducted, internally rotated. The arm is internally rotated, and this position is called sling position. Patient will come to OP like this. This is posterior shoulder dislocation. Since the head of the humerus is internally rotated, when I take an AP view, I cannot see where is GT, where is LT. So the head smoothly, it looks, you see here, since the head is internally rotated, I am not able to see any GT or LT. Smoothly, this exactly looks like a light bulb. This is called light bulb sign. This is called light bulb sign. So two named signs, X-ray signs are there in shoulder dislocation. Both the signs are reserved only for posterior shoulder dislocation. We will move on to the next MCQ. Yes. Okay. Yes. Fadir. Okay. Flexion, adduction. Via and Dr. NSH, Fadir, you had written this. Fadir, that comes in the hip dislocation. Flexion, adduction, internal rotation. Faber, flexion, abduction, external rotation. That comes in the hip dislocation, that mnemonic. Okay. A 65-year-old lady had fallen in bathroom 2 days back. 2 days back. X-ray showed a Gordon's type 3 neck of femur fracture. Okay. Gordon's type 3. Okay, neck of femur fracture. Gordon's type 3 means totally displaced. It is displaced. The fracture is displaced. Gordon's type 3. Ideal treatment is screw fixation, no surgery, hemiarthroplasty, THR. You just see age is 65-year-old lady, fallen bathroom 2 days back. Yes, busy talkies, Dushyant, Shivani Sharma, Medi. Okay, so all of you, superb man. Oh, how many right answers? How many right answers? Superb. So the best treatment for this is hemiarthroplasty. Best treatment for this is hemiarthroplasty. You see very clearly, fracture neck of femur is a fracture which has to be treated with some surgery. It can be treated with some surgery. It cannot be treated non-operatively. It won't unite because fracture neck of femur. Neck means it is inside the joint capsule. Since it is inside the joint capsule, see, you know, ball and socket type of joint. Head and neck is inside the capsule. It's inside the joint. So since it is inside the joint, it is surrounded by synovial fluid. Synovial fluid contains an enzyme called lysine. So whenever fracture happens, first thing is hematoma formation. Only when hematoma is formed, over the hematoma a callus will be formed. Okay, but here since there is an enzyme called lysine in the synovial fluid, whenever the fracture breaks open, okay, hematoma is not formed. Hematoma is not formed. So callus cannot be formed. So 100% that is going to be a non-union. So you have to fix it with some surgery. The problem is whether I am trying to save the original head, that is called head saving surgery, head preserving surgery, okay, or I am going to replace the head. That's called head sacrificing surgery, head preserving surgery or head sacrificing surgery. That is the only question. So to decide for that, you should take into account two things. One is Gordon's classification, another is age of the individual. You see, in Gordon's type 1, fracture is incomplete. Okay, you can save the head. So I can do a hip spica, immobilized or novel screw. If it is Gordon's type 2, the fracture is complete but undisplaced. I can fix it with a 3-point fixation or dynamic hip screw. If it is Gordon's type 3 or type 4, type 3 means partially displaced, type 4 means completely displaced. Once the word displacement is there in the question, only treatment is replace the head with a prosthesis. So prosthetic replacement, very simple. Okay, so take this into account. I repeat once again. There are 4 stages. Gordon stage 1, 2, 3, 4. Gordon's type 1 means incomplete fracture. Gordon's type 2 means complete but undisplaced. Gordon's type 3 means complete partially displaced. Gordon's type 4 means complete totally displaced. So for Gordon's type 3 and type 4, you have to go for a head sacrificing surgery. That is, I have to replace the head with a prosthesis. Gordon's type 1 and type 2, I can try a head preserving surgery. What is the surgery I will do? I can do what is called a 3-point fixation. That is, for example, you see here, just I will draw a diagram. This is your head, okay. This is your GT, this is your thing, this is your LT, and so, okay. This is your neck, okay. So a fracture has happened here, neck. What is this 3-point screw fixation? From here, I will apply 3 screws. I will apply 3 screws like this. I will put 3 screws from here and fix the fracture. In the cut section, when you see, the screws will be placed like an inverted triangle. In the cut section, the screws will become inverted triangle. This is called 3-point fixation, a gold standard treatment for Gordon's type 1, type 2 fractures. Otherwise, I can go for what is called a dynamic hip screw, which we use for intertrochanteric fracture. One plate will be here. It is fixed with a single screw. That's called dynamic hip screw. Okay. So these are the head preserving surgeries. For Gordon's type 3 and type 4, I can, okay, Gordon's type 3 and type 4, I can replace. I have to go for some replacement. The replacement is of 2 types. One is called hemiarthroplasty. So this is the, you see, this is the 3-point screw fixation. Look at the diagram, 3 screws. In the cut section, it looks like an inverted triangle. Yes or no? So this is the 3-point fixation. And this is called dynamic hip screw. With a plate, I had fixed the fracture. Here is the fracture. I had fixed it with the screw. Okay. So this is the head preserving surgery. Coming to the replacements, either it can be hemiarthroplasty or total hip replacement. Hemiarthroplasty means only head and neck is replaced. Acetabulum is patient's original acetabulum. Okay. So I can do a hemiarthroplasty with an Austin Moore's prosthesis, asked question, or Thompson's prosthesis. You, in an image based, when you see a prosthesis like this, 2 holes are here, use the word Austin Moore. If there is no holes, that should be Thompson. This is called hemiarthroplasty. In total hip replacement, I am replacing head, neck and the acetabulum also. This is called total hip replacement. Okay. So here, why I preferred hemiarthroplasty? It is Gordon's type 3, age is only 65 years and it has happened only 2 days back. That means only neck fracture is there. The acetabulum will be very fine. So no need to replace the acetabulum. So the gold standard is hemiarthroplasty. Okay. This is in short, because in fracture neck of femur, only 2 points that are important for FMGE, our entrance is Gordon's classification 1. They will ask you what is this type. Number 2, how will you manage? They will give an age and Gordon's type and they will ask you what is the best management. Okay, we will move on to the next question. Okay, we are running short of time, man. I have to pump myself. Best treatment for displaced patellar fracture. Cylinder cast, Tension band wiring, patelectomy, screw fixation. Yes? Yes? Okay. Okay. Yes. Marvelous. Very good. Indian 22 and Sheikh, many of you, many guys and girls, you are given the right treatment. Best treatment for whenever a displaced patellar fracture, the best management is tension band wiring. Best management is tension band wiring. Best management is, if it is undisplaced fracture, best management is cylinder cast. Undisplaced, it is cylinder cast. Displaced means it is tension band wiring. When to call, see, patellar fracture, 2 X-ray views are taken. A plate is kept here, the knee joint is flexed only to, you see here, 45-degree angulation. Okay, this view is called axial view. Axial view. You will see an X-ray like this, you are seeing a fracture line here. Axial view. When you flex the knee joint to 110 degrees, this is called sunrise view. Okay, sunrise view. 2 views, good views are there. Commonly asked question is this axial view, 45-degree flexion. In both the views, you can see a patella very clearly. When the patella between the fragments, when the distance is less than 2 millimeter, that is called undisplaced. When the distance is more than 2 millimeter, that is called displaced. So undisplaced fracture patella, best treatment, you see less than 2 millimeters. Okay, undisplaced fracture patella, best treatment is called cylinder cast. Cylinder cast means from middle of the thigh up just above the ankle. So only the knee joint is immobilized, only the knee is immobilized. Your hip is free, your ankle is free. This is called cylinder cast. Okay, this is called cylinder cast. This is the best management for undisplaced fracture patella. If it is displaced fracture patella, you have to fix it with what is called tension band wiring. What is called tension band wiring? This is called, you see like a figure of 8. Okay, this is called a tension band wiring. This is called tension band wiring. Martin circumferential tension band wiring is the treatment of choice for undisplaced fracture patella. If the same question, severely comminuted fracture patella, what is the best management? The treatment is, hello, anybody? Please answer. What is the best treatment for comminuted fracture patella? Somebody answer. Please, somebody answer. Yes, Abdul Rahim, Divya, Ayush Keshari, all of you answered very superb, man. Patelectomy. I feel very happy. I feel really very happy for you. So it is patelectomy. Severely comminuted fracture, it is patelectomy. So let us revise. Undisplaced transverse fracture patella, cylinder cast. Displaced fracture, transverse fracture patella, tension band wiring. Comminuted fracture patella, patelectomy. Okay, very simple. We'll move on to the next question. A 30-year-old male met with road traffic accident. X-ray showed fracture both lower end of fibula and medial malleoli. Lower end of fibula and medial malleoli. Okay, lower end of fibula is called lateral malleoli, medial malleoli. So it is bimalleolar fracture. What is the fracture name? What is the fracture name? Marvelous. Divya has answered yes. Akra once, oh, all of you, oh, just like that you are answering. It is called bimalleolar fracture, is called Pott's fracture. Bimalleolar fracture is called Pott's fracture. Okay, so see, everything is typed here. Okay, you will get the PDF, you just go through. Quickly I will tell. Okay, you see here, you see, when it is bimalleolar fracture, it is called Pott's fracture. When it's trimalleolar fracture, it is called Cotton's fracture. Medial malleoli, lateral malleoli, posterior malleoli. Okay. Aviator's fracture is fracture of the neck of talus. Fracture neck of the talus is called aviator's fracture. Masonovi's fracture, you know, fracture proximal 1/3 of fibula associated with distal tibiofibular syndesmosis, and this is the distal tibiofibular syndesmosis injury. It's called Masonovi. That may have a medial malleoli, may not have a medial malleoli. That's called Masonovi. So this is a new question for you. If they ask a question, this will be new. Several times repeat is spots and cotton. Okay. Aviator's fracture is nothing but fracture neck of talus. Fracture neck of talus. Olden days that was happening in the pilots during crash landing because the hit of the talus over the rudder bar. Okay. Nowadays this is very common in RTA, road traffic accidents, aviators. We'll move on to the next thing. Seagon fracture happens in medial meniscal injury, lateral meniscal injury, ACL injury, PCL injury. Yes. Yes. Hello. Yeah. Dr. Marathi has given the right answer. Okay. Good. 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 Many of you have answered it correctly. Yes. Seagon fracture classically happens only in anterior cruciate ligament injury. Okay, Seagon fracture classically happens only in anterior cruciate ligament injury. You see, what is the Seagon fracture? This is an X-ray of a knee joint. Okay, whenever there is ACL injury, you see fibula is here. So this is the lateral side of the tibia. You zoom your app and see here. A small chip fracture here is seen in the lateralmost tip of the tibial plateau. Tibial condyle. The tibial condyle, lateralmost portion, a small avulsion fracture has happened. This fracture is called Seagon. This fracture is called Seagon. Radiologically, when somebody is seeing Seagon fracture, indirectly that indicates the patient is having anterior cruciate ligament injury. When you take an MRI, you can see the anterior cruciate ligament is torn. Okay, this is called Seagon fracture, unasked question in ACL injury. All other things in ACL they had asked. Okay, we'll move on to the next thing. A 40-year-old woman who is washerwoman by occupation. She is a washerwoman by occupation. Complaints of pain in base of her thumb. Severe tenderness over the radial styloid. This is another important thing. Very favorite area of FMGE is this question. No history of obvious trauma. Likely diagnosis is. Likely diagnosis. Hey, this is. Hello, guys. Please stop chatting. All of you are giving some answer. Hey, please wait. Read the question one more time. Then you answer. Please read the question one more time. So far, no, Sheikh Pratap Singh has answered it correctly. Right? No. Yeah, many have answered it correctly. Now you are answering. Okay. Now you are answering. Varada. Okay. Yes. Now you are answering. Yes. Now your answer is right. Because please, when you read very superficially, you will tick scaphoid fracture. Okay. Scaphoid fracture, there won't be any pain in base of the thumb, or there is no pain over the radial styloid. There will be pain in the anatomical snuff box. Anatomical snuff box is here. Radial styloid is here. Okay. Number 2, 40-year-old woman, washerwoman by occupation, pain over the radial styloid, no history of trauma. Then how can that be a scaphoid fracture? That is why it's a catch question. That's why I said the right answer is de Quervain's tenosynovitis. De Quervain's tenosynovitis. Very favorite FMGE area. De Quervain's disease. Okay. What is this de Quervain's disease? This is otherwise called washerwoman's sprain. Because now washerwoman, after washing, they will twist their thing to dry the cloth. They will do this movement is very common in them. Washerwoman. Okay. What happens? It causes chronic inflammation of the tendon of abductor pollicis longus, extensor pollicis brevis. This is the question. 1 lakh time repeated MCQ. Inflammation of the abductor pollicis longus tendon and extensor pollicis brevis tendon. Okay. This is called de Quervain's tenosynovitis. Other is called washerwoman's hand. Common age is 40 to 60 years. More common in females. What they will have, what is called the classical triad is tenderness over the radial styloid, swelling over the first extensor radial compartment, positive Finkelstein's test. positive Finkelstein's test. What is that Finkelstein's test? You just give resistance. You please watch the video, please, my demonstration. You see, I am giving resistance to the thumb. I am abducting my thumb against resistance. If my wrist is normal, no problem. If I have the coherent stenosynovitis, when I abduct, no, severe pain is produced along here. Or the abductor pollicis longus and extensor pollicis brevis. This is called Finkelstein's test. So Finkelstein's test is classical clinical sign to diagnose the coherent stenosynovitis. Such a common condition in our country. Okay, right? So this is more common in females, right? So this is called Finkelstein's test. Another test is called Akoff test. Two names. Please go through this. Right. We will move on to the next question. 35-year-old woman sustained a dashboard injury in her car. She was unable to stand. Unable to stand. Dashboard injury. It gives the diagnosis. Her lower limb is flexed, adducted, internally rotated. What is the probable diagnosis? Yes, all of you have answered it correctly. Marvelous, man, marvelous. All of you are answering it correctly. Flexion, adduction, internal rotation. PADIR. Flexion, adduction, internal rotation. It is posterior dislocation hip. Posterior dislocation hip. You see here, mechanism of injury, dashboard injury. Okay, dashboard injury. Okay, right. Mechanism of injury, this is air crash. Air crash. That's why I always used to teach my undergraduate student. Posterior dislocation hip is a low socioeconomic state injury. This anterior dislocation is a high socioeconomic state injury because it happens in air crash. That's what the book says. Okay. So the classical attitude of posterior dislocation is flexion, adduction, internal rotation, marked shortening, vascular sign of Norath positive. Okay. Vascular sign of Norath means palpating the femoral artery. Femoral artery pulsation is feeble or absent. That is called vascular sign of Norath. Okay. So in posterior dislocation, the hip has dislocated posteriorly, head has dislocated posteriorly, underlying bony prominence is not there, so I cannot feel the femoral pulse. That's called vascular sign of Norath. In anterior dislocation of hip, this has come in front anteriorly, so underlying bony prominence is there, head and neck is there, but it is anterior. So vascular sign of Norath will be negative. Okay. So here the attitude is flexion, abduction, external rotation. Faber. This is Faber, external rotation. This is PADIR. Okay. Don't forget this. Repeatedly asked question in FMGE, dislocation of hip. In central dislocation of hip, what is happening? No, central dislocation. The acetabulum is broken. Head is entering inside the acetabulum. So it's going inside the pelvic cavity. Perrectally, when you do a perrectal examination, when the head is palpable, that is central dislocation hip. So limbs won't show any deformity. Like posterior dislocation, flexion, adduction, internal rotation. Anterior dislocation, flexion, abduction, external rotation. Central dislocation looks normal. Looks normal. Okay. Yes. You see, we'll move on to that. You see this. You see this X-ray. This is your acetabulum. Your head has gone posteriorly. This is your acetabulum. Head is in front anteriorly. In central dislocation, you see the head has broken the acetabulum. It's entering the pelvic cavity here. Okay, you see this. Zoom and see. So this is central dislocation. Central dislocation. One should not forget in X-ray Shenton's line. Okay. In any hip dislocation, in anterior and posterior hip dislocation, Shenton's line is broken. What is Shenton's line? Normal line. See, this is superior pubic ramus. When I draw a line on the inferior aspect of the superior pubic ramus, it forms a smooth curve towards the neck like this. This is normal. See, now I will try to draw a line here. This is the superior pubic ramus. I am trying to draw a Shenton's line coming, and it is broken because your head and neck is here. The Shenton's line is broken. Whenever a word Shenton's line is broken, a word is coming in the radiology or in orthopedics, you should suspect a hip dislocation. It can be posterior, it can be anterior, it can be central, any hip dislocations. Okay. Yes. We will move on to the next question. Yes. Yeah. Dr. SH has answered it, which is more. Yes. Zazo is asking question, which is more common. Okay. Okay, no complication. Okay, so you want me to tell few points about which is common complication. Focus your attention, guys. Focus your attention. Yes, no need to answer this. Focus your attention. Hey, come on. They had asked a doubt. Let us focus your attention. You come. There are three types of hip dislocation: posterior, anterior, and central. The most common type of hip dislocation is posterior. Second type is anterior. Rarest is central. Okay. In shoulder dislocation, most common type is anterior. Second common type is posterior. Least common type is inferior. Coming to the complication, in posterior dislocation hip, the most common nerve that is damaged is sciatic nerve. In anterior hip dislocation, most common nerve that is damaged is femoral nerve. Okay? Yes. Right? Good. We will move on to the next question. Yes. A 70-year-old man presented with backache. The age is 70. Backache. X-ray shows the following finding. What is the probable diagnosis? Is it disc prolapse, spondylolisthesis, multiple myeloma, lumbar spondylosis? What is the answer? Yes. What's the answer? Hey, this is a tricky question. Yes, doctor's life. Dr. Anita Vaishnavi. Okay, you have answered it. Shakul Rahman. Okay, Medi. All of you have answered it correctly. You see, focus. Yes, focus your fullest attention, guys. First is 70-year-old man. He complains of some vague backache. This X-ray shows, focus your fullest attention, guys. You are seeing something. This is called the spinous process of the end on view of spinous process of the vertebra. These two things like an eye, this is called the pedicle. This is called pedicle. When I see this X-ray, two pedicles seen here. Here the pedicle is absent, only one pedicle is there. Here again two pedicles are seen. In one particular vertebra, one pedicle is absent, and this is called winking owl eye sign. Winking owl eye sign, otherwise called pedicle sign. Otherwise called pedicle sign. A sure sign of multiple myeloma. A sure sign of multiple myeloma. Pedicle sign, otherwise called winking owl eye sign. You know what are the radiological? So important. This multiple myeloma, very often repeated area in all our entrances. Biconcave vertebra. You see, normal vertebra is, this is the shape of the normal vertebra. This is the shape of the normal vertebra. In case of multiple myeloma, the vertebra becomes biconcave like this. Biconcave like this. This is called biconcave vertebra, otherwise called codfish vertebra. Multiple myeloma is one differential diagnosis. Okay. Number two, when you see the skull, multiple punched out lesions, it looks like a raindrop. So this is called raindrop skull or punched out lesions in the skull. Another important sign of multiple myeloma. Third thing is called pedicle sign, otherwise called owl eye sign. You see one pedicle, two pedicle, pedicle. Here one pedicle, here pedicle is absent. It's looking like a winking owl. No, one eye is open, another eye is closed, like a winking. So it's called winking owl eye sign. Other is called pedicle sign. Okay. So owl, why they had compared this? No, this looks like, you see, these two big eyes like owl and a nose. Okay. So that's why they compared this with an owl. Then comes, you see here, because the biconcave vertebra, when it is worser, no, the vertebra totally is absent. I am able to count the lumbar vertebra. 1, 2, 3, 4 is absent. Okay. See, 1, 2, 3, 4, 5. 4 is absent. So this is called vanishing vertebra or disappearing vertebra. Whenever a word vanishing vertebra, disappearing vertebra comes, the diagnosis is multiple myeloma. Diagnosis is multiple myeloma. We'll move on to the next thing. Which bone tumor has the highest radiosensitivity? Several times repeated MCQ. Please answer. Highest radiosensitivity. Yes. Yes. Okay. Marvelous, man. Marvelous. Most of you have answered it correctly. Marvelous. The bone tumor with highest radiosensitivity is Ewing sarcoma. Okay. Ewing sarcoma. Okay. Now, yeah. Answer is over. All of you have answered. Stop. Now you just tell me. The bone tumor with the highest radiosensitivity, Ewing sarcoma. Now my question is, what is the best treatment for Ewing sarcoma? Please answer. Please answer. Guru has answered Ewing sarcoma, young children, onion peel. That means you have read well. Excellent. Yes. Hey, guys, superb, man. What is the best treatment for Ewing sarcoma? All of you are answering correctly. Surgery. Because you should not wrongly tick that is radiotherapy. No, surgery is that. Hey, this says your result. Hey, guys and girls, you are answering so well. This says your result. You all have already passed. I am telling you. You have already passed. 17th is the exam. Already you have passed. Okay, that means you have read well. You have done a hard work. Definitely all of you are going to pass. There is no doubt. Okay. So Ewing sarcoma is otherwise called small blue cell tumor. It arises from endothelial cell of bone marrow. Focus your fullest attention. Dear guys, two malignant bone tumors arises from bone marrow. Two malignant tumors arises from bone marrow. One is multiple myeloma. Another is Ewing sarcoma. Multiple myeloma arises from plasma cell of the bone marrow. Ewing sarcoma arises from endothelial cell of the bone marrow. That's the difference. So bone marrow, malignant tumors of bone, two tumors are arising. Multiple myeloma, Ewing sarcoma. Plasma cell of bone marrow, multiple myeloma. Endothelial cell of bone marrow, Ewing sarcoma. Okay, you should not forget. Most common age is 5 to 25 years. Most common male sex. Most common site is lower end of the femur, upper end of tibia, that is knee joint, is the most common site of Ewing sarcoma. Ewing sarcoma arises from diaphysis. Okay, osteogenic sarcoma, metaphysis. Ewing sarcoma, diaphysis. Giant cell tumor, epiphysis. I repeat, osteogenic sarcoma, metaphysis. Ewing sarcoma, diaphysis. Giant cell tumor, metaphysis. Okay, giant cell tumor arises from, epiphysis. Giant cell tumor arises from epiphysis. One more time I will repeat. Ewing sarcoma arises from diaphysis. Osteogenic sarcoma arises from metaphysis. Giant cell tumor arises from epiphysis. Gold standard MCQ. Okay. Yes. Highly radiosensitive tumor, but the treatment of choice is surgery. And okay, cytogenic abnormality 1122. It shows pseudo rosette formation. Closely resembles neuroblastoma. Closely resembles neuroblastoma. And one more thing, clinical presentation resembles osteomyelitis closely. Because only thing, osteomyelitis happens in metaphysis, Ewing arises in diaphysis. See, one special point which is not typed here, I want to mention. If they ask a question, bone tumor which spreads to bone quickly. If they ask a question, bone tumor which spreads in the bone quickly, the answer is Ewing sarcoma. Ewing sarcoma starts from the diaphysis. Slowly it will spread on both sides. Okay. So bone tumor spreading in bone very quickly is Ewing sarcoma. We are giving radiotherapy to shrink the tumor. But that is not the treatment of choice. Definitive treatment is amputation. You have to chop it out. Surgery is the treatment of choice. Coming to the chemotherapy, because the regime repeatedly they are asking, chemotherapy is given again to shrink the tumor to prevent the recurrence. That's called wide regime. Vincristine, ifosfamide, doxorubicin, etoposide. Wide regime is the best treatment for Ewing sarcoma. For multiple myeloma, the regime is called SCUM regime. SCUM, SCUM regime. Steroids, cyclophosphamide, urethane, melphalan. Steroids, cyclophosphamide, urethane, melphalan. SCUM regime for multiple myeloma. Wide regime for Ewing sarcoma. Okay. Yes. Coming to the X-ray finding, this and all 1 lakh time, 10 lakh times repeated question. This I am just telling all the X-ray findings of the 3 malignant tumors. I am able to see a elevation of the periosteum. This is called Codman's triangle. Okay. This is called Codman's triangle. Okay. It is osteogenic sarcoma. Here I am seeing what is called a sunburst appearance. This is called sunburst appearance. sunburst appearance, again osteogenic sarcoma. Here I am seeing in the metaphysis I am seeing a soap bubble appearance, soap bubble. This is giant cell tumor, osteoclastoma, there is giant cell tumor. I am seeing multiple striped layers of periosteum. When you zoom your app, you can see 10, 11, 12 layers of periosteum. This is called onion peel appearance. Onion peel appearance. It is Ewing's sarcoma. Now, this is looking like this is the only question which is unasked so far in any of the Indian entrants. These three things have been repeated 10 lakh times. This is so far unasked. This is looking like a moth-eaten appearance. Okay, this is moth-eaten appearance. Ewing's sarcoma. So far unasked. Okay, this needs a special mention. Moth-eaten appearance. Okay, we'll move on to the next question. Diagnose the following condition. I am seeing lower end of femur, upper end of knee joint. I am seeing some tumor. Diagnose the following condition. Yes. 1 minute. Stop chatting. Okay, come. See, Medico Traveler has asked a question. Sir, moth-eaten appearance looks like soap bubble. Okay, soap bubble. Okay, soap bubble. You are, see, the thing is, giant cell tumor, it looks like a soap bubble here. The giant cell tumor, this soap bubble should get confined to the, usually to the epiphysis. To the epiphysis. In case of Ewing's sarcoma, it is looking like a soap bubble, but here this is because of multiple tuberculous inside a lytic lesion. This is small holes, and this is mostly in the diaphysis here. It's in the diaphysis. So in diaphysis, you are seeing small hole-like lesions. That's called moth-eaten. The X-ray which I have shown is not very classical. Okay, so small dot holes-like thing in diaphysis, that is moth-eaten in Ewing's sarcoma. Multiple tuberculated like a soap bubble in the epiphysis, that is giant cell tumor, otherwise called osteoclastoma. Good. We'll move on to the, yes, come on, answer please. Yes. Osteoclastoma. Okay, yes. So we will finish in another 10 minutes. We will finish in another 10 minutes. Excellent, man. Diagnose the following condition. This is a classical X-ray of, very good. Most of you have answered osteochondroma, otherwise called exhastosis. Okay, how to say by looking at the X-ray exhastosis? You see, this arises first from the, this is epiphysis, this is metaphysis, this is diaphysis. This arises from the metaphysis. Okay, so this is a metaphyseal lesion and this is growing away from the epiphysis. This is epiphysis. So you are seeing a lesion which grows away from epiphysis. It arises from the metaphysis, growing away from epiphysis. The only diagnosis is osteochondroma, otherwise called exhastosis. Okay, quickly I will tell the points. Most common site is lower end of femur, upper end of tibia, that is around knee joint. Most common in males. Most common age group is pubertal age group, 16, 17, like that, pubertal age group. Usually that will present as painless bony mass, swelling, painless swelling. Pain usually should not happen in osteochondroma. When pain happens in osteochondroma, a secondary bursitis, compression of the surrounding neurovascular structure, or fracture of the osteochondroma. Fourth important thing is malignant transformation of the osteochondroma. The point I want to stress here is risk factors and signs of malignant transformation. This is the question we are expecting in osteochondroma. Okay, 1% chance in solitary and 5% in multiple hereditary. There are two types of osteochondroma. One is called sessile, another is called pedunculated. Sessile means it's fixed to the bone. Pedunculated, it has a nice stalk. So, sessile type is more prone for malignant transformation. The most important thing, repeated question, very important, this time also it may come, is when you take an MRI, the cartilaginous cap thickness more than 2 centimeters in MRI. That is why when somebody complains of pain, osteochondroma patient complains of pain, the next investigation you have to do is not biopsy. Confirmation is by biopsy. Next step is MRI. MRI, when it shows the cartilaginous cap thickness more than 2 centimeter, it says that malignant transformation has happened. Okay, so this is very important. We will move on to the next question. A 27-year-old male complains of pain over sacroiliac joint for 6 months. Pain is more on getting up from the bed, decreases as he starts working. This is an inflammatory arthritis. Rest worsens the pain, activity decreases the pain. That gives the diagnosis, sacroiliac. Marvelous, man. All of you have answered it correctly. Superb. Ankylosing spondylitis. Superb. Okay. Please focus your fullest attention. There are two important inflammatory arthritis in orthopedics. One is rheumatoid arthritis. Another is ankylosing spondylitis. Rheumatoid arthritis is common in women. Ankylosing spondylitis is common in men. Rheumatoid arthritis will not involve spine. It will involve the peripheral joint. Ankylosing spondylitis involves the spine mainly and the sacroiliac joints. Okay, finally, all other joints like your rib cage joints can be involved. That is why when you take inspiration expiration difference, normally when you take the chest circumference measurement, the inspiration expiration difference in a healthy lung and a healthy rib cage should be 5 centimeters difference. When the chest expansion is decreased, that's a very good, it is a very, very important clinical sign of ankylosing spondylitis. So ankylosing spondylitis means it is involved, it comes under spondyloarthropathy, that is involving joints as well as spine. Okay, it is strongly associated with HLA-B27. HLA-B27. It's common in men. The classical difference in the classical presentation of both inflammatory arthritis, that is rheumatoid as well as ankylosing spondylitis. When you get up from the bed, the hand joints will be stiff and painful in rheumatoid. When you start working, when you do exercise, the pain will go away. Like that, sacroiliac pain will be there when getting up from the bed. When you walk for quite some time, the pain will go away. That is the classical presentation of rheumatoid and ankylosing spondylitis. Coming to the thing, the important X-ray you should take is sacroiliac joint. This is a normal. When you see the sacroiliac joint, I am seeing a small gap between the sacrum and the ilium here. Okay, this is the gap. I will erase now, you see. In case of ankylosing spondylitis, you cannot see, this is the supposed to be the sacroiliac joint, but you cannot see any gap. Totally the sacrum and the ilium got merged. Okay, so this is a classical sign, X-ray sign of ankylosing spondylitis, sacroiliitis. Okay, and in the early sign, when you take a lateral X-ray of the spine, the corners of the spine will be shiny. It will be sclerosed. It will be opaque, shiny. This is called shiny corner sign, otherwise called Romanov's sign. Very important question. Then the spine is called exactly everything fused together like this. Okay, it's fused together like this. And this is called bamboo spine. This is called bamboo spine. 1 lakh time asked a repeated question. The anterior longitudinal ligament is calcified, looking like a dagger. So this is called dagger sign. Don't forget this. And you see, all are components of congenital talipes equinovarus except. We are going to another two topics. Another two topics we are going to finish. Yes. Come on. All are components of CTV except varus of the subtaloid joint, equinus of the ankle, cavus of the midfoot, adduction of the hind foot. Yes. Vipul has answered. Shivangi Bharatwaj. Yes. Marvelous, man. All of you have answered it correctly. Superb. Congenital talipes, there is no question paper with that CTV, CDH. Okay. Congenital talipes equinovarus, all are components except adduction of the hind foot. It should not be adduction of the hind foot. It is adduction of the forefoot. Okay. So what are the classical deformities of talipes equinovarus? Okay, you see, there will be forefoot adduction, metatarsal, that your fingers, no toes, forefoot adduction, adduction of the forefoot, cavus of the midfoot, varus of the subtaloid joint, equinus of the ankle. I repeat once again, adduction of the forefoot, cavus of the, this is the cavus of the midfoot, varus of the subtaloid joint, then you see this is the varus of the subtaloid joint, equinus at the ankle. Equinus means like a horse foot. Okay, so this is called congenital talipes equinovarus. I repeat for the last time, forefoot adduction, cavus of the midfoot, varus of the subtaloid joint, equinus at ankle. These are the 4 important deformities of congenital talipes equinovarus. The question that is expected is associations of CTEV. Whenever you are delivering a baby and the baby is having CTEV, what are the other conditions that you will rule out? You have to rule out. Number 1, spina bifida. That's called meningomyelocele. Okay. Meningomyelocele. Arthrogryposis multiplex congenita, very rare. Tibial hemimelia. Tibial hemimelia means only one side is affected. Tibial hemimelia means, for example, both lower limbs, when you examine the child, one side will have normal tibia and fibula. On the affected side, there will be only fibula and tibia is absent. That's called tibial hemimelia. And this CTEV, many patients are associated with the lateral popliteal nerve injury. Then, olden days, most of the CTEVs are associated with polio. Nowadays, polio is eradicated. But I am a government orthopedician. I am a government medical college professor. How many camps I would have attended? You won't believe, guys, in our country, I used to go to different villages and I used to give the disability certificate. It's called National Disability Certificate. When I give that certificate, the percentage exceeds 60%, he will get some benefits from the government. Free train pass, something like that. Okay. So, you won't believe, whenever I am seeing CTEV, it is almost always associated with polio. Okay. The last association is cerebral palsy. This is a very favorite area of NEET PG. Something tells my mind, they will ask this question this time in FMGE. All are associations of CTEV except. Please go through this twice. Yes. Okay. Treatment of congenital talipes equinovarus is another important thing. Don't follow all these things. In short, I will finish in 10 seconds. 0 to 3 months. Okay. 0 to 3 months. Birth to 30 days. Okay. 0 to 30 days. Okay. 0, that is 1 month. 0 to 30 days. Manipulation by mother. Okay. Manipulation by mother. Right. From 30 days to 3 months. Okay. Again, manipulation by mother. 3 months to 1 year. 3 months to 1 year. Best thing is Ponseti's method. But the child has crossed 1 year, 1 to 5 years, posteromedial soft tissue release, and that is called turquoise procedure. Okay. What are the 13 structures? Everything is there in our main recording. Don't forget tibialis posterior. Don't forget tendoachilles. It is 1 year to 5 years, posteromedial soft tissue release. That's called PMSTR. That's called turquoise procedure. When the child has crossed 5 years to 10 years, you can't do soft tissue procedure. You have to reshape the talus or reshape the calcaneum. When you reshape the talus, that's called Dwyer's osteotomy. When you reshape the calcaneum, that's called Gilvin-Evans procedure. When the child had exceeded 10 years, the only thing what we can do is triple orthodesis. That is fusing 3 joints. What are the 3 joints that are fused? Subtalar joint, calcaneocuboid joint, talonavicular joint. These 3 joints are fused. That's called triple orthodesis. The treatment protocol, again, one more time I will repeat. From birth to 3 months, manipulation by mother. 3 months to 1 year, Ponseti's method. 1 year to 5 years, turquoise procedure. 5 years to 10 years, Gilvin-Evans procedure. That's the best. When compared to the Dwyer, Gilvin-Evans the best. Gilvin-Evans procedure. When it is exceeded 10 years, only thing what we can do is triple orthodesis. We'll move on to the next chapter. Yes. Good. 2 months old child was brought to the ortho OPD with a dislocated hip. Already the hip is dislocated. Under sedation, slow abduction with internal rotation caused a click sound and the hip was reduced. This is called what test? This is called what test? Marvelous. Superb. All of you have answered it well. Ortolani's test. Ortolani's test. See, what is Ortolani's test, Barlow's test, Ali's test, telescopic test. 4 tests in case of congenital dislocation hip. What is that? No. See, you are getting a baby with a dislocated hip. Slow abduction and internal rotation. With a click sound, the hip will get reduced. That is called Ortolani's test. That is why Ortolani's test is otherwise called test of entry. Okay. Ortolani's test is otherwise called test of entry. Barlow's test is a provocative test. You are receiving a baby. Baby is not having a dislocated hip. You are suspecting a DDH. So you are trying to dislocate a dislocatable hip. That's a provocative test. So it is highly theoretical. In practice, no orthopedician will try a Barlow's test. Telescopic test is easy to perform. Already it's a dislocated hip is coming. You are pushing it, it will go down, pull up, it will come like a telescope will go down, come up. Because the hip is not in the socket. That's called telescopic test. Ali's test, otherwise called Galeazzi's sign, is make the baby lie down in a supine position, flex both the hip to 90 degree, flex both the knee to 90 degree. Normally, both the level of the knee joint should be at the same level. If it is a case of congenital dislocation hip, on the affected side, level of the knee joint will be at lower level. Then that is called Ali's test positive, otherwise called Galeazzi sign positive. Galeazzi fracture is different, Galeazzi sign is different. Because Riccardo Galeazzi was an Italian orthopedician who demonstrated Galeazzi fracture for the first time, who demonstrated congenital dislocation hip for the first time. Okay, yes. A 40-year-old female, known case of pulmonary tuberculosis, has severe pain in her right hip. On right lower limb, the limb is flexed, abducted, externally rotated, terminal range of movement is decreased. Probably she is having TB hip. What stage she is suffering from? Synovitis, there are 4 stages, no? Yes, Broken Angel. Hey, why the name is like that, man? Broken Angel, Vaishnavi, all of you, yes. Sime, Vaibhav, all of you have answered very well, excellently. She is suffering in stage of synovitis. Only terminal range of movement is affected. Hip is in flexion, abduction, external rotation. Then she is in stage of synovitis. This is called Ponde's clinico-radiological classification. Stage 1 is stage of synovitis. Faber will be there, irritable, terminal range. Stage 2 is called stage of early arthritis. That flexion, adduction, internal rotation. Stage 3, late arthritis, marked flexion, adduction, internal rotation. Stage of pathological dislocation. This is called traveling acetabulum. Stage of pathological dislocation. Kindly go through. Okay, everything is there in our recording. Yes. Coming to the next question. A 2-year-old child brought to the OP with complaints of angulation of the lower limb. The lower limb is angulated. That is, it can be genu varum, can be genu valgum, whatever it is. And the pediatrician tests and the anterior fontanelle is not closed. Age is 2 years, anterior fontanelle is not closed. Commonest cause in our country. It's scurvy, Paget's, rickets, osteogenesis imperfecta. Marvelous, man, marvelous. Superb. All of you have answered it correctly. The right answer is rickets. Okay, you just see, rickets is, please focus your fullest attention. I know it is tiring, but you no other go. We are having exam. Please focus your attention. Rickets is vitamin D deficiency happening before epiphyseal closure. Osteomalacia is vitamin D deficiency happening after epiphyseal closure. Vitamin D deficiency causes defective mineralization of the bone. So the bone will become pliable, plastic-like. That is causing certain deformities. In the head, it causes, when you press the head, it will go like a ping pong skull. Okay, that is called craniotabes. This is, we have 2 sutures. This is called sagittal suture. This is called coronal suture. So 2 sutures are dividing it into 4 zones. Both sides frontal bossing and occipital bossing. Looks like a hot cross bun. So this is called hot cross bun skull. Right. When you check the rib cage, costochondral junction is very, what I can say, it is blunt and it is, it is prominent. as if you are palpating a rosary bead. So this is called ricketic rosary. This is called ricketic rosary. The same thing happens in scurvy also. The only difference in scurvy, when you touch it is painful. In rickets it is painless. Then when you look at the sternum, it is projected like a pigeon's chest. So this is called pectus carinatum. Other is called pigeon chest. Right? Then the lower limb deformity can be a genu varum, can be a genu valgum. This is called wind swept deformity. Genu varum, genu valgum, wind swept deformity. When you just look at this, the wrist is enlarged. Enlargement of the wrist, okay, in a child, the commonest thing one has to suspect is rickets. And when you see here, I am seeing one malleoli here, another malleoli here, malleoli-like thing here. So this is called double malleolar sign. This is called double malleolar sign. This is called Marfan sign. The other name for this is Marfan sign, double malleolar sign. Okay, excellent sign of rickets. Right, coming to lab investigation, 10 lakh time repeated question. Serum calcium, early stage serum calcium is low. This stimulates parathormone. So after some times serum calcium may come to normal. So this is not a reliable investigation. Serum phosphorus is low if it is hypophosphatemic rickets. Otherwise it is again not reliable. The only consistent sign is elevated alkaline phosphatase. Case of rickets, the most reliable biochemical marker is not low calcium or low phosphorus, man. It is elevated alkaline phosphatase. Okay, very important. Coming to X-ray, all these things humpty number of times we have discussed. Cupping of metaphysis, fraying of metaphysis, playing of metaphysis. Cupping means depth of the metaphysis goes too much. Cupping. Fraying means irregularity of the metaphysis. Splaying means widening of the metaphysis. Three rhyming words: cupping, fraying, splaying. Okay. Then one should not forget looser zone, hallmark of osteomalacia, rickets. Right. And the therapy is called Stosh therapy. 3 lakh to 6 lakhs international units of vitamin D is administered orally or IM in 2 to 4 divided doses in the same day. The same day. In only one day. That's called Stosh therapy. Very effective. Okay. Yes. A 25-year-old man, this is the last question, man. This is the last question. 25-year-old man presented with history of pain in the right knee. Joint is swollen, warm, no history of trauma. Probable diagnosis. Yes, excellent. Most of you have answered. Plug boost. Most of you have answered that as marvelous, marvelous. At the end, important bone parts of foot. Okay. Okay. All of you have answered it excellently correct. The last question, the right answer is pseudo gout. It is pseudo gout. Okay. When knee joint is involved, it is pseudo gout. Okay. When great toe is involved, it is gout. Gout is hyperuricemia. Okay. It is excess monosodium urate. Pseudo gout is calcium pyrophosphate. Okay. So when you take the synovial fluid aspiration in pseudo gout, you can see rhomboid shape. These things have been repeated several times. This year also definitely they will ask. Rhomboid shaped crystals, calcium pyrophosphate, it is pseudo gout. Okay. If it is needle shaped crystals, monosodium urate, it is gout. It is gout. You should not forget this. Most common site of gout is great toe, base of the great toe. Okay. Most common site of pseudo gout is knee joint. Both the patient will have swollen, reddened, inflamed joint. Okay. Great toe means gout. Knee joint means pseudo gout. Okay. Calcium pyrophosphate means pseudo gout. Monosodium urate means gout. Rhomboid crystals means pseudo gout. Needle shaped crystals means gout. Okay, that's all. And when you take knee joint X-ray, you can see calcification of the menisci. You can see here when you zoom the app very clearly, you can see this calcification of the menisci. Calcification of the menisci. This is called chondro. This is called chondrocalcinosis of the menisci. Whenever an X-ray, when a question comes like that, the cause is gout. Okay, to some extent we have completed a very what I can maximum speed. Usually I am a sort of what I can say a test player like Rahul Dravid, slow and steady. But today, it's like a T20 session. I hope this will be very useful for you. Any general doubts in orthopedics, you can clarify with me, guys and girls. Hello. Anything? Yes. Yes. Anything you want to clarify? Okay. Management of shoulder, 1 minute. Management of who is asking? 62. Arun Safias asking management of shoulder dislocation. Please, yes. Anterior shoulder dislocation. Many techniques are available like Hippocrates method, Stimson's gravity method. Many methods are there. The method of choice is called Kocher's method. Kocher. Kocher's method. You are giving traction, external rotation, adduction, medial rotation. What are the four things? Traction, external rotation, adduction, medial rotation. So the mnemonic which we use is TEAM, team. Traction, external rotation, adduction, medial rotation. This is called Kocher's method. That is the method of choice for anterior shoulder dislocation. Another thing you have asked a doubt is management and fibrous dysplasia. Bharathi have asked the thing fibrous dysplasia. Okay. Bharathi, fibrous dysplasia. Okay. Fibrous dysplasia is not a true bone tumor. It is an hamartoma. Hamartoma means faulty formation, fibrous dysplasia. What happens? No, the bone, when you take a histopathology, the cortical and cancellous bone is converted like a honeycomb-like appearance. That's called mosaic pattern. This usually can involve any one bone. That is called monoastotic. One single bone is involved. But many times it involves many bones, and that's called polyostotic. Many bones are involved. Polyostotic. Whenever you come across a polyostotic fibrous dysplasia, the question they are asking is McCune-Albright syndrome. That is, polyostotic fibrous dysplasia is associated with Kephale spots and precocious puberty. The combination of polyostotic fibrous dysplasia plus Kephale spots, multiple Kephale spots with precocious puberty. We all know usually puberty should happen around 13 years. When it happens before that, it's called precocious puberty. So this 3 is called McCune, M-C-U-N-E, McCune-Albright syndrome. Okay. So this is the question repeatedly they are asking. The classical deformity is seen in the hip, and the deformity is called Shepherd-Crook deformity. That is called Shepherd-Crook deformity. These are the points they are asking. There is no definitive management for fibrous dysplasia. Ananya, sir, please say anything in Tamil. Okay, ella nalla irunga. Vanakkam. Tamil, excellent. Okay. All of you, ellarum pass aga poringa. Guaranteed all of you are going to pass. Yes. Sir, rheumatoid versus ankylosing, how to differentiate? Rheumatoid versus ankylosing spondylitis, how to differentiate? See, I told you already. Rheumatoid arthritis is common in women. Ankylosing spondylitis is common in men. Rheumatoid arthritis involves only the peripheral joints, especially the small joints, especially the hand joints. Whereas ankylosing spondylitis involves spine mainly. Other joints can be involved. Both are inflammatory arthritis. Rheumatoid arthritis, the HLA is HLA-DRW4. The ankylosing spondylitis, the HLA is HLA-B27. The drug of choice for rheumatoid arthritis nowadays is methotrexate. Drug of choice for ankylosing spondylitis is sulfasalazine. Okay? Yes. Okay. Thank you so much. Guys and girls, what is the first sign, sir? Cupping or fraying? Oh, your question, what is the first sign? Cupping or fraying? Was a very good question, man. Aditya Kumar has asked cupping or the first sign is cupping of metaphysis. Okay. Next sign is playing. Fraying comes very late. Yes, superb. Koch's method traction, excellent. Okay, so thank you so much. Happy Pongal, sir. Happy Pongal, happy Pongal. Excellent. Okay, thank you so much. Okay, so dear guys and girls, in the chat box, it is in open YouTube also. Whenever you have doubt, you can chat with me, no problem. I hope this was a useful session to you. I pray to God very sincerely, to the Almighty, that all my girls and boys should clear FMGE this time with flying colors. All the best. Thank you so much.
Hello my dear doctors, a very good afternoon. This is Dr. Azam here, your faculty of anatomy at PrepLadder, and now we are going to discuss all the very high yield topics in anatomy for your upcoming FMG exam. So now at PrepLadder we are actually doing this 48 hours marathon session where you are going to revise all the subjects. I hope you are revising all your subjects at this last moment just before the exam. And the main intention behind this, अक्सर ऐसा होता है कि मतलब जब रिजल्ट आता है तो रिजल्ट के दिन बहुत सारे स्टूडेंट्स एग्जाम तो क्लियर करते हैं, वी आर हैप्पी फॉर देम, बट एट द सेम टाइम दे लाइक सो मेनी ऑफ द स्टूडेंट्स विल बी लाइक 142 सर, 143 सर, 148 सर, एक मार्क से रह गया. तो एट PrepLadder वी आर एक्चुअली ट्राइंग टू पुश दो स्टूडेंट्स हु आर एक्चुअली स्टक बिटवीन 135 एंड 150. तो इस 48 आवर सेशन में इतने हाई यील्ड टॉपिक्स आपको बताए जाएंगे ताकि वो जो बैरियर है ना, जो 10 से 12 मार्क्स का, 10 से 15 मार्क्स का जो बैरियर है, वो स्टूडेंट्स थोड़े ना 150 के आगे पुश हो जाए. तो ये हमारा मेन इंटेंशन है यहाँ पर, ताकि स्टूडेंट्स को अच्छा रिजल्ट मिले और दे शुड बी हैप्पी. सो विद दिस नोट लेट्स गेट स्टार्टेड माय डियर फ्रेंड्स. Yeah, a very good afternoon to all of you. Yes, welcome everyone. So we are going to discuss Namaskaram, Baguna, Nenkuda Baguna. So in this session already my dear friends, you are done with the main videos. We are also done with the rapid revision. We are also done with the LRR, the last resort revision, and now comes the marathon revision. Okay, so in this one I'm just going to revise the very high yield topic, and yes, the most predicted topics that can be expected in your exam. Fine. So now let's get started with the first topic, that is neuroanatomy. In neuroanatomy, you have to learn about the sections of the brain. So first, let us discuss about the sections of the brain. And remember, your exam paper will not be completed without a section of the brain. So you have to know each and every structure in all the three sections, whether it is coronal, sagittal, or the transverse section of the brain. Let's go ahead with this one here. Now in this coronal section of the brain, first of all, you're able to appreciate here, this is the lateral ventricle and this is another lateral ventricle here. They are located in telencephalon, and both of them are going to open into this third ventricle, which is actually located in diencephalon. The lateral ventricles are connected to the third ventricle with the help of foramen of Monro. Okay. Now above this lateral ventricle here, you'll be able to see bundle of fibers which are going to connect the right and left half of the brain. And this bundle of fibers which are connecting the right and left half, they'll be like commissure, and this is the largest commissure, that is your corpus callosum. So from here we can say that corpus callosum is going to form the roof of the lateral ventricle. Corpus callosum is going to form the roof of the lateral ventricle. Now once you are done with this one, between the two lateral ventricle you are able to appreciate a septum in the middle, and this is nothing but septum pellucidum, which was recently asked in the INICET exam also. The recent INICET exam. And remember, this septum pellucidum here, it is going to form the medial wall of the lateral ventricle. So septum pellucidum is going to form the medial wall of the lateral ventricle. The next comes here, there will be a nucleus, and this nucleus here will be the caudate nucleus. To be more specific, it is the head of the caudate nucleus. Then after that, this one here will be a vein here, and this vein here will be the thalamostriate vein. Followed by that, just beneath that one here will be the thalamus. This one here will be the thalamus. And of course, if this is the septum pellucidum in the middle here, just beneath the septum pellucidum, you will be able to appreciate the most important structure that you have to know for your exam, that is fornix. Now, my dear friends, you imagine my hand here to be like septum pellucidum. Try to learn the things conceptually. Don't try to mug up here. If this is septum pellucidum, on either side you're having lateral ventricle. Now, the lower border of septum pellucidum here, the two fornix will be actually attached. So understand the sequence here. First, you'll be having the corpus callosum connecting both the halves of the brain, and in the middle you'll be having septum pellucidum, and the lower border of that one will be attached to the fornix here. That is a fornix. And then you'll be having the network of capillaries over here, and this network of capillaries here will be the choroid plexus. And all these structures together they are actually going to form the floor of the lateral ventricle. They're going to form the floor of the lateral ventricle. That's all. So by this, we are able to identify all the structures in this coronal section here. Let us just have a quick revision of this one here. What is going to form the roof of the lateral ventricle? That is corpus callosum. What is going to form the medial wall here? Septum pellucidum. And the floor will be formed by caudate nucleus, thalamostriate vein, thalamus, choroid plexus, and the fornix present over here. All these structures together, they are going to form the floor of the lateral ventricle. Now, once you are done with these structures, of course, in your FMGE exam, 2 times this image was given recently. I meant to say in the last 3 years, 2 times this image was given, and they have actually marked the arrow marked over here. Now, can anyone tell me what is this nucleus here? Now, if this here will be the caudate nucleus, then this here will be the thalamus. Remember, this lens-shaped nucleus will be the lentiform nucleus. And we know that the lentiform nucleus is in turn made up of 2 parts, that is putamen and globus pallidus. You also have to remember the location of that one. Remember, the outer part will be actually the putamen here, and the inner part here will be the globus pallidus, which will be in turn having 2 parts, that is globus pallidus externus and internus, my dear friends. You also have to know that one. And recently, once more this image was given, the arrow mark was actually here. Identify this structure in the middle, and this one here will be the internal capsule. This is the internal capsule. So you should be able to identify all the structures in this coronal section. Now, once you are done in the PG exam, this structure was actually arrow marked here. Identify this black colored pigmented structure here. That one will be the substantia nigra. Substantia nigra. So by this, my dear friends, you are done everything in the coronal section. So right now you're almost at the last stage of your preparation, my dear friends. So it's not about like, don't keep on asking about the PDF and all. It's not about the notes, writing or something like that. Have a quick revision along with me right now. The moment I'm telling something, you have to just revise in your mind. Am I able to recall that or not? Am I able to identify or not? So that should be your intention. So keep on doing this exercise along with me right now. So everything in the coronal section is done. Now, one interesting thing, let me tell you here itself that suppose if this is your third ventricle over here, in this diagram itself, you are able to learn 2 boundaries of third ventricle. What is going to form the roof of the third ventricle? It is formed by choroid plexus as well as fornix here. That is going to form the roof of that one. What is going to form the lateral wall here? The lateral wall is formed by thalamus, and below that you'll be able to appreciate the hypothalamus. So you don't have to mug up everything or utilize some mnemonics or something. Try to understand conceptually here itself. If that is your third ventricle, roof is actually formed by choroid plexus and the fornix, whereas the lateral wall will be formed by thalamus as well as the hypothalamus. Here itself we are able to learn. Perfect. Now let us discuss a few more points regarding the fornix. Fornix nowadays is a very important topic for your exams. So let us discuss everything related to fornix right now. Now in this diagram, first of all, there will be hippocampus here, and from the hippocampus follow this red colored line. This one is your fornix going all the way up to the mammillary body here, and from the mammillary body there will be mammillothalamic tract, and that is going to the thalamus. And which nucleus of thalamus? The anterior nucleus of thalamus. So let me just write down here. First of all, you'll be having hippocampus, and from the hippocampus it is connected to the mammillary body via fornix. Extremely important. And from the mammillary body, there will be mammillothalamic tract. There will be mammillothalamic tract, and it is connecting with the anterior nucleus of thalamus. You got to remember the anterior nucleus. Why? Because it has been already asked in your exams previously also. And this one statement is very much important. Many a times the questions has been asked from here in some way or the other. So it is worth repeating. Let us repeat once more here. Hippocampus via fornix to mammillary body via mammillothalamic tract to the anterior nucleus of thalamus. Now I hope all of you have studied about like the white matter. The white matter is actually classified into three categories: association fiber, commissural fiber, and projection fiber. N number of times in my videos I taught you how to learn that, so I think it is not necessary to repeat again. So white matter is again divided into three categories: association, commissural, and projection. Now about the phonics, you have to remember that it belongs to all the three categories. It is belonging to association, commissural, and projection fibers. If all the three are given, answer all the above. Now if you have to select any one best option, remember association will be better than commissure than projection here. So go for association fiber. In one of the exam recently they have asked the combination, then go for the combination of association and commissure. Association and commissure. Why? Because in your Gray's Anatomy they did not include phonics under the projection fiber. So about phonics I have completed every MCQ possible here. Now once you are done with this one, let's go with the next one, that is your basal ganglia. Now in basal ganglia it is made up of all this gray matter, that is your caudate nucleus as well as the lentiform nucleus. Caudate and lentiform together it will be referred to as corpus striatum. And this lentiform is in turn made up of two parts, that is your putamen and globus pallidus. We know that very well. But what I want you to revise just before your exam is the disorders. And they are asking in vice versa. I mean to say ethetosis, then which part of the basal ganglia will be involved, that is globus pallidus. Recently asked in the exam in chorea, which part of the basal ganglia will be involved, that is putamen and caudate. In Parkinson's disease, everyone knows this one, substantia nigra will be involved here, and in hemibalismus, subthalamic nucleus will be involved. So you got to remember which structure of the basal ganglia will be involved in which movement disorder. Okay, na? Then after this, my dear friend, let us go ahead with the sagittal section. In the sagittal section, you are able to appreciate this one here will be the third ventricle. Now, if this one here is your third ventricle, just now I told you what is going to form the roof of the third ventricle. It will be formed by choroid plexus and the fornix. Choroid plexus and the fornix, that is going to form the roof. Anterior wall here, it is actually formed by this commissure, that is your anterior commissure here. And followed by that, there is a lamina here. This one will be known as the lamina terminalis. Now you got to remember 2 points regarding the lamina terminalis here. Remember, this is the structure which comes under the circumventricular organs. What do you mean by circumventricular organs? The organs where you don't have blood-brain barrier. There is no blood-brain barrier. And remember, it's actually the remnant. Lamina terminalis is actually the remnant of the anterior neuropore. I hope you all remember neural tube. In the neural tube, there will be like anterior and the posterior neuropore. The anterior neuropore normally has to close on 25th day, and remember the remnant of that one will be the lamina terminalis. तो ये 2 पॉइंट आपको यहाँ पर याद रखने होंगे. I repeat again, lamina terminalis, there will be no blood-brain barrier, as well as remember that this it is a remnant of anterior neuropore. Yeah, and of course, these two structures together they are going to form the anterior wall of the third ventricle. These two structures are going to form the anterior wall of the third ventricle. Now welcome to the posterior wall. In the posterior wall, first try to identify this gland. If you are coming across this diagram in your exam, now remember this gland here will be the pineal gland. Above the pineal gland there will be one commissure, that is habenular commissure. Below the pineal gland there is one more commissure, that is posterior commissure. And then of course this duct here will be the aqueduct of Sylvius. And all together these structures are going to form the posterior wall of third ventricle. Perfectly done. I repeat again, सबसे पहले आप क्या करोगे? You are going to identify the gland, that is your pineal gland. Above the pineal gland there will be habenular commissure. Below the pineal gland there will be posterior commissure. Then there will be aqueduct. All together they are going to form the posterior wall. Now lastly we left out with the floor. In the floor, this crossing here will be the optic chiasma. Then there will be infundibulum or the pituitary stalk. And then you will be having the mammillary body, and then my dear friend there will be posterior perforated substance here, and then tegmentum part of the midbrain. All these structures together they are going to form the floor of the third ventricle. They are going to form the floor of the third ventricle. So these are the structures that you have to revise before going to the exam. If you know these structures, well and good, you are expert in the sagittal section of the brain. क्योंकि इसके बाद वाले जो structures है ये तो सबको पता होते हैं. You don't have to worry about that one. This one of course will be the midbrain, and this big structure here will be the pons. This one here will be the medulla oblongata. Behind here this is the cerebellum, and yes of course this ventricle will be fourth ventricle. ये तो सबको पता होता है. So whatever structures I told you, please remember that. That is more than enough, guys. Okay. Yes, of course, behind the aqueduct, that structure will be tectum part. Fine. Next one, my dear friends, of course, in your FMG exam, they have given this type of image. I mean to say, after learning the gross anatomy like this here, they are trying to correlate this one with the radiological image. Everyone knows very well the largest commissure here will be the corpus callosum. Just beneath this one here will be the fornix. I told you this crossing here will be optic chiasma. Behind that, this is infundibulum, and this gland here will be the pituitary gland, and this body here will be the mammillary body. Then midbrain, pons, and medulla oblongata. Everyone knows that very well. Fine. Now, why I'm showing you this picture here? Once in your FMG exam, this image was given, and the arrow mark was on this structure. So it's very simple. Pons, answer that one, and you get 1 mark. Perfectly done. So I hope you remember our planning. We are actually learning about the 3 sections of the brain. We are done with coronal section and we are done with the sagittal section. And now moving ahead with the transverse section. Now in transverse section, I want you to please look at this small diagram first of all. In this small diagram, the green colored highlighted part will be the corpus callosum. Corpus callosum has got like 4 parts. This will be the rostrum, then genu and the body and the splenium here. Right in front of the genu, this lobe here will be the frontal lobe. And then behind the splenium, this lobe here will be the occipital lobe. अब exactly हम कहाँ से देख रहे हैं? From exactly where are we looking at this diagram? We are going to take a transverse section, remove the upper part of the brain, and then let's look from above. We are going to take a transverse section, remove the upper part of the brain, and then look from above. हम ऊपर से देख रहे हैं. तो अगर आप ऊपर से देखोगे, when you look from above, okay, you are going to look at the genu here, and then the splenium over here. In front of the genu, this one here will be the frontal lobe, and behind the splenium, this one here will be the occipital lobe. Perfect. Now observe the diagram very carefully. From the genu, you are able to see that the white matter fiber connecting the frontal lobe on either side. This one here will be the forceps minor. Now similarly, from the splenium, this white matter fibers connecting the occipital lobe here, this one will be the forceps major. So from the genu to the frontal lobe, it will be forceps minor, and from the splenium to the occipital lobe, that will be forceps major. Now this one here will be the caudate nucleus, this is thalamus, and then again the lentiform nucleus. Already मैंने आपको बता रखा है, between them, this capsule here will be the internal capsule. Now if this is internal capsule, outside this lentiform nucleus, again you'll be able to appreciate external capsule. If this is your external capsule, observe the diagram more carefully, my dear friend. You'll be able to see here one more sheet of white matter, and this one here will be the extreme capsule. This is extreme capsule here. And between the external capsule and extreme capsule, there will be a thin sheet of gray matter, and that gray matter will be the claustrum. इसको हम claustrum कहते हैं, ठीक है? और जो आपके एग्जाम में पूछा गया था, outside the extreme capsule, this is nothing but insula, the hidden lobe of the cerebrum, that is insula. Perfectly done. तो इस तरीके से if you are able to identify all the structures over here, yes my dear friends, you are ready in your exam with the transverse section. Is it okay? अब हम एक काम करते हैं यहाँ से ना, from this transverse section, let us pick up this much part from here. Let me zoom that. Once you zoom that, you'll be able to appreciate the internal capsule. So internal capsule में मैं आपको बताता हूँ कि कौन से points आपको याद रखने होंगे. Number 1, how many parts do you have in the internal capsule? Remember, they are like totally 5 parts. Come on, I hope you are revising along with me. They are totally 5 parts. आपने भी 5 parts बोला है कि 3 parts बोला है? Remember, internal capsule में totally 5 parts होते हैं. There will be anterior limb, and then there is a bent in the middle genu, and then posterior limb, and then retrolentiform part, and then there will be sublentiform part. Totally 5 parts. Okay. Now this one here will be the caudate nucleus, and this one here will be the thalamus, and then this one here is the lentiform, and in between them, this capsule here will be the internal capsule. I hope you are understanding the diagram first of all. Now once you have understood this diagram, in the internal capsule कुल मिलाकर कितने part होते हैं? 5 parts are there in that one. Now this one here will be the anterior limb, and this bent here will be the genu, and this one here will be the posterior limb, and then below the lentiform, sublentiform, and then behind the lentiform, retrolentiform. Lentiform के नीचे sublentiform, lentiform के पीछे, that is retrolentiform. 5 parts done. Now the most important thing to remember are 2 things, sir. Number one, relations of the internal capsule, and number two, the tracts passing through the internal capsule. Relations I don't even have to tell. My students are intelligent enough to answer right now. अगर ये वाला internal capsule होगा, let me go back to the same diagram again. अगर ये वाला internal capsule होगा, what is there on the lateral side? On the lateral side, you're having lentiform nucleus. Then what is there on the medial side? On the medial side, you'll be having the caudate and the thalamus. Caudate and the thalamus. As simple as that. No need to mug up sir. रट्टा मारने का जरूरत नहीं है, कोई निमोनिक का जरूरत नहीं है, बस ये डायग्राम याद रखिए, ठीक है ना। अगर इंटरनल कैप्सूल होगा, लेटरल साइड में लेंटिफॉर्म न्यूक्लियस होगा और मीडियल साइड में कॉर्डेट और थैलामस होगा। रिलेशंस डन। नेक्स्ट वन विल बी द ट्रैक्ट्स। ट्रैक्ट्स में आपको दो ट्रैक्ट यहां पर याद रखने होंगे कि व्हाट इज द ट्रैक्ट व्हिच इज गोइंग टू पास फ्रॉम द जेन्यू पार्ट। फ्रॉम द जेन्यू पार्ट देयर विल बी कॉर्टिको-न्यूक्लियर ट्रैक्ट. Cortico-nuclear tract is going to pass from the genu part of the internal capsule. And then corticospinal tract. Corticospinal tract कहाँ से पास हो रही है? याद रखिए, of course it is going to pass from the posterior limb. ये तो फर्स्ट ईयर MBBS स्टूडेंट को भी पता है, posterior limb से होता है. But in that posterior limb, please remember anterior two-third. Anterior two-third of posterior limb. ओके, एंटीरियर टू-थर्ड ऑफ द पोस्टीरियर लिम्ब. बस आपको ये दो ट्रैक्ट्स याद रखने होंगे. लेट अस रिपीट दैट वंस मोर हियर. चलिए एक बार दोबारा इंटरनल कैप्सूल कंप्लीट टॉपिक हम रिवाइज करते हैं. हाउ मेनी पार्ट्स आर देयर? 5 पार्ट्स. एंटीरियर लिम्ब, जेन्यू, पोस्टीरियर लिम्ब, सबलेंटिफॉर्म, रेटिकुलरिफॉर्म. देन what are the relations of this one? On the lateral side there will be lentiform nucleus, and on the medial side you'll be having the caudate and the thalamus. Cortico-nuclear tract is passing from genu part and corticospinal tract is passing from anterior two-third of the posterior limb. Perfectly done. Okay. Now my dear friends, in this manner we are done with all the 3 sections of the brain. सारे sections हमने revise कर लिए हैं फटाफट और इसी के साथ में I told you all the concepts related with that one. ठीक है ना, सारे कॉन्सेप्ट भी हमने साथ में रिवाइज कर लिए हैं. अबाउट द फॉर्निक्स, अबाउट द इंटरनल कैप्सूल, अबाउट द बेसल गैंग्लिया, द क्लिनिकल कोरिलेशन ऑफ दैट वन, एवरीथिंग इज डन डन डन. तो इस तरीके से अगर आपको तीनों सेक्शन आपने रिवाइज किए, यू विल बी एबल टू आंसर मेनी क्वेश्चंस इन न्यूरो एनाटॉमी. नाउ मूविंग ऑन टू द नेक्स्ट इंपॉर्टेंट सेगमेंट, यस ऑफ कोर्स अबाउट द ब्रेन स्टेम. याद रखिए, विदाउट अ क्वेश्चन फ्रॉम हियर द एग्जाम पेपर विल नॉट बी कंप्लीटेड. मार्क माय वर्ड्स. On 17 January in the evening time, you are going to tell me which question came from the brainstem topic. Definitely यहाँ से एक सवाल आएगा, तो सुनिए ध्यान से. And now at this moment I don't have to tell you like brainstem is made up of midbrain, pons and medulla. वो तो हम सबको पता है. अब आपको यहाँ पर याद रखना होगा cranial nerves. From the ventral aspect of the brainstem, the cranial nerves are going to begin. That is from 3rd to 12th. 3 to 12, all these cranial nerves are going to begin from the ventral aspect of the brainstem. Now, out of 3 to 12, remember the 3rd oculomotor nerve and the 4th trochlear nerve. These two are going to begin from midbrain. And please remember the 4th nerve very much carefully here. It is the only one which will be having dorsal origin. It's coming from behind. Now, because it is originating dorsally, then taking a turn and coming in front, so of course it will be having the longest course. So 4th nerve is the one which is having the longest course, that too intracranial. Intracranial. And remember, it is also having internal decussation. Internal decussation, sir. Okay. So it is having longest origin and it is having the longest intracranial course. It will be having dorsal origin as well as internal decussation. And please remember, it is the smallest cranial nerve as well as, remember, it will be the thinnest cranial nerve. Now, once you are done with this one here, sir, 150 questions की PDF send कर दो प्लीज. काश आप वहां से प्लीज कहिए और मैं कहूंगा काश. Smallest and thinnest will be the 4th cranial nerve, sir. Done. Now, in this one here will be your 5th cranial nerve, that is your trigeminal nerve. And trigeminal nerve is going to come out from the pons. To be more specific, it is between the pons and middle cerebellar peduncle at the junction of that one. Now this one here will be the 6th nerve and the 7th nerve, and this one here will be the 8th nerve, and these three are going to exit out between the pons and the medulla oblongata. So ponto-medullary junction. Now once you are done with this one, in the medulla oblongata, in the center you will be able to appreciate a sulcus. अगर sulcus होगा, on either side will be having elevation, and this elevation here will be the pyramid, and this one here will be the olive and olive. Now lateral to olive there will be the 9th nerve, and then there will be 10th nerve, and then there will be the 11th nerve. So 9th, 10th and 11th are going to exit lateral to olive, and the 12th nerve is going to come out between the pyramid and olive. Perfectly done. अगर आपने ये रिवाइज कर लिया है तो चलिए थोड़ा सा इसको हम जूम करते हैं. Now in this one, this crossing here will be the optic chiasma. Optic chiasma will continue into this optic tract here, everyone knows very well. And this one here will be the cerebral peduncle. Cerebral peduncle. Please listen to my word very much carefully. I am telling you cerebral peduncle, not cerebellar. I am not telling cerebellar peduncle. I am telling you cerebral peduncle. ठीक है? Now between the two cerebral peduncle, अगर ये cerebral peduncle होगा और ये वाला cerebral peduncle होगा, between the two cerebral peduncles, you'll be able to find a depression here, and this depression will be nothing but fossa, and that will be the interpeduncular fossa. So between the two peduncles, there will be interpeduncular fossa, and you got to remember what are the contents of this one. Now in the contents of interpeduncular fossa, number one, they will be infundibulum. And this infundibulum will be along with tuber cinereum. Just behind this, you'll be able to appreciate the mammillary body and the mammillary body here. And after that, there will be posterior perforated substance here. And finally, there will be cranial nerve number 3, oculomotor nerve. All this will be the contents of interpeduncular fossa. अगर आपको ये सारे structures पता है, then of course, my dear friend, you are ready for questions on ventral aspect of the brainstem. By the way, before moving ahead, can anyone tell me what is the name of the common nucleus of 9, 10, 11? What is the common nucleus of 9, 10, 11? 9, 10th and 11th nerve, the common nucleus will be nucleus ambiguous. Very good. That is nucleus ambiguous will be the common nucleus of this one. ठीक है ना? Medico traveler is asking, sir, cranial nerve number 1 and 2 कहाँ है? तो मेडिको ट्रैवलर आपको पता होना चाहिए कि cranial nerve number 1 is going to begin from your nose and passing through the cribriform plate directly entering into the brain, and cranial nerve number 2, that is your optic nerve, is going to be beginning from your eyeball here. तो ये दोनों यहाँ से होते हैं. तो इन दोनों को छोड़कर बाकी सारे जितने भी cranial nerves होती हैं वो सारी cranial nerves आपकी ब्रेन स्टेम से बिगिन होती है. सो फर्स्ट एंड सेकेंड ब्रेन स्टेम से बिगिन नहीं होती हैं. लर्न कॉन्सेप्चुअली. ओके, तो फर्स्ट वन हियर olfactory and optic will be from here. तो leaving them, remaining all will be from the brain stem. Perfectly done. And ये मैंने आपको क्लियरली बताया है आपके मेन वीडियोस में. अगर आप देखे होंगे तो आपको पता होगा. ओके, आई होप मेडिको ट्रैवलर यू गॉट दिस पॉइंट. चलिए आगे बढ़ते हैं. लेट्स गो अहेड राइट नाउ. वंस यू आर डन विद द वेंट्रल एस्पेक्ट ऑफ द ब्रेन स्टेम हियर, लेट अस टर्न द ब्रेन स्टेम बिहाइंड. लेट्स सी द डॉर्सल एस्पेक्ट बिहाइंड द ब्रेन स्टेम. नाउ बिहाइंड द ब्रेन स्टेम, फर्स्ट ऑफ ऑल लेट अस सी बिहाइंड द मिड ब्रेन. मिड ब्रेन के पीछे होते हैं 4 बॉडीज. देयर विल बी 2 सुपीरियर कॉलिकुलस एंड देयर विल बी 2 इंफीरियर कॉलिकुलस. और कुल मिलाकर यहां पर कितने बॉडीज हो गए हैं? 4 बॉडीज को हम कहते हैं कॉर्पस, तो इसीलिए वर्ड होगा कॉर्पोरा. और कितने होंगे? 4, तो इसीलिए इसका नाम होगा क्वाड्रीजमाइना. वाओ, लुक एट द मीनिंगफुल नेम देयर, कॉर्पोरा क्वाड्रीजमाइना. So corpora quadrigemina, in total we are having like 4 bodies, 2 superior colliculi and 2 inferior colliculi, and they are present behind the midbrain. Superior colliculi, they are actually concerned with vision, okay, and inferior colliculi will come under this auditory pathway. तो superior colliculi yes visual pathway में आते हैं, inferior colliculi auditory pathway में आते हैं. बहुत सारे स्टूडेंट्स यहाँ पर कंफ्यूज होते हैं कि सर हम कैसे याद रखें कौन सा वाला क्या है. बड़ा आसान है, आंखें ऊपर होती है और कान थोड़े से नीचे होते हैं. तो superior colliculi visual and inferior colliculi auditory, no confusion at all. Then after that, can you identify this cranial nerve over here? ये भी सवाल पूछा गया था पीजी एग्जाम में. Can you identify this cranial nerve? मैंने आपको अभी अभी बताया था, out of all the cranial nerves, the only cranial nerve that has got dorsal origin will be the 4th nerve. It has to be the 4th nerve, trochlear nerve. Wonderful. Now after that, welcome to this part here, that is the behind the pons and behind the medulla oblongata here, you are able to appreciate the floor of the 4th ventricle. Now in the floor of the 4th ventricle, you are having 4 elevations here. Now this elevation here will be referred to as facial colliculus. After that, this elevation here will be the vestibular area, and then this triangle here will be the hypoglossal triangle, and this triangle here will be the vagal triangle. Now for your exam, you got to remember what is the reason why it is elevated. So remember, vagal triangle is actually elevated due to vagus nucleus, the 10th nucleus. Hypoglossal triangle will be elevated due to 12th nucleus, that is hypoglossal nucleus. Vestibular area is actually elevated due to the vestibulocochlear nucleus, that is your 8th nucleus. And remember, my dear friends, your examiner is not going to ask you any of this one. You might be thinking why? Study very smartly. Examiner के mindset से पूछिए यहाँ पर, नाम में ही लिखा है, it is already there in the name itself, vagal triangle, it is formed due to vagus nucleus. They will never ask you. Hypoglossal triangle is formed due to hypoglossal nucleus. He will never ask you. Okay, तो आप इस पर अपना time waste मत करिए. Try to learn about the facial colliculus. Remember, the name is facial colliculus, but it is actually formed due to which nucleus? 6th nucleus, that is abducens nucleus. Sir, फिर इसका नाम ऐसा क्यों रखा गया है? Why? Because, yes, of course, even though it is formed by 6th nucleus, remember the 7th nerve is going to take a turn around that one, and because of that reason, the name is given as facial colliculus. So the name is given as facial colliculus. Why? Because facial nerve is going to take a turn around the 6th nucleus, abducens nucleus. Perfectly right. तो आपको ना लाइक बिफोर गोइंग टू द एग्जाम, जो हम लोग अभी क्विकली रिवाइज कर रहे हैं इस मैराथन सेशन में, तो आपको याद रखना होगा सिर्फ और सिर्फ फेशियल कॉलिकुलस, रिमेनिंग ऑल भूल जाइए. अगर ये आएगा, इफ दिस इज even if it is asked in your exam, I believe my students, you will be able to answer that one. आप इसको आंसर कर पाओगे. Don't worry about that one. Okay. Now in this one, are you able to see this bluish pigmented area? Now this bluish pigmented area here will be known as the superior fovea, and that area is actually the locus ceruleus. And please remember, that is going to secrete what? It is going to secrete the dopamine. Now in the fourth ventricle, this is actually the floor of the fourth ventricle. ये जितने भी सारे मैंने आपको एलिवेशन बताए हैं वो सारा फ्लोर होता है. Now what about the roof? In the roof you'll be having the superior medullary velum and inferior medullary velum. There'll be superior and inferior medullary velum, the roof of the fourth ventricle. Now remember, the only one point that you have to remember here is superior medullary velum is actually a nervous structure. It is made up of nerves, and whereas inferior medullary velum will be the non-nervous structure. Superior medullary velum will be the nervous structure. Inferior medullary velum will be the non-nervous structure. Is it okay? Fine. Fine. Okay. Now once you are done with this one here, let's go ahead with the next one. We are done with the ventral aspect of the brainstem as well as dorsal aspect of the brainstem. Now in your exam, once what happened is they have given this radiological image here. अब इस image में आपको यहाँ पर arrow mark, identify which nerve is visible. Of course, if it is your midbrain here, behind the midbrain, fourth nerve will be visible here. But be careful, if the arrow mark is given behind the pons, it will be the 7th nerve which will be visible here, sir. So behind the midbrain it will be 4th nerve, and behind the pons that will be the 7th nerve. 7th nerve, sir. Perfectly done. Please be careful with the arrow mark. ध्यान से देखना कि वो कहाँ पर है, ठीक है ना. अब चलिए आगे बढ़ते हैं. Let us look at the midbrain syndromes and all. Now my dear friends, in this session, like many times in your FMGE exam, they are asking about the syndromes, और बहुत सारे students ना syndrome से confuse होते हैं कि सर इसको कैसे पढ़ें, हम पैथो और मेडिसिन में बड़ा confusion होता है and all. तो let's start from the anatomy part. तो आपके लिए बड़ा आसान हो जाएगा, ठीक है ना. ऑलरेडी ये सारे syndromes मैंने अपने मेन वीडियोस में इन डिटेल पढ़ा रखे हैं, तो अगर आपने वो देखे हैं तो बहुत अच्छी बात है, वरना यहाँ पर हम क्विकली रिवाइज करेंगे, ठीक है. Now once you take a transverse section of the midbrain का अगर आप सेक्शन लोगे तो midbrain कुछ ऐसे होगा. Now in this is the ventral aspect of the midbrain and this is the dorsal aspect. अभी मैंने आपको बताया है कि on the dorsal aspect there will be colliculi. There will be two superior, two inferior colliculi. Now for example, we are taking the section at the level of superior colliculus. Then in the center there will be aqueduct of Sylvius surrounded by the gray matter here. And then my dear friend, remember, because of this aqueduct of Sylvius, that is a landmark, our midbrain is actually divided into like three parts here. This part behind here will be tectum part. This part in the middle here will be tegmentum part, and this part here will be the cerebral peduncle. So tectum, tegmentum and cerebral peduncle. Now because we have cerebral peduncle here on either side, that is why this one here will be the interpeduncular fossa. interpeduncular fossa. Now in the cerebral peduncle there will be gray matter, substantia nigra, and then in front of that there will be white matter, that is crus cerebri. Gray matter here will be the substantia nigra, and this white matter will be the crus cerebri. Now we are taking the section at the level of superior colliculus here, and at the level of superior colliculus you will be able to appreciate the third nerve coming out here. So I told you third and fourth nerve will be coming out from midbrain. So out of that third and fourth, remember, third one will be at the level of superior colliculus. I hope this concept is like crystal clear now. Now once you know about the transverse section of the midbrain, apart from this एक और point जो आपके FMG एग्जाम में पूछा गया था, याद रखिए, यहाँ पर एक न्यूक्लियस होता है रेड कलर वाला, इसको हम कहते हैं रेड न्यूक्लियस. एंड नॉट ओनली दैट, यहाँ से लेमिनिस्काई पास होते हैं. Okay, you'll be able to appreciate all that three lemnisci here. The fourth one, that is your later lemniscus, will not be actually visible over here. I hope this concept is very much clear. Now once you know about this transverse section of the midbrain, this structure is very much clear. Already आपके FMG एग्जाम में यहाँ से रेड न्यूक्लियस पूछा गया था. Already आपके FMG एग्जाम में substantia nigra आपको पूछा गया था. Please remember this one here. Now let us go towards the syndromes here. The first thing here, if this much part is involved here, अगर ये वाला part यहाँ पर involve होगा तो इस syndrome को हम कहेंगे Weber syndrome. This syndrome will be the Weber syndrome. Now please look at the highlighted part. In this highlighted part, are you able to see the third nerve? Yes sir. So third nerve will be involved here. Along with that, I told you this part here will be the crus cerebri. Crus cerebri will be the white matter part. अगर आप इसको तीन part में divide करोगे, in the middle part there will be corticospinal tract passing from here. There is your pyramidal tract will be passing from here sir. That is also involved. तो आपको याद रखना होगा, mainly in Weber syndrome what is going to happen, two things, the third nerve and the corticospinal tract is involved. Whenever third nerve will be involved, I hope you know that very well, third nerve palsy, classical down and out eyeball, down and out eyeball होगा with the loss of those reflexes, ठीक है ना? So you have already studied about that in detail in your ophthalmology. I don't have to repeat the third nerve palsy right now. Now my intention here is that many of the students will be confused between ipsilateral and contralateral. Now my dear friends, remember that whenever you come across the word as nerve, nerve will be actually the lower motor neuron. So it has to be ipsilateral involvement only. इधर वाली थर्ड नर्व यहाँ से दूसरी ओर नहीं जा सकती है. एटलीस्ट इतना तो आप एज ए लेमैन याद रखिए कि थर्ड नर्व अगर कह रहा है तो वो इप्सिलेटरल होगा. रट्टा मत मारिए. Don't try to mug up here, my dear friends. Okay. So therefore, if the third nerve is involved, it will be ipsilateral third nerve palsy. And corticospinal tract, pyramidal tract, हम सबको पता है कहाँ पर क्रॉस होता है, in the lower medulla. Where are we right now? In the midbrain. तो midbrain, pons और medulla, ये तो medulla में क्रॉस होगा. तो इसीलिए क्या होगा? Contralateral hemiplegia होगा. Okay. That will be contralateral hemiplegia. And then, my dear friend, even the upper motor neuron or seventh nerve will be involved. Whenever they will be having the seventh nerve palsy, UMN, of course what is going to happen, it will be contralateral facial paralysis, but only the lower half of the face will be involved. All these things will be happening in the Weber syndrome. Now if this much part will be involved here, then it will lead to what guys? Benedict syndrome. Benedict syndrome में again फिर से कौन सी वाली nerve involve हो रही है? third nerve palsy होगा. Plus just याद रखिए red nucleus involve होता है यहाँ पर. And red nucleus is the one which is going to connect with the basal ganglia. और अगर ये involve होगा, it will lead to contralateral chorea as well as resting tremors. अभी के लिए for now, if you remember this, that is more than enough. Don't go into this lemnisci as of now. If you remember these two features, you will be able to answer the question. So remember the concept here. Third nerve palsy along with the chorea and resting tremors, it will be Benedict syndrome. After that, my dear friend, remember the midbrain is actually connected behind with the cerebellum, and that is connected with the help of superior cerebellar peduncle. And superior cerebellar peduncle is connecting with the cerebellum over there. Of course, cerebellum agar involve hoga, so what is going to happen? Gait ataxia will be there, intentional tremors will be there, and again that will be contralateral. And third nerve, मुझे दोबारा नहीं कहना आपको, there will be ipsilateral third nerve palsy. So ipsilateral third nerve palsy with the contralateral gait ataxia, that syndrome is referred to as North-Nagel syndrome. इसको हम कहते हैं North-Nagel syndrome. Fine. तो चलिए एक बार ना दोबारा क्विकली हम रिवाइज करते हैं. थर्ड नर्व पाल्सी with the contralateral hemiplegia, Weber syndrome. Third nerve palsy with the contralateral chorea, that will be Benedict syndrome. Third nerve palsy with the contralateral gait ataxia, North-Nagel syndrome. इस तरीके से आपको याद रखना होगा तीनों syndromes. Simple हो गया sir. In one page itself we are done with everything. Now one more thing, behind here you'll be able to appreciate the pineal gland. Pineal gland यहाँ पर होगा pinealoma, और जब pinealoma होगा तो obviously it is going to compress the superior colliculi. मैंने आपको already कहा है superior colliculi are concerned with your visual pathway. So therefore there will be impaired vertical gaze. When there will be impaired vertical gaze, it will be leading to the classical sun setting sign. The classical sun setting sign, and then in the pinealoma, that syndrome will be referred to as peri-nod syndrome. इसलिए मैं आपको बार बार कह रहा था, अगर आपने मेरे मेन वीडियोस देखे हैं तो all these syndromes at one place I have concised so that it becomes easier for my student to revise just going before the exam. I hope it is like crystal clear right now. Next one here. After this, let us go ahead with the pons. And from the pons, जैसे मैंने आपको concept अभी बताया था, this is the sixth nucleus and the sixth nerve coming out. And then the seventh nucleus and the seventh nerve is going to take a turn and come out here. And this is the eighth nucleus and the eighth nerve is coming out. And sixth, seventh and eighth, these three will be at the pontomedullary junction. Okay, pontomedullary junction, sir. Now if this much part will be involved here, this syndrome here will be the Millard-Gubler syndrome. Now what all is getting involved here? Of course the sixth nerve, of course the seventh nerve, as well as the corticospinal tract. अगर सिक्स नर्व इन्वॉल्व होगा, मैंने आपको क्या कहा था, अगर नर्व होगा डोंट इवन थिंक इट हैज टू बी इप्सिलेटरल. एंड इफ सिक्स्थ नर्व इज इन्वॉल्व, वी नो very well SO4 LR6 restall by 3 LR lateral rectus is supplied by the sixth nerve. If that is gone, of course it will be leading to convergent squint. Seventh nerve is involved, it will be ipsilateral facial paralysis will be there, and corticospinal tract अगर involve होगा तो hemiplegia होगा, लेकिन contralateral, क्योंकि क्रॉसिंग कहां पर होता है, लोअर मेडुला में होता है. If you see this combination, of course it is Millard-Gubler syndrome. Now if this part of the pons will be involving here, this one here will be the pontocerebellar angle syndrome. Please remember here, it's actually due to acoustic neuroma. That's something important. And then of course the seventh nerve will be involved here. Seventh nerve involved होगा, ipsilateral facial paralysis होगा. Eighth nerve will be involved here, it will be ipsilateral progressive deafness. Immediate नहीं होता है, क्योंकि this will be having the bilateral combination here. That is why it will be progressive deafness will be there. And yes, of course, you'll be having the ataxia also, क्योंकि यहाँ पर cerebellar peduncles भी involve हो रहे हैं. Done? Now, once you are done with this one, welcome to the medulla oblongata. This transverse section was given once in your FMGE exam, and you have to just identify the transverse section of medulla oblongata. Fine. Now, in the medulla oblongata, of course, I'm like, if this part is actually involved here, it is the medial part, and that syndrome will be referred to as medial medullary syndrome. And medial medullary syndrome, remember, it is also referred to as Dejerine syndrome. It is also referred to as Dejerine syndrome. Now, what is getting involved here? The 12th nerve. अगर 12th nerve involved होगा, अब ipsilateral tongue deviation होता है. Hypoglossal nerve is the one which is supplying to all the muscles of tongue, except palatoglossus, वो अपने को पता है. So therefore, there will be ipsilateral tongue deviation. And then medial lemniscus will also be involved here. And medial lemniscus अगर involved होगा, then there will be contralateral loss of touch and conscious proprioception, etc., etc. Because medial lemniscus is the continuation of dorsal column tract. Dorsal column tract, fasciculus, gracilis, and cuneatus will be involved there. And they are going to carry fine touch, vibration, stereognosis, and proprioception. Perfect. And then, of course, the corticospinal tract is also involved here, leading to contralateral hemiplegia. अगर आपको ये वाला combination नजर आएगा, of course it is medial medullary syndrome or Dejerine syndrome. Now welcome to the lateral part. Lateral medullary syndrome. First learn the another name of this one, Wallenberg syndrome. अक्सर आपके एग्जाम्स में पूछा जाता है. यहाँ पर ना बहुत सारे स्ट्रक्चर्स इन्वॉल्व होते हैं, but I want you all to remember right now two things. The 5S. What do I mean by this one here? Trigeminal nucleus. That too sensory wala. Trigeminal nerve in total will be having like 4 nuclei. There will be 3 sensory, 1 motor. 3 sensory, 1 motor. Fine. So out of that 3 sensory and 1 motor, in the medulla oblongata, you are actually having the sensory nucleus here. And that sensory nucleus is nothing but the spinal nucleus here. If that is gone, it will lead to ipsilateral loss of pain and temperature, but that is from the face. Trigeminal nerve, sensory supply to the face. Now spinal lemniscus. Spinal lemniscus is actually the one which is continuing from where? From the lateral spinothalamic tract. And you know very well, lateral spinothalamic tract, LAT. LAT spinothalamic tract is going to carry pain and temperature from the body. So therefore, यहाँ पर हो क्या रहा है? What is happening here? There will be ipsilateral loss of pain and temperature from the face, but contralateral loss of pain and temperature from the body, and this is referred to as crossed hemianesthesia. इसको हम कहते हैं क्रॉस्ड हेमी एनेस्थेशिया. If you see this feature, mark the answer as lateral medullary syndrome or Wallenberg syndrome. That is a classical feature, my dear friend. That is a most important feature, the crossed hemi anesthesia. Fine. Now, once you are done with all the syndromes over here, let's go ahead with the next topic here, my dear friends. I hope you're able to understand the syndromes here. Another next one here will be the Brown-Sequard syndrome. Brown-Sequard syndrome will occur due to the hemi section of the spinal cord. Okay, अगर मान लो कि this is the site of lesion. If this is the site of the lesion here, then what is going to happen? There will be contralateral loss of pain and temperature here, and then there will be ipsilateral loss of fine touch, vibration, proprioception, as well as stereognosis. If you see this combination, yes, of course, it is which one here, sir? The Brown-Sequard syndrome. Yes, it has been asked many a times in your FMGE exam, so please remember that very much carefully here. I'll repeat that again. Contralateral loss of pain and temperature and ipsilateral loss of fine touch, vibration, stereognosis as well as conscious proprioception. I hope ये आपने रिवाइज कर लिया होगा. अब चलिए आगे बढ़ते हैं. Broadband areas. There are so many broadband areas, but the one which I want you to revise just before going to the exam, area number 44 and area number 45. That is Broca's speech area. And area number 22, 39 and 40 here. 22 and then 39 and then 40 here. That will be the Wernicke speech area. Wernicke speech area will be the sensory area and the Broca's speech area will be the motor area. Question number 1, the Broca's and Wernicke, they are connected to each other with which fasciculus? That is arcuate fasciculus. The Broca's and Wernicke, they are connected by which fasciculus, sir? Arcuate fasciculus. Arcuate fasciculus here, sir. Now, Broca's speech area will be the motor. This is the place from where the person is actually able to speak. And Wernicke's speech area is the sensory, where we are actually having the comprehension, understanding. If there is a lesion in Broca's speech area, the person will not be able to speak, but he will be able to understand everything. And there is nothing but Broca's aphasia or the motor aphasia. If the Wernicke is gone, then what will happen? The person will be able to speak, but whatever is speaking does not make any sense, because he is not able to understand anything over there. That is Wernicke aphasia or sensory aphasia. And then what is going to connect them? That is arcuate fasciculus. If that is gone, there will be no conduction. So therefore, that is known as conduction aphasia. If all the three are gone, then it is nothing but your global aphasia. Please remember this, guys. If you are not able to revise all the broadband areas at the end, lack of time and all, at least recall these broadband areas. That is very much important. Next one, how can we forget this topic here? Cerebellar cortex. In cerebellar cortex, there are actually three layers, the molecular layer, then the Purkinje layer, and then you'll be having the granular layer. In the molecular layer, you're having two types of cells, that is stellate cell and basket cell. Purkinje layer, you'll be having Purkinje cell. In granular layer, you'll be having granular cells as well as the Golgi cells. There are like 5 different types of cells. Remember, all these cells are actually inhibitory, except for the granular. Granular cells are actually excitatory. That is the thing you have to remember. And yes, of course, in your exam, they will be giving this image always in your exam. And always your examiner will be marking at this cells only, the Purkinje cell, and identify that one. I hope you'll be able to identify. This one will be like largest of all the cells, and they are flask shaped. Largest, and they are like flask shaped. So, okay. Next one, the deep nuclei of the cerebellum. We remember with the mnemonic as doctors ate good food. D for dentate nucleus, E for emboliform, G for globose, and F for fastigial. Doctors ate good food. Which is the medial most one? Fastigial. Which is the lateral most one? Dentate. And that is the largest one. And you can clearly see the shape of this one will be like crumpled paper bag. Sometimes what will happen, the globose and emboliform are combined together, and together it is referred to as interpositus nucleus. Interpositus nucleus. Perfectly done. Now, my dear friends, in this manner, we have revised all the topics of neuroanatomy that are required to be revised just before going to the exam. I hope all of you are happy with this one. सब कुछ रिवाइज हो गया अपने माइंड में? These are like must know topics, my dear friends. Yes, sir. Thank you. Let's go ahead with the next topic, that is head and neck topic here, sir. In head and neck topic, you should be able to identify which nerves are going to pass from which cranial foramina. Thank you everyone. I hope it's like quickly revising everything like fresh in your mind. So it's almost like 13 January right now. Another 3 days, 14, 15, 16, and then on 17th you'll be able to actually put everything on the paper there, है ना? Yes. अब तो कैसे भी हमारा एग्जाम डेफिनेटली क्लियर होगा ही. Sir, will you be covering most of the anatomy in the session quickly or selectively? Wow. That's a nice question. Let me try my best. Now, we have to remember about the, all the cranial foramens and what are the structures passing from here. Cribriform plate, yahan se jayega cranial nerve number 1, that is your olfactory nerve. Optic canal, yahan se hoga optic nerve, sir. Okay, now, optic canal, yahan se pass hoga optic nerve, cranial nerve number 2. Okay, now. And then the most important one, there will be a superior orbital fissure. Between the lesser wing and the greater wing of the sphenoid bone, there will be superior orbital fissure. Now from the superior orbital fissure, there will be cranial nerve number 3, the cranial nerve number 4 and the cranial nerve number 6 passing from here. लेकिन यहाँ पर याद रखिए, this one here will be 3 here and the one which is coming from behind and entering here will be the 4th one here. और जब भी आपको इस डायग्राम में कोई नर्व नजर आए which is climbing up that slope, उस स्लोप से जो ऊपर आ रही है वो होगी आपकी 6th nerve. Try to identify this very clearly. I repeat again, this one here will be your 3rd nerve and the 4th nerve is actually taking a dorsal origin and coming from behind. And remember, if you find any nerve climbing up from the slope there, that has to be your 6th nerve. So 3, 4 and 6 are going to pass through the superior orbital fissure. Of course, along with the 5-1. Okay, so this one here will be your trigeminal nerve, that is your 5th one. So out of that, 5-1 is actually passing through the superior orbital fissure. 5-2 will be passing from foramen rotundum and 5-3 is going to pass from ovale. And who don't remember about that one? आप सबको याद होगा foramen ovale आपके एग्जाम्स के लिए बहुत इंपॉर्टेंट है और यहाँ से जो स्ट्रक्चर पास होते हैं mnemonic will be like male. M for mandibular nerve, A stands for accessory meningeal artery, L stands for lesser petrosal nerve and E stands for the emissary veins. Is it okay? Next one, sir. After that, this is the internal acoustic meatus. यहाँ से pass होगा from here the 6th, internal acoustic meatus, the 7th and 8th nerve is going to pass from here. And then this one here will be the jugular foramen, the 9th, 10th and 11th nerve is going to pass from here. And hypoglossal canal, there will be 12th nerve passing from here. So you got to remember the cranial foramen and the structures passing from them. Now out of the cranial foramen, remember superior orbital fissure is very much important. I told you that the cranial nerve number 3, cranial nerve number 4, cranial nerve number 6 as well as 5-1 is going to pass from here. But remember the branches of 5-1 are going to pass. Now what are the 3 branches of the 5-1? The frontal nerve, the lacrimal nerve as well as the nasociliary nerve. These 3 are the branches of 5-1. Along with all these nerves, even the ophthalmic veins are also going to pass from the superior orbital fissure. Okay. But your examiner is actually asking, near the superior orbital fissure, there will be a tendinous ring of Zinn. So what are the structures which are going to pass inside the ring and outside the ring? So please remember, left is left outside the ring. Now what is left here? L for lacrimal nerve, F for frontal nerve, and T stands for the trochlear nerve. So please remember LFT, left is left outside the ring. Left is left outside the ring, sir. LFT. So L for lacrimal, F for frontal and then T stands for trochlear nerve. And even the ophthalmic veins are also present outside only, sir. खत्म. तो जो मैंने यहाँ पर हाईलाइट किया है वो रिंग के बाहर होंगे, बाकी सारे स्ट्रक्चर्स रिंग के अंदर से पास होंगे. जुगुलार फोरामेन अक्सर आपके एग्जाम्स में दिया जाता है. I told you the 9th nerve and 10th nerve and 11th nerve is passing from here along with inferior petrosal sinus and sigmoid sinus, and all of them will be arranged in the same order. In this, one more important point to note down here is, out of the 3 nerves which is present in a separate sheath here, that is your 9th nerve, 10th and 11th are present in one sheath only and together they are going to form VAC, that is vago accessory complex form करते हैं. तो इस तरीके से याद रख लीजिए कि 9th nerve will be actually present in a separate sheath here. Next one, how can we forget this concept here? Pterion. ये तो hot favorite question FMGE exam में, pterion sir. Pterion is formed between 4 bones, that is your frontal bone, the parietal bone, the squamous part of the temporal bone and the greater wing of the sphenoid. Now what are the structures present just deep to pterion? Number 1, there will be the middle meningeal artery. Now, which division of the middle meningeal artery? याद रखिए, it is the anterior or frontal division of the middle meningeal artery. Along with that, even the middle cerebral vessels are also present deep to pterion. The sylvian fissure. मान लो यहाँ पर आपका brain है, and in the brain this is the frontal lobe here, this is the temporal lobe here. Between them there is a sulcus, and this sulcus is referred to as sylvian fissure or the lateral sulcus. ये भी यहीं पर होता है, and even inside that there will be lesser wing of the sphenoid. Please don't get confused here. Pterion is actually formed by the greater wing of the sphenoid, but inside that there will be lesser wing of the sphenoid. Recently आपके FMG एग्जाम में सवाल दिया गया था, if there is a hit or trauma at this pterion, then what is going to happen? Just inside the pterion there is, yes, middle meningeal artery, and if this artery is ruptured, it will lead to epidural hemorrhage. So if there is an injury at this pterion, if there is a hit at the pterion, remember, of course it will lead to epidural hemorrhage. परफेक्टली डन सर, ये बहुत इंपॉर्टेंट है. और जब एपिड्यूरल हैमरेज की बात आती है तो आप सबको पता है, ऑब्वियसली द हैमरेज विल बी लाइक दैट इडली शेप, यू नो, और बाई कॉन्वेक्स शेप एंड ऑल. एंड प्लीज डोंट फॉरगेट अबाउट द ल्यूसिड इंटरवल, देयर विल बी ल्यूसिड इंटरवल. तो अगर आपको ये पॉइंट्स याद है, यू विल बी एबल टू आंसर एनी क्वेश्चन ओवर हियर. Muscles of mastication. In total, you're having 4 muscles of mastication. Number 1, this one here will be masseter. This one here will be temporalis. And this one here will be the lateral pterygoid. And this one here will be medial pterygoid. First, you should be able to identify all the 4 muscles of mastication. After identifying, let me tell you the 5 points here. And from these 5 points, the questions will come in your exam. Point number 1. What is the nerve supply to all the muscles of mastication? Remember, all of them are supplied by mandibular nerve. That is your 5-3. Now, in that mandibular nerve also, I taught you already in the main videos, mandibular nerve will be having a trunk. And the trunk is supplying to medial pterygoid. And remaining all the muscles of mastication are supplied by the anterior division. Okay? Opening of the jaw is actually done by lateral pterygoid muscle. I told you this one, how to remember. Please don't get confused between lateral and medial pterygoid. Remember L for lateral pterygoid and remember L for lowering the jaw. L for lateral pterygoid and for lowering the jaw. So opening the jaw is done by lateral pterygoid. Remaining all the 3 muscles are helping in closing the jaw, elevation of the mandible. Retraction of the mandible is done by temporalis. Remaining all the 3 will be helping in protraction. Most commonly involved in trismus. Trismus, lockjaw. Lockjaw, the person is not able to speak. Mute. Mute, remember M for mute, remember M for medial pterygoid muscle. Okay, तो इसीलिए मैंने आपको ये कहा है, normally I don't give mnemonics and all, but जहाँ required है वहीं पर थोड़ा सा, अक्सर मैंने देखा है students are getting confused between lateral pterygoid and medial pterygoid. तो remember, lowering the jaw, lateral pterygoid, mute, trismus, lockjaw, mute, remember medial pterygoid. Now, accessory muscle of mastication here will be buccinator. The buccinator muscle will be the accessory muscle of mastication. If you remember these points, my dear friend, you will be able to answer any question related to the muscles of mastication. Now, moving ahead with the tongue topic, another very important topic for your FMG exam. In the tongue topic, when you learn about the muscles, please don't worry about the intrinsic muscle. They will never ask you. Extrinsic muscles are important, sir. और इसको याद रखने का तरीका होता है बड़ा आसान, आगे, पीछे, ऊपर और नीचे, ठीक है ना? आगे, this muscle here will be genioglossus. पीछे, this one will be the styloglossus. ऊपर, from the palate, that is palatoglossus. And नीचे, from the hyoid bone, it is hyoglossus. Genioglossus, styloglossus, palatoglossus and hyoglossus. 3 सवाल आपको यहाँ पर याद रखने होंगे. Which is the largest muscle of tongue? That will be genioglossus. And which is the safety muscle of the tongue? That is also genioglossus. Why? Because genioglossus is helping in protrusion of this one and will be preventing the tongue from falling back. So therefore, it is actually the safety muscle of the tongue. And which is not a true muscle of the tongue? Not a true muscle of tongue will be the palatoglossus. नाम में ही लिखा है, it's actually the muscle of the palate also, muscle of the tongue also, palatoglossus. Now, what is the nerve supply to all the muscles of tongue? All the muscles of tongue will be supplied by 12th nerve except for palatoglossus. And palatoglossus will be supplied by vago-accessory complex, VAC. That is the reason why whenever you have to test the 12th nerve, you will ask the person to protrude the tongue. अगर मान लो the tongue is not getting protruded straight, it is deviating, समझ लो कि 12th nerve is gone. But which one, sir? Ipsilateral or contralateral? For 12th nerve, remember it will be ipsilateral. If the tongue is deviating towards the left, that means left 12th nerve is actually gone. Perfectly done, sir. Is it okay? Next concept here. Now in this, like, marathon session, still even though it's like marathon session here, I have included this topic here. I'm telling you sir, somehow that intuition जो कहते हैं ना, ये आ रहा है कि मतलब इस एग्जाम में on 17 January there'll be a question from this slide sir, पक्का. On this slide you are able to see your mandibular nerve, that is your 5-3 mandibular nerve. Mandibular nerve के ना दो डिवीजन होते हैं, एक होता है anterior, दूसरा होता है posterior division. One is anterior division, another one is posterior division. Don't worry about the anterior division right now. It will be supplying to the muscles of mastication. Anterior division is supplying to muscles of mastication. Don't worry about that right now. Now please worry about the posterior division. Posterior division will actually give rise to 3 branches, and those 3 branches we are going to remember as Ali branches. A-L-I. A-L-I sir. Ali branches. And A stands for auriculotemporal nerve. ATN. And that auriculotemporal nerve, नाम से ही याद रख सकते हो आप कि this auriculotemporal nerve is going back here, supplying to the skin over the auricle. Listen to me with 200% concentration here. Supplying to the skin over the auricle here, upper 2/3, and even the temporal region here, auriculotemporal. It will be supplying to the joint here, temporomandibular joint, as well as the parotid gland. How can you forget that one? Auriculotemporal nerve is supplying to which gland here? Parotid gland here. तो ऐसे याद रख लो, easily याद हो जाएगा. Then L stands here for the lingual nerve sir. Lingual nerve, remember first of all, this is the lingual nerve here. It is passing through this ganglion, and that ganglion will be submandibular ganglion. And lingual nerve हम सबको function अच्छे से पता है कि it is going to carry general sensation from anterior 2/3 of the tongue. General sensation from anterior 2/3 of the tongue, and it is passing through which ganglion? Submandibular ganglion. Submandibular ganglion. Is it okay? So remember, it is going to pass through which ganglion? Submandibular ganglion. अब यहाँ पर important point here is that if you are going to appreciate here, there will be a salivary gland. Which salivary gland? Submandibular. Submandibular gland. And submandibular gland has a duct, and that duct is going to, yes, take a turn around the lingual nerve. Try to understand the anatomy here. Submandibular gland, the duct of that is going to take a turn around the lingual nerve. So therefore, always in your exam, they'll be giving a clinical question. They'll make some story, some or the other story. The person was consuming that gutka and all something. We had to do submandibular gland resection. Now, when you have to remove that submandibular gland from there, the most common nerve that will be injured, lingual nerve. The most common nerve to be injured, lingual nerve. Clear with this one here? तो lingual nerve के साथ में आपको ये concept याद रखने होंगे. Now I stands for inferior alveolar nerve. ये तो इसके नाम में ही लिखा है. It is there in the name itself. Inferior alveolar, alveolar jaw, lower jaw. Which jaw here? Lower jaw. Lower jaw nothing but your mandible. Acha, that means inferior alveolar nerve will be entering into the lower jaw, that is mandible, via which foramen? Mandibular foramen. ये सवाल आपको पूछा जाएगा. So Ali branches. Remember, posterior division will give rise to Ali branches, and all the 3 branches has the questions associated with that one, जो मैंने आपको बता दिया है. And from here, definitely one question will come in your exam, sir. Okay, now definitely one question will come in your exam. Next concept. Nowadays, this is like very commonly given in the exam. That is your facial nerve and its palsy. Facial nerve palsy. UMN, LMN. LMN palsy जब होती है सर, LMN नथिंग बट द आपके FMGE एग्जाम में ना ये वर्ड भी यूज किया गया था. ये न्यूक्लियस के ऊपर वाला जो होता है UMN होता है. Okay, upper motor neuron, and because it is above the nucleus, that is supranuclear. And some students got confused here. Sir, we always have learned about UMN, LMN. Suddenly, what is this supranuclear, infranuclear? Yes, of course. Makes sense. जो nerve fibers nucleus के पहले होते हैं उनको हम कहते हैं UMN. बाद में जो होते हैं उसको हम कहते हैं LMN. Fine. Now, whenever there will be the LMN lesion, lower motor neuron lesion, both the neurons are gone, which are supplying to the lower half of the face as well as upper half. So complete half of the face will be gone, sir. So if there is a paralysis of complete half of the face, then of course it will be the lower motor neuron lesion. In upper motor neuron lesion, what is going to happen? Only the lower half of the face will be gone, sir. Only the lower half of the face, not the upper half. Upper half will be actually spared. Okay. The problem here is that in your exams, they will not give you so beautifully lower half of the face or upper half of the face. कैसे दिया जाएगा? Lower half of the face, if these bulbs are gone, then what will happen? There will be drooping of angle of the mouth. If the angle of the mouth is drooping, saliva will be dribbling from here. and then because these muscles are not working here, the food will be stuck here. जो recently exam में दिया गया था, food is stuck in the cheek here. Is it okay? So this is indicating that, okay, lower half of the face is actually paralyzed. I repeat the 3 points again: drooping of the angle of the mouth, dribbling of saliva, and then stucking of the food here. Done. And then what about upper half of the face? Yes, the person will not be able to raise the eyebrows. There'll be no horizontal wrinkles on the forehead. Raising the eyebrows will be gone. No horizontal wrinkles on the forehead. अगर ये दिया गया है, that means upper half of the face is gone, sir. Your examiner is trying to tell you that upper half of the face is actually gone. Are you understanding me here? So please remember the UMN LMN lesion of the facial nerve बहुत important है. ये सवाल भी आपके एग्जाम में recently आ सकता है. Now the next one here will be the great auricular nerve. First you should be able to identify in this diagram. This nerve here will be the great auricular nerve here, sir. This one. So this one here will be the great auricular nerve. Great auricular nerve, sir. ठीक है ना? Now the point number 1, the great auricular nerve is going to run along with external jugular vein. External jugular vein यहीं पर होता है और ये इसके साथ में होती है. ठीक है? Point number 2 that you have to remember, it is supplying to what? That is something important. Remember, the great auricular nerve is supplying to, okay, number 1, the skin over the angle of the mandible here, and number 2, the lobule of the auricle. अभी मैंने कहा था upper 2/3 of the auricle is supplied by auriculotemporal nerve, lower 1/3 is taken care by great auricular nerve. Okay, I repeat again, the skin over the angle of the mandible and the lobule of the ear is supplied by great auricular nerve. After that, yes, suppose if you're going to do parotidectomy जब करते हो तो क्या होता है? Sometimes what is going to happen, this great auricular nerve is also gone. Then one fine day the person was shaving. So while shaving he is not able to sense anything. Loss of sensation in the shaving area. Which nerve is involved? Great auricular nerve. And then after that, the last and final point to remember here is about the Frey syndrome. In Frey syndrome, normally the nerve that is injured will be auriculotemporal nerve, which is supplying to your parotid gland. वो injure हो जाती है. But while regenerating, that auriculotemporal nerve will be going and joining with the great auricular nerve. So that is why whenever the person is eating the food, while eating the food, this area will become red and they'll be sweating from here. And that is nothing but Frey syndrome. Frey syndrome, sir. Perfect. So we are done with everything here. Now, in your FMGE exam, they're also asking about the Zenker's diverticulum. But the main thing is that you have to remember is it is present between which two muscles here. अगर आप इसको ध्यान से देखोगे, यहाँ पर thyroid cartilage है. Now from the thyroid cartilage, there is a muscle going and getting attached to the pharyngeal raphe. This one here will be the thyropharyngeus muscle. And then from cricoid cartilage also there is a muscle getting attached to the pharyngeal raphe, cricopharyngeus. And these two muscles together, they are going to form the inferior constrictor. The inferior constrictor is made up of two muscles. One is thyropharyngeus, another one is cricopharyngeus. इन दोनों के दरमियान में यहाँ पर एक weak area होता है, and that weak area is referred to as Killian's dehiscence. And in the elderly people, suppose they are exerting more pressure, like they're coughing and all, the wall of the pharynx will become very much weak, and there will be a diverticulum, and this diverticulum will be known as Zenker's diverticulum. Zenker's diverticulum. So it is present between which two muscles? That is my intention here to teach you in anatomy. It is present between thyropharyngeus and the cricopharyngeus. Moving on to the next one. Nowadays, hot favorite, sir. Yes, on 17 January, you can expect a question based on tonsillar bed. 17 January, tonsillar bed से सवाल आ सकता है. Nowadays, they are repeating this one in almost every exam. Is it okay? So please revise this carefully here. In this diagram, you are able to appreciate the tonsil here and what is going to form the tonsillar bed. इसको पढ़ने का तरीका जैसे मैं सिखा रहा हूँ वैसे सीखते जाइए. Please learn in the same manner. Now, first of all, you are able to appreciate a muscle here, and this muscle here will be the superior constrictor. In fact, you have superior constrictor muscle here, and the tonsil is located inside that one. It's something like that, okay ना? अगर यहाँ मसल होगा तो मसल के अंदर एक फेशिया होगा और मसल के बाहर एक फेशिया होगा. There is a fascia inside and there is a fascia outside. So inside that fascia will be the pharyngobasilar fascia. Outside that will be the buccopharyngeal fascia. So there will be superior constrictor. Inside there will be pharyngobasilar fascia. Outside will be having the buccopharyngeal fascia. Now once you are done with this one, of course the tonsil is covered by a capsule here. There is a capsule. And then between the capsule and this muscle, Remember like this, there is a capsule in the muscle, here there is a space, and that one will be the paratonsillar space, and that space will be having a vein here, and this vein will be the paratonsillar vein. What is a vein? That is your paratonsillar vein. That is a vein from where the bleeding will occur post tonsillectomy. Post tonsillectomy, the bleeding that is going to occur is actually from the paratonsillar vein. तो इसको पढ़ने का तरीका आपको उसको आसान कर लीजिए सर. डोंट ट्राई टू मगअप. मेनी ऑफ द स्टूडेंट्स आर राइटिंग द टॉन्सिलर बेड 1 2 3 स्ट्रक्चर्स और उसको सीक्वेंस में मगअप करना, मेकिंग सम निमोनिक एंड ऑल. नथिंग. मसल है, टॉन्सिल है, मसल होगा तो दोनों फेशिया होगा. दैट्स ऑल. देयर इज अ स्पेस बिटवीन देम, पैराटॉन्सिलर स्पेस, और वहां पर वेन होती है, पैराटॉन्सिलर वेन. दैट्स ऑल. मेक सेंस. ओके, एंड दैट इज गोइंग टू फॉर्म योर टॉन्सिलर बेड. Next one, sir. Yes, another very important question and a repeat question in your exams, that is a pyriform fossa. Pyriform fossa को हम ना fishbone area भी कहते हैं और या फिर smuggler's pouch भी कहते हैं. Now, what are the boundaries of this one here? On the medial side, first of all, here you will be able to appreciate the pyriform fossa here. On the medial side, you are able to see the airy epiglottic fold, and on the lateral side, there is a mucosa on the thyroid cartilage. Boundaries तो simple है, they will never ask you, but the most important thing is this one here. Remember, it is located on either side of the laryngeal cavity, fine, but what is a nerve? Internal laryngeal nerve runs superficially. Internal laryngeal nerve, ये आपको याद रखना होगा. Yes, that nerve will be running superficially over there, and in that fishbone area, they'll be asking you this question only. That is about the internal laryngeal nerves. Clear? Done. So I have revised all the concepts in head and neck topic, my dear friends, and on to that we have even updated the concepts here, which concepts are actually trending nowadays and which one you have to revise just before going to the exam. Okay, so tonsillar bed अच्छे से याद रखिए, mandibular nerve सवाल आते हैं, UMN and LMN lesion of the facial nerve वहाँ से सवाल आते हैं, तो please remember these concepts very well. Perfectly done, sir. Now let us go ahead with the limbs, upper limb and the lower limb. And in the upper limb, remember you have to revise those 3 nerves. Perfectly going. Thank you. Thank you. Thank you. In the upper limb, you actually have to revise those 3 nerves. That is your ulnar nerve, median nerve, and the radial nerve. I am going to show you all these 3 nerves in 3 slides here, one by one. And definitely one question is going to come from these 3 slides here, sir. So welcome to the first slide, ulnar nerve. Ulnar nerve कहाँ से originate होता है? We know very well. From the medial cord of the brachial plexus. Mnemonic for that is M4U. So ulnar nerve is going to begin from medial cord. Root value of that one will be the C7, C8 and T1. है ना? So ulnar nerve is going to originate from the medial cord, and then remember the root value will be C7, C8 and T1. ये भी आपके एग्जाम में पूछा गया था. Now first of all, ulnar nerve is actually going to pass through the arm. Now after passing from the arm, it is going to enter into the forearm by passing behind the medial epicondyle. And this question has been asked like repeatedly in your FMGE exam many times. Behind the medial epicondyle, which nerve is passing from here? That is ulnar nerve. And after passing from there, it is going to enter into the forearm. But before entering into the forearm, now will ulnar nerve supply to any muscle in the arm? Remember, in the arm, it is not supplying to any muscle. There is no supply in the arm. Why? Because we know our golden rule very well. In the arm, all the muscles in the anterior compartment of the arm will be taken care by musculocutaneous nerve. All the muscles in posterior compartment of the arm will be supplied by radial nerve. So musculocutaneous here and the radial nerve over here. So ulnar nerve is not supplying to any muscles in the arm. Neat and clear. Then after that, the ulnar nerve is going to enter into the forearm. How it is entering? It is going to enter the forearm between the 2 heads of flexor carpi ulnaris. Now why I am stressing here? Why? Because between the 2 heads of flexor carpi ulnaris, you will be able to appreciate a tunnel, and that tunnel will be the cubital tunnel. Be careful, it is not carpal, it is cubital tunnel. It is not carpal tunnel, it is actually cubital tunnel. And sometimes the ulnar nerve is getting compressed there. And yes, my dear friend, that syndrome will be referred to as cubital tunnel syndrome. Now, after entering into the forearm here, yes, what is the supply? Remember, in the forearm, ulnar nerve will be supplying to medial 1.5 muscles. Of which compartment? Of course, the anterior compartment. It is supplying to 1.5 muscle of anterior compartment. What is the name of that one muscle? Flexor carpi ulnaris. and half it is supplying to FDP, flexor digitorum profundus, medial half of that one. I hope all my students are able to quickly recall. We have learned in detail, word by word, meaning by meaning in our classes, in our videos. We have learned them in detail. तो अभी है quickly आपको revise करना है. So in the anterior compartment, medial 1.5 muscle, one muscle will be the flexor carpi ulnaris and the medial half of FDP, flexor digitorum profundus. And then my dear friend, from the forearm, now the ulnar nerve is going to enter into the hand. And here, यहाँ पर आपको 2 पॉइंट याद रखने होंगे. Is it going superficial or deep to flexor retinaculum? Remember, ulnar ऊपर, ulnar ऊपर. तो ulnar nerve कहाँ से पास होगी? It is going to pass superficial to flexor retinaculum. ठीक है जी, it is going to pass superficial to flexor retinaculum, and there also it is going to pass through a canal, and that canal will be the Guyon's canal. ये भी सवाल आपके FMG एग्जाम में पूछा गया था. Now after entering into the hand here, what is going to happen? It is dividing into superficial branch and the deep branch. Superficial branch is supplying to only and only one muscle, that is palmaris brevis muscle, which belongs to hypothenar group. And not only that, it is also supplying to the skin of medial 1.5 digit. The little finger and half of the ring finger is taken care by ulnar nerve. And then the deep branch is actually supplying to remaining all the muscles. It will be supplying to hypothenar muscles, third and fourth lumbrical, all the interossei, 4 palmar and 4 dorsal interossei. Then the ulnar nerve is going on the other side and finally ending in adductor pollicis. And because it is going and ending in adductor pollicis, that is why that one will be referred to as the graveyard of ulnar nerve. Adductor pollicis will be referred to as graveyard of ulnar nerve. So this is about the supply of ulnar nerve in the hand. Done. Now once you are done with this one, number 1, adductor pollicis को test करना होगा और इसके लिए होता है book test. Now suppose if someone is giving me a book here, I am going to hold the book in this manner. So therefore I am going to adduct my thumb. So this first diagram here, it's actually normal. अगर मान लो, for example, my ulnar nerve is gone, then adductor pollicis is gone. I am not able to adduct, but still I want to hold the book. How will I hold the book here? By using the flexor pollicis longus. So therefore my thumb will be flexed. If you see that there is a bent in the thumb here, समझ जाओ कि वहाँ पर ulnar nerve is gone. So therefore if the thumb is bent there, and that sign will be referred to as Froment sign. Froment sign will be positive. ये भी सवाल आपके एग्जाम में पूछा गया था. So basically the book test is actually done for ulnar nerve, for testing which muscle? Adductor pollicis muscle. Now similarly, palmar interossei will be helping in adduction of the fingers. Palmar interossei will be helping in adduction of the fingers, and dorsal interossei will be helping in abduction of the fingers. Adduction of the fingers, give a card in the middle. If the person is able to hold the card, adduction perfect, interossei perfect, ulnar nerve perfect. So even card test is also done for ulnar nerve only. Now similarly, dorsal interossei will be helping in abduction of the fingers. So therefore for that we have Egawa test. Ask the person to keep the hand on the surface here and then move the middle finger on either side. If he is able to move that, yes, of course the dorsal interossei are perfectly working. That means Egawa test is also done for ulnar nerve. Everything about the ulnar nerve has been revised, and those simple question वो तो आपको already पता है. If the ulnar nerve is injured here near the wrist, अगर मान लो कि ulnar nerve यहाँ पर इंजूर हुआ है near the wrist, all these 15 muscles supplied in the hand will be gone and the hand will become like this here. Is it a claw hand? Yes, of course. Complete or partial? Partial claw hand. What is the nerve involved in partial claw hand? Ulnar nerve. अगर मान लो even median nerve is also gone, the remaining 5 muscles will also be gone there. So therefore the hand will become complete claw hand. Complete claw hand, the nerve involved will be ulnar and median nerve. ये तो आपको अच्छे से पता है. I repeat again, partial claw hand only ulnar nerve, complete claw hand both ulnar nerve as well as median nerve will be involved. Okay, so everything about the ulnar nerve has been revised. You can expect one question from this slide here. Now moving on to the next one, median nerve. Again the same thing. Will median nerve supply to any muscles in the arm? Absolutely no. It is not going to supply to any muscle in the arm. Our golden rule, anterior compartment musculocutaneous nerve, posterior compartment radial nerve. तो median nerve यहाँ पर supply नहीं करेगा. अब चलिए कहानी को आगे बढ़ाते हैं. Now this median nerve is going to enter into the forearm. How? It is going to pass between the two heads of pronator teres muscle. So this one here will be the pronator teres muscle. So median nerve is going to pass between the two heads of pronator teres muscle. Sometimes the median nerve is getting compressed over there, and that syndrome will be referred to as pronator teres syndrome. Done. Now in the forearm, Of course, it will be supplying to all the muscles in the anterior compartment except that medial 1.5. And my student knows very well that medial 1.5 muscle is taken care by ulnar nerve. So in the forearm, it is supplying to all the muscles in anterior compartment except that medial 1.5. But one interesting point here is median nerve will give rise to a branch, and that branch here will be AIN, that is anterior interosseous nerve. It is between the two bones here. That is why the name of the nerve will be interosseous nerve, and it is in the anterior compartment, anterior interosseous nerve, sir. Anterior interosseous nerve, guys. Okay, now the interesting point here is that in the anterior compartment, whatever muscles you have, all those muscles will be divided into two layers, superficial layer and the deeper layer. So remember, the superficial layer is actually supplied by the median nerve itself. The median nerve itself is supplying to the superficial flexors, whereas the deeper layer will be actually taken care by AIN, anterior interosseous nerve. That is something really important. After that, the next landmark is it is going to enter into the hand. How it is entering into the hand? By going deep to the flexor retinaculum. Yaad rakho, median nerve is going deep to flexor retinaculum. It is going through the carpal tunnel. It is going through the carpal tunnel. Fine. And after that, it is again going to divide into two branches there. And one of the branch will be supplied to the muscles here. Now, what are the muscles which will be taken care by the median nerve in the hand? It will be thenar muscle, but remember, except which one? Except adductor pollicis. And then it will be supplied to the lumbrical number 1 and the lumbrical number 2 here. Lumbrical number 1 and 2 here. Done. So these 5 muscles will be taken care by the median nerve in the hand. But the important thing is about the digital branch and the palmar cutaneous branch. Now the point to note down here is that the palmar cutaneous branch is given before the flexor retinaculum, and that too it is coming from above the flexor retinaculum, whereas median nerve is coming below from the flexor retinaculum. Please keep that in mind. Median nerve is going to come from below or deep to flexor retinaculum, but palmar cutaneous branch is coming from above. And yes, of course, it will be supplying to what? Naam se pata chal raha hai ki it will be supplying to the skin of the palm, that to lateral 3.5, and then 3.5 digits here will be supplied by digital branch. So digital branch is supplying to the skin of the lateral 3.5 digits here, and skin of the lateral 3.5 palm is taken care by the palmar cutaneous branch. Done. Now what will be the clinical applications of this median nerve, sir? Point number 1. If median nerve is gone, of course, all the thenar muscles are gone except adductor pollicis. So therefore, the thumb will be adducted along with the fingers, and this is the feature of apes, ape thumb deformity. Median nerve will be involved. And then you ask the patient to make a fist. These muscles are working well, so this will be folded, but this will be remaining like this only. So pointing index, which nerve will be involved? Median nerve. Along with that, remember the same explanation is there for hand of benediction also. Yes, which nerve will be involved? Median nerve will be involved there, guys. So remember, ape thumb deformity, pointing index, as well as the hand of benediction, median nerve will be involved, and the person will not be able to make that OK sign. Remember that one. That is nothing but the interosseous nerve syndrome. And then how to test. अगर median nerve injure होती है तो टेस्ट कैसे करेंगे? पेन टेस्ट. पेन टेस्ट में क्या होगा? You'll ask the person to touch the pen like this here. If he's not able to touch the pen there, of course the abductor pollicis brevis muscle is not working, which is one of the thenar muscle. So therefore, my dear friend, remember pen test is done for median nerve, sir. है ना? Yes, Fallon test भी होता है. Fallon test भी करते हैं ना? वो आपको पता ही होगा. आपने ऑर्थो में पढ़ा होगा. So all these things are important here, sir. Crystal clearly we have completed here, guys. Okay. Next one, moving ahead with the radial nerve. Radial nerve will be first coming from the axilla, and in the axilla itself it will be supplying to the long head and a part of the medial head, sir. Then from there the radial nerve will be going into the spiral groove. In the spiral groove it will be supplying to the remaining part of the medial head as well as the lateral head as well as the anconeus muscle. And then next, near the lateral side of the arm, it will be supplying to brachioradialis muscle as well as ECRL. Very much important, sir. ECRL is very much important there. And then right in front of the lateral epicondyle, it will be dividing into two branches, superficial branch and the deep branch. Superficial branch will be supplying to the skin of the dorsum of the hand, whereas deep branch is going to pierce a muscle. And which muscle it is piercing here? Supinator. After piercing the supinator, it is going back. And now the name changes. It's no more the deep branch. It is now PIN, posterior interosseous nerve. And that is supplying to all the muscles present in the posterior compartment of the forearm. That is extensors muscle, guys. I hope the concept is like crystal clear. Fine here. What is the root value of the median nerve? The root value of median nerve will be C5, C6, C7 and then C8 as well as T1. Why? Because it will be originating from both lateral cord as well as the medial cord of the brachial plexus. So due to lateral cord, its root value will be C5, C6, C7, and whereas due to medial cord, it will be C8 and T1. I hope this is answered here. Fine. Now, if the radial nerve is injured, then what is going to happen, my dear friends? Radial nerve अगर injured होता है, तो I'm not able to extend the wrist here. So there will be a wrist drop. Wrist drop, what is the nerve involved? Radial nerve. But remember, finger drop. A wrist drop, radial nerve will be there. If it is only finger drop here, but no wrist drop, my dear friend, then your answer has to be PIN. Okay. So PIN अगर injure होता है, तो it will lead to finger drop, but no wrist drops. This question will also is also asked in your exam. Please remember this one here. Okay, now. So finger drop but no wrist drop, then it is nothing but PIN involved there. And remaining things you know very well. Radial nerve is also involved in crutch palsy. Radial nerve is also involved in the Saturday night palsy and so and so. वो आपको अच्छे से पता है. Is it okay? Is it okay, my dear friends? I hope it is clear. अब चलिए आगे बढ़ते हैं सर. Let's go here right now. How can we forget this topic here? When we are revising upper limb for the last marathon here, last leap before going to the exam, ये topic आपको revise करना बहुत ज़रूरी है. It's like hot favorite of your FMGE examiner. Anatomical snuff box. Remember, on the lateral side there will be two tendons. And these two tendons on the lateral side will be abductor pollicis longus and extensor pollicis brevis. And on the medial side there will be only one tendon. And that one tendon here will be the extensor pollicis longus. So first you are going to learn the boundaries. Now once you are done with the boundaries, floor. Actually in the floor of the anatomical snuff box, we are having four structures. The styloid process of the radius, scaphoid, trapezium and the base of the first metacarpal. I don't want you all to remember all these structures right now. At least remember only scaphoids. Just scaphoid याद रखिए, ठीक है ना? Now after that the content will be the radial artery. The content of anatomical snuff box will be the radial artery, sir. Yes, thank you. Yes, radial artery will be the content here, sir. Now why I'm asking you to remember only the scaphoid here? Recently in your FMG exam there was a clinical question. A person falls down on the outstretched arm. A person falls on the outstretched arm. और जब बंदा गिर जाता है, after falling down, he is coming to the clinic with a pain in anatomical snuff box, and that pain is due to the fracture of which bone? We know very well, out of the 8 carpal bones, the most commonly fractured will be scaphoid. The most commonly fractured will be scaphoid. तो इसलिए scaphoid आपको फ्लोर में याद रखना बहुत बहुत जरूरी है. Is it okay? Now once you are done with this one here, nerves related to humerus. Remember there are totally like 3 nerves which are related to humerus. Number 1, axillary nerve, and that is going to pass behind the surgical neck of the humerus. Number 2, there will be a radial nerve, and that is going to pass in the groove, and that groove will be the radial groove or spiral groove. And number 3 will be the ulnar nerve, and ulnar nerve is going to pass behind the medial epicondyle. Already मैंने आपको बता रखा है. In your FMG exam, they are actually giving these X-ray images here. If there is a fracture at the surgical neck of the humerus, then which nerve will be involved? Axillary. If there is a fracture at the shaft of the humerus, then it will be radial nerve involved. And if there is a fracture at the medial epicondyle, it will be ulnar nerve that will be involved, sir. Done. So these are the topics that you have to revise just before going to the exam. The most important topics in upper limb, sir. Let's go towards the lower limb. In the lower limb, actually now, the most important thing nowadays I'm seeing, they are asking the questions from all those small topics which students think that ये तो छोटे-छोटे topics है, कहाँ से सवाल आएगा? Like tarsal tunnel, you know, like small nerves, minor nerves of the lumbar plexus, यहाँ से सवाल आ रहे हैं, तो please revise that before going to the exam. तो इसलिए मैंने वो यहाँ पर include किया है. Everyone look here, let us revise this quickly here. Yes, of course, supracondylar fracture, it will be AIN involved, sir. Okay. Now first of all, remember this is the lumbar plexus, and in the lumbar plexus I am telling you about the minor nerves right now. Now from L1, the first lumbar, remember iliohypogastric and ilioinguinal will be originating from L1. Then from L1 and L2 together, you can see here there will be genitofemoral nerve originating here. So what is the root value of genitofemoral nerve? L1 and L2. Now this is something really important here. Yes, from L2 and L3 together they are going to form the lateral cutaneous nerve of thigh. L2 and L3, lateral cutaneous nerve of the thigh. तो ये आपको याद रखना होगा. Now what is going to happen? From L2 and L3, the lateral cutaneous nerve of the thigh, it's going all the way from inside the ilium and then it is going here. Now the people, number one case here will be obesity, number two will be pregnancy, and number three wearing tight clothing. Now in obesity and in pregnancy, what is going to happen? The abdomen will be protruded, and because of that, this nerve is getting compressed beneath the inguinal ligament here. If this nerve is getting compressed here beneath the inguinal ligament, then the patient is going to come to you with numbness, tingling, burning, pain or stabbing sensation on the lateral side of the thigh, and this condition is referred to as meralgia parasitica. So meralgia parasitica, what is the nerve involved? Lateral cutaneous nerve of the thigh. And what is the root value, sir? The root value will be L2 and L3. Please remember this carefully. ये बहुत important concept है. Now, the paper will not be completed with the Trendelenburg sign question. Yes, just answer me one thing here. When the Trendelenburg sign is positive here, tell me what is the nerve involved. The nerve will be the superior gluteal nerve. And superior gluteal nerve will be supplying to two important muscles. One is gluteus medius, another one will be the gluteus minimus. Okay. And now the last and final and the most important point to remember here. मान लो कि if the hip is actually fallen onto the left side, sir. The hip is sagging on the left side, dropping on the left side here. So which nerve will be gone? The right side, contralateral. The right side superior gluteal nerve will be actually involved, sir. That is something really important to remember. Okay, so read the question very much carefully. I am including this one here because of this reason only. If the hip is sagging or dropping on the left side, then right superior gluteal nerve will be actually involved there. So please remember that carefully here. You'll be easily able to answer the question from here. And what is the nerve involved? Which muscles are involved? ये तो सबको अच्छे से पता है. Okay, next one, sir. Attachments on the femur. Many a time questions will be coming from here. Now, first of all, in this diagram, you're able to see this is your ASIS, anterior superior iliac spine here, and this one here will be the anterior inferior iliac spine, AIIS. Anterior superior iliac spine, there will be a ligament attached here, inguinal ligament, and sartorius muscle is going to originate from here. Anterior inferior iliac spine, there will be rectus femoris muscle beginning from here, sir. Then after this, you got to remember about the gluteus muscle. Remember, gluteus maximus muscle is getting attached onto the gluteal tuberosity. So what is the muscle attached onto the gluteal tuberosity? Gluteus maximus. What are the two actions of gluteus maximus? Yes, it is helping in extension at the hip joint as well as external rotation. Whereas gluteus medius and gluteus minimus, both of them are attached on greater trochanter only. They are attached on greater trochanter, but the difference will be gluteus medius will be attached onto the posterior surface, whereas gluteus minimus will be attached onto the anterior surface. And both of them are actually helping in abduction at the hip joint as well as internal rotation. And if these two muscles are actually gone, it will lead to Trendelenburg sign. This sign will be actually positive here, sir. Now, nowadays this is like trending in your exam, that is ischial spine. Now, three structures are going to take a turn here, and we remember that with the mnemonic as pin structures. That is pudendal nerve, as well as the internal pudendal artery, as well as the internal pudendal vein. These three structures are going to take a turn around the ischial spine. Now, another important point to remember here, that is the place where you can actually block the pudendal nerve. So, what is the site of pudendal nerve block? That is ischial spine. The site of pudendal nerve block will be the ischial spine, sir. Please remember that very much carefully. और image याद रखिए सर, क्योंकि बार बार आपके एग्जाम में image में ischial spine वहाँ पर ना mark किया जा रहा है. Now once you are done with this one, lesser trochanter. Lesser trochanter पर क्या attach होगा? दो muscle यहाँ पर attach होंगे. One is iliacus, another one will be the psoas major. Iliacus and the psoas major will be attached onto the lesser trochanter. Tarsal tunnel. Expected question on the 17th January. टार्सल टनल से यहाँ से ना सवाल आएगा आपके 17 जनवरी एग्जाम में सर. Now from this tarsal tunnel, first of all, three tendons are passing from here. This is tibialis posterior tendon, and then flexor digitorum longus tendon here, and the flexor hallucis longus tendon here. Tibialis posterior, flexor digitorum longus, flexor hallucis longus. Along with that, there will be nerve which is going to pass from here, that is tibial nerve, and this is something really important nowadays, the artery. That is posterior tibial artery is also passing from here. और आपके FMGE एग्जाम में ये वाला इमेज दिया गया था, and in this image the doctor is trying to measure the pulse, and the pulse is measured there with the help of which artery? That is nothing but the posterior tibial artery. Yes, we can palpate the artery here, that is posterior tibial artery. Please remember that one. Now moving on to the thorax topic. Those are the topics that you have to revise in the lower limb, my dear friends. Now moving on to the thorax. In thorax nowadays what I'm observing is repeatedly they're asking about the constrictions in the esophagus. Esophageal constrictions. So number one, remember there are like four constrictions in the esophagus. Number one, at the very beginning of that one. And number two, remember where the arch of aorta is crossing that one. Number three, where you have the trachea, the principal bronchus. Trachea is dividing into the principal bronchus, the left principal bronchus crossing. And number four, of course, where the esophagus is crossing the diaphragm. There are like four constriction here. Fine. Now in this slide, why I have included this screenshot from 42nd edition of Grey's Anatomy? Why? Because some students during my offline sessions, they have actually said that in the surgery, actually the faculty has taught about like only 3 constrictions. So my dear friends, let me show you very, very clearly in the Grey's Anatomy. After that, you decide what to answer in paper 1 and what to answer in paper 2. Is it okay? So remember, from Grey's Anatomy 42nd edition, esophageal constriction, remember it's given very, very clearly. There are 4 esophageal constrictions here. The 4 constrictions. Okay. And you all know very well, we'll be measuring from the incisors, right? So number 1 constriction will be right at the very beginning, where you have cricopharyngeus muscle, and that is 15 centimeters from incisors. Number 2, where you have arch of aorta, and that is 23 centimeters from incisors. And number 3, where you have the left main bronchus, that is 28 centimeter from incisors. And finally diaphragm, and that is 40 centimeter from incisors. So this is given clearly in the Grey's Anatomy 42nd edition, page number 1057. Okay, there are 4 constrictions. Remaining you can manage in your exam. कैसे आंसर करना है, क्या आंसर करना है, ठीक है ना? Yes, 15, 23, 28 and 40, sir. Next one. After that, welcome to the abdomen topic here. See, remaining things in the thorax you can easily manage, sir. See, this is not the time when we are dealing with marathon here. This is not the time I tell you about, heart is supplied with coronary artery, right coronary artery, left coronary artery. ये चीज़ें तो आपको ऑलरेडी पता ही होती है ना. एपेक्स ऑफ द हार्ट इज फॉर्म बाय लेफ्ट वेंट्रिकल, बेस इज फॉर्म बाय एट्रियम. तो इसीलिए मैं आपको वो टॉपिक्स बता रहा हूँ जहाँ पर बच्चे मिस्टेक करते हैं. मोस्ट ऑफ द टाइम द स्टूडेंट्स आर ट्रैप्ड टू मेक अ मिस्टेक. सो आई एम डिस्कसिंग दोज थिंग्स. रिमेनिंग यू कैन इजीली मैनेज इन दैट वन. नाउ वेलकम टू abdomen topics. In abdomen topic, nowadays what is happening is they are giving about the planes, the imaginary planes, and you have to remember they are at which level. So many a times the students are omitting this topic. ये छोड़ो, abdomen में हम पढ़ते हैं directly inguinal hernia and all. So please don't omit this topic here, sir. Welcome here. Number 1, transpyloric plane. So the transpyloric plane, which is also referred to as Addison's plane, that will be at the level of L1 here. And then the subcostal plane, which is touching the lowermost margin of the, lowermost costal margin, that will be at the level of L3 here. And then there is one more plane here, that is the supracristal plane, which was asked in your FMGE exam, and that is going to touch the uppermost part here, that is your iliac crest. और इस plane को कहा जाता है supracristal plane, touching the iliac crest, and that will be at the level of L4. And then after that, intertubercular plane between the tubercles here, that is transtubercular or intertubercular plane, and that will be at the level of L5. Okay. Now, one more important point to remember here is about the umbilicus here, sir. Now I am saying one thing here. Many of the students, the moment you say umbilicus, they'll be like mugging up, रट्टा मारते हैं umbilicus T10 करके ना. तो क्वेश्चन को थोड़ा ध्यान से पढ़िए. If they are going to ask you the dermatome of the umbilicus, then your answer has to be like T10. If they are asking you the location of the umbilicus here, please remember the answer has to be between L3 and L4, sir. Dermatome will be at the level of T10, but the location is between L3 and L4. Please keep that thing in mind. And yes, of course, this is like old question, sir. Very old question here. Transpyloric plane जो होता है, at that level, which structure will you find? It's given in the name itself. Yes, pylorus of the stomach. Of course, at the level of that one, you'll be having the origin of superior mesenteric artery. Okay, and then even the hilum of the kidney also present there, sir. Perfect. So keep these points in mind because you will be normally omitting this one. इसलिए मैंने आपको बता दिया है. Now welcome to inguinal canal. Very, very important concept here. Now don't say me that you don't know about the layers of anterior abdominal wall. वो तो आपको पता होगा. There are totally like 8 layers in the anterior abdominal wall. Now in the layer number 6, that is transversalis fascia, you will be able to appreciate the deep inguinal ring. और ये सवाल आपके FMGE एग्जाम में 3 बार पूछा गया था. Deep inguinal ring कौन से वाले लेयर में होता है? ये होता है in the transversalis fascia. Then in the superficial inguinal ring is present in the external oblique. External oblique वाले लेयर में होता है superficial inguinal ring. अब इन दोनों को जोड़ दो, join them together. So join the deep inguinal ring with the superficial inguinal ring. Join the deep inguinal ring with the superficial inguinal ring. That is going to form your inguinal canal. Now what are the boundaries of the inguinal canal and what are the contents? Yes, look at this diagram, you will get every answer here, sir. What are the boundaries? Anteriorly there will be, yes, external oblique and then internal oblique. Anteriorly you'll be having external oblique and then internal oblique. Posteriorly you'll be having the conjoined tendon and the transversalis fascia. ओहो, तो अगर ये वाला इंग्वानल कैनाल होगा, आई रिपीट दैट अगेन, अगर ये वाला इंग्वानल कैनाल होगा तो आप देख सकते हो डायग्राम में बड़ा क्लियरली यहाँ पर कि उसके आगे होता है एक्सटर्नल ऑब्लिक एंड इंटरनल ऑब्लिक, and what you have behind that one, there will be conjoined tendon and then transversalis fascia. Then what is going to pass above that one here? This one is internal oblique and this one here will be the transversus abdominis. These two are present above the inguinal canal, and what you have below the inguinal canal, there will be inguinal ligament. Perfectly done. Now what is the content of inguinal canal? Remember, in males you'll be having spermatic cord along with the nerve, that is ilioinguinal nerve. And in the females, you'll be having a round ligament of the uterus along with the same nerve, that is ilioinguinal nerve. So by this, we complete everything about the inguinal canal in a simple and crystal clear manner. Now let's go ahead with another important topic, that is openings of diaphragm. There are three major openings of diaphragm. Number one, you'll be having vena cava opening, and number two, there will be esophageal opening. Number three, there will be aortic opening. The vena cava opening will be present in the central tendon of the diaphragm, whereas esophageal opening will be present in the muscular part of the diaphragm. Okay, it is in the muscular part of the diaphragm. And then finally aortic opening is present between the right and left crus of the diaphragm. तो पहले आपको लोकेशन पता होना चाहिए. Second thing, you need to remember the extent. Remember, vena cava opening will be at the level of T8, esophageal T10, and aortic opening will be at the level of T12. And you remember the mnemonic very well, voice of America. Remember T8 and then T10 and then T12. And yes, of course, if there is an opening, some structures are going to pass from here. You need to remember what structures are passing from here, sir. Vena cava opening, of course, inferior vena cava is going to pass from here, but write and forget about them. इसे भूल जाओ. Examiner will never ask you vena cava opening से vena cava ही pass होगा, है ना? तो please concentrate onto the right phrenic nerve is going to pass from here, sir. Then esophageal opening, of course, esophagus will pass from here, and along with the esophagus, remember vagus will also pass from here. So esophagus and vagus, remember, like a rhyming word here. And aortic opening, of course, यहाँ से aorta pass होगा. इसके साथ में आपको याद रखना होगा, yes, azygous vein. Azygous vein is going to pass from here, and along with that azygous vein, remember, even thoracic duct is also going to pass from here. So thoracic duct is also going to pass from here. So diaphragm and all the openings of diaphragm are very much important. So you can see here, even though this is like, last sort of revision right now, that is your mega marathon revision here, but in this we are covering like every topic possible here, my dear friends. Okay, now moving on. Yes, another very important topic. I hope you're also observing in your previous year questions and all those things. In your FMGE exam, many of the times they're asking about peritoneal folds, and in that peritoneal folds they're asking about epiploic foramen. And what are the boundaries of epiploic foramen? Welcome, in two diagrams I'll make the things easier for you. In this diagram you are able to appreciate the stomach here. ये वाला आपका stomach होगा, and this one here will be the liver here, and this one here will be the spleen. You know very well about the rotation of gut. So after the rotation, the liver will be coming towards the right and the spleen will be going towards the left over there. Now right in front of the liver there is a ligament here, and this ligament will be falciform ligament, and that will consist of ligamentum teres in that one. Now between the liver and the stomach there will be lesser omentum, and that is the free margin of lesser omentum, and in the free margin of lesser omentum you will be able to see that there will be portal triad, and that is made up of portal vein, the bile duct, and the proper hepatic artery. Now between the stomach and the spleen here, this one will be the gastrosplenic ligament, and this ligament will consist of gastroepiploic artery as well as the short gastric arteries. And then finally between the spleen and the kidney here, this one here will be the splenorenal ligament, or we'll also call it as lenorenal ligament, which was recently given in your FMGE exam, lenorenal ligament. And in this it will consist of, you can clearly see the celiac trunk, and from the celiac trunk what is going to happen, the splenic artery is coming here, coming here, coming here. Of course it will consist of the splenic vessels as well as tail of pancreas. Now after rotation what is going to happen, there is a small space here, and this space is referred to as lesser sac, and whereas this remaining space here is referred to as greater sac. Now this lesser sac and greater sac, they are connected by this opening here, and this opening will be referred to as epiploic foramen. The biggest mistake done by the student, they'll be thinking this is the epiploic foramen. No, that is not the epiploic foramen here, my dear friends. Remember, this one here will be the epiploic foramen here. Now what do you find in front of the epiploic foramen? The free margin of lesser omentum, which will consist of the portal triad, the portal vein, the bile duct and hepatic artery. And what do you have behind the epiploic foramen? What is the posterior relation? Of course, inferior vena cava. So in this diagram, I am done with the anterior and posterior relation. That's all. आपको mug up नहीं करना है. You don't have to mug up. Please, I am requesting you, don't make any mnemonics. Simple diagram here. Epiploic foramen कहाँ है वो आपको पता होना चाहिए. You should be knowing where is epiploic foramen. Epiploic foramen ikkad undi. Anteriorly ఏమవుతుంది? There will be, yes, free margin of the lesser omentum, and that will consist of the portal triad, and posteriorly will be consisting of inferior vena cava. Yes, of course, Pringle's maneuver is done here. And now we got to learn what do you have superiorly, inferiorly here. Yes, my dear friends, remember, if this one here will be the epiploic foramen here, that is behind the free margin of lesser omentum. This is lesser omentum here. Behind that one, there will be epiploic foramen. तो उसके ऊपर क्या होगा? What do you have above that one? Liver. But remember, which lobe of the liver? Caudate lobe of the liver. And below this, you are able to clearly see that is the duodenum. Of course, the first part of the duodenum, sir. Of course, the first part of the duodenum. Okay. So epiploic foramen के ऊपर क्या होता है? What do you have above that one? That is caudate lobe of the liver. And what do you have below? Below you'll be having the first part of duodenum. Done. Is it okay? Done, sir. So these are the topics which you have to revise in the abdomen. And now welcome to pelvis and perineum. Make a note, my dear friends. Short question on 17 January. Definitely it's going to ask about the extravasation of urine. And extravasation of urine, there are two clinical cases. Number one, straddle injury. A person is riding a bicycle on the bumpy road. Straddle injury होगा. Okay, इसको हम straddle injury कहते हैं. And then number two, the pelvic fracture. Pelvic fracture. They'll be mentioning these two keywords in the exam, sir. So please look for these two keywords, sir. Fine here. So one will be the straddle injury. Straddle injury का मतलब क्या होता है? Don't look at this kind of English and get surprised in the exam. भाई साहब ये straddle injury क्या होता है? Riding the bicycle on the bumpy road, and then pelvic fracture, fracture of the pelvis. Fine. Now remember one thing here. The first point remember here is that whenever there is a straddle injury, this should be by default bulbar urethra will be ruptured. And whenever there will be a pelvic fracture, then which urethra will be ruptured, sir? Membranous urethra. So pelvic fracture agar hoga, membranous urethra will be ruptured here, and therefore the urine is just going out into the deep perineal pouch. The urine is going out into the deep perineal pouch. ठीक है ना? So it is going where? Into the deep perineal pouch, and even the urine can also go into the space surrounding the urinary bladder, that is space of Retzius. And after that, जब कभी भी straddle injury होता है, bulbar urethra rupture होता है, सर ये बड़ा खतरनाक होता है. अगर bulbar urethra rupture होगा, if this bulbar urethra is ruptured, then the urine will go out into the superficial perineal pouch. The urine will also go into the scrotum. The urine will also go into the penile shaft as well as into the anterior abdominal wall. Into the anterior abdominal wall, sir. So repeat again, if there is a straddle injury, bulbar urethra is gone, then superficial perineal pouch, the scrotum, the penis as well as the anterior abdominal wall, the urine will be extravasating out, sir. Now, यहाँ तो यूरिन जाता है, लेकिन आजकल आपके ना FMGE एग्जाम में थोड़ा और डेप्थ में पूछा जा रहा है. What they are asking in depth here, if bulbar urethra is getting ruptured here, you know very well where the urine is going, but you also have to learn where the urine cannot extravasate. The urine cannot go into the thigh due to which fascia? Due to fascia lata of the thigh. It cannot go into the deep perineal pouch. Why? Because you'll be having that perineal membrane there, sir. And it cannot go into the ischiorectal fossa because of the Colles fascia. Please remember this one also, where the urine can go and where the urine cannot go. I hope it is like crystal clear here. और ये सवाल आपके एग्जाम में definitely आएगा. Is it okay? Yes. Now welcome here to the last wala part of the anatomy here, that is your embryology wala part. Now in embryology, you should be aware about this diagram here. In this diagram, you should be able to identify all the structure. Now this one here will be the notochord. हम सबको ये अच्छे से पता है. Above the notochord, there will be a tube-like structure. This tube here will be the neural tube, sir. On either side of the neural tube, there will be cells, and these cells here will be the neural crest cells. Okay. Now, obviously, we are seeing the transverse section of the embryo in which week here, sir? That is the third week. And in third week, we'll be having 3 germ layers. This one here will be the ectoderm, this one is the endoderm here, and this one here will be the mesoderm. Okay. Now that mesoderm is in turn divided into 3 parts. Number 1, this one here will be the paraxial mesoderm here. This one here will be the intermediate mesoderm here, and this one here will be the lateral plate mesoderm. So paraxial mesoderm, intermediate mesoderm, and the lateral plate mesoderm. Is it okay? Now once you know this diagram very well, let us discuss the concepts here one by one. Neural crest cells derivatives याद रखना आपको बहुत जरूरी है आपके FMG एग्जाम के लिए, ठीक है ना? Now in this neural crest cells derivatives, I'll tell you, like, there are so many derivatives here, but I'll tell you the most important ones to be remembered for your FMG exam. First thing, it is going to form your peripheral nervous system. So obviously it is going to form all the ganglions. Number 2, it is going to form Schwann cells. ये बहुत important है. Number 3, the neural crest cells are going to form adrenal medulla. In the adrenal gland, you'll be having adrenal cortex and medulla. Remember, only the medulla is formed from neural crest cells. Parafollicular cells or C cells are derived from neural crest cells. And please remember about the conotruncal septum. Conotruncal septum is actually made up of 2 septums. One is your spiral septum, another one will be the bulbar septum. And these two together, they are going to form your conotruncal septum. Okay, so whatever I have put the star mark there, please remember, my dear friend, these are the structures that you have to recall before going to the exam. Now, once you are done with this one, of course, there can be a question from here. One more question you can actually expect on 17 January from the neural tube defect. अब यार न्यूरल ट्यूब हम सबको पता है, नाम में ही लिखा है ट्यूब लाइक स्ट्रक्चर होता है. And this neural tube, it is the one which is going to form your central nervous system. Cranial part is going to form the brain and the caudal part is going to form the spinal cord. Now, if it is a tube-like structure, there is one opening here, and that opening will be referred to as cranial neuropore or anterior neuropore, or your examiner loves to ask the questions in a different manner. So in FMG, it was given as rostral neuropore. So anterior, cranial or rostral neuropore sir. और ये वाली होती है caudal neuropore. अब normally in the normal people like you and me, what should happen? It has to be closed here. So remember, the anterior neuropore will be closed on 25th day, whereas the posterior neuropore will be closed on 27th or 28th day. Better option will be 28th day. 28th day close hota hai. Fine. Now, if the cranial neuropore doesn't close, then it will lead to a condition known as anencephaly. Okay. And if the caudal neuropore does not close, it will lead to a condition known as spina bifida. But this picture was also given in your FMG exam, where you have anencephaly as well as there is bony defect of the spine. Bony defect of the spine. The spine is not closed there. That is also exposed outside. And this condition will be referred to as cranioracheschisis. Cranioracheschisis. Is it okay? So these are the things which you have to definitely revise before the exam. You can expect one question from here, sir. Next one. Development of diaphragm. Diaphragm will be actually derived from 4 structures. So the one which are given here, number 1, this septum that you are able to observe here, this will be the septum transversum, and then the muscle wala part will be derived from somites, cervical somites, and the body wall mesoderm bhi kehte hain. And then after that, this one here will be the dorsal mesoesophagus, and then this membrane here will be the pleuroperitoneal membrane. I want all of you to revise before going to the exam this one, pleuroperitoneal membrane. So अगर मान लो this pleuroperitoneal membrane is absent, अगर ये absent है, form नहीं होता है, if the pleuroperitoneal membrane is absent, then what is going to happen during development? The coils of intestines will be actually herniating into the abdomen, and that condition is referred to as congenital diaphragmatic hernia. ये आपके एग्जाम में कई बार पूछा जाता है कि why do you have congenital diaphragmatic hernia? Absence of pleuroperitoneal membrane. And even this image was given where you can clearly see the coils of intestines are herniating into the thorax, and they are going to compress the lung, and therefore lung hypoplasia will occur. So please remember this image also very well, because this image was given in your exam, sir. Next one. Now once you are done with this one, how can we forget this one? Arterial system. Development of arterial system nowadays another high-yield topic, sir. Very, very important topic. Yes, on 17 January, we can expect one question from here also. And now I don't have to tell you the orientation of this diagram. In our regular classes and in our videos, main videos and all, I told you very clearly how this diagram comes from. dorsal aorta, aortic sacs, the 6 arch arteries and all. अभी आपको याद रखना होगा arch arteries. How many arch arteries do you have? 6 arch arteries are there, sir. Out of the 6 arch arteries, remember the third arch artery. So the third arch artery, it is the one which is going to form your carotid arteries. Then the fourth arch artery, only the left one. Left fourth arch artery, it is going to form arch of aorta. Left fourth arch artery. And then remember the sixth one. Sixth arch artery, it is the one which is going to form pulmonary arteries. And on to that, this is something like really important here. Between the pulmonary artery here, this is the pulmonary artery over here, and this is the arch of aorta. Between them, you'll be able to find ductus arteriosus. And ductus arteriosus will be derived from the left sixth arch artery. Class. So let us just quickly revise this one here, my dear friends. Third arch artery is going to form carotid arteries. Left fourth arch artery is going to form arch of aorta. And then sixth arch artery is going to form pulmonary artery. And only the left sixth arch artery is going to form the ductus arteriosus. Ductus arteriosus, guys. Okay. Next one. Now, some of the students will be like, sir, you told only about the third one, you told about fourth one and sixth one. What about the remaining? Remember, out of the 6 arch arteries, the 5th arch artery is completely gone, completely degenerated. तो यहाँ से कुछ भी form नहीं होता है. So don't worry about the 5th one. 5th वाला हमारा answer होगा ही नहीं. Sir, what about the first and second one? First and second one, they will also degenerate, but there is a remnant. So what is the remnant of the first arch artery? Remember, it is maxillary artery. Maxillary artery is the remnant of first arch artery. And remember, the remnant of second arch artery, this one here will be the, yes, hyoid artery. Hyoid artery and even the stapedial artery. Hyoid artery and stapedial artery, these two will be the remnants of second arch arteries. Remnant, I'm telling you, not the derivatives. Done. So this diagram is important here. It's all about the numbers. Memorize all those numbers. That will be done. Now, once you are done with this one, nowadays they are even asking this question about the right and left recurrent laryngeal nerve. Everyone knows that the left recurrent laryngeal nerve is longer. Now, why it is longer? Why? Because it is going to take a turn around the arch of aorta. Gross anatomy आपको पता है, लेकिन embryology वाला आंसर आपको याद रखना होगा. Remember, the left recurrent laryngeal nerve is longer because of the 6th arch artery. Because of the left 6th arch artery, क्योंकि वहां पर वो उसके ऊपर नहीं जा पाएगा. Is it okay? Whereas on the right side, this is not formed, this is not formed. Everything remaining in dotted lines there is actually gone. Therefore, it is coming up and taking a turn around the subclavian artery. I hope this is crystal clear. The left recurrent laryngeal nerve is longer when compared to the right one because of the left 6th arch artery. Remember that one, my dear friends. Next one. Now, abnormal right subclavian artery. तो जैसे मैंने आपको बताया, sometimes what will happen is that on the right side, the right subclavian artery is forming from here. Now, if this is not formed, sir, I mean to say this right 4th arch artery. Okay, the right 4th arch artery is obliterated. It's already written here. Later on, you'll be getting the PDF. Don't worry. So, right 4th arch artery will be obliterated, and this caudal part is actually persisting. And that will actually give rise to what? The aberrant subclavian artery, the right subclavian artery. And that right subclavian artery, which is aberrant one, is going to take a turn from behind the esophagus and the trachea and compressing them. This condition will be referred to as dysphagia lusoria. Dysphagia lusoria. So please remember, it is due to what, sir? It is due to the obliteration of right 4th arch artery. Next one. Now welcome to the gut embryology. In gut embryology, you know this diagram very well. The outer black colored line here is the body wall. Inner red colored line here is the gut. Gut is having the foregut, midgut and hindgut. Midgut is giving rise to an extension known as the vitello-intestinal duct, and hindgut is going to give rise to an extension known as allantois. Allantois. Is it okay? Last 5 minutes, guys, don't get impatient here, but because I was given exactly like 2 hours of time, so I think I started somewhere around at 12:35 or 12:40, and by 2:40 we are going to finish. Okay, in exactly 2 hours. Okay. So now welcome to the midgut, hindgut. Midgut is given an extension known as vitello-intestinal duct here, sir. Done. Now this is going to the future umbilical cord here. Now you have to remember what are the contents of the umbilical cord. Number 1, which is already visible here, vitello-intestinal duct. Number 2, which is visible here, allantois. Okay. Number 3, surrounding this there will be jelly-like substance known as Wharton's jelly. Done. And then, yes, this is the place where most of the students will be actually getting confused here. Umbilical cord will consist of umbilical artery and umbilical vein. But in the artery, please remember there will be two of them. Right and left umbilical artery will be present. But in the vein, we have only and only the left umbilical vein. Only the left umbilical vein. The right will regress, left is left. Left umbilical vein is only present, the right will be gone, sir. Done? Now let me tell you all the clinical applications over here. Now in the clinical application, in the normal people like you and me, normally what should happen? Vitellointestinal duct should be gone. Okay, it should be closed. But in some individuals, what is going to happen? It is going to persist. If this vitellointestinal duct is going to remain there, then what is going to happen? You will be able to see the meconium coming out from the umbilicus. So the question which will be asked in your exam, meconium around the umbilicus. What is the cause? It is due to persistence of vitellointestinal duct. Now suppose entire vitellointestinal duct is not remaining, only a proximal part of that. Only this much part is remaining. This is gone. This is gone, sir. And that diverticulum will be referred to as Meckel's diverticulum, which will be attached to the midgut. Or to be more specific, it is attached to the ileum part of the midgut. Is it okay? So I repeat the two MCQs here. Persistence of the entire vitellointestinal duct. If it is persisting, then meconium around the umbilicus. If only the proximal part is persisting, that will lead to Meckel's diverticulum. Now after that, what about this hindgut? Hindgut will actually give rise to the extension known as allantois. But later on, what is going to happen? This will be separated apart. So the mesoderm is actually going to separate them apart. Now once they are separated apart, we know very well hindgut is the one which is going to form the rectum, and it is also going to form the anal canal here. Okay. But what about this allantois? Allantois is the one which is going to form a sinus here, and this sinus will be the urogenital sinus. And the cranial part of this urogenital sinus will be referred to as urachus. Now the first point to remember here is that urogenital sinus is going to form your entire urinary bladder except what? Except the trigone. और ये भी सवाल आपके FMGE एग्जाम में पूछा गया था कि ट्राइगोन कहाँ से फॉर्म होता है? तो याद रखिए ट्राइगोन will be derived from Wolffian duct, mesonephric duct, nothing but Wolffian duct. Okay. Now, if this is going to form urinary bladder, what about this urachus then? Urachus will be closed to form a ligament, and that ligament will be the median umbilical ligament, sir. It is going to form median umbilical ligament, N. Be careful, it is median umbilical ligament, okay. Now that median umbilical ligament is derived from where? Urachus. Thank God in your body and my body that is closed, that is ligament. Agar मान लो close नहीं होता है, if this median umbilical ligament is not formed there, the urine that is present in the urinary bladder will start coming out from the umbilicus, and that condition is actually known as weeping umbilicus. Urine coming out of the umbilicus. It is due to what? Persistence of urachus. Urine coming out from the umbilicus, then it will be persistence of urachus. I hope the concept is clear. So in one slide, everything we have discussed here, sir. तो जैसे मैंने आपको बताया था, ileum will be attached to a diverticulum here, and that diverticulum here will be the Meckel's diverticulum, my dear friends. Okay. So if they give you this image in the exam and ask you what is the reason for this one, it is due to persistence of proximal part of the vitellointestinal duct. Now before moving ahead, one more concept to learn is about the rotation of the gut, sir. चलिए बताइए, foregut rotate होता है कि नहीं होता है? Foregut rotate होता है कितना? 90 डिग्रीज. कहाँ पर? कैसे? क्लॉकवाइज डायरेक्शन में. मिडगट रोटेट होता है कि नहीं होता है? होता है. कितना रोटेट होगा? 270 डिग्रीज. इन विच डायरेक्शन? इट विल बी इन एंटी क्लॉकवाइज डायरेक्शन, सर. एंड फाइनली हाइंडगट रोटेट नहीं होता है. तो फोरगट विल रोटेट 90 डिग्रीज क्लॉकवाइज, midgut will rotate 270 degrees anti-clockwise, and hindgut will not rotate. Now during the rotation of midgut, the important thing is that midgut, it will be having long coils of ileum as well as jejunum, and therefore those long coils of ileum, jejunum and all cannot be accommodated in the abdomen. During development in the abdomen, the space will be very much less. So therefore what is going to happen, that midgut is going to herniate out, it is going to come out, and that is referred to as physiological hernia. Question number 1, when will physiological hernia occur? 6th week. And after rotating 270 degrees anti-clockwise, it is going to reduce back, and that is going to reduce back by 10th week. Second question here. Okay, I repeat again. When will physiological hernia occur? By 6th week. When will the physiological hernia reduce back? By 10th week. नाउ यू एंड मी, अगेन आई एम टेलिंग यू, बार बार मैं कह रहा हूं, ऊपर वाले का शुक्र अदा कीजिए कि अपना मिडगट बाहर आया है, रोटेट हुआ है, अंदर अच्छे से चला गया है. थैंक गॉड वी आर लाइक परफेक्ट राइट नाउ. In some unfortunate babies, their midgut will not reduce back in the abdomen, and that is going to remain outside. That condition is referred to as omphalocele. So what is omphalocele? Omphalocele is actually the failure of reduction of physiological hernia. Is it enclosed by a sac? Of course, that is covered by the sac there. Okay, now many of the students will be getting confused with gastroschisis. Please remember, the gastroschisis is not due to the reduction of that physiological hernia and all. Gastroschisis is actually the herniation of this one, herniation of that coils of intestines from the weak part of the anterior abdominal wall. So anterior abdominal wall rupturing and then the coils of intestines are coming out. So if it is rupturing and coming out, will it be covered by a sac? No, the sac will be absent, and here the intestinal obstructions will be most common. तो इट इज ऑल्सो इंपॉर्टेंट कॉन्सेप्ट. इमेज बेस्ड क्वेश्चन भी आपके एफएमजी एग्जाम में यहां से दिया गया है. इज इट ओके? नेक्स्ट वन सर, ectodermal cleft and the endodermal pouches. So remember, ectoderm is the one which is going to form the cleft, endoderm is the one which is going to form the pouches. How many clefts do you have? 4. How many pouches do you have, sir? 4. Now out of that, remember, the first ectodermal cleft, it is the one which is going to form external acoustic meatus and the outer layer of tympanic membrane. And thank God, the second and the third and the fourth cleft will be obliterated, it will be closed. और अगर ये close हो जाता है तो यहाँ पर हमको कुछ नहीं पढ़ना होगा. Now the first pouch here, it is the one which is going to form your middle ear cavity. Attached to that one will be eustachian tube and even the inner layer of tympanic membrane. Second endodermal pouch is the one which is going to form palatine tonsil, but remember only the epithelium of this one here. और सबसे जो important है यहाँ पर third and fourth pouch here, sir. Now the third pouch, remember with the rhyming word there, third thymus. Third pouch is going to form thymus, and because the thymus has to go down, along with that there is a formation of inferior parathyroid gland. And the fourth pouch is the one which is going to form your superior parathyroid gland, sir. Perfectly done. These are the derivatives of the cleft and the pouches that you have to remember here. Is it okay? Now once you are done with this one, all the important topics definitely coming in the exam from embryology has been revised. Now histology, I'll just tell you that whenever you're going to write down your FMG exam, in the histology, please revise epithelium. And in this histology, I don't have much to teach you here. In epithelium, you have to remember the examples only. And along with that epithelium, please recall or revise about the cartilage, hyaline, elastic and fibrous cartilage, and as well as please revise about the lymphatic tissues, guys, lymph nodes and the spleen and thymus, how do you differentiate that one. And we have done that in detail in our main videos. Now in epithelium, पता नहीं आप सारे example revise करोगे कि नहीं करोगे, so I don't want to take any risk, sir. Like 1 or 2 epithelium which are like utmost important, I want to revise in this session itself. Number 1, pseudo stratified epithelium. Now pseudo stratified epithelium, you know very well why the name is given like that. Even though it is a single layer of cells, all the cells are present on the basement membrane, but because the nuclei are arranged at different heights there, it's falsely appearing like multiple layered. Stratified. It is falsely appearing like multiple layered there, stratified there. So therefore it is named as pseudo stratified epithelium. Example important है trachea and the bronchus. Next one, transitional epithelium or urothelium, hot favorite of your examiner. Image दिया जाएगा. How to identify in the image? Look at the topmost layer. In the topmost layer, you'll be having umbrella shaped cells, and that cells will be enclosing like 2 or 3 cells beneath them. So you'll be having that umbrella shaped cells onto the top. That is the identifying feature of the transitional epithelium, also known as urothelium. By the way, why it is known as urothelium? Why? Because that is present in your entire urinary tract. That is your ureter. From the ureter, you go into urinary bladder. From the urinary bladder up to prostatic urethra. You will be able to find the transitional epithelium. Please remember that one. 17 January, ये वाला सवाल आ सकता है. Is it okay? Then after that, yes, as I told you about the collagen. I told you about the cartilage. Remember, there are like 3 types of cartilage: hyaline, elastic and fibrous cartilage. सबसे पहले ना आपके एग्जाम में इमेज दिया जाएगा, तो सर इमेज में कैसे पहचानना है? How to identify in the image here? Remember, just 2 पॉइंट आपको देखने होंगे. First of all, look at the chondrocytes. The chondrocytes will be in the groups. If the chondrocytes are in the groups, it will be hyaline or elastic. Then how to differentiate, sir? In hyaline, what will happen? Then look at the matrix. The matrix will be like hyalose. Hyalose, plain, glass-like, shiny, transparent hyaline cartilage. Then if you look at the matrix here in elastic cartilage, in the matrix you'll be able to find those elastic fibers which are like branched fibers everywhere here. So the matrix will not be plain, that is elastic cartilage. Itna aasan hai. Then fibrous cartilage, if it is given in your exam on 17 January, you are lucky. Why? Because it's easy to identify. The chondrocytes will be present in the form of rows. The chondrocytes are arranged in the form of rows. They are not in the groups, they are formed in the rows, and then the fibers are arranged in the proper pattern here. तो इतना आसान है इनको डिफरेंशिएट करना. And of course after that you need to actually learn all the examples आपको याद रखने होंगे. I hope you have already learned them, sir. ठीक है ना? Then next one, sometimes normally this is like more favorite of your PG examiner, but sometimes in the FMG exam also they're giving about the glands, mode of secretion. So based on mode of secretion, the glands are divided into merocrine, apocrine and holocrine. Merocrine, what is going to happen? Whatever secretions, they're actually packed in the vesicle will come near the membrane and they're going to release by exocytosis. Simple stuff, that is merocrine. Example will be your exocrine glands as well as sweat glands. Apocrine में क्या होता है? Whatever secretions are there, they are coming to the apical part of the cell and the apical part of the cell itself will disintegrate. Apocrine. An example here will be the mammary gland and atypical sweat glands like that of the axilla and pubis. Holocrine में क्या होता है? Entire cell itself will get disintegrated along with the products. Is okay? Along with the secretion. And holocrine example will be the sebaceous glands. तो बेस्ड ऑन सेक्रेशन आपको याद रखना होगा मेरोक्राइन, एपोक्राइन, होलोक्राइन अक्सर आपके एग्जाम में दिया जाता है. Okay. Then last and final thing, my dear friends, the types of joints. Yes, यहाँ से भी आपके एग्जाम में हमेशा FMG एग्जाम में एक सवाल आता है, तो इसको याद रख लीजिए. There are like 3 types of joint there: fibrous joint, cartilaginous joint, and then synovial joint, sir. Immovable, fibrous; partially movable, cartilaginous; completely movable will be synovial joint, sir. Okay. And then, my dear friends, please remember the examples of the primary and secondary cartilaginous joint. 17 January को आएगा, sir. Remember all the examples there. The midline joints will be the cartilaginous joint, secondary cartilaginous joints, symphysis wala. Is it okay? Is it okay? And by this we have revised the entire anatomy in exactly 2 hours of time which was given to us. So thank you for listening to me. All the best for your exam. I think we have revised enough. Rapid revision, last resort revision, and now the marathon. And now you should show us the result there. We are waiting for 17 January your exam, and then most probably in February your results will be out there. Come out with the flying colors. God bless you all. Thank you. All the best.
Hi everyone. Good afternoon, guys. Am I audible and visible? Everybody give me a thumbs up if I'm audible and visible. Good afternoon. Good afternoon. Welcome to this massive marathon that we're having for our FMG students. I know exam is very near, so I'm not going to take too much of your time over here. I will show you the other slides later on, but let us start with our discussion. Now, I have planned this marathon in such a way that we will be covering all the FMG 2025 PYQs. We will be covering 100 one-liners. We'll be covering important one-liners, as well as we will be covering certain important images with the formula. So that is the plan for today's session, guys. Are you all with me? I need a thumbs up before we begin, everybody. Are you all with me? Give me a thumbs up before we begin. And it's a very rapid session, guys. So all I want is quick answers from all of you. Most of the things I've written. So sit down, enjoy the session for almost 1.5 hours. And let me give you a quick run through the entire PSM. All right. Chalo, so what is the first question? FMG 2025. A group of experts delivered speeches one by one. No discussion was permitted between them. At the end, one person summarized the key points. Which method of health communication is this? Now, most of you have given the answer correct. No discussion was permitted between them. So when there is no discussion permitted between the experts, what is it, everybody? Symposium. Okay? Every time the answer is going to be symposium. Now, another FMG, if there was discussion among experts, it would have been a panel. Now, look at another FMG 2025 question. So, basically, health education and communication is one topic that you're not going to miss out in this last minute revision. The government posted public awareness posters in public areas. What type of communication method does this approach represent? Quick answers. फटाफट से आंसर करना है, ठीक है? अब देखो, public awareness posters लगाए हैं public areas में. That means a lot of people can go through this. So this is an approach. Which approach is it, everyone? Mass approach. Mostly the questions turn up from group approach. तो जो भी हमारे lecture होते हैं, या FGD है, या symposium है, all right, symposium, or for that manner panel discussion or conference, ठीक है, conference, seminar, workshop, demonstration, all of these are going to be your group approach. And one PYQ that had also come earlier for group approach was, guys, Delphi. अगर ये question repeat होता है, Delphi is an FMG PYQ. It is a technique of group approach. ठीक है? Let's go to the next question. Now I want some quick answers over here. Let's do one-liners for health education and communication. So what is the answer to the first one? All the one-liners we are going to cover here from health education and communication. The process by which individuals learn to behave in a manner conducive to promotion, maintenance and restoration of health, guys. ये क्या है? This is nothing but health education. ठीक है? Exchange of ideas, feelings and information in the field of health. Exchange of ideas, feelings and information in the field of health. ये क्या है हमारा? This is nothing but health communication. This is nothing but health communication. ठीक है? उसके बाद you have a communication cycle. So what is the communication cycle, guys? Let's revise once. Communication cycle. So there is a sender. Sender frames a message. The message goes through a proper channel. Channel से किसके पास जाता है, guys? Audience के पास जाता है. और audience से लिया जाता है एक feedback. Okay, so this is your health communication channel. And what is that ITA model? I hope you remember. Audience के through एक ITA model चलता है, which is awareness. Okay, awareness. The message should generate an awareness. It should generate an interest. So awareness, interest, evaluation होगा. उसके बाद क्या होगा? I'm going to try it. कि should I do this thing or not? Trial, and finally we are going to adopt. So this ITA model is again a PYQ that you have to remember for your exams. Awareness, interest, evaluation, trial, adoption. ठीक है? इसका आंसर क्या है? If you get this line, discussion of 4 to 8 experts in front of an audience. So what is this? When they discuss in front of an audience, it is going to be a panel discussion. ठीक है। 6 to 12 मेंबर्स के बीच अगर डिस्कशन होता है गाइज, 6 to 12 मेंबर्स, तब तुम्हारा आंसर क्या होगा? बजवर्ड्स बता रही हूँ अभी मैं, आई एम गोइंग टू गिव यू ऑल द बजवर्ड्स। 6 to 12 मेंबर्स मीन्स इट इज नथिंग बट फोकस ग्रुप डिस्कशन, ठीक है। सीरीज ऑफ 4 or more meetings under an expert, if they give you this question, it is going to be a workshop. And series of speeches on a given subject guys, it is going to be a symposium. ठीक है, मजा आ रहा है? Give me a thumbs up everybody. This is how we are going to revise. Whatever topic से FMG 2025 में questions आए हैं, we are going to take up those. Along with that, we are going to go through a quick one-liner from all those topics. So those are your high yield topics जो miss नहीं होंगे, ठीक है। चलो पूरा रिविजन हो जाएगा, टेंशन नहीं लेना है। चलो नेक्स्ट क्वेश्चन FMG 2024 का एक है, death rate continues to decline and birth rate starts to decline, reflects which phase of demographic transition model? 4-star question, demography transition model आना ही है एग्जाम में। What is the answer to this one guys? Very good. So birth rate starts to decline, okay, death rate continues to decline. It is which stage? Most of you got it correct, great guys, it is stage 3, the late expanding phase, okay। अब इसी से let's quickly have a look at our one-liners for demography. So what are the stages or the steps of a demography transition model? I hope you just look at these, okay। पहला step क्या होता है? जब birth and death rates both are high. So what is this? This is nothing but high stationary. This is nothing but high stationary. Birth and death both are high. So what is this? High stationary. All right. Next one, birth rate remains unchanged, but death starts to decline. So this is which stage guys? This is nothing but early expanding, early expanding. What is the third one? Birth rate starts to fall, death rate continues to decline. What is this phase? This is nothing but late expanding. Birth and death rate both low. This is nothing but low stationary. And what about this one? Birth rate is below death rate. So this we all know, this phase is nothing but the declining phase. This is nothing but the declining phase. So I've given you each of the phase, how the question would come. You should know that. Discussion अभी बहुत ज़्यादा नहीं कर सकते, ठीक है, हमारे पास time नहीं है. Now look at this question. This image was asked as an FMG PYQ. So you need to know this image guys. The name of this image is demography transition model. Also notice the markings. ये पहला line NEET PG में पूछा गया था. The original line over here is birth rate and this one over here is death rate. Pay attention to the marking, ठीक है. Now what is demographic gap guys? It is nothing but CBR minus CDR, ठीक है. Now which stage is the demographic gap minimum? कहाँ पे minimum होता है? So we all know it is in this one and it is in this one, stage 1 and 4. Where is the demographic gap maximum? It is over here. So ये कौन सा stage है guys? This is late stage 2. When does it start to contract? It starts to contract over here. So what is this stage everybody? Early stage 3. And where is it negative guys? Where is it negative? So it is negative in stage 5. It is negative in stage 5. ठीक है. Speed सबके लिए सही है. I mean the speed is okay for everyone. ठीक है. This is the speed I'm going to maintain. I hope I'm not going too fast, neither too slow. So let's continue. All right, now let us see this one. चलो आगे आ जाओ. Dependency ratio guys, मैं बता रही हूँ, I'm telling you, dependency ratio has come in INI-CET, NEET PG, FMG exam. So you will expect it either as a numerical or as a simple question. So what is dependency ratio? You all know it is children below 15 years, ठीक है, plus elderly beyond 65 years. They are dependent on the working class which is 15 to 65 years. ये कोई नहीं भूलेगा. You can also get it as a numerical. Now what is this next definition? Can anybody बता सकते हैं मुझे? Decline in dependency ratio due to decline in young age dependency. Again a PYQ. What is this? This is nothing but, I told you, this is nothing but demographic बोनस. बोनस का मतलब क्या होता है? कुछ अच्छी चीज, समथिंग गुड. सो व्हाट इज द गुड थिंग ओवर हियर? डिक्लाइन इन डिपेंडेंसी रेशियो. बट व्हेन आई हैव इंक्रीज इन डिपेंडेंसी रेशियो ड्यू टू इंक्रीज इन ओल्ड एज डिपेंडेंसी, एवरीबडी, व्हाट इज दिस? दिस इज नथिंग बट डेमोग्राफी बर्डन. ठीक है, बर्डन इज इंक्रीज, बोनस इज डिक्रीज. ठीक है, chalo, let's go to the next MCQ. Now let's see this one. What is the answer to this one? Again in FMG 2025, I will be covering all the questions that came in FMG exam during the year 2025 and unse related sare PYTs, I mean high yield topics. ठीक है, which out of the following health information collecting system provides data on registration of birth, death, infant mortality, abortion, marriage, contraception use? Please इसमें एक common mistake मत करना, इसमें कभी भी SRS आंसर नहीं है. This is National Family Health Survey, because SRS doesn't give you idea of marriage and contraception and abortion in pregnancies. ठीक है, इसमें NFHS is the answer. Now let's do one-liners from this slide. ठीक है, health information collection system. So what are the one-liners you can expect? Number one, which is the most efficient health information collection system? The best one is sample registration survey. सबसे अच्छा है. और SRS को और क्या बोलते हैं? Dual recording system, because there's a part-time enumerator and there's a full-time enumerator. Plus these are the data that you get: CBR, CDR, IMR, MMR, annual growth rate. Nothing else. Okay, so this one again is SRS. Then you get the estimates every year. Conducted once every 5 to 6 years. We have completed 5 rounds now. It is under International Institute of Population Sciences, Mumbai. This is nothing but NFHS. ठीक है? Conducted once every 10 years under Ministry of Home Affairs. This is a PYQ. ये क्या है बच्चे? This is nothing but census. ठीक है? Least information, least efficient health information collection system that supervises birth and death registration. दोनों कितने दिन में होना चाहिए? 21 days. What is this? This is CRS, Civil Registration System. And when I send a health worker to the field to collect the data, इसको बोलते हैं lay reporting. It was asked in UPSC exam. Maybe it can get repeated in NEET PG or FMG exam. Data collected by health workers in the field. ठीक है? And I had given you an LRR also. LRR में I have shared this PDF. The same PDF, I mean this क्या बोलते इसको? Table. Okay, I have shared it. So this same table you will have to go through in this session also. यहाँ पे मैं आपको ये बताना चाहती हूँ, de facto and de jure मत भूलना. Currently इंडिया का census de jure method पे है. ठीक है? So this you should know. Ministry of Home Affairs, this we have already discussed. It's a compiled table. Okay, let's go to the next question guys. Again a topic, fertility indicators. बहुत बार ये सवाल आ चुका है guys. चलो बताओ. Number of live births per 1,000 mid-year population. What is it that you're going to write as answers? Number of live births per 1,000 mid-year population. I'm going to, who will register? See, basically it is Registrar General Office, but जहाँ पे delivery होती है hospital, that is responsible, the responsibility उनकी होती है. ठीक है? Number of live births per 1,000 mid-year population. Some of you are writing TFR. No guys, ये क्या है? Crude birth rate. Okay, and mid-year population is again taken on 1st of July guys. ठीक है? Crude birth rate, please remember, is the simplest measure of fertility. It's the simplest measure of fertility. Crude birth rate is the simplest measure of fertility. Now denominator में mid-year population है, so not everybody is exposed to giving birth to a baby. So we made it a little more specific. Per 1,000 mid-year population and reproductive age group. What is this? General fertility rate. But again, not everyone from 15 to 49 years is equally exposed. So we made it married women. तो ये क्या हो गया? General marital fertility rate. ठीक है? Then certain buzzwords. If you see the word children, average number, या एग्जाम में लिख के आता है total number of children a woman will have throughout her reproductive years, which is computed by summing the age specific fertility rate. ये क्या होता है guys? TFR, total fertility rate. And this is an indicator of a famous PYQ, complete family size. All those students who have a doubt, please remember family side में सिर्फ बच्चे आते हैं. You will not include your mama and your papa. Okay. Now, if you see the buzzword girls, average number of girls that a woman will have throughout her reproductive years, assuming no mortality. Girls मतलब gross reproduction rate. ठीक है. But if you see this, a number of daughters a newborn girl will bear throughout her lifetime, assuming fixed age, specific fertility and mortality, guys. So when I say mortality dependent fertility indicator, ये क्या है? NRR. ये मत भूलना. ठीक है. This is very important and expected ones. Okay. Chalo, next one. Indicates prevalence of contraceptive practice. So you all know it is nothing but couple protection rate. Okay, it is nothing but couple protection rate. Now let me ask you one more thing. किसी भी कंट्री के पॉपुलेशन को स्टेबलाइज होने के लिए, दिस इज अगेन अ PYQ, फॉर अ कंट्रीज पॉपुलेशन टू स्टेबलाइज, व्हाट शुड बी द TFR? TFR शुड बी 2.1. 2.1 means 2 child norm, and this will be achieved when NRR मतलब 1 woman 1 girl child, and when contraceptive prevalence rate is more than 60%. ठीक है. अब बहुत सारे some of you guys have a confusion, ma'am, what is desirable TFR? Please remember, desirable TFR for any country is 2.1, or it could be written in the exam ideal TFR, that is also 2.1. ठीक है. हर country को ये achieve करना है. But if I ask you what is the current TFR of India, what is the current TFR of India? रब अब ये हो गया है 1.9. Towards the end of the session I will give you all लेटेस्ट अपडेटेड वैल्यूज. ठीक है. सो जस्ट वेट फॉर द एंड, जब मैं तुम्हें सारे अपडेटेड वैल्यूज बताऊंगी. ठीक है. दिस करंट TFR इज 1.1. और इंडिया कौन से फेज में है? आई होप यू ऑल रिमेंबर, इंडिया इज स्टिल इन द लेट एक्सपैंडिंग फेज. ठीक है. Okay, moving to the next question. Come on, FMG 2025. OCP can be advised safely to a woman in which of the following conditions? Breast cancer, congenital hyperlipidemia, liver disease, PID. ऐसा एक सवाल पक्का आएगा. ठीक है. OCP हो गया, IUD हो गया. We have also covered in LRRs, guys. So we are just doing a quick revision. Very good, everybody. Breast cancer का रिस्क बढ़ाता है, cervical cancer का रिस्क बढ़ाता है, liver carcinoma रिस्क बढ़ाता है, hyperlipidemia में एडवाइस नहीं है, PID. PID में what is contraindicated, guys? IUD is contraindicated in PID. But OCPs you can definitely use it. ठीक है. नेक्स्ट देखो एक और क्वेश्चन. OCPs are protected against the following cancers except. Which cancer is OCP protecting against? Like it's protective for all of them except. So what is your answer to this question, guys? Except में क्या लिखोगे? Very good. Cervical cancer. दो कैंसर जिसका रिस्क बढ़ाएगा. OCP increase risk. Okay. Cervical more important, and then I can say breast cancer. But if I have to mark one, I will go for cervical. OCP decrease risk. ये सारे ovarian, endometrial, colorectal cancer. ठीक है. Now same this thing I have also given you out in your LRR. ये टेबल वहां पे भी है. ये पक्का देख के जाना. Absolute contraindications of OCP. So this one is very important. CCC-ULT. Cult इसका pneumonic हो गया. Liver disease, thromboembolism, past or present. Indication of OCP आने की बहुत chances है, guys. Please do go through this list. We can give it in HIV/AIDS also, but of course in addition to a condom use. ठीक है. So do go through these lists also later. Chalo, let's go to the next question. Now tell me the answer to this one. Contraceptives, one-liners. OCPs protect against which cancers? Already discussed. So this protect against ovarian, endometrial, कोलोरेक्टल. ठीक है. कोलोरेक्टल हो गया. OCP इंक्रीज द रिस्क ऑफ कौन सा कैंसर का है? सर्वाइकल, ब्रेस्ट कैंसर. ठीक है. एडवाइस लिवर कैंसर्स. ठीक है. लिवर कैंसर में भी एडवाइस मत करना. एडवाइस दैट यू हैव टू गिव पोस्ट वेसेक्टोमी. प्लीज यूज अ कॉन्ट्रासेप्टिव. ठीक है. यूज अ बैरियर मेथड. यूज बैरियर मेथड फॉर हाउ लॉन्ग? यूज बैरियर मेथड फॉर 3 months और 20 ejaculations free, और कम से कम 20 ejaculations free, ठीक है, 20 ejaculations, 30 नहीं बोलेंगे कोई, 20 ejaculations. ये काफी एक्सपेक्टेड है. MTP एक्ट अच्छे से पढ़ के जाना. इन केस ऑफ कॉन्ट्रासेप्टिव फेलियर MTP इज अलाउड ओनली अप टू 20 वीक्स, ठीक है, ओनली अप टू 20 वीक्स, 1 डॉक्टर. 20 to 24 वीक्स में वी रिक्वायर 2 डॉक्टर्स, अदरवाइज नहीं. 24 वीक्स के बियॉन्ड भी हो सकता है MTP इन सर्टन सिचुएशंस, बट बाय द एक्सेप्टेंस ऑफ द मेडिकल रिव्यू बोर्ड. ठीक है, आगे बढ़े. चलो अब एक न्यूमेरिकल देखते हैं, ठीक है. वील जस्ट क्विकली गो थ्रू अ न्यूमेरिकल विच केम इन योर FMG 2025 बिकॉज आई थिंक यू विल गेट अगेन वन और द अदर न्यूमेरिकल गाइज. सो स्क्रीनिंग अ न्यूमेरिकल आई ऑलवेज वांट टू रिवाइज एट द एंड सो दैट यू डोंट मेस अप इन योर एग्जाम्स. गाइज देखो, टोटल 2000 पेशेंट्स assessed in HIV, 200 were confirmed positive. New ELISA screening test was conducted on the same group, identifying 260 positive cases, but only 130 of them actually had the disease. Calculate specificity. अभी रटना नहीं है, but please try to recollect without using any calculators. तो होगा एग्जाम में, but try to see 2000 क्या है guys, A plus B plus C plus D. Now 200 were confirmed positive. तो positive यानी disease, yes, 200 क्या है, A plus C. ठीक है, बट अ न्यू ELISA टेस्ट was conducted on the same group, identifying 260 positive cases. That means screening test positive, A plus B is 260, but out of them only 130 had the disease. All you need to figure out guys कि एग्जाम में A क्या होगा, B क्या होगा, C क्या होगा, D क्या होगा. That is very very important. So if you see over here, disease, HIV, yes, no. ठीक है, ये हो गया स्क्रीनिंग टेस्ट, पॉजिटिव, नेगेटिव, ABCD सारे को याद रखेंगे. ABCD, it's not like this, it's like this. And I hope you remember TP, FP एक बार रिवाइज कर लेते हैं everyone. FN and TN, first row all positives, second row all negatives. So this is your 200 and 260 positive, जिसमें से 130 is this. Now you are asked specificity. So specificity basically क्या होता है, TN upon TN plus FP into 100. So if you have this 260, now this is your 200. So ये कितना हो गया, total 2000 है. So this is 1800. 260 minus 130, 130 यहाँ, 1670 here. So I know you might feel it a little challenging guys, but देखो एग्जाम में आएगा ही. ट्राई टू फिगर आउट दैट व्हाट इज गिवन टू यू. डोंट पैनिक, इट्स नॉट नेसेसरी दैट एवरी टाइम आपको सारे नंबर्स याद करने होंगे या यूज करने होंगे. ठीक है, कैलकुलेटर आप यूज कर सकते हो. अब देखो, लेट्स क्विकली डू सम वन लाइनर्स फ्रॉम स्क्रीनिंग टेस्ट. प्रॉपर्टीज ऑफ अ स्क्रीनिंग टेस्ट आर दीज 3. ARV, acceptability, reliability, validity. ठीक है, what is the answer to this one? Ability of a screening test to differentiate diseased, all those who are true positives from true negatives. इसका आंसर है guys validity. ठीक है, वेरी गुड, गुड, यू डिडंट राइट सेंसिटिविटी, बहुत अच्छी बात है. दिस इज वैलिडिटी और एक्यूरेसी, ऑल दोज हु आर डिजीज्ड फ्रॉम नॉन डिजीज, सो वैलिडिटी. अबिलिटी टू आइडेंटिफाई ऑल दोज हु हैव द डिजीज गाइज, दिस इज योर सेंसिटिविटी. अबिलिटी टू आइडेंटिफाई ऑल दोज हु डू नॉट हैव द डिजीज, एवरीबडी, दिस इज योर स्पेसिफिसिटी. ओके, चलो अब आगे देखते हैं. What is the answer to this? Diagnostic power of a screening test to correctly include the disease. If I have come screening test positive, do I really have the disease? So what is this? Positive predictive value. Diagnostic power of a screening test to correctly exclude the disease. Negative predictive वैल्यू. ठीक है, जहां पे भी आपको डायग्नोस्टिक टेस्ट दिखेगा, इट इज प्रेडिक्टिव वैल्यूज. सिनोनिम्स ऑफ रिलायबिलिटी इज अ PYQ गाइज. इट इज नथिंग बट रिप्रोड्यूसिबिलिटी. ऑलराइट, रिप्रोड्यूसिबिलिटी, रिपीटेबिलिटी, कंसिस्टेंसी, प्रेसिशन. कंसिस्टेंसी, प्रेसिशन, all of these are the same terms for reliability. ठीक है, अब ये किसका फॉर्मूला है? कैन एनीवन इन द क्लास टेल मी? TP अपॉन TP प्लस FM. दिस इज द फॉर्मूला फॉर एवरीबडी. True positive. So this is sensitivity. TN upon TN plus FP, guys. This is the formula for nothing but specificity. But मैंने आपको एग्जाम के लिए golden rule दिया था. Everything positive. TP upon TP plus FP. Everything positive. PPV. Everything negative. What is this? NPV. And if you have to select only both diseased as well as non-diseased, TP plus TN, ये हो जाता है तुम्हारा validity. ठीक है, revision done of the numericals. So keep a note of this. Okay, one more. What is this? Time interval between first possible point of diagnosis and usual time of diagnosis. What are you going to write for this? First possible point of diagnosis and usual point of diagnosis. क्या है आंसर बताओ? Very good, guys. This is lead time. Screening time मत बोलना, lead time. But look at this. First point of diagnosis and critical point. Critical point is screening time. Okay, critical point is screening time. B क्या है? B is, what is B? B is the first possible point of diagnosis. This is the first possible point. First possible point of diagnosis means अभी there is no signs and symptoms. X क्या है? Critical point. X is the critical point. And what is Y? Y is the usual time. Usual time of diagnosis का मतलब क्या होता है? Signs and symptoms are present. So ideally we should apply a screening test at point Y instead of point B. So B to Y is your lead time. कर लोगे सारे इसको? B to Y is your lead time हो जाएगा सबको? चलो आगे बढ़ते हैं. फटाफट से कैलकुलेट करो. CFR एग्जाम में आ सकता है, SAR आ सकता है. कैलकुलेट केस फैटेलिटी रेट. लेट्स सी इफ यू कैन डू दिस एज क्विकली एज पॉसिबल. Out of 60 patients diagnosed with COVID, 12 cases of deaths reported. Calculate the CFR. So what is the case fatality rate, everybody? So it is the number of deaths due to a disease out of the total cases due to the disease into 100. So यहाँ पे कितने deaths हुए? 12. और कितने cases जिनको COVID था? 60 into 100. अब or very honestly speaking, यहाँ you can do it without a calculator or anything. We all know the answer is 20%. Okay, CFR and SAR. If time permits, I will also revise once SAR calculation. But now let me see how many of you remember this. What is the answer to this? Which indicator is used to measure virulence of disease or severity of disease? चलो जितनी जल्दी हो सकते हैं आंसर लिखो. Which indicator can calculate or measure virulence of disease or severity of disease? Very good, guys. Case fatality rate. Great. Okay, next one. Communicability of disease, transmissibility of disease. Communicability का आंसर क्या है? नेक्स्ट वन आ चुके हम लोग. Communicability और transmissibility of disease. This is nothing but secondary attack rate. The communicability. Great. Simplest measure of burden of disease अगर कोई पूछ ले, it is nothing but proportional mortality rate. The simplest measure. But if somebody asks you best measure for burden of disease, सबसे अच्छा measure burden of disease के लिए क्या है? What is the best measure for burden of disease? Please remember, best measure for burden of disease is always DALY. DALY is the best measure. Maximum DALY is due to cardiovascular diseases right now. ठीक है? And among mental illnesses, unipolar depression. DALY होता है YLL plus years of life lost due to premature death and years lived with disability. ठीक है? Okay, let's see this one. Which indicator? You have to mention a couple of indicators. Which indicator are you going to use to find out about the overall development of a country and population? कौन सा indicator use होगा? Overall, if I want to use one indicator, overall development of a country and this thing, overall development. See, when I have to talk about overall development, I will go for IMR. Why will I go for human development index? Overall development country की देखनी है, हम IMR से देख सकते हैं. Best indicator of availability, utilization and effectiveness of health services, again IMR. But if they ask you UN indicator, it is what? Under 5 mortality rate. ठीक है? Best indicator for combined obstetrics and pediatrics care, perinatal mortality rate. ये है पेरीनेटल, ठीक है, पेरीनेटल मोर्टालिटी रेट. बट इफ द क्वेश्चन ओनली मेंशंस socio-economic development, even if it's not written UN or anything, your answer will be U5MR. socio-economic development of a country के लिए guys हमारा indicator क्या है? अंडर 5 मोर्टालिटी रेट, ठीक है. सोशो इकोनॉमिक डेवलपमेंट के लिए अंडर 5 मोर्टालिटी रेट. HDI इज यूज्ड टू कंपेयर स्टैंडर्ड ऑफ लिविंग ऑफ कंट्रीज, ठीक है. HDI से आप क्या कंपेयर करते हो? आप कंपेयर करते हो स्टैंडर्ड ऑफ लिविंग ऑफ कंट्रीज. यू कंपेयर स्टैंडर्ड ऑफ लिविंग ऑफ कंट्रीज, ठीक है. सो डोंट गेट कंफ्यूज्ड. ऑलराइट. Okay, next one, let's talk about water. Disinfecting property of chlorine is due to, anybody in the comment section, disinfecting property of chlorine is due to, what are the agents that are responsible for disinfecting property? Sare batao, is it only HOCl? No, it is HOCl and OCl minus, hypochlorous acid as well as hypochlorite ion, dono hai guys. But major disinfecting property of chlorine is due to, major is due to HOCl, major is due to hypochlorous acid. These are direct MCQs, ठीक है. ये direct PYQ है. 90% disinfection is due to hypochlorous acid, but it is due to which other agent? HOCl as well as OCl minus. Chlorine acts best at which pH, everybody? 7. So you all know that. 100 grams bleaching powder releases 33 grams of free chlorine. Chlorine demand is measured by the instrument that you can see niche. This is what? Horrocks apparatus. And what is the indicator that we use in Horrocks apparatus, guys? Starch iodide. But the question that you can expect is ये वाला formula. N into 2 grams of bleaching powder can disinfect how many liters of water? 455 liters of water. And what is N, guys? N is equal to the first cup which shows color change. First cup which shows color change. इसको confuse मत होना. First cup which shows color change. That is your N. ठीक है. The point at which everybody chlorine demand is met, the point at which chlorine demand is met, this is known as breakpoint chlorination. Breakpoint chlorination. ठीक है. याद रहेगा सबको this formula, everybody? Okay. Now if I have to measure residual chlorine, what is it that I have to use? अगर मुझे residual chlorine या free chlorine use करनी है, so if I have to measure residual chlorine or free chlorine, हमारे पास कौन सा टेस्ट होता है? OTA and OT test. They are the months that can measure your free chlorine. ठीक है. So इससे just related pointers, true and false. Okay. OTA test is better than OT test. True. Yellow color change within 10 to 15 seconds is due to free chlorine. True. उसके बाद after 10 to 15 seconds it is due to free and combined chlorine. OTA test can detect both free and combined chlorine separately. True. ठीक है. OT test can detect free chlorine separately. OT test separately free chlorine detect करता है. True. But can OT test detect combined chlorine? True. But not separately. ठीक है. Separately OT test नहीं कर पाएगा. So these are just one liners, guys, that you should know for your exam because they have already come in the previous sessions. Okay, tell me the answer to this. Most reliable and efficient indicator of fecal contamination of water. What are you going to mark here? Most reliable and efficient indicator of fecal contamination of water. मैं options नहीं दे रही हूँ. Great. E. coli. Very good. But if the question was evidence of recent contamination of water, answer क्या है? Fecal streptococci, recent contamination, fecal streptococci. What about remote contamination? The answer is what, everybody? Clostridium perfringens. Okay, the answer is Clostridium perfringens. ठीक है. What about this screening test for E. coli, guys? So screening test का नाम क्या है? Multiple tube method, multiple tube method, or we could also call it as presumptive coliform test. What do we call it as? Presumptive कोलीफॉर्म टेस्ट. एक ही चीज है, प्रिजम्पटिव कोलीफॉर्म टेस्ट. बट अगर डायग्नोस्टिक टेस्ट कोई आपसे पूछे, द न्यूमोनिक इज EIC. दिस इज आइजकमैन टेस्ट, आइजकमैन टेस्ट. दिस इज इंडोल टेस्ट एंड दिस इज सिट्रेट यूटिलाइजेशन, सिट्रेट यूटिलाइजेशन. ठीक है. सो जस्ट अ कपल ऑफ वन लाइनर्स दैट यू शुड नो फॉर योर एग्जाम फॉर अ क्विक रिविजन. चलो, FMG 2025 safe drinking water guidelines. Anybody can tell me the answer to this? Which is not a acceptable limit? Which one is not within acceptable limits? फ्लोराइड बिल्कुल सही है, ठीक है. पानी में फ्लोराइड 0.5 to 0.8, सो दैट इज एब्सोल्युटली करेक्ट गाइज. नाइट्रेट पानी में कितना हो सकता है? अप टू, ऑलराइट, अप टू लाइक 50 मिलीग्राम पर लीटर. अगर पानी में नाइट्रेट है, इट इंडिकेट्स रिमोट कॉन्टैमिनेशन, ठीक है, रिमोट कॉन्टैमिनेशन ऑफ वाटर. एंड व्हेन आई से TDS अभी मैं बताती हूँ. द आंसर ओवर हियर इज कैडमियम. कैडमियम इज नॉट 0.3 मिलीग्राम, 0.3 माइक्रोग्राम होता है वो, ठीक है, नॉट मिलीग्राम, ठीक है. अब देखो, लेट मी शो यू सम वन लाइनर्स, क्योंकि ये एग्जाम में आ चुका है. ऑलराइट, मोस्ट अनडिजायरेबल मेटल इन वाटर इज lead. We allow a little bit of it, 0.01 milligram. That's okay. pH पानी में कितना acceptable है? 6.5 to 8.5. But chlorine acts best at pH 7. Softening of water is recommended at 150 milligram per liter. ठीक है. Temporary hardness of water and permanent hardness. So this is due to, if you talk about temporary hardness, this is calcium and magnesium salts of bicarbonates. Okay, it is bicarbonates. But if you talk about permanent hardness, calcium and magnesium salts of chlorides, CNS, chlorides, nitrates, and S for sulfates. ठीक है. TDS standards prescribed is 600, maximum permissible level 1000 जा सकता है, ठीक है. दिसका क्लोराइड्स का स्टैंडर्ड प्रेस्क्राइब्ड इज 200, मैक्सिमम परमिसिबल लेवल कैन गो अप टू 600, ठीक है. ये सब याद रखना. टर्बिडिटी 5 नेफ्लोमेट्रिक टर्बिड यूनिट. बट अगर पानी का टर्बिडिटी 4 नेफ्लोमेट्रिक टर्बिड यूनिट है, 4 NTU is visible to naked eyes. Okay, it's visible to naked eyes. So remember these couple of one-liners that you can get in your exams. Okay, most important air pollution indicator quickly. 15 true color unit or 5 Hazen unit. Very nice. मजा आ रहा है? Thumbs up in between. I need thumbs ups. Then we can go on with the session, guys. Most important air pollution indicator, exactly, SO2. But most widely distributed, सबसे widely and most common air pollution indicator, great, thank you so much. Let's move ahead. कार्बन मोनोऑक्साइड, ठीक है. मैकार्डल्स इंडेक्स क्या मेजर करता है? परमिसिबल स्वेट रेट विच इज 4.5 लीटर्स per 4 hours. Okay, this is nothing but permissible sweat rate. Nowadays there is so much of talk going on AQI, so मैंने सोचा एक बार रिवाइज करा ही देते हैं. कैटेगरीज देख लो. There is no very severe category. Okay, 401 to 500 is your severe category. कोई very severe category नहीं है, ठीक है. चलो, let's go to the next one. Housing criteria is expected this time. 1 person, कितना स्क्वायर फीट स्पेस दोगे उसको? 1 person 70 to 90 square feet, ठीक है. Floor space for 2 person, guys, 2 person is 100 to 110 square feet. Doors and windows 2/5 of floor areas. They should cover 2/5 of floor area, ठीक है. Window का height कितना होना चाहिए? Window का height होना चाहिए 3 feet above the floor, ठीक है. Roof up to 10 feet. This is the PYQ. Cubic feet of airspace. Per capita cubic feet airspace. At least 500 cubic feet airspace. If the word is cubic feet. Preferable कितना है? 1000 cubic feet. ठीक है. Daylight factor over more than 1% over half of the floor area. This is also a PYQ. Setback is the open space that we leave around our houses. So in the rural areas, it is 2/3. In the urban areas, guys, we don't have space. So this is 1/3. Clear? चलो, moving to the next question over here. Type of sanitation facilities provided for soldiers returning from war. A little bit of confusion some of you had, so I thought I'm going to discuss this. What is your answers over here? Pit method, dumping method, aqua privy, trench latrine. ये है trench latrine, ठीक है. ये सारे तुम्हारे the other methods that we have, that is not for soldiers, like they are not type of sanitation facilities we would prefer. So let me just sum up sewage for all of you and refuse. Best method for disposal of solid waste. Solid waste क्या होता है guys? Refuse होता है. तो solid waste या refuse का सबसे अच्छा तरीका क्या है? So it is controlled tipping. The name is controlled tipping or sanitary landfill. Very good guys. Sanitary. Dumping is most unsatisfactory. Sanitary landfill. Now isme you should know about these three methods. Trench method is kind of the best method, but it is actually a costly technique. और हमने क्या पढ़ा था? For a population of 10,000, 2 मीटर डीप ट्रेंच आपको डग करना है, फॉर विच कितना एकड़ लैंड चाहिए? 1 एकड़ लैंड, फॉर विच 1 एकड़ लैंड पर ईयर इज नीडेड. ठीक है. Area method guys, we need disused lands. Disused lands, this is one of the most common methods. ठीक है. Rural areas के लिए हम लोग अपने घरों के पीछे what do we construct? Manure pits. We construct manure pits. 2 pits can be constructed. And if you are going to go for a camp, how are you going to dispose the waste? Burial. Which is method is not preferred as a method for solid waste disposal? Please remember the answer is incineration. Incineration क्या होता है guys? It's को जलाना, like let's burn the waste. So now please remember, end product of solid waste disposal is manure, which is used in farming. So if any method which is not going to yield farming, we will not prefer it. Incineration is preferred only when land will not be available, then only we will use. इन सब methods को करने के लिए land चाहिए. ठीक है, land available. But जब land नहीं बचेगी, we obviously will have to burn the solid waste also. All right, sewage composition. Anyone in the comment section quickly बताओ sewage composition क्या होता है? So I hope you remember 99.9% water plus 0.1% solids. ठीक है. Which is the most important test done on sewage? It is biological oxygen demand. That's the most important. Strong sewage के लिए BOD का value more than 300 milligram. ये आता है, बहुत बार आता है. Also we can measure by suspended particle count. So for strong sewage, this is more than 500. ठीक है. Now you have sewage treatment plants. So primary sedimentation tank में SGS, if you remember, screening grid chamber sedimentation tank, which process is occurring over here? It is nothing but anaerobic process. ठीक है. Secondary treatment sewage, we can do it by activated sludge or we can also do it by trickling filter. But what is the method जो यहाँ पे हो रहा है? वो हो रहा है aerobic process. ठीक है. Activated sludge process का heart, this is a PYQ. Heart मतलब everything is based on that. So this is nothing but aeration tank. This is nothing but aeration tank. What about oxidation pond, ditches or lagoons which are used for smaller communities? So if you know, during daytime के दौरान aerobic is more than anaerobic. During day aerobic is more than anaerobic, and during night time anaerobic is more than aerobic. ठीक है. Aerobic process upper layers में होगा, anaerobic lower layers. Household treatment of sewage or smaller community, you will have septic tank. And what is the process? So inside the tank, inside जहाँ पे सब ढका हुआ है, ठीक है, inside the tank कौन सा process होता है guys? Anaerobic. And what about outside the tank? What about outside the tank? So outside the tank it is aerobic. This is one of the very expected slides for your exams. ठीक है, one of the most expected slides जो exam में आ सकता है. Bangalore method, somebody is writing. केतन लिख रहे हैं बैंगलोर मेथड. प्लीज याद रखना गाइज, CBI, इफ यू रिमेंबर, CBI वॉज कॉम्पोजिटिंग. ये है बैंगलोर मेथड और ये है इंदौर. दे आर सॉलिड वेस्ट डिस्पोजल मेथड्स. ठीक है, रेफ्यूज नॉट सीवेज, सॉलिड वेस्ट. बैंगलोर रिलाइज ऑन एनारोबिक, इंदौर रिलाइज ऑन एरोबिक. ठीक है, डन. चले. All right, let's go to the next MCQ. In a study, the recovery phase consists of which of the following? So just wanted to discuss quickly disaster in a couple of one-liners. बताओ. In a sudden onset disaster, the recovery phase, preparedness, response, rehabilitation, mitigation. क्या है आपका आंसर? क्या है everybody? या वेरी गुड। सो यहाँ पे एक मेरे से ही मिस्टेक हो गया है गाइस, ये 2 नहीं होगा, ये 1 है, ठीक है। रिस्पॉन्स एंड रिहैब आर, सो सॉरी, रिस्पॉन्स एंड रिहैब आर ऑलवेज इमीडिएट रिस्पॉन्स। ये देखो, रिस्पॉन्स, रिकवरी, रिहैब, दिस इज आफ्टर डिजास्टर स्ट्राइक। सो आई थिंक देयर वाज एन एरर इन मार्किंग। Preparedness and mitigation. Oh, I have been asked about, sorry, I have been asked about recovery phase, not before. Okay, so your answer is 2 and 3. Yeah, recovery phase पूछ रहे हैं. So the answer is 2 and 3. I have asked recovery phase. So don't get confused. I just showed you how you can get confused. Okay, if it was before disaster हो जाता preparedness and mitigation. ठीक है, ये recovery phase है. So response and rehabilitation. All right. Okay, so let's have a look over here. Before disaster is mitigation and preparedness, and after disaster is all of these phases. ठीक है, so phases of a disaster cycle पढ़ लेना. इसको बताओ, planning and legal measures to make communities safe and decrease the impact of resources disaster. ठीक है, mitigation क्या होता है? You have to prevent a hazard from becoming a disaster. और gather resources में क्या होता है? gather resources का मतलब होता है search capacity, how well we are equipped to fight a disaster. Mitigation most important आएगा guys before disaster strikes. ठीक है, all right, before disaster strike. So sorry for that. मतलब I was just showing you, okay, कि कहाँ पे इंसान मिस्टेक कर सकता है. मैं उसको पढ़ रिकवरी रही हूँ, but I'm telling you that it's before disaster. Okay, so it was just this thing. Don't get confused. All right. Now making buildings earthquake resistant. ये है mitigation. ओके, चलो आगे में चलते हैं. मोस्ट कॉमन डिजीज रिपोर्टेड पोस्ट डिजास्टर. सबसे कॉमन डिजीज जो पोस्ट डिजास्टर रिपोर्ट होता है, एवरीबडी, आई होप यू ऑल नो, जीआई इन्फेक्शंस. ठीक है, जीआई इन्फेक्शंस. चलो, मोस्ट कॉमन कॉलरा, टाइफॉइड, दैट्स करेक्ट. मोस्ट कॉमन विटामिन डेफिशिएंसी रिपोर्टेड पोस्ट डिजास्टर, वी ऑल नो इट इज विटामिन ए बिकॉज ऑफ मैलन्यूट्रिशन. ट्रायाज में गाइस मैं एक चीज क्लियर कर दे रही हूं, रेड इज 0 to 6 hours. दिस इज हाईएस्ट या हाई, दोनों. इट कुड बी एनीथिंग, हाईएस्ट और हाई प्रायोरिटी. हीमोथोरैक्स, न्यूमोथोरैक्स, ऑल ऑफ दोज थिंग्स. ओके, हाईएस्ट और हाई इज द वर्ड विद दिस. देन यू हैव येलो. ठीक है, येलो. इन सर्टन बुक्स इट कुड ऑल्सो बी ब्लू, दैट्स ओके. दिस इज 6 to 24 hours. You've stabilized a fracture, the person can wait. This is कौन सा प्रायोरिटी? मीडियम प्रायोरिटी. फिर है तुम्हारा ग्रीन. ग्रीन क्या है गाइस? एम्बुलेटरी, चल फिर रहा है आराम से. ठीक है, दिस इज लो प्रायोरिटी. एंड द लास्ट वन दैट यू हैव एवरीबडी, सो दैट इज ब्लैक. ब्लैक क्या होता है? डेड या मॉरिबेंड. ओके, डेड और मॉरिबेंड. डेड और मॉरिबेंड मीन्स दिस इज द लीस्ट प्रायोरिटी. प्लीज डोंट गेट कंफ्यूज्ड इसमें. ठीक है, सो अगर बहुत सिवियर कोई 3rd degree 4th degree burns है, it's not possible to save him that time. Okay, so accordingly you have to classify. Okay, long term sequel of disaster, some disease जिसका इफेक्ट काफी टाइम बाद तक भी दिखता है. So long term sequel is protein energy malnutrition. ठीक है, zoonotic diseases are very commonly reported. Most common zoonotic disease is leptospirosis, and to stay safe from leptospirosis we can distribute doxycycline tablets. Okay, distribute doxycycline. Diseases that take time to develop post disaster, so they are nothing but vector borne like malaria हो गया. ठीक है, malaria हो गया. You can also have, yeah, you can also see dengue and all that. ठीक है, but please never say filariasis and all, they are not seen. काला आजार ये सब नहीं दिखता है. All vaccines contraindicated in post disaster phase except measles. That too it will be given to children, that too within 0 to 3 days of exposure. Confuse मत होना. ठीक है, but what about health workers, those who are working in disaster endemic zone? Health workers को give all measles, I mean give all vaccines. सारे vaccines मतलब टाइफॉइड दो, कॉलरा दो, टेटनस दो, हेपेटाइटिस दो, except measles, because measles we give to children only. So is not needed over here. Ministry already done, Ministry of Home Affairs, ठीक है, Ministry of Home Affairs. What about World Disaster Reduction Day? This is second Wednesday of October. Guys, ये बहुत आने का चांस है. Home Affairs याद रखना. Census, in census we count the houses, so Home Affairs. In disaster, houses get disrupted, so again Home Affairs, ठीक है. All right, now quickly let's answer this one, guys. The time interval between entry of organisms and appearance of first sign and symptom. What is the answer to this one? Entry of organism and appearance of first sign and symptom. इसको क्या बोलते हैं? Incubation period. But what is the term which is given to non-communicable disease? इसको क्या बोलते हैं? Latent period. ठीक है? First case of infectious disease introduced in a population, primary case. But remember, primary case need not be the index case. ठीक है? Cases developing following exposure to a primary case, guys, ये हो गया तुम्हारा secondary case. Time interval between primary case, secondary case, एक episode से दूसरे episode तक. This is nothing but serial interval. And the first case to come to the notice of an investigator. So this is your index case. This is your index case. Time interval between entry of organisms and maximum infectivity, ये हो गया तुम्हारा generation time. बहुत आने का chance है. 50% cases to occur, ये हो गया median incubation period. And entry of organism to coming lab positive. Lab positive मतलब this is nothing but your window period. ठीक है? This is nothing but your window period. All right? Chalo. Let's go to the next one. Look over here. There is a term which is done for diseased people till period of communicability. What is that term? So what is that term? Is it isolation or is it quarantine? For diseased people, आप diseased people को क्या करते हो? Isolate करते हो. Isolation. ठीक है? But healthy people को आप separate करते हो for maximum incubation period. This is known as absolute quarantine. And don't have any confusion in your mind. They both are primary level prevention, guys. They are not secondary. They both are primary because they are acting as a risk factors. चलो, now let's quickly revise EPID. Everybody on the clock. इसका आंसर क्या था? ये हमने LRR में भी डिस्कस किया, but I just wanted to list out certain buzzwords for you. So I'm going to do that in EPID. See, aniline dye exposure, bladder cancer, two groups were formed. One group directly handling dyes, other group involving office workers not directly exposed to dyes. Now you can see past records. That means we are going backwards. When we go backwards, it could be a case control or a retrospective cohort. But if you go backwards and you divide into exposed, non-exposed, यहाँ पे handling dyes, that means they were what? Exposed. Office workers not directly exposed. तो ये क्या हो गया? Non-exposed. So what is this? The answer to this is retrospective cohort study. ठीक है? एक और question देखो. Yeah, a study was started in a university in 2000 with 10,000 individuals to evaluate the role of exercise and impact on hypertension in 2025. So identify the type of study design. अब इसको क्या mark करोगे? We have started in 2000 and we are looking at, we are proceeding from cause to effect or effect to cause. We are going from cause to effect. So which type of answer is this? I mean, क्या है इसका question? Prospective cohort study. ठीक है? So like I've always told you guys, approach पे ध्यान देना. Determine what is exposure, what is outcome. Look at the direction. Forward looking is prospective, backward looking is retrospective. Same point of time could be your ecological as well as cross sectional. अब देखो buzzword. An assumption yet to be verified. This is known as a hypothesis. Okay, which study design helps you formulate a hypothesis? So it is nothing but descriptive study. ठीक है? Descriptive study. Test a hypothesis के लिए you have which one everybody? Analytical study. But what about confirm a hypothesis? तो confirm a hypothesis के लिए we have experimental study. Experimental study. And which study design would you use for multiple exposures, guys? Multiple exposures. Multiple exposures. That means you're going from effect to cause. So multiple exposures के लिए क्या था? Anybody? Multiple exposures. It is nothing but case control. Multiple outcomes. It is nothing but cohort. Alcoholic, non-alcoholic. Now I can follow you up and I can study for cancer, hypertension, diabetes, so many things. Rare diseases के लिए what is the best study design that we are going to take everybody? Rare diseases we take case control. Rare exposure we are going to take cohort. Rare investigation कम chance है nested case control. So that you don't have to worry. Nested case control is like a prospective in nature. अभी उसके detail में नहीं जाएंगे, but one liners के हिसाब से एक बार देख लो. What is the measure of strength of association in a cohort study? This is highly expected relative risk. Relative risk is also known as everyone risk ratio. I hope you remember more than 1 equal to 1 less than 1. More than 1 risk factor equal to 1 no association, less than 1 protective factor. Case control study में odds ratio same, more than 1 equal to 1 less than 1. Incidence of disease exposed versus non-exposed, relative risk. ठीक है. Amount of disease proportion in the exposed group, this is attributable risk. And what is the largest prospective cohort study? I hope all of you remember, this is nothing but Framingham Heart study. Largest prospective cohort is Framingham Heart study. ठीक है. कर लोगे सारे कोई? Can we go to the next slide? Okay, look at this. Choice of study. इस स्लाइड को एक बार कर लेते हैं. If you are asked to calculate incidence, guys, which study design am I talking about? Incidence. Incidence is calculated from which study design? Please remember, cohort study. Prevalence is calculated from which study design? Cross-sectional study. Cause to effect. Cause to effect. Cause to effect मतलब smoking to lung cancer. Cohort study. Effect to cause, effect to cause. So what is this? Case control. But if you have a population study, correlation, इसमें word क्या था? Ecological study. ठीक है. Unknown disease, something new has happened, we don't know anything about it. So which study design we will use? Descriptive study. ठीक है. One point of time using primary data, cross sectional, but using secondary data, answer क्या है? Ecological. And what is the unit of study in ecological study design? I hope all of you remember the unit of study in ecological study design, guys, is population. कर लोगे. जैसे अगर एग्जाम में लिखा आया नोएडा, हैदराबाद, दिल्ली, यूके, कनाडा, that means we are referring to a ecological study design. ठीक है. Variable which is common to both exposure and outcome as well as independent risk factor for the outcome, काफी expected है, इसको बोलते हैं confounder. Known confounders in a case control, what was the technique, guys, that we will use? Matching. But both known and unknown confounder, what is the technique that you are going to use over here, everybody? We are going to use randomization. Known and unknown दोनों के लिए क्या था? Randomization. So matching will be your buzzword in a case control study design. Last but not the least, let's look at bias once, guys. If you see this word systematic error, systematic, जानबूझ के नहीं, we are making some error which is bringing about a faulty relationship between exposure and outcome. This is bias. कौन कौन सी स्टडी डिजाइन में recall bias, selection bias and interviewer bias दिखेगा? Case control study. Hospital admission bias is also known as Bergsonian bias. Bergsonian bias is a type of selection bias only. Okay, it is a type of selection bias only. Where do you see attrition bias and Hawthorne bias, guys? So you see this in cohort study design. Subjects modify their behavior on being observed. What is this one? Subjects modify their behavior on being observed. This is Hawthorne bias. And how do you treat bias? B for B, that is known as blinding. What is the most common method to eliminate bias, guys? सबसे common method bias को eliminate करने का क्या है? I hope you remember double blinding. But the best one, where subject and investigator both are unaware, but best method to eliminate the biases, guys, triple blinding. ठीक है, कर लोगे? All right, chalo, let's go to the next question. Let's see this one, guys. Gold standard for evidence-based medicine. The best study design is nothing but meta-analysis. And look at this image. Only I'm going to name the image for you. This is funnel plot and this is your forest plot. Forest plot is drawn only for meta-analysis, only for meta-analysis. But funnel plot is drawn for both systematic review as well as meta-analysis. Clear? Will you be able to do this? ठीक है. एक और question I wanted to discuss which came in last INI-CET, Hill's criteria. ठीक है. Most essential Hill's criteria is which one? Most essential is temporality. And temporality का मतलब क्या होता है? Cause precedes effect. If you smoke, then only you will go on to develop lung cancer. Least essential or most difficult to establish is guys specificity. ये दोनों का आंसर कोहॉर्ट है. ठीक है. Temporality was best established by cohort and natural history of a disease was also best established by cohort study design. ठीक है. Natural history होता है how a disease progresses without any intervention. Done. Thumbs up. Give me a thumbs up, guys. Now see, one liner again. What is the answer to this? All cases occur within one incubation period of the disease with rapid rise, rapid fall of cases, explosive in nature. Clustering of cases are within one incubation period. क्या नाम देना चाहोगे इस type of study design? I mean this type of epidemic को? Very good. Point source, or you could also say common source. But what about the exposure? The exposure is, I've got only one answer, single exposure epidemic. ठीक है. This is what? Single exposure epidemic. But all cases occur over more than one incubation period with secondary waves and prolonged plateau. This is common source. कौन सा exposure? This one is common source. Continuous exposure, common source, continuous exposure epidemic. But if you see the word person to person transmission, मतलब ये कौन सा epidemic है? Propagated epidemic. All right, this is propagated epidemic. Along with the images, I want you to revise. ये कर लेना revision. ये है तुम्हारा single exposure epidemic. Okay, this is single exposure epidemic. This is gradual rise over multiple incubation period. Non-explosive. This is your continuous exposure because image base आ चुका है exam में. And this one person to person transmission. So this is your propagated epidemic. Done. Okay. Plus everything is in this table. This table I have also shared in your LRRs. ये देख लो. Food poisoning, Bhopal gas tragedy, single exposure, contaminated well, commercial sex worker, infected milkman. ये सब क्या है? Continuous exposure, and this is your propagated epidemic. ठीक है. चलो. Now let us go to this revision. क्या बोलते हैं उसको? Biostats. Okay. Are you in for everybody? Biostats. Let's do in 5 minutes the entire biostats. Okay. Let's see how. Question FMG 2025. Vaccination status, gender of students and pain scale scores can be measured in which scale? क्या है answer? Vaccination status. Now the answer could be yes, no. Right? It's not an order. So it is nominal scale. Gender of patients, male, female, transgender. Again कोई order नहीं है. But pain scale क्या है? Order है. So nominal, nominal, ordinal. Please remember qualitative variables categorical होता है, nominal and ordinal, and quantitative variables are your measurable variables. ठीक है. So ये आप कर ही लोगे मेरे हिसाब से. चलो FMG 2025. Let's see. Let's revise this formula. In a group, the mean blood glucose level is 105 with a standard deviation of 10. Approximately, assuming a normal distribution, what is the expected range of blood glucose values for 95% population? So मेरे को सिर्फ ये रिवाइज कराना था guys. Mean plus minus 1 ST covers 68% observations. Mean plus minus 2 ST covers 95% observations. And mean plus minus 3 ST covers everybody 99%. So यहाँ आपको दिख रहा है 105 plus minus 10 but 95. तो 2 into 10 will cover 95%. तो आंसर क्या हुआ? Everybody got the same answer. Okay, 85 to 125. ठीक है. अब कुछ वन लाइनर्स देखते हैं. Sum of all observation divided by the total number of observations. This is nothing but mean. ठीक है. Statistically सबसे अच्छा measure central tendency का mean because we don't miss out any observation. Mean. Middle value when data is arranged in ascending or descending order. This is nothing but median. And when you have odd number of observations, median is the middle value. Also in the numerical it will help you. But when you have even number of observations guys. Median कैसे निकालोगे? It is going to be the average of the two middle values. Okay, भूलना नहीं. But most important, don't forget to arrange in an ascending order. You have to arrange it. ठीक है? Most frequent occurring value in any data set. So most repeated or frequent occurring value is mode. But if you have a skewed data जहाँ पे outliers है, outliers, skewed data, too high or too low values, what is the best measure of central tendency? Median. And in a skewed data, which is most affected measure is mean, and least affected is mode. ठीक है, least affected mode होता है, but most affected skewed observation में mean होता है, but skewed observation में best median होता है. Too high or too low values in a data set is known as outliers. ठीक है, चलो, measure, these were your measures of central tendency, mean, median and mode. Now see, what are the measures of dispersion? Let's quickly revise the formulas everybody. Range क्या होता है? So the range is maximum minus minimum, if you remember. Standard deviation का formula I want you to remember, summation mu I minus mu whole square by n. They can give you to identify the correct formula. If it is smaller than 30 sample size, summation mu I minus mu whole square by n minus 1 हो जाएगा. ठीक है, coefficient of variation, standard deviation upon mean into 100. And what about variance guys? Variance is standard deviation square. ठीक है, याद रहेगा सबको. Standard error of mean is standard deviation upon square root of n. Standard error of proportion is square root of pq by n. p होता है prevalence and q होता है 100 minus p. But if they give you to calculate confidence interval guys, तब formula मान लो 95%, mean plus minus 2 standard error of mean लिखना, not standard deviation. p plus minus 2 standard error of proportion. ठीक है, so you should know this one. ठीक है, स्क्वायर रूट का कैलकुलेशन नहीं आएगा. यू कैन ओनली गेट टू आइडेंटिफाई द करेक्ट फॉर्मूला फॉर योर स्टैंडर्ड डिविएशन. ऑलराइट, नाउ लुक, व्हाट इज नॉर्मल डिस्ट्रीब्यूशन? नॉर्मल डिस्ट्रीब्यूशन होता है मीन इज इक्वल टू मीडियन इज इक्वल टू मोड, ऑल आर इक्वल. बट व्हेन mean is equal to median is equal to mode is equal to 0, इसको बोलोगे standard normal curve. ठीक है, टोटल एरिया इज 1, इसीलिए मीन 0 होता है एंड स्टैंडर्ड डिविएशन इज 1. दिस यू विल नॉट फॉरगेट, हाईली इंपॉर्टेंट. राइट साइडेड स्क्यूनेस और पॉजिटिव स्क्यूड क्या है? मीन इज मोर देन मीडियन इज मोर देन mode. And what about left sided skewness guys? Mean is less than median is less than mode. कर लेंगे सारे कोई. This is very very easy. Mean plus minus 1 SD 68, 2 SD 95, 3 SD 99 and this is your 90%. Just an additional one I have given you. ठीक है, some common image which could get asked in your exam, although we have discussed the rest in our LRR. जहाँ पे भी आपको gap दिखेगा, wherever you see a gap, please remember gap is a 3-letter word, bar is a 3-letter word. So this is your simple bar. ये क्या है? Simple bar. But what about this one? This one is your multiple bar and this one is your component bar. Okay, component bar. And where you do not see any bar and any gap, okay, ये हो गया histogram. Histogram is meant for frequency of continuous variables. Okay, qualitative variables. ठीक है, चलो, definition based. True, null hypothesis true, 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 but rejected. ये कौन सा error है guys? This is type 1 error. I am not going to go into detail. I am just giving you a one-liner here, or you could also say it alpha error. But null hypothesis false, false but accepted. So ये क्या हो जाएगा everybody? Type 2 error. Type 2 error मतलब क्या हो गया? Beta error. P value is probability of type 1 error. कितना chance है type 1 error commit करने का? And if you ever get this value, P value 0.02, 0.03, less than 0.05, इसका मतलब क्या होता है? This is nothing but statistically significant. Okay, statistically significant, which means कि नया drug अच्छा है. And formula for power of this study 1 minus beta. Power of this study 1 minus beta. चलो, now let us see a question that came in FMG 2025, test of statistical significance. एक बार देख लेते हैं फटाफट से. A clinical trial was done between two groups to measure the blood pressure after treatment. Which of the following tests would be appropriate here? Okay, what is the answer over here? Very good. Two groups blood pressure, that means quantitative variable, और दो group है तो आंसर क्या हो जाएगा? Unpaired t-test. Okay, what is the answer? Unpaired t-test. I hope you remember this. Whenever you get a question, सबसे पहले देखना quantitative है या qualitative variable है. So if you have to compare qualitative variable between two or more than two groups, your answer will be chi-square. ठीक है, but if you have to compare quantitative data, means and SDs in one single group, it is कौन सा? Paired t-test. But if you have to compare in two groups, it is what? Unpaired t-test. Okay, और three or more than three groups में क्या है? ANOVA. ठीक है. Very good. So this you should be able to do it. सबको समझ आ रहा है? Can I go to the next question, guys? And one more thing, these are the names of the test which I have discussed before also. Parametric test quantitative variables के लिए use होगा, non-parametric qualitative variables के लिए. Alphabets parametric, hi-fi fancy names are going to be your non-parametric tests. Clear? Can we go to the next one? अब देखो, every kth या nth interval is selected. मान लो क्वेश्चन में आया every 10th person, every 25th person, every 7th person is selected. What is your answer? Everyone in the comment section इसको लिख के दिखाओ. Every kth और nth. Very good. The first one to answer, Abdul. Very good, guys. Systematic random sampling. Good. Heterogeneous population को homogeneous में convert करोगे stratified. And this is the most efficient. सबसे अच्छा होता है. ठीक है. Sampling frame where I need a list of all the people. This is simple. Simple random. Simple random is done for homogeneous groups. ठीक है. Then what is the answer to this? 30 into 7 हमने किस में लिया था? Cluster random sampling. And hidden population के लिए which is it? Snowball. Like commercial sex workers, migrant population, homeless population. So it is snowball. ठीक है. Now we come to the last two things. We'll be revising vaccines as well as we'll be covering a couple of diseases and national health programs. ठीक है. Another half an hour में we will try to look at the remaining things. What is your answer here? FMG 2025. 32-year-old traveled to Africa, reported fever. Which vaccine if he had taken पहले he would not have developed this. Very good. इसका आंसर है 17D. तो कुछ कॉमन स्ट्रेन्स जो पता होने गाइज, और 17D का वैलिडिटी लास्ट्स लाइफ लॉन्ग. आई होप यू नो वैलिडिटी ऑफ सर्टिफिकेट लास्ट्स लाइफ लॉन्ग. ठीक है, वैलिडिटी लास्ट्स लाइफ लॉन्ग. जेरिलिन इज मम्स. ठीक है, फैंसी नेम. एडमॉन्स्टन जैग्रब एवरीबडी इज मीजल्स. ठीक है. ओका के से चिकन पॉक्स. ऑल राइट, ओका से चिकन पॉक्स. सो यू शुड रिमेंबर. देन आई ऑल्सो टॉट यू ड्यूकोरल सैंशॉल बिकॉज दिस केम इन योर नीट पीजी. दे कुड आस्क यू, ये है कॉलरा का स्ट्रेन्स. ठीक है. उसके बाद SA 14-14-2 एक देख लो. SA 14-14-2 इज जेई का विच वन इज दिस? लाइव. बट इन इंडिया नाउ वी हैव स्टार्टेड यूजिंग जीव ऑल्सो यूजेस किल्ड स्ट्रेन ऑफ SA 14-14-2. ठीक है, बट ये है तुम्हारा किल्ड. And of course we have Genvac. Genvac is again the polar strain. ठीक है, polar strain. That is also a kill strain. Got it? So you should remember these couples of vaccines, strains जो exam में पूछ सकते हैं. ठीक है. FMG 2025 measles vaccine is which type of vaccine? So you should also be doing the classification of vaccines. बताओ. मीजल्स वैक्सीन किस तरीके का वैक्सीन है? यू ऑल नो मीजल्स वैक्सीन इज अ लाइव वैक्सीन. सो आई हैव मेड यू अ लिस्ट. दिस इज द क्लासिफिकेशन विच आई हैव ऑलरेडी रिटन फॉर यू. आई लव चिकनब्रायो. सो इसमें आई से इन्फ्लुएंजा, चिकन पॉक्स हो गया, ओका स्ट्रेन, जे मीजल्स, BCG, रुबेला, येलो फीवर and OPV. ठीक है. किल्ड में आई वॉन्ट यू टू रिमेंबर दिस. डॉग बाइट से रेबीज इज अ किल्ड वैक्सीन. इट कुड बी गिवन टू एनीबडी. TT NIS में नहीं देते हैं. NIS में वी गिव TD वैक्सीन्स. पॉलीसैकेराइड कॉन्जुगेट, दीज आर ऑल सब यूनिट वैक्सीन्स. एंड पेंटावैलेंट, आई होप यू रिमेंबर, कवर्स 5 डिजीजेस: डिप्थीरिया, pertussis, tetanus, Haemophilus influenza as well as hepatitis B. And hepatitis बी अलोन, अगर कोई आपसे पूछे हेपेटाइटिस बी अलोन, दिस इज विच टाइप ऑफ वैक्सीन गाइज? हेपेटाइटिस बी अलोन. सो दिस इज अ रिकॉम्बिनेंट टाइप ऑफ वैक्सीन. हेपेटाइटिस बी अलोन इज अ रिकॉम्बिनेंट वैक्सीन. व्हाट इज द आंसर टू दिस? NIS रिवाइज करना है. व्हाट इज द करेक्ट फ्रैक्शनल डोज ऑफ IPV वैक्सीन? एनीबडी? करेक्ट फ्रैक्शनल डोज ऑफ IPV वैक्सीन. सो IPV इज इनएक्टिवेटेड पोलियो वैक्सीन. कब कब देते हैं इसको? 6 वीक, 10 वीक्स, 6 वीक्स, 10 वीक्स, 14 वीक्स? नहीं नहीं, ऐसे गड़बड़ क्यों हो रहा है? IPV में गड़बड़ क्यों हो रहा है? व्हेन डू यू गिव इट? 6 वीक्स, 14 वीक्स एंड वी ऑल्सो गिव इट एट 9 months. ये आप कंफ्यूजन नहीं कर सकते गाइस. ये देखो, एवरीबडी लुक एट दिस IPV का, आई मीन NIS का स्केड्यूल. बर्थ, BCG, OPV, हेपेटाइटिस बी, 6, 10, 14, OPV 1, पेंटा 1, रोटा 1, PCV 1, FIPV 1. 10 weeks, OPV 2, Penta 2, Rota 2, but 14 weeks we have FIPV 2. And when is the other dose? 9 months, FIPV 3. ठीक है. और 9 months में और क्या देते हैं? विटामिन A, जो आपको पता है 1 ml और 1 lakh international unit. Thereafter every 6 months till 5 years of age 2 ml और 2 lakh international unit. Please don't mess up NIS guys. This is not expected. अभी एकदम लास्ट मोमेंट में आप NIS मिस नहीं कर सकते हो. 6 weeks, 10 weeks, 6 weeks, 14 weeks, and when do we give it? 10 weeks नहीं, 6 weeks, 14 weeks, and we give it at 9 months. ठीक है. All right. What is the answer to this? FMG 2025 vaccine which was contraindicated in pregnancy. So pregnancy में हम लोग कौन से वैक्सीन नहीं देते हैं guys? Pregnancy में we don't give live vaccines, right? So varicella is the live vaccine that you are not going to give. Now you will have this in the presentation, all the चार्ट ऑफ कॉन्ट्राइंडिकेशंस. इसको देख के जाना है. ठीक है. प्रेगनेंसी और लाइव वैक्सीन कॉन्ट्राइंडिकेटेड एक्सेप्ट येलो फीवर. लैक्टेशन में येलो फीवर भी मत दो. जनरल कंडीशंस है फीवर, डायरिया, हल्का फुल्का कफ एंड कोल्ड. कोई भी वैक्सीन ऐसा नहीं है विच इज कॉन्ट्राइंडिकेटेड. ठीक है. HIV में नाउ फॉर सिम्टोमैटिक HIV इन अ न्यूबॉर्न वी डोंट इवन गिव BCG, अदरवाइज देयर इज रिस्क ऑफ डिसेमिनेटेड TB इन्फेक्शन. ठीक है. एपिलेप्सी, प्रोग्रेसिव न्यूरोलॉजिकल डिजीज, वी ओनली वरी अबाउट पेंटा एंड DPT बिकॉज ऑफ पर्टूसिस कॉम्पोनेंट. बट ये देखो, एग एलर्जी क्वेश्चन है. येलो फीवर एंड इन्फ्लुएंजा इज नॉट मेंट टू बी गिवन. नियोमाइसिन, मीजल्स वैक्सीन नहीं देना है. एब्डोमिनल सर्जरी अगर किसी को हुई है, रोटावायरस कॉन्ट्राइंडिकेटेड. व्हाई गाइस? बिकॉज रोटावायरस लीड्स टू इंटरसेप्शन. ठीक है. All vaccines, anyone who suffers from anaphylaxis to previous dose, सारे vaccines, but live vaccines you will not give in all of these conditions. ठीक है. सबको याद है इंटरसेप्शन, रोटावायरस. ठीक है. आई विल टेल यू NIS once I finish the schedule chapter. ठीक है. All right. ANM worker has to conduct vaccination camp in a village. She received 2 open vials. One is Penta and the other is MR vaccine. Which statement is true regarding utilization of this? So you all know open vial policy. You can reuse up to 4 weeks provided they fulfill certain conditions. You will discard MR and you're going to use Penta because reconstituted vaccines open vial policy follow नहीं करता. ठीक है. So if you see over here, reuse of partially used multi-dose vials in subsequent sessions up to 4 weeks. Vaccines which follow open vial, all T series vaccine plus PIO प्लस JE killed. लाइव JE नहीं फॉलो करता है, किल्ड JE फॉलो करता है. एंड ऑल T सीरीज मीन्स रोटावायरस, DPT, पेंटा, TT, TD. ठीक है. सब में जिसमें लेटर T है दे फॉलो. हेपेटाइटिस, ओके, दे फॉलो. PIO से PCV, IPV and of course what do we have? OPV. That do not follow the reconstituted ones. So this you can see reconstituted ones में तुम्हारा आ गया BCG. BCG का डाइल्यूएंट क्या है? सोडियम क्लोराइड या नॉर्मल सलाइन. मीजल्स का क्या है? योर आंसर शुड बी बेटर देन डिस्टिल्ड वाटर, स्टेराइल वाटर. JE में आंसर क्या है गाइस? फॉस्फेट बफर, फॉस्फेट बफर. एंड येलो फीवर में वी हैव कोल्ड saline, cold saline. Clear? Will you be able to do this? Okay. Couple of more things. Two things more I wanted to tell you. सबसे heat sensitive vaccine is are bombs. So most heat sensitive vaccine is reconstituted BCG. ठीक है, कभी मत बोलना OPV. OPV is second in number. फिर है तुम्हारा measles. But most heat sensitive is R-bomb. And most freeze sensitive, जो freeze से सबसे जल्दी डैमेज हो जाता है, हेपेटाइटिस बी. ठीक है. Next, loss of vaccine, potency of vaccine to heat. You all know VVM. ये तुम्हारा VVM है, इसको पढ़ के जाना है, इसको use करेंगे. These are the two things we are not going to use. Inner square lighter than outer circle use. Inner square darker or same color do not use. ठीक है. Loss of potency to cold में what is it that we do? We do what is known as the shake test. ठीक है. Yes, yellow fever, cold saline. ठीक है. Maximum failure of cold chain you are going to expect at subcenter everybody. Vaccine carrier में कितने vaccine vials can carry? 16 to 20 vaccine vials lined by 4 ice packs. Day carrier can carry 6 to 8 vaccine vials lined by 2 ice packs. सबसे bottom most of ILR देख लो, OPV है, hepatitis B सबसे ऊपर है, that's why I've summed it up. And what do we use to monitor temperature? A dial thermometer. We use dial thermometer. Clear? Okay, coming to the last few things, guys. Let's revise biomedical waste and then we will have a look at certain national health programs and healthcare delivery system. ठीक है, चलो आंसर दो. Cotton swabs used for cleaning a wound contaminated with pus should be disposed in which color bag? अब इसमें guys confuse मत होना. All the bags are meant to be non-chlorinated. They are not chlorinated. Otherwise, they release polyvinyl chloride, which is very dangerous. ठीक है. Chalo, one more question. Identify the correct statement. Syringe with needle should be disposed in a black translucent container. Is it correct? No. Syringe with needle has to go in a white container. Used cotton swab should be discarded in a red bag. No, it should be discarded in a yellow bag. Used vaccine needle should be bent and thrown in a red bag. No, needle white में जाएगा. Used vaccine vial, अगर कभी question आया vaccine vial, ठीक है, blue bag. Broken vaccine vial, blue bag. Is it clear everybody? Please remember these are the couple of things that you should know. यहाँ पे जितने first में list हैं, ठीक है, all these things they go into yellow bag. इसको पढ़ना है आपने, ठीक है, which is important. अगर vaccine vial में vaccine vial which is like discarded, okay, expired vial, something that has vaccine in it, it will go in a yellow. All right, gloves, recyclables, plastic tubes, vacutainers, syringes without needles, any tube kind of structure, IUD, they are all going to go into red bag. Guys, gloves soiled हो unsoiled हो, they are going to go into red bag. Blood bag हमेशा yellow में जाएगा. Blood bag is going to go into yellow bag. But if I talk about urine bag किस में जाएगा? Red में जाएगा. Sharps and other metals white में जाएगा. ठीक है. And this one of orthopedic implants, glasswares as well as pacemakers, ठीक है, they are all going to go into blue bag. ठीक है. वैक्सीन वायल लिखा हो, ब्रोकन वैक्सीन वायल, all of them are going to go into blue bag. Please don't mess out this. Last time they ask you this symbol, guys. This symbol we have done in our RRs also. ये recyclable का symbols है. 3 R's. Reduce, recycle, reuse. ठीक है, ये biomedical waste है. And this one over here is a radiation hazard. The symbol was asked last time, so you cannot mess it up. It can come again in your exams. ठीक है. All right, now let us have a quick look at some of the initiatives that we have. Minimum antenatal visits according to WHO is 8. According to Government of India is 4. Minimum postnatal visits is 3 to 4. But if somebody asks you ideal ANC visits कितना होना है? 13 to 14. Don't get confused. All right. Then I hope you remember this one. To increase institutional delivery, JSY, Janani Suraksha Yojana. Free service for pregnant and sick infants, this is JSSK, Janani Sishu Suraksha कार्यक्रम. 9th of every month, प्रधानमंत्री सुरक्षित मातृत्व अभियान, free antenatal visits 9th ऑफ एवरी मंथ लगाना है हाई रिस्क प्रेगनेंसीज को आइडेंटिफाई करने के लिए, ठीक है. लेबर रूम क्वालिटी क्या है गाइस? लेबर रूम क्वालिटी इज लक्ष्य. Trained doctors for and ENMs for intrapartum and immediate postpartum care, दक्षता. Maximum maternal mortality postpartum period में होती है, don't forget. And something where we are guaranteeing services, all right, zero tolerance to non-denial of services. This is सुरक्षित मातृत्व आश्वासन, the सुमन scheme. 4Ds के लिए ये क्या था गाइस? राष्ट्रीय बाल स्वास्थ्य कार्यक्रम. वी हैव टू स्क्रीन फॉर 4Ds और इसमें चेकअप बाई एनुअली करना है, ठीक है, बाई एनुअल चेकअप. 10 to 19 ईयर्स अगेन राष्ट्रीय किशोर स्वास्थ्य कार्यक्रम में हम लोग बेसिकली 10 to 19 ईयर्स को देखते हैं, बट अगर स्क्रीनिंग वर्ड यूज हुआ 10 to 19 ईयर भी राष्ट्रीय बाल स्वास्थ्य कार्यक्रम में आता है. Now I'm not going to discuss these logo, but I hope you remember प्रधानमंत्री सुरक्षित मातृत्व अभियान का लोगो है, ये वाला तुम्हारा लक्ष्य का लोगो है, because these are certain things which is expected. This is मातृ वंदना योजना, 6,000 इंसेंटिव देना है इसमें, 5,000 इंसेंटिव in 2 installments. This you should know. This is your सुमन initiative, ठीक है. Home based newborn care, everybody should remember number of visits 7, 6 in case of hospital delivery, 5 in case of C-section. So a couple of things that you could be asked in your exams. All right, now let us have a look at another MCQ. What is your answer to this one? Now we are just going to see healthcare delivery system and a couple of national health programs logo. Then we will wrap up the session. A woman with a history of schizophrenia presents to PHC. The medical officer of the PHC should take to which government portal to book an appointment. Guys, Telemanas एक psychiatric consultation के लिए है, ठीक है. Now NEET and all, you all know it is for TB. UN 0 to 5 years वैक्सीन एंट्री के लिए बच्चों के लिए. मेरा अस्पताल इज क्वालिटी एश्योरेंस, हॉस्पिटल में सर्विसेज सही चल रही हैं कि नहीं. दिस वी हैड डिस्कस्ड इन आवर दिस थिंग ऑल्सो. दिस इज द लोगो ऑफ टेलीमानस, ठीक है. ये हो गया अनमोल, ये सेफ फैक्ट. दिस इज इवन विच इज टॉक्स ऑफ वैक्सीन एंड दिस इज अ यूविन पोर्टल, ठीक है. नाउ आई होप यू ऑल रिमेंबर this question. Can you do this one? I'm going to make a diagram for all of you, ठीक है. So let's see if you can answer this one. ये हो गया 1, ये हो गया 2, ये हो गया 3. क्या है इसका आंसर? 1, 2, 3. इसका आंसर क्या है? वेरी गुड. 1 is your sub centers, primary level PHCs, 2 is your CHCs, sub district hospital, district hospital, and 3 is your medical college and super specialty hospital. ठीक है, दिस इज एन इम्पॉर्टेंट वन. प्लस आई हैव रिटन एवरीथिंग फॉर यू. वी कैन ऑलवेज हैव अ लुक एट दिस. सब सेंटर्स का पॉपुलेशन, प्लेन एरिया 1 per 5,000, हिली एरिया 1 per 3,000. सेम PHC एंड सेम दिस वन you should know. For CHCs also you should know the this thing. Category is very important, more important for type A and type B PHC. Type A less than 20 deliveries per month, type B more than equal to 20 deliveries per month. Total staff, ठीक है, स्टाफ के नंबर्स उतना इंपॉर्टेंट नहीं है. पॉपुलेशन एंड कैटेगरीज आर मोर इंपॉर्टेंट एंड ऑल्सो यू हैव द बेड्स विच आर इंपॉर्टेंट. टाइप ए PHC में 4 to 6 बेड्स है. टाइप बी PHC में एवरीबडी 6 to 10 बेड्स है, विच कुड बी आस्क्ड. रूरल CHC में मिनिमम 30 बेड्स है एंड मैक्सिमम 50 बेड्स है. ऑलराइट, प्लस बेड में इतना कंफ्यूज नहीं होने का जरूरत है. प्लीज रिमेंबर PHC 4 to 6 to 10, that's it. And rural CHC, it's a CHC giving us so many services, so minimum 30 beds and maximum 50 beds. This is your urban health center. So this is urban areas में you must know ये वाला urban PHC. This is important. 1 per 50,000, highly expected. Urban CHC metro city 1 per 5 lakh population. Urban CHC non-metro city 1 per 2.5 lakh population. ठीक है. And this one you should remember. USHA FMG 2025 में आया था 1 per 1,000 to 2,500. अगर एक वैल्यू उठाना है this will be 2,000. क्लियर, एवरीबडी कर लेंगे ये वाले क्वेश्चन. ओके, वन मोर थिंग आई वांटेड टू डिस्कस ओवर हियर. बताओ इसका आंसर फटाफट से. हु इज रिस्पॉन्सिबल फॉर मेंटेनिंग द एलिजिबल कपल रजिस्टर फॉर फैमिली प्लानिंग, मेंटेनिंग द records and distributing oral contraceptives under National Health Mission? So what is your answer over here? Eligible couple register n number of times आ गया है. Multi-purpose worker female और like we also say ANM. ठीक है. मल्टीपर्पज वर्कर मेल का काम याद रखना क्लोरीनेशन है, क्लोरीनेशन है. ऑल्सो प्रिपेयर मलेरिया स्लाइड्स. ओके, मलेरिया स्लाइड्स, एक्टिव मलेरिया सर्वेलेंस है. एंड कलेक्ट स्प्यूटम सैंपल्स, कलेक्ट स्प्यूटम सैंपल्स. ठीक है, कलेक्ट स्प्यूटम सैंपल्स. डोंट मिस आउट ऑन दिस वन बिकॉज दिस इज इंपॉर्टेंट. अब देखो, ग्रास रूट लेवल 25 to 40 year old, 10th pass, resident of local community, married, widow, divorced, selected by village panchayat, duration of training 23 days, trained by ANM Anganwadi worker, existing population norm 1 per 1000. Asha 2 per 1000 is proposed. ठीक है, in this I have summed up everything for you. No educational qualification, receives 30 days training, existing population now 1 per 1000, main role conducts delivery, trained birth attendant. ठीक है. 6th pass, receives 3 months of training with existing population norm 1 per 1000, main role health education, village health guide. ये मेल्स भी हो सकते हैं गाइस, बट हम लोग प्रेफर फीमेल करते हैं. 10th pass full, just like Asha worker, 10th pass, 4-month training, plain area, Anganwadi center 1 per 400 to 800, hilly area 300 to 800. ठीक है, ये कौन है? आंगनवाड़ी वर्कर है. शी इज नन अदर देन आंगनवाड़ी वर्कर. याद रहेगा सबको, एवरीबडी. ऑलराइट, प्लीज रिमेंबर ANMs जो होती है ना, दे हैव टू बी 12th pass, okay, and 12-month training. What was the answer to this one? A factory worker suffered burns involving 25% of his body on duty. He later developed infections and related complications under ESI Act. Which benefit he has to receive, guys? Extended sickness benefit. तो ये benefit का चार्ट वापस से रिवाइज करके जाना है. इसमें everything is mentioned for all of you. This is an important one. ये देख लो, extended sickness benefit is for 34 days, more than 20% burns with infections and complications भी इस पे आता है. ठीक है, funeral expenses is 15,000. and if you talk about medical benefit, guys, medical benefit तुम्हारा cashless benefit है only. It's given for direct medical care and direct as well as indirect medical care. Okay, what's the answer to this one? फटाफट बताओ. Chronic smoker who has worked in a cement factory, cement factory but अभी mesothelioma लेके आए, तो आंसर क्या होगा गाइस? देखो, अगर सीमेंट फैक्ट्री अकेले आए, सीमेंट फैक्ट्री मोर एसोसिएशन विद सिलिकोसिस, बट द क्वेश्चन मेंशन्ड mesothelioma, therefore the answer is your asbestosis. Otherwise single handedly cement factory is silicosis. Sorry, not this one, पहले ये वाला. Most dangerous size of dust particles that we inhale, it is point. What is the most dangerous size? Let me see if you remember. Don't say 0.5 to 3 micron. Up to 5 micron मत बोलना. 0.5 से 3 micron. Most common pneumoconiosis, most common cause of death, disability is all silicosis. ठीक है, प्लस सिलिकोसिस टीबी के साथ एसोसिएट होता है, वो आपको याद रखना है. स्नोस्टॉर्म अपीयरेंस, वो मैंने आपको LRR में भी पढ़ाया था. ग्राउंड ग्लास एस्बेस्टोसिस, दैट वी हैव डिस्कस्ड इन LRR. ठीक है, ओके. अंडर IDSP, सेंटिनल सर्वेलेंस इज कंडक्टेड फॉर विच? FMG 2025. नाउ वी कम टू द लास्ट पार्ट, द नेशनल हेल्थ प्रोग्राम. ठीक है, ओके. मेडिको ट्रैवलर, जस्ट मेक अ नोट ऑफ इट, आई विल टेल यू एट द एंड. सेंटिनल सर्वेलेंस किसके लिए करते हैं गाइस? सेंटिनल सर्वेलेंस इज व्हेन वी मिस आउट ऑन केसेस. वी कांट रिलाई ऑन एक्टिव as well as passive surveillance, so we rely on HIV and hepatitis B. ठीक है, ये है इंटीग्रेटेड डिजीज सर्वेलेंस प्रोग्राम का लोगो. दिस इज इंपॉर्टेंट. 3 फॉर्म फिल होते हैं, SPL, सस्पेक्टेड फॉर्म्स. ठीक है, जो हेल्थ वर्कर फिल करते हैं, हेल्थ वर्कर दे फिल सस्पेक्टेड फॉर्म. दिस इज प्रोबेबल फॉर्म जो कि फिल होगा बाय मेडिकल ऑफिसर, एंड दिस इज द लैब कंफर्म्ड फॉर्म. Okay, data which is reported to health system, please remember this is passive surveillance. And when we go house to house looking for cases, this is active surveillance. And when we select from certain medical colleges, when we are missing out cases, we can't rely on active and passive surveillance, then guys we have sentinel surveillance. Clear kar lenge sare koi this one? Okay, yellow fever control is a very famous question. Type of vaccine 17D already discussed. Immunity starts from 10 days of vaccination. Validity of vaccination certificate lasts lifelong guys. Quarantine period 6 days है और Aedes aegypti index को below 1% हमें रखने की जरूरत है. ठीक है, चलो, आयुष्मान आरोग्य मंदिर is the correct name now. We don't call them sub centers, we don't call them PHCs, we don't call them CHC, we don't call them sub centers and PHCs. We upgraded. पहले उनको बोला था health and wellness centers, अब क्या बोला? आयुष्मान आरोग्य मंदिर essential drugs. This I had taken up in LRR also, so आयुष्मान आरोग्य मंदिर. But please remember urban area में sub center term use नहीं होता, ठीक है? So we call them health and wellness centers. These are the services. We are also taking care of mental health care. Now we come to the last part, diseases and some programs. A quick revision in 10 minutes. A patient with leprosy received treatment for 4 months but then discontinued it for 1 year. Now the patient presents again with a skin lesion. What should be the next thing that we have to do? Please remember, अगर किसी ने 1 साल तक treatment छोड़ दी leprosy की, he or she is a defaulter. You have to start the treatment with the new pack and new schedule. Okay, so now see, this is all the common logos. I'm going to discuss once quickly. This is the logo of National TB Elimination Program. We are trying to eliminate TB by 2025. All right, ये तुम्हारा National Leprosy Eradication Program है. This is National Leprosy, don't say Elimination, Eradication Program, guys. This one with a bird flying, this is for Meena. Meena mascot was for what rights? Child's right. But इसका concept हमने उठाया था सपना से. सपना is under which initiative? Sparsh initiative. And she's a school girl who's spreading awareness on leprosy. This is the logo for prevention of parent to child transmission of HIV. और ये NACO guys, this is the logo of NACP. इसमें जिसका headquarter कहाँ पे है? The headquarter is in New Delhi. ठीक है, this one over here, if you see National Vector Borne Disease Control Program, vector has 6 letters, so it protects us from 6 diseases. Already we have discussed that many number of times, so you can just have a look. ये National Mental Health Program का logo है. The planning is done at district level. This is National Iodine Deficiency Disorder Control Program. ये आपका आयुष्मान भारत है. And this one is National Program of Non-Communicable Diseases, the new initiative where we have also included a couple of more diseases. Okay, chalo, now just one more thing. What is the indicator that is used to measure burden of malaria, and elimination strategies are based on this? What do you want to answer over here? Something which is used to measure burden of malaria and all your elimination strategies, guys. Elimination strategies तुम्हारे इस पे based है. क्या आंसर करना चाहते हो? Burden of malaria. Very good. Annual parasite incidence. We want it to be less than 1 case per 1,000 population. Index of operational efficiency, annual blood examination rate should be more than 10%. Endemicity of malaria के लिए, what is the indicator that we have, guys? Spleen rate. Okay, we have spleen rate. Most sensitive indicator of recent malaria transmission, so that is nothing but infant parasite rate. And what is it that you calculate during outbreak? So it is slide positive rate. Slide positive rate that you must kind of remember. Treatment malaria का सबको याद है guys. I have made a very short this thing for you. Vivax अगर है chloroquine plus primerquine. But if you have falciparum, northeastern states, ACT-AL, I have given you the doses also, and other states, ACT-SP. Mixed infection, dekh lo, that could come in your exams. Pregnancy, yes, first trimester, Plasmodium falciparum. Answer is quinine plus Clinda. अकॉर्डिंग टू द प्रोग्राम, ठीक है, बट अकॉर्डिंग टू WHO इट इज ACT, बट अगर कुछ नहीं मेंशन्ड है वी विल फॉलो द प्रोग्राम, एंड सेकेंड एंड थर्ड ट्राइमेस्टर वी ऑलरेडी नो द सेम थिंग ACT, ये हमने ऑलरेडी किया हुआ है. प्रोफाइलैक्सिस, शॉर्ट टर्म प्रोफाइलैक्सिस, डॉक्सी का 100 मिलीग्राम टैबलेट, डॉक्सीसाइक्लिन लेना है, स्टार्टेड 1 to 2 days बिफोर एंड कंटिन्यूड 4 weeks आफ्टर ट्रैवल. मोर देन 6 weeks लॉन्ग टर्म है, सो वी आर गोइंग टू गिव मेफ्लोक्विन, प्रोटेक्ट्स फ्रॉम 6 diseases. दिस आई हैव ऑलरेडी डन. ऑलराइट, API शुड बी बिलो एक्चुअली लेस देन 1 case per 1000, ABR मोर देन 10%. ठीक है. देन NACP में आई होप यू रिमेंबर, एनी प्रेग्नेंट वुमन HIV पॉजिटिव, व्हाट इज इट दैट यू आर गोइंग टू पुट हर ऑन? TLD. न्यूबॉर्न हु इज बोर्न टू अ मदर ऑन ART, लो रिस्क इन्फेंट है, सिरप नेविरपीन इररिस्पेक्टिव ऑफ द टाइप ऑफ फीडिंग फॉर 6 weeks. हाई रिस्क है, यू आर गोइंग टू ऐड both of them. And what are the high risk groups? Core high risk groups for HIV guys 4 हैं: commercial sex workers, men having sex with men, injectable drug users and transgenders. इसके अलावा please don't say doctors and all are high risk. No, they are not high risk. Okay. Bridge population for HIV कौन कौन से है? Clients of commercial sex workers, all right, and also single male migrants, along with that you have truck drivers. Okay, truck drivers, ये सब आपको भूलना नहीं है. चलो, वेबसाइट फॉर ऑनलाइन नोटिफिकेशन ऑफ TB पेशेंट, एवरीबडी रिमेंबर्स निक्षय. लेप्रेसी पेशेंट, आई होप यू रिमेंबर निकुष्ट. UPT किट इज निश्चय, ठीक है, एंड मैंडेटरी नोटिफिकेशन होता है TB केसेस का, अदरवाइज इट्स अ पनिशेबल ऑफेंस. क्लियर. रेबीज रिवाइज करके देना. मल्टीपल डॉग बाइट्स HIV पेशेंट कौन सा कैटेगरी है? सो मल्टीपल डॉग बाइट्स इज ऑलवेज कैटेगरी 3 वुंड. कैटेगरी 3 वुंड में वी हैव टू गिव ऑल द 3 थिंग्स, बट इन HIV गाइज, इन HIV पॉजिटिव इवन फॉर कैटेगरी 2 आप उसको ऐड करोगे इम्यूनोग्लोबुलिन. प्लस आई होप यू ऑल रिमेंबर द रेजिमेंट्स दैट वी हैड. पोस्ट एक्सपोजर prophylaxis, Thai updated Red Cross regimen, day 0, 3, 7 and 28 days, 2 sites. SM regiment होता है day 0, 3, 7, 14 as well as 28 days. Okay, so this is important. Now what's the answer to this one everybody? What's the answer to this one? You can see a very big siphon tube. अगर बड़ा siphon tube है, it is QLEX, so that you must remember. ठीक है, ये हमने पहले भी किया हुआ है, QLEX है. Resting position, inclined, breathes in stagnant water, single boat shaped eggs with lateral floats, no siphon tube in the larva. This is your anopheles. But अगर hunchback है, white stripes on black bodies है, cigar shaped eggs है, so what is this? Shorter siphon tube. This is your Aedes. Okay, but white stripes, sorry, no white stripes, with white stripes on black body, yeah, but without white stripes, polluted water, egg in cluster, this is your QLEX and this is your Mansonia. Plus I had also shown you the images in the previous LRR also. Image hamesha yaad rakhna. Hunchback, so this is your Aedes. This one is no hunchback, QLEX हो गया, ये भी QLEX है, but 45 डिग्री में जो बैठेगा spotted wing, anopheles, and this one guys is your Mansonia. Okay, I hope you will remember. hairy wings लेके अगर आएगा, that's your sandfly. Plus ये chart देख के जाना guys. I have given a list of all the important diseases that are being transmitted by different vectors. जैसे louse important है, एपिडेमिक टाइफस, पर्ट उसका न्यूमोनिक था, रैट फ्ली इंपॉर्टेंट है, ब्यूबोनिक प्लेग एंड एंडेमिक टाइफस विच कुड कम इन योर एग्जाम. रेस्ट फ्रॉम दिस टेबल, नॉट दैट थिंग. हार्टिक और सॉफ्टिक के डिजीजेस आपको पता होना चाहिए. हाउएवर गाइस, क्यू फीवर हैज नो वेक्टर इन ह्यूमंस. ओके, हैज नो वेक्टर इन ह्यूमंस, हैज नो वेक्टर इन ह्यूमंस. ऑलराइट, चलो. Now 5 more minutes. Chemotherapy in a patient diagnosed with cancer is which level of prevention? एक बार prevention भी देख सकते हैं. बताओ इसका आंसर बताओ. Chemotherapy in a patient diagnosed with cancer. So chemotherapy everybody. कीमोथेरेपी हमेशा टर्शरी में जाएगी, नॉट सेकेंडरी. Chemotherapy is which level of prevention? So chemotherapy is like a person is diagnosed with cancer. So now you're like, so this is tertiary level of prevention. Okay. 45-year-old man presents with a history of small streaks of blood in his stool. Father was diagnosed with colon cancer at the age of 58 years. Colonoscopy. Now again, any screening modality, everybody, screening modality kaun sa level of prevention ho jayega guys? Screening would be secondary. So this was a list that you must know. Vaccines वगैरह, chlorination, any form of prophylaxis that we have, ये सारे primary हैं. But dots हो गया, ACT, ART, LASIK, any form of health checkup, ये क्या है? Secondary है. But if you talk about crutches for polio, giving prosthesis, amputations, all of these are what guys? All of these are tertiary level of prevention. Great. Okay, everybody understood? Chalo. Just a little bit of vitamins guys. What is the richest source of vitamin A and vitamin D? I hope you remember. It is nothing but halibut fish. Xerophthalmia को public health problem बोलना है. Night blindness more than 1%. Bite hotspot 0.5%. It is reversible till which age? ठीक है, reversible till which age? I mean till which stage? X1A, X1B, X3. X3A, X3B is not reversible. ठीक है, I mean X2 लिखो. X2 तक reversible है. X3A and X3B is not reversible. Most common manifestation क्या है vitamin A deficiency का? I hope you remember, night blindness. Okay, night blindness. Earliest presenting sign, सबसे पहला sign जो है that is conjunctival xerosis. And treatment dose वगैरह I hope you remember, most specific is bite hotspot. Treatment dose सबको याद है? Treatment dose में एक catch था guys, less than 8 kg. Even if the baby is more than 1 year old, the dose will be 1 lakh international unit. ठीक है, that we had also discussed in our LRR. ये देखो, an 8-month-old baby on examination shows vitamin A deficiency. So 8 month है, up to 6 months 50,000. 6 months to 1 year 1 lakh. More than 1 year कितना होता है? More than 1 year अगर होगा 2 lakh. And you're going to show it, give it on day 1, day 2 as well as day 14. But less than 8 kg weight है, then you're going to stick to 1 lakh guys. Chronic alcoholics, polished rice eaters, I hope you remember, thiamine deficiency. ठीक है, A riboflavinosis triad सबको पता है. Angular stomatitis, so you have angular stomatitis, you have that's one of the most specific one. Geographical tongue हो जाएगा या glossitis हो जाएगा. ठीक है, these and chlosis, but सबसे specific angular stomatitis. Maize and jawar eaters, everybody remembers pellagra. ठीक है, and यहाँ पे it is due to excess of leucine. Burning soul syndrome, vitamin B5 deficiency, ये B6, strict vegetarian में B12 है. Done. Revision. Anemia मुक्त भारत, in and out, ये doses important है anemia मुक्त भारत के. I have explained to you this many times guys, so I'm not going to repeat it again. ये हमने बहुत बार पढ़ा है anemia मुक्त भारत के doses. आयरन की नीली गोली, विव्स प्रोग्राम इज फॉर एडोलेसेंट. प्रेग्नेंट एंड लैक्टेटिंग सेकेंड ट्राइमेस्टर से शुरू करके गिव इट अप टू 6 months पोस्ट डिलीवरी. Purpose of this is to prevent which anemia? Megaloblastic anemia. Clear? Okay. Example of all our examples of food adulteration. Let's once quickly revise last food adulteration और एक ministry का chart और formulas. All our examples of food adulteration disease except, so you all know, fluorosis is not a food adulteration disease. ठीक है? Okay. Fluorosis में double edged sword is fluorine. Dental fluorosis more than 1.5 milligram. Skeletal 3 to 6 milligram. Crippling fluorosis more than 10 milligram per liter. And I mean this thing milligram. Okay, this you must remember everybody. Dental caries is less than 0.5. Nalgonda technique to remove excess of fluorine. Lab mnemonic is lab, lime add करो, alum add करो, bleaching powder add करो. पक्का से fluorine और food adulteration every time turns up. ठीक है. FMG 2025 40-year-old man है, presented to OPD, complaints of drowsiness. sorry, complaints of this one, just we're about to finish, drowsiness and giddiness, history of bajra roti, bajra se kya tha, autism, very good. Okay, so ek table hai, yaad hai, we've also discussed a table, I keep showing you that table. Khesri dal, neurolethyrism se bachne ke liye, what is the thing that you're going to give, guys? Vitamin C. Nobody should forget to revise this food adulteration table. I have given it n number of times. LRR में हाँ है, यहाँ पे है, that means it is a must for you. पढ़ के जाओगे इसको, ठीक है? और यहाँ पे देखो sudden non-inflammatory edema है. Name of the tests you should know. Aspergillus flavus has already come. Autism is the one that came last time. ठीक है? World Health Days का list है मेरे पास. I'm just going to show you. Recommended by School Health, recommended by Bhor Committee, guys. Renuka Roy improvised it, but recommend Bhor ने क्या था? In charge is Medical Officer PHC. Number of students in a class 40. Area sitting 10 square feet. Desk होना चाहिए तुम्हारा negative type. Windows ठीक है, doors and windows. 1 urinal for 60 students. 1 latrine for 100 students. Light हमेशा left side से आएगी. Mental health teacher भी कर सकती है. Eye checkup, visual acuity 6/9 से कम होगा. Paramedical ophthalmic assistant पे भेज दिया जाए. ठीक है? Family cycle देख लो. Everyone in a nuclear family of husband, wife and 2 children, a new child is born. Period being considered extends from birth of the child up until the point where the first child leaves home. So ये मैंने आपको बोला है, family cycle को पढ़ना जरूरी है. So what is the answer to this? Yes, complete extension. See, every phase will be denoted by the first part. ठीक है? मैरिज टू बर्थ, फॉर्मेशन, ये हो गया एक्सटेंशन. बर्थ टिल फर्स्ट चाइल्ड लीव्स होम. ठीक है? सो फर्स्ट चाइल्ड लीव्स होम, कंप्लीट एक्सटेंशन, दैट्स व्हाट वाज आस्क्ड. देन कॉन्ट्रैक्शन, देन कंप्लीट कॉन्ट्रैक्शन, एंड देन ऑफ कोर्स डिसोल्यूशन. ओके, सो वी हैव डन दिस एन नंबर ऑफ टाइम्स. मिनिस्ट्रीज सारे याद रखोगे गाइस. ऑल नेशनल हेल्थ प्रोग्राम इज अंडर मिनिस्ट्री ऑफ हेल्थ एंड फैमिली वेलफेयर. ICDS, उजावला, पोषण अभियान, प्रधानमंत्री मातृवंदना योजना, उजावला, मिनिस्ट्री ऑफ विमेन एंड चाइल्ड डेवलपमेंट. ठीक है? डिजास्टर, दिस इज योर मिनिस्ट्री ऑफ होम अफेयर्स. ESI एक्ट तुम्हारा लेबर है. एंड बायोमेडिकल वेस्ट, मिनिस्ट्री ऑफ क्लाइमेट चेंज. एनवायरमेंट एंड क्लाइमेट चेंज. ठीक है? एनवायरमेंट एंड क्लाइमेट चेंज. ओके, चलो. SDG, these are the latest demographics of India. Some of you wanted to know, so I have written it. Crude birth rate कितना है, death rate कितना है, currently IMR, NMR, under 5, MMR देख लो 88 है. But according to SDG, total goals is 17, 169 is the target. Direct health related goal is 3. 2412456 is indirect. ये पढ़ लो. MMR को कितना कम करना है? less than 70 per 1 lakh live births. Okay. NMR 12 per 1000 live births. Under 5 25 per 1000 live births. Premature mortality due to NCDs reduced by 33%. Okay, reduced by 33%. Clear? And these are the formulas. अब एक बार formulas पे नजर दे दो guys. All the child health formulas, multiplier will be 1000, denominator would be live birth. ठीक है? This you have to remember. Neonatal first 28 days, early neonatal 0 to 7 days, late neonatal 8 to 28 days, post neonatal 29 day to 1 year, infant 0 to 1 year, under 5 0 to 5 years. ठीक है? चाइल्ड डेथ रेट में डिनोमिनेटर क्या होता है? मीडियम पॉपुलेशन. पेरीनेटल में यू हैव टू टेक स्टिल बर्थ्स एंड डेथ इन द फर्स्ट 7 days ऑफ लाइफ. अब लाइव बर्थ की जगह वी कैन ऑल्सो यूज टोटल बर्थ्स ओवर हियर. ठीक है? बट मेटर्नल मोर्टालिटी रेशियो, आई होप यू ऑल रिमेंबर मेटर्नल डेथ, एंड द ओनली थिंग, द मल्टीप्लायर इज ऑलवेज गोइंग टू बी 1 lakh गाइज, एंड रेशियो यहाँ पे क्या हो जाएगा? लाइव बर्थ. प्लीज एक्सक्लूड एक्सीडेंटल इंसिडेंटल कॉजेज. अगर कोई वुमन स्लिप होके गिर गई वॉशरूम में, फॉल्स फ्रॉम अ स्टेयर्स, रोड ट्रैफिक एक्सीडेंट्स, इलेक्ट्रिक शॉक, डोंट कंसिडर दैट. एंड दिस विल ओनली इंक्लूड डेथ ड्यूरिंग ANC, डिलीवरी एंड अप टू 6 weeks पोस्ट डिलीवरी. याद रहेगा सबको, एवरीबडी. ठीक है? सबको याद रहेगा. दिस इज इंपॉर्टेंट. ओके, ऑल द फॉर्मुलाज ऑल्सो हैव समड अप. रिवाइज अ कपल ऑफ मोर फॉर्मुलाज. नेशनल डीवर्मिंग डेज 10th of Feb and 10th of August. Now, some of you wanted the entire list. So this time what I've done in this, you will find certain important list. I have already written. जैसे National Deworming Days, World Cancer Day देख के जाना, TB Day सबको पता है 24 मार्च, World Health Day, you all know 7th April, WHO से, ठीक है. Immunization Week, that is not that important. Population Day, Malaria, World Population Day, July 11th है. From here, what you can see is breastfeeding week could come in your exam. Mental health day आ सकता है guys, 10th of October. I'm not asking you to ratify everything. World AIDS Day and Universal Health Coverage देख लेना, ठीक है. चलो, last question. Study was conducted among nursing staff, FMG 2025. This we have also discussed in our LRR, guys. What is the answer to this, everybody? What is the answer to this? Work sampling. The answer to this is work sampling. LRR में a PDF में there is a table which is provided. Do go through it. And what is this one? Group of tourists following a tourist guide is an example of. So I've already told you, it is not a crowd. Crowd is no leader. It is a mob. Mob में emotional quotient होता है, ठीक है. Band is a permanent group, ठीक है. Band is a permanent group. Crowd, mob, herd, ये सब temporary है. Herd में there is no emotional connection. Clear, everybody. So this was a run through of PSM. I hope you enjoyed. पहले एक thumbs up दे दो. Everybody, you can do it. Please remember, I know दिन अभी कम है, जितना हो सका we are trying to tell you the most important stuff, guys. You just have to remember one thing, that it is your chance, it is your moment, and हो जाएगा. Have that faith. We are trying our best to be with you, to help you throughout this session, and it is like मेरा बहुत मन है each one of you clears. Don't study anything new now, guys. Revise your PYQs if possible. NEET PG का भी देख के जाओ. I have in this session now, what is the next thing that you will do for PSM? LRR PSM, don't miss out on that. ये marathon तो देख ही लिया है, ठीक है. Those are for now, those are sufficient. I have also covered all the PYQs, not left out anything. Handicap बता दो, ठीक है. Handicap में क्या था ना, देख एक होता है DIDH, disease, like accident is disease. Disease leads to impairment when the person, like anatomical loss of structure, so anatomical impairment. Function gets restricted, physiological, mentally affected, psychological. उसकी वजह से disability, you cannot walk, and then handicap, you cannot perform your roles and responsibilities, ठीक है. चलो, so that is handicap. Okay, so thank you so much. Bye bye, have a good day. And LRR एक बार देख लोगे तो बहुत अच्छा होगा. Isolation is cases के लिए, isolate them for the period of communicability, and quarantine is for healthy contacts. Okay, PDF will be given. So that's it. And do remember, we are starting with this super allied plan resolve, so you can let your friends also know. So bye bye, have a good day. Okay.
मैं आपका फोन काट रहा हूँ. Hello guys, I hope you all are fine. Okay, Arjun is saying leak the paper. Arjun, I wish I could. So I hope your preparation is going very well and this marathon series indeed will help you for sure. And remember what is the status of marathon series? Remember सबसे पहले होता है RR, उसके बाद होता है LRR and LRR के बाद है marathon series. Okay. So as we are going from RR to marathon, we are concising our notes, we are concising our content. So understand, at least आपको LRR तो देखना ही देखना है. And you will become much more confident अगर आपने पहले से RR देखा हुआ है. Okay. So remember, in this section, I will be telling you all the important content. MCQ हम discuss नहीं करेंगे. All the one-liners kind of a things we will discuss. Okay. So let's start without wasting your precious time. Okay. So all the questions will be discussed here. So we will start with our session with general pharmacology. So I want all of you to answer very rapidly. So what is known as pH at which the drug becomes 50% ionic and into 50% non-ionic form? So can you tell me 50% ionic and 50% non-ionic will be your? Yes, it is known as pK value of a drug. A last year MCQ. In which route a drug undergoes first pass metabolism in liver? Answer is which route? Oral route. Because in oral route, drug goes into stomach and intestine, from where it goes into liver. Now tell me which GIT routes bypass the first pass metabolism of liver. They bypasses sublingual route and rectal route. They bypass the first pass metabolism of liver. Which route has 100% oral, 100% bioavailability? 100% bioavailability will be seen in IV route, intravenous route. And remember, when we give a drug, we make a graph known as concentration time graph. In this concentration time graph, we denote Tmax and Cmax. The highest point is known as Tmax. Tmax means time, and Tmax, it tells you about the rate of absorption. It tells you about rate of absorption. Okay. Some students are saying voice is very less. Don't worry, I'll correct it. I'll correct it. Don't worry. Okay. Let me correct the voice then. Okay. I hope now it will be better. The voice will be better. ठीक है बेटा? Now, in this graph, there is a term known as AUC, area under the curve. Area under the curve tells you about the total extent of absorption. Total extent of absorption. And this area under the curve is used to calculate BA. BA stands for bioavailability of a drug. Okay. Voice got reduced. Okay. Okay. No problem. अब देखिए, अब ठीक है आवाज? ठीक है? Okay. Okay, let me change the voice. Don't worry. अब आवाज सही आएगी. ठीक है? ठीक हो गई थी? Oh, okay. So I don't want to waste my time here. ठीक है? अब ठीक है बेटा? चलो. Let's talk about which drug is available as a transdermal patch for motion sickness. Remember, in drug के end में amine word will come. So the drug name is scopolamine. Amine word is coming, and diphenhydramine. Amine word is coming in both of these drugs. They are motion sickness drug given as a transdermal patch. Which drug is available as a transdermal patch for Alzheimer disease? Rivastigmine patch. And the brother of Alzheimer disease is Parkinson disease. Which drug is available as a transdermal patch? Roti wala drug, rotigotin. Now, forced alkaline diuresis is done for poisoning of. Remember, we make the urine alkaline in cases of acidic drug की poisoning में we make the urine alkaline, and similarly we make the urine acidic in the poisoning of which drug? In the poisoning of alkaline or basic drugs. So which drug is acidic drug? You will remember aspirin. Aspirin is an acidic drug. And remember a basic drug, amphetamine, we do forced alkaline diuresis. Now how we do? Remember, in alkaline diuresis, we do by giving sodium bicarbonate. And that is why sodium bicarbonate is considered to be an antidote of aspirin poisoning. And we turn the pH of urine acidic by giving ammonium chloride. क्या देते हैं बेटा? Ammonium chloride, which is considered to be an antidote of amphetamine poisoning. Very good. Now tell me the answer in yes or no. Can we do hemodialysis in the poisoning of digoxin and amphetamine? What is your answer? क्या हम hemodialysis digoxin amphetamine poisoning में करते हैं? The answer is big no. We don't do, because these drugs have a very high VD. VD means volume of distribution. They are not present in blood. They are rather deposited in organs. Now which drug causes bullseye maculopathy? Why? Bullseye means they deposit in retina as a target lesion or shooting board or bullseye, because it has a highest volume of distribution of 15,000 liter. This drug is an anti-malarial drug known as chloroquine. The drug is anti-malarial chloroquine. Next question. Which TB drug causes contraceptive failure? Anyone? It causes red color urine also. Yes, we are talking about rifampicin causes contraceptive failure. Then which muscle relaxant is degraded by pseudocholine esterase enzyme? Choline word is coming, beta. Tell me the name of that muscle relaxant. Yes, the muscle relaxant is succinylcholine. Succinylcholine is degraded by pseudocholine esterase. Now which muscle relaxant undergoes Hoffman elimination? Hoffman means अपने आप डिग्रेड हो जाता है. अपने आप डिग्रेड हो रहा है तो अपने से A स्टार्ट होगा, that is एट्राक्यूरियम. And the small brother of etracurium is cis-etracurium. And add-on question of anesthesia is cis-etracurium does not cause histamine release. इनमें से कौन सा ड्रग हिस्टामिन रिलीज नहीं करता? That is cis-etracurium. Etracurium causes histamine release. Now first order kinetic versus zero order kinetic. Remember, in first order kinetic, the half-life of a drug is constant, while elimination of a drug is directly proportional to plasma concentration. Now this thing becomes opposite in zero order kinetic. In zero order kinetic, half-life becomes directly proportional to plasma concentration, while elimination becomes constant in zero order kinetic. Okay. Now what are the formulas of three important factors: half-life, loading dose and maintenance dose? Remember, the formula of half-life is 0.693, which can be taken as 0.7, volume of distribution upon clearance capacity. Formula of IV loading dose will be volume of distribution into plasma concentration. PC is plasma concentration. While formula of IV maintenance dose is clearance capacity into plasma concentration. Okay, plasma concentration. So these are very important formulas, remember. Then nicotinic receptor, serotonin 5-HT3 receptor, glutamate and GABA A receptor are which type of receptor? The answer is inotropic receptor. Now if we see the shape of inotropic receptor, they are just like a flower with 5 subunit. Yes, their shape is pentameric rosette. Shape is pentameric rosette. Then muscarinic receptor of acetylcholine, angiotensin and dopamine receptor are GPCR. GPCR beta stands for G protein coupled receptor. And if we see their shape, they are just like a snake. They are 7 serpentine helical shape. Serpentine helical shape. And GPCR, they are also known as metabotropic receptor. इनको और क्या बोलते हैं बेटा? Metabotropic receptor भी बोलते हैं, क्योंकि ये बॉडी में मेटाबॉलिज्म को कंट्रोल करता है. Now, insulin and IGF, insulin like growth factor, they are which type of receptor? Yes, they are TKR. Anyone who can tell me the full form of TKR? Yes, they are tyrosine kinase receptor. While growth hormone and cytokine receptors, they are JAK-STAT receptors. They are JAK-STAT receptors. Now, steroids and vitamin D. Vitamin D is known as calcitriol. They are cytoplasmic receptors. Steroids and vitamin D are cytoplasmic receptor, while thyroid receptors are nuclear receptors. They are nuclear receptors. Fine. Now, let's talk about which molecule is agonist and which molecule is antagonist. Remember, this is a dose response curve, and if a drug produces 100% of the response or full effect, this first molecule will be known as full agonist. But if a molecule produces less than 100% effect, this second one, this is known as partial agonist. This is known as partial agonist. And if a molecule produces opposite effect, let's say negative effect, then it is known as inverse agonist. The name itself is telling you full, partial or inverse. Now, if we give a drug and there is no change in effect, मतलब ये ड्रग बड़ा न्यूट्रल है, then we call this molecule as antagonist. Then we call this molecule as antagonist. Understood this part? So the third one is antagonist, previous year question. Now tell me the difference between efficacy and potency. Efficacy means maximum effect produced by the drug, while potency means dose required to produce a desired effect. तो potency क्या होता है? Dose. Efficacy क्या होता है? Effect. Now on this dose response curve, how do we determine efficacy and potency? Remember a mnemonic help. Remember, if there is more height, अगर height ज़्यादा है, the drug will be more efficacious. Height means efficacy. So can we say X and Y are having more height, equal height, but they are more efficacious than, X and Z, they are having more height, but they are more efficacious than Y. Now, if the graph is left-sided, then the drug will be more potent. The drug which required lesser dose means left-sided will be more potent. So X will be more potent than Y. Y will be more potent than Z. As simple as that. Okay, as simple as that. So you can easily remember this mnemonic help. Now, on this dose response curve, how we can identify competitive and non-competitive antagonist. So remember, this is agonist, blue one. And if a graph shift towards rightward, अगर right में parallel shift हो जाता है, this is competitive antagonist. And if the graph shifts downward, then it is known as non-competitive antagonist. So rightward shift, competitive, downward shift, non-competitive. Now remember, in cases of competitive antagonist, the Vmax, which is known as response, it remains same. So you can see Vmax remains same, while the Km or the dose which we require will be more. So the drug dose requirement will increase. While in non-competitive antagonist, Vmax will reduce permanently and Km will remain same. Okay, the Km will remain same. Good, simple and easy. Now let's talk about therapeutic index of a drug. So therapeutic index is the difference between ED50 and TD50. So ED50 means effective dose. Why it is known as 50? In 50% of people. Fine. So now can you tell me what is LD50 and TD50 stands for? Yes, LD50 will be lethal or toxic dose in 50% of people. Now, if we divide this TD50 upon ED50, and TD50 is also known as LD50. So LD50 upon ED50, this is known as therapeutic index. It is the difference between these two graphs, and this therapeutic index, remember beta, it tells you about the safety margin of a drug. So therapeutic index, what does it tells us about? Safety margin of a drug. Very good. Now let's talk about, tell me in one point, drugs for rare disease are known as, these drugs are known as orphan drugs. Agreed? Next question, dummy drug. Dummy matlab nakli, it doesn't have active drug. It rather contains inert substance, and this drug is used in RCT to maintain blinding. So this kind of a drug is known as placebo. So placebo mein 3 points you have to remember: dummy drug, inert substance, used in RCT to maintain blinding is placebo. Now tell me, which drugs are given for highly prevalent disease? Orphan drugs are for rare disease. The drugs which are highly prevalent disease, they should be cheap and cost effective, and they should be avoided as FDC, fixed dose combination. Yes, these drugs are known as essential drugs. They should not be combined with other drug. Avoid them as FDC. So which branch of pharmacology monitors adverse drug reaction? Adverse drug reaction is monitored by pharmacovigilance. This branch of pharmacology is known as pharmacovigilance. Good. Now let's talk about schedules of drug. So veterinary drugs which are used in animals, they come under schedule Z. They come under which schedule? Schedule Z. Now prescription drug, they come under schedule H. Example, insulin. Now narcotic and psychotropic drug, they are highly addictive drug. So they come under schedule X. X तो सबकी addictive होती है, like morphine, highly addictive drug. Teratogenic drugs, they come under category X drug. So can you tell me what is the difference between schedule X and category X? Schedule X drugs are addictive drug. Category X drugs are teratogenic drug. This is the difference. So tell me the teratogenic effect produced by thalidomide. Thalidomide produces phocomelia. So in phocomelia, there is short limbs. Lithium, it produces a cardiac anomaly. Which cardiac anomaly? It causes a cardiac defect known as Epstein anomaly. Now ACE inhibitor, which ends with the word pril wale drug, angiotensin receptor blocker, sartan wale drug, they are absolutely contraindicated in pregnancy because they produce renal agenesis. They causes renal agenesis. Understood this part? Now remember, carbimazole, methimazole, anti-thyroid drug, they can lead to aplasia cutis. So aplasia cutis, the skin of the child will not be produced properly. So you can see this aplasia cutis, the skin is not produced properly. Valproate and methotrexate are antifolate drugs. Because they are antifolate drugs, they can cause neural tube defects like spina bifida, etc. So neural tube defects will be there. Now let's talk about antimicrobial drugs first. So penicillins, cephalosporins and carbapenem. Remember, they inhibit cell wall of a bacteria, and cell wall we know is made up of peptidoglycan. So in peptide word is coming, so it inhibit transpeptidase enzyme. कौन सा enzyme inhibit करते हैं ये? Transpeptidase enzyme. Vancomycin, which is the big brother of penicillin, it also inhibits cell wall of a bacteria by inhibiting peptidoglycan. में glycan word रह गया, so it inhibits transglycosylase enzyme. Now remember, all these penicillin, cephalosporin and vancomycin, these drugs are not effective in mycoplasma. ये mycoplasma में effective नहीं है. They are not effective in chlamydia. They are not effective in rickettsia. These three bacteria, because these three bacteria lack cell wall. इनमें cell wall बेटा नहीं होती, इसीलिए penicillin वाले drugs effective नहीं है. So what is the drug of choice for penicillin allergy? So you eat amoxicillin, gala kharab hota hai, but sometimes amoxicillin is very costly. So instead we take azithromycin or erythromycin, है ना? So erythromycin or azithromycin, they are the drug of choice for penicillin allergy. So which penicillin is the longest acting penicillin? बेटा नीचे ही लिखा हुआ है, that is benzathine penicillin. अब इतना long acting drug है, बार बार नहीं देना पड़ेगा. A person doesn't have to take every day. So it can be given for prevention of a disease. Yes. So it can be given for as a drug of choice for prophylaxis of rheumatic fever और rheumatic carditis भी लिख सकते हो आप, है ना? So it is the drug of choice for rheumatic fever. Benzathine penicillin is also the drug of choice for syphilis infection. But in one syphilis it is not effective. In which syphilis it is not effective benzathine penicillin? Here न्यूरोसिफिलिस. न्यूरोसिफिलिस में ये इफेक्टिव नहीं होती बिकॉज न्यूरोसिफिलिस ये ब्रेन में एंटर नहीं कर पाती. नाउ विच पेनिसिलिन एक्ट्स अगेंस्ट सूडोमोनास? तो इस पेनिसिलिन के एंड में स्टार्टिंग में पी वर्ड आएगा. पी वाली कोई पेनिसिलिन बताओ. यस, पिप्रासिलिन वर्ड हमें याद रखना है. सो पिप्रासिलिन इज इफेक्टिव अगेंस्ट सूडोमोनास. नाउ व्हाट इज द ड्रग ऑफ चॉइस फॉर एमआरएसए? यू नो द फुल फॉर्म ऑफ एमआरएसए? Methicillin resistant Staph aureus. So here the drug of choice is IV vancomycin. Okay, vancomycin. But अगर vancomycin resistance है, we call it as VRSA. Here the drug of choice is linezolid. Linezolid is the drug of choice, but there is one more drug you have to remember, daptomycin. Daptomycin. But do we have any topical creams for MRSA? Yes, we have topical creams for MRSA. M से ही है mupirocin 2% cream for MRSA. Mupirocin 2% cream is given for MRSA. Now, which drug causes red man syndrome? Remember, it is not red color urine, it is red man syndrome. Red man syndrome is a side effect of IV vancomycin, because vancomycin causes histamine release which causes flushing. It leads to red man syndrome. But where do we use oral vancomycin? So oral vancomycin and a new drug fidaxomicin, they are given for Clostridium difficile infection. Now remember, Clostridium difficile infection causes a disease known as pseudomembranous colitis. And in Clostridium difficile infection, we also do fecal transplant. So we replace the good bacteria. We can also do fecal transplant. But the drug which are used is oral vancomycin and fidaxomicin, which is the most effective drug we have. So which antibiotic use can lead to Clostridium difficile infection? Highest risk is seen with clindamycin. Clindamycin से खुद क्या हो जाता है? Clostridium difficile infection हो जाता है. Now, toxic shock syndrome, which is caused by staph and streptococcus bacteria, and the toxin produced by them will kill a person. So to kill a bacteria in toxic shock syndrome, we give IV vancomycin. But in toxic shock syndrome, if you want to reduce the toxin production, here we give IV clindamycin. तो टॉक्सिन को कम करने के लिए हम क्लिंडामाइसिन देते हैं. बैक्टीरिया को किल करने के लिए we give vancomycin. So which cephalosporin causes disulfiram like reaction? तो अगर डाइसल्फिराम लाइक रिएक्शन है तो एल्कोहलिक्स में अवॉइड करना है. रिड्यूस फिब्रिन लेवल, फिब्रिन का लेवल कम होगा तो वारफरिन से ब्लीडिंग हो जाएगी. बट गुड थिंग इज इट इज अ रीनल सेफ ड्रग. सो 3 पॉइंट, डाइसल्फिराम, रिड्यूस फिब्रिन एंड रीनल सेफ सेफेलोस्पोरिन इज. किसी को ओपेरा सुनने का मजा आता है? ओपेरा सुनते हो? ओपेरा म्यूजिक. सो दिस सेफेलोस्पोरिन विल हैव ओपेरा वर्ड इन इट. सो दैट इज cefoperazone. It has 3 important properties. Now, which carbapenem drug is most neurotoxic and nephrotoxic? So the drug is imipenem. FMGE question. Imipenem is the most neurotoxic and nephrotoxic carbapenem. That is why imipenem is combined with the drug cilastatin. Cilastatin will reduce the toxicity of imipenem. Okay. Now, what is the treatment of meningococcal meningitis? We give injections of ceftriaxone. In meningococcal meningitis, we give injections of ceftriaxone. But to prevent meningococcal meningitis, we give ciprofloxacin. Prevention के लिए ciprofloxacin. If ciproflox is not in the option, then you will go with rifampicin. Okay, both names you have to remember. Now tell me this disease I am talking about. तो इस disease के बारे में बताओ बेटा. एक female है with vaginal discharge. Clue cells are there. Amstel test is positive. Can you tell me which disease we are talking about? Yes, we are talking about bacterial vaginosis. And the drug of choice for the treatment of bacterial vaginosis is metronidazole. Or any drug which contains nidazole word in it, you can give like tinidazole or nidazole, etc. Tell me the answer of next question. Greenish fishy odor, vaginal discharge, cervix shows hemorrhage. Because cervix is showing hemorrhage, let's call it as strawberry cervix. So can you tell me which disease I am talking about? Yes, we are talking about Trichomonas vaginalis, and the treatment is again metronidazole or any drug which ends with the word nidazole. Now tell me, if a person is on metronidazole, what should not be consumed? Tell me, if a person lives in metro city, जो लोग metro city में रहते हैं वो तो बहुत दारू पीते हैं, है ना? तो मेट्रो सिटी वाले तो बहुत दारू पीते हैं, तो दारू हमें अवॉइड करना है, बिकॉज एल्कोहल शुड बी अवॉइडेड विद मेट्रोनिडाजोल, बिकॉज मेट्रोनिडाजोल also shows disulfiram like reaction. It also shows disulfiram like reaction. Now, drug of choice for pertussis is azithromycin or erythromycin. But here the question came, pertussis in infant. Remember, in infant, azithromycin is safe, while erythromycin is contraindicated in infant. Why? Because it causes hypertrophic pyloric stenosis. It causes hypertrophic pyloric stenosis. इसीलिए अब आंसर क्या हो जाएगा? The answer will be only and only azithromycin. Now, which antibiotic causes Achilles tendon rupture? That is fluoroquinolones. They will end with the word floxacin. They will end with the word floxacin. Now, which fluoroquinolone is safe in renal failure? Remember, PMT. तो अगर हम PMT नहीं देते तो हम FQ होने से बच जाते. FQ word I can't pronounce, it's a very bad word. So remember 3 fluoroquinolone, pfloxacin, moxifloxacin and trovafloxacin are safe in renal failure. It's a very frequently asked question. Now, rickettsia, chlamydia infection का drug of choice, that is doxycycline. That is doxycycline. Nahi Vaibhav, we can't speak. Which antibiotic causes tooth damage? Because वो कैल्शियम से बाइंड कर जाती है. That is tetracycline. That is tetracycline. Which antibiotic inhibit MAO enzyme, monoamine oxidase enzyme, and it causes thrombocytopenia? एक और लिख लेते हैं. And peripheral neuropathy. What is the answer? Yes, the answer is linezolid. The answer is linezolid. Fine. Now, which drug is not given in myasthenia gravis? You will write streptomycin, amikacin, and this group is known as AMG. AMG stands for aminoglycoside group, should not be given in myasthenia gravis. Now, tell me this antibiotic in neonate causes hyperbilirubinemia and it causes kernicterus. That is why this antibiotic should not be given in neonate. Yes, we are talking about sulfonamide. So sulfonamide causes kernicterus, and sulfonamide, you can also remember a drug, cotrimoxazole. Cotrimoxazole नहीं देना हमें बच्चों में. Simple and easy. It causes kernicterus. Now, Now, let's talk about TB drug HRZD, H for isoniazid, rifampicin, pyrazinamide and ethambutol. So remember, isoniazid is a prodrug. It is a prodrug. It gets converted into active form by an enzyme known as catalase peroxidase enzyme. और कौन सी जीन बनाती है? कैटजी जीन बनाती है. And after converting into active form, it inhibits mycolic acid synthesis, which is the cell wall. So this mutation in CAT-G gene will lead to resistance to isoniazid. It leads to resistance to isoniazid. Now isoniazid side effects are, it is neurotoxic, it causes peripheral neuropathy, and it is hepatotoxic. Now to treat neurotoxicity due to isoniazid, the treatment is vitamin B6. क्या देंगे बेटा? Vitamin B6 देते हैं for the treatment of neurotoxicity. Now rifampicin inhibit RNA polymerase enzyme. क्या inhibit करता है? RNA polymerase enzyme, and this RNA polymerase enzyme is made by which gene? RPOB gene. And RPOB gene mutation will lead to resistance to rifampicin. And this RPOB gene resistance of rifampicin is detected by which test? It is detected by CB NAT test. कौन से टेस्ट से बेटा? CB NAT टेस्ट से. The side effect of rifampicin is it causes red orange urine, and rifampicin is also hepatotoxic. Rifampicin is also hepatotoxic. Now pyrazinamide inhibit protein synthesis. P से pyrazinamide, P से protein synthesis, and you will write it is the most hepatotoxic drug and it causes gout. While ethambutol, it inhibits, mechanism is not important. Ethambutol affect eyes. कौन सा TB वाला ड्रग eyes को इफेक्ट करता है? ethambutol. It causes optic neuritis. इससे क्या होता है बेटा? Optic neuritis. Among these four drugs, which drug is bacteriostatic drug? The only bacteriostatic drug we have is ethambutol. बाकी के सारे ड्रग क्या होते हैं? बैक्टीरिसाइडल होते हैं. ठीक है, ठीक है, बिल्कुल सही बात. नाउ टेल मी which drugs in TB are renal safe? Renal safe drugs are R and H. Rifampicin and isoniazid are renal safe drug. Now which drugs are liver safe drug? Liver safe drugs are ethambutol. Ethambutol is a liver safe drug. Now can you tell me the most hepatotoxic drug? The most hepatotoxic drug we have is pyrazinamide. Pyrazinamide is the most hepatotoxic drug. Now in HIV, TB is the most common opportunistic infection. You just learned PSM. So if TB and HIV occurs together, which disease or which infection must be treated first? पहले किसको ठीक करोगे बेटा? सबसे पहले हम ठीक करेंगे TB को, and we will start ATT. क्या start करेंगे? ATT. And after 2 to 8 weeks, after a gap of 2 to 8 weeks, we start ART. फिर हम HIV का ट्रीटमेंट देंगे. तो पहले किसको ठीक करना है? पहले हमेशा अपॉर्चुनिस्टिक इन्फेक्शन को ठीक करना है, अदरवाइज आयरिस सिंड्रोम हो जाता है. सो नाउ लेट्स टॉक अबाउट वेरी इंपॉर्टेंट सेकेंड लाइन ड्रग फॉर टीबी. सो फर्स्ट वी हैव इस बिडाकुलिन. बिडाकुलिन में ए और क्यू वर्ड आ रहा है, ए और क्यू वर्ड आ रहा है. सो मैकेनिज्म इज इट इनहिबिट एटीपी सिंथेसिस, सो इट रिड्यूसेस एनर्जी प्रोडक्शन. क्यू वर्ड आ रहा है, साइड इफेक्ट इज क्यूटी प्रोलोंगेशन, इट कॉजेस क्यूटी प्रोलोंगेशन. Then you can see Delamanid, Pretomanid. Manid में MA word आ रहा है. MA means they inhibit mycolic acid inhibitor. They inhibit mycolic acid. Side effect is also QT prolongation. QT prolongation. Ethionamide. Ethionamide causes hypothyroid goiter as a side effect. And thioacetazone, HI word is coming. It is contraindicated in HIV patients. Thioacetazone is contraindicated in HIV patient. Now, what is the treatment of MDR and RR-TB? MDR is multi-drug resistant TB. RR is rifampicin resistant TB. Now, the treatment of choice is B-PAL M regimen. कौन सा रेजिमेन देना बेटा? B-PAL M regimen. कितने मंथ्स के लिए देना है? 6 months के लिए देना है. So B will be your bidaculin. P for pretomanid. Pretomanid is a very important potential MCQ this year. Then L for linezolid and M for moxifloxacin. So this is the treatment of MDR and RR-TB. Okay, MDR and RR-TB. Now let's talk about leprosy. Paucibacillary leprosy is treated for how many months? 6 months. Okay, so in this, the skin lesion and nerve involvement in leprosy will be 1 to 5 skin lesion and 0 nerve involvement. While multibacillary leprosy is treated for 12 months, here the skin lesions will be more than 6 and nerve involvement or nerve thickening will be more than 1. So which drugs we give? For 6 month and 12 month, we give 3 drug combination known as RDC combination. So RDC stands for बेटा, अभी डर्मा में भी पढ़ा होगा, rifampicin, dapsone and clofazimine. So these are the 3 drug combination we give. So what is the mechanism of action of dapsone? Remember, dapsone is an antifolate drug. It inhibits folic acid synthesis. And dapsone, apart from leprosy, where other dapsone is used? Dapsone is also used for dermatitis herpetiformis, which is a skin lesion seen in celiac disease. ये celiac disease में भी use करते हैं. So which drug in leprosy causes coloring of skin? Colored skin कौन सा drug करता है? So colored skin will be skin hyperpigmentation, fish-like ichthyosis. तो colored skin will be a side effect of clofazimine. Clofazimine causes colored skin in leprosy. तो आदमी को लगता है मेरा leprosy increase हो गया है. Okay. Now let's talk about which HIV drug causes bone marrow suppression, anemia and muscle damage. That is zidovudine. And zidovudine is which class of drug? NRTI. न्यूक्लियोसाइड रिवर्स ट्रांसक्रिप्टेज इनहिबिटर. अब ये डोलूटाग्राविर क्या है? ग्राविर वाले जितने भी ड्रग होते हैं, they are integrase inhibitor. They are integrase inhibitor. How we can remember? Gra word is coming. Gra word is coming. And remember dolutegravir. If you are combining with rifampicin, rifampicin is a CYP enzyme inducer. It increase the degradation of dolutegravir. So dolutegravir की डोज को क्या करना पड़ेगा? dolutegravir की डोज को हमें डबल करना पड़ेगा if you are combining dolutegravir with rifampicin. Now, which drug causes lipodystrophy syndrome in HIV? Lipodystrophy में क्या होता है? Obesity हो जाती है, diabetes mellitus हो जाता है. That is protease inhibitor. And all protease inhibitor, remember, they will end with the word navir. किससे end करते हैं? Navir. So all protease inhibitor causes obesity and diabetes mellitus. But which protease inhibitor also causes renal stone? Renal stone भी करेगा. Indinavir, India वाला drug, renal stone. QT prolongation, इसमें तो Q word भी आएगा. This protease inhibitor will have Q word in it. So because QT prolongation, saquinavir. Saquinavir, Q word is also coming. Then hypertension, जिससे stroke हो जाएगा, that is tipranavir. Tipranavir. So remember these important side effects of HIV drug. Now neonatal prevention of HIV is given by which drug? Neonate में कौन सा drug दोगे? N से neonate, neonate में दोगे बेटा nevirapine. कितने months के लिए दोगे? Remember you should give for 6 weeks. कितने weeks के लिए दोगे? 6 weeks के लिए दोगे at least for 6 weeks. Now for post-exposure prophylaxis of HIV, it is given for 28 days. And we give 3 drugs. कितने drugs देते हैं? 3 drugs देते हैं. That is TLD. TLD देते हैं tenofovir, dolutegravir, दौलत वाला ड्रग, एंड लेमीव्यूडीन, तीन ड्रग्स देते हैं फॉर पोस्ट एक्सपोजर प्रोफाइलेक्सिस। बट फॉर प्री एक्सपोजर प्रोफाइलेक्सिस जिसमें रिस्क होता है एचआईवी होने का, लाइक इंट्रावीनस ड्रग अब्यूजर, मेन हैविंग सेक्स विद मेन, आइदर वी गिव टीई और वी गिव टीएल। हियर वी गिव 2 ड्रग्स। कितने ड्रग देते हैं प्री एक्सपोजर में? 2 ड्रग देते हैं। तो टी से बेटा क्या हो गया? टी से तो हो गया टीनोफोविर विद एम्ट्रीसिटाबीन या फिर लेमीव्यूडीन। दिस वाज अ recent question, that is why we are discussing. Now, tenofovir, which is used in HIV, and entecavir, they are also the drug of choice for hepatitis B virus. So tenofovir HIV में भी देते हैं, हेपेटाइटिस बी वायरस में भी देते हैं। पैलिविजुमैब, VI मतलब कोई वायरस होगा और किसी के प्रोफाइलेक्सिस के लिए देते होंगे। सो पैलिविजुमैब इज अ मोनोक्लोनल एंटीबॉडी अगेंस्ट विच वायरस? इट इज गिवन फॉर प्रोफाइलेक्सिस ऑफ रेस्पिरेटरी सिंसिटियल वायरस। रेस्पिरेटरी सिंसिटियल वायरस। इन्फ्लुएंजा वायरस का ड्रग ऑफ चॉइस क्या है? इन्फ्लुएंजा वायरस का ड्रग ऑफ चॉइस है ओसेल्टामेविर। ओसेल्टामेविर क्या है? मेविर वर्ड आ रहा है, न्यूरा मिनीडेज इनहिबिटर। होता होगा कोई एंजाइम, इसमें भी एमआई वर्ड आ रहा है, इसमें भी एमआई वर्ड आ रहा है। सो इट इज अ न्यूरामिनिडेज इनहिबिटर, comes with the brand name Tamiflu. So what is the drug of choice for herpes simplex 1, herpes simplex 2 and varicella zoster virus which causes chickenpox and shingles? Yes, the answer is acyclovir. But what is the drug of choice for cytomegalovirus? It causes retinitis. In cytomegalovirus, beta, you give ganciclovir. You give ganciclovir. Now, what is the drug of choice for Bell's palsy? सबसे पहले क्या देना है? Prednisolone. Prednisolone is the overall drug of choice. Later on you can add acyclovir. अगर दोनों आ जाएंगे तो किसके साथ जाओगे? You will go with prednisolone. Now what is the drug of choice for papilloma virus? It causes laryngeal tract carcinomas, cancer. That is pseudofovir. That is pseudofovir for respiratory papillomatosis. Okay, papillomatosis. Now let's talk about malaria. Primaquine, which is an anti-malarial drug, it is not effective in which stage of malaria? Sir, RBC को ये kill नहीं कर पाता. RBC stage is known as erythrocytic schizogony. This erythrocytic schizogony stage, it is also known as clinical cure. It is also known as clinical cure में कौन सा ड्रग इफेक्टिव नहीं है? That is primaquine. So let's talk about the cure of P. vivax endoval. P. vivax endoval we give combination of chloroquine with primaquine. Chloroquine for 3 days, primaquine for 14 days is the treatment of Plasmodium vivax endoval. What is the treatment of P. falciparum? In all states of India and northeastern state. In all states of India we give ASP. क्या देते हैं? ASP. ASP is artesunate plus sulfadoxine pyrimethamine combination. It is given in all states of India except which state? Northeastern state. Here we give treatment with AL. AL stands for artemether with lumefantrine. Artemether with lumefantrine. Now traveler's prophylaxis का drug of choice, that is mefloquine. If mefloquine is not given in the option, go with doxycycline. And if a person after traveling to that country comes back to his home country, remember this traveler's prophylaxis must be continued for another 4 weeks. अपनी कंट्री में आने के बाद भी 4 वीक्स तक खाने हैं. Now, which drug kills gametocide in malaria? Gametocidal drug is primaquine. Radical cure of P. vivax endoval, primaquine. But primaquine is not effective in which cure? It is not effective in clinical cure. So which anti-malarial drug is contraindicated in pregnancy? primaquine. So how to treat complicated malaria in any trimester of pregnancy? We give IV artesunate. That we give IV artesunate. Now remember bullseye maculopathy, we have already discussed chloroquine. Now the drug of choice for amoebic dysentery and amoebic liver abscesses, again metronidazole या कोई भी ड्रग जिसके एंड में क्या वर्ड आ रहा है, निडाजोल वर्ड इज कमिंग. But what about paramomycin diloxanide furet? They are luminal amoebicidal drug. ये ल्यूमन में किल करते हैं, not in dysentery or amoebic liver abscess. You know that in amoebic dysentery there is flask shaped ulcer. There is a flask shaped ulcer in amoebic dysentery. Give metronidazole as a drug of choice. Give metronidazole as a drug of choice. Now let's talk about helminthic, very important for FMGE. So if you talk about tapeworms and which are known as cestode, and if you talk about flukes like schistosomia, paragromius, all cestode, all fluke infection, the drug of choice is praziquantel. क्या है बेटा drug of choice? Praziquantel. But what is the drug of choice for hydatid cyst, neurocysticercosis? Here the drug of choice is albendazole. Albendazole देना है. Liver fluke का treatment of choice triclabendazole. Can you tell me liver fluke is caused by which fluke? Liver fluke कौन से fluke से होती है बेटा? Fasciola hepatica. Fasciola hepatica का drug of choice क्या है? Triclabendazole. Let's talk about nematodes. Nematode की बात करते हैं. Cestode हो गया, fluke हो गया, nematode. Roundworm, pinworm, hookworm. Treatment of choice albendazole. Albenda नहीं है तो कौन सा दे दो? Mebendazole. Agreed? Now strongyloid और river blindness तो almost अब eradicate हो चुकी है इंडिया से. We give ivermectin. What is the treatment of lymphatic filariasis? DEC, diethyl carbamazine. Now mass deworming is done in school going children. It is done with albenda and mebendazole. And mass deworming must be done in which age group? Children above 1 year of age group we do mass deworming. पेट के कीड़ों को मारना. What is the drug of choice for scabies and pediculosis? 5% permethrin cream. 5% permethrin cream, which is a topical cream. But remember, you can also give ivermectin orally. Ivermectin orally. But remember, ivermectin we don't give in children. Ivermectin is contraindicated in children. Children में हम ivermectin नहीं देते, तो children में क्या दोगे बेटा? 5% permethrin cream. Now, let's talk about black fungus, mucormycosis. Drug of choice. Drug of choice for mucormycosis is AMB. Full form बताओ बच्चा लोग फटाफट. Short form लिखी है. That is amphotericin B. Cryptococcal meningitis. यहाँ पे तो 2 ड्रग देंगे. Amphotericin B plus 5 flucytosine का कॉम्बिनेशन देंगे. Okay? Here we give the treatment with 2. Onychomycosis, nail का infection. That is terbinafine. टर्बिनाफीन. नाउ टर्बिनाफीन तो दे ही सकते हैं. नाउ देर इज अ ड्रग विच इज अवेलेबल एज नेल पॉलिश ऑल्सो. विच ड्रग इज अवेलेबल एज अ नेल पॉलिश फॉर ओनिकोमाइकोसिस? सिक्लोपाइरोक्स. सिक्लोपाइरोक्स इज अवेलेबल एज अ नेल पॉलिश. एस्परजिलोसिस वोरिकोनाजोल. एस्परजिलोसिस वोरिकोनाजोल. नाउ esophageal candidiasis, fluconazole. Vulvovaginal candidiasis, clotrimazole pessary. Clotrimazole pessaries, vaginal और suppositories वहीं पे इंसर्ट कर दो. Tinea capitis, Greciofulvin. Tinea capitis, Greciofulvin. Now remember amphotericin B का mechanism of action क्या है? It create pores बना देता है on ergosterol cell membrane. ergosterol सेल मेम्ब्रेन पे पोर्स बना देता है. Agreed? So this is an important MCQ. And amphotericin B is a nephrotoxin. Now let's talk about third unit, autonomic nervous system. Botulinum toxin, it inhibits the release of which neurotransmitter? It inhibits the release of acetylcholine. While tetanus toxin, it inhibits the release of GABA and glycine. GABA and glycine. Now, any drug which is ending with the word curare, tubocurare, etracurium, mivacurium, these drugs are SMR, skeletal muscle relaxant, and they block which receptor of acetylcholine? They block NM receptor. M का मतलब मसल्स पे होता है, N का मतलब निकोटिनिक मसल रिसेप्टर ऑफ acetylcholine. So what is the choice of reversal agent of these muscle relaxant? If you want to reverse the effect, we give neostigmine. Because neostigmine will increase acetylcholine level, acetylcholine will stimulate NM receptors. But Sugamadex, it is a specific reversal agent for क्यूरोनियम वाले ड्रग जिनके एंड में क्यूरोनियम वर्ड आता है, लाइक वी क्यूरोनियम, रो क्यूरोनियम का स्पेसिफिक एजेंट क्या है, स्पेसिफिक एंटीडोट क्या है? सुगामाडेक्स. ओके, वाइल ओवरऑल कॉमन एंटीडोट इज neostigmine, specific antidote sugamadex is for V and rocuronium. Now tell me beta, very simple question but repetitive question. Nicotine transdermal patch, lozenges, nasal spray, they are given for smoking de-addiction. It is given for smoking de-addiction. Tell me the most effective drug for smoking de-addiction. Most effective drug is varenicline. वेरीनिक्लीन. कैसे याद करें? निक वर्ड आ रहा है, निकोटीन होता है इसमें. वेरी मीन्स वेरी इफेक्टिव ड्रग फॉर निकोटीन डी एडिक्शन इज वेरीनिक्लीन. विच एंटी डिप्रेसेंट ड्रग इज यूज्ड फॉर स्मोकिंग डी एडिक्शन? दैट इज ब्यूप्रोपियन. ब्यूप्रोपियन स्मोकिंग डी एडिक्शन में एंटी डिप्रेसेंट ड्रग है, अप्रूव्ड है. गैलेंटामीन, रिवास्टिग्मीन एंड डोनेपिजिल. लेट्स कॉल इट एज डगर. 3 ड्रग लिखते हैं डगर. डोनेपिजिल, गैलेंटामीन एंड रिवास्टिग्मीन, they are given for the treatment of Alzheimer's disease. And among them, which drug is available as a transdermal patch? Transdermal patch which is available is rivastigmine. Rivastigmine patch is available as a transdermal patch. Another drug given in Alzheimer's disease is memantine. Memantine increases memory. Memantine improves memory. It is an NMDA antagonist or NMDA blocker given for the treatment of Alzheimer's disease. Given for the treatment of Alzheimer's disease. Now, what is the antidote of cobra bite poisoning? Antidote is antivenom. But with antivenom, you will add neostigmine. And neostigmine is combined with atropine. Neostigmine is combined with atropine. Muscle weakness in myasthenia gravis is treated by, again, neostigmine with atropine. Which drug is given for diagnosis of myasthenia gravis? आंखें खुल जाएंगी. That is idrophonium. And this test is known as Tensilon test. इस टेस्ट को क्या बोलते हैं बेटा? टेंसिलॉन टेस्ट बोलते हैं. Now what is this मेलेथियन, TIC20, Tabun Sarin Soman? Remember, they are organophosphate. What they are? They are organophosphate. And what is the treatment of choice for organophosphate and carbamate poisoning? The treatment of choice is atropine. But remember, in cases of organophosphate poisoning, we give pralidoxime also. So pralidoxime is given for which poisoning? OP poisoning as an add-on drug, and it is contraindicated in carbamate poisoning. It is contraindicated in carbamate poisoning. Now, which poisoning produces hot skin, hyperthermia, flushing because of vasodilation, dry eyes, dry mouth, and the person will become blind? Yes, we are talking about atropine poisoning. These are the features of atropine poisoning. And atropine is obtained from which plant? Datura plant, which is also known as belladonna plant. So what is the antidote of atropine poisoning? The antidote of atropine poisoning is physostigmine. क्या है antidote? Physostigmine is the antidote of atropine poisoning. That's great. I hope it's a quick recap. You all can remember. सब याद आ रहा है धीरे धीरे, कहीं ना कहीं पढ़ा था बट अब याद आ रहा है. गुड. नाउ विच ड्रग इज यूज्ड एज अ ट्रुथ सीरम, सच उगलवाने वाला, इन अ टेस्ट नोन एज नार्को एनालिसिस, स्कोपोलामीन. And another drug which we can give is thiopentone. Because they reduce intelligence, you cannot speak a lie. So tell me, amine word is coming, zine word is coming. These drugs are anti-emetic drug for motion sickness. Motion sickness. Now, which drug is used as a pre-anesthetic medication to reduce laryngeal secretion during surgery? दैट इज ग्लाइकोपाइरोलेट. ग्लाइकोपाइरोलेट को सर्जरीज के दौरान देते हैं रेस्पिरेटरी सिक्रीशन को ड्राई रखने के लिए. नाउ विच इज द मोस्ट इफेक्टिव एंटी कोलिनर्जिक ड्रग फॉर ओवर एक्टिव ब्लैडर? ओवर डार है तो ओ से लिखोगे बेटा ऑक्सीब्यूटाइनिन. कौन सा ड्रग? ऑक्सीब्यूटाइनिन. व्हाट इज द साइड इफेक्ट ऑफ ऑक्सीब्यूटाइनिन? मेमोरी लॉस. Anticholinergic drugs, they produce memory loss. So tell me, which drug should be given in overactive bladder in a patient of dementia? Dementia में तो पहले से ही memory loss है. In this case we give a drug trospium. कौन सा ड्रग देना है? trospium देना है. Now which beta 3 drug agonist which relaxes bladder is given for the treatment of overactive bladder? Mirabegron. कौन सा ड्रग? Mirabegron is a beta 3 agonist for overactive bladder. Now, norepinephrine, epinephrine, dopamine. They are synthesized from which amino acid? They are synthesized from tyrosine amino acid. किससे बनते हैं? टायरोसिन से. So there is a drug known as metyrosine, mabityrosine. It inhibits which enzyme? It inhibits tyrosine hydroxylase enzyme, and this drug is considered to be the drug of choice for pheochromocytoma, because in pheochromocytoma it will decrease the production of epinephrine, norepinephrine and dopamine. But in pheochromocytoma you want to control hypertension. So hypertension को control करना है तो फी वाला ड्रग ही देना है, फिनॉक्सीबेंजामीन. तब क्या दोगे बेटा? फिनॉक्सीबेंजामीन दोगे. ओके. नाउ व्हाट इज द ड्रग ऑफ चॉइस फॉर 3 शॉक, कार्डियोजेनिक, न्यूरोजेनिक एंड सेप्टिक शॉक? द आंसर इज नॉरएपिनेफ्रीन. नॉरएपिनेफ्रीन. डोज याद रखनी है 1 ml ऑफ 1:1000 IV. 1 ml of 1:1000 IV. But what is the drug of choice for anaphylactic shock and cardiac arrest? Here the treatment of choice is epinephrine. Epinephrine is also known as ADR, adrenaline. The dose in anaphylactic shock is 0.5 ml of 1:1000. While in cardiac arrest we give 1 ml of 1:1000 nahi beta, 10,000 of epinephrine. Okay. Now what is the drug of choice for acute renal failure or oligouria? In oligouria we give dopamine. Dopamine. And a similar drug which is just like dopamine can be given in oligouria, that is phenoldopam. कैसे याद रख सकते हैं बेटा? phenoldopam, क्योंकि इसके एंड में भी क्या वर्ड आ रहा है? डोपामीन जैसा डोपाम वर्ड आ रहा है. These two drugs, by acting on dopamine receptor, they increase GFR. That is why we want to increase GFR in ARF or oligouria. Now which drug is given for acute heart failure and during stress echocardiography, that is dobutamine. Because dobutamine heart पे beta 1 receptor agonist, it stimulates which receptor on heart? Beta 1 receptors on heart. Now let's talk about hypotension treatment. Hypotension in pregnancy, which drug to be given? Ephedrine. But hypotension due to change in posture, postural hypotension, midodrine. Midodrine. Now, xylometazoline, नेफाजोलिन, ऑक्सीमेटाजोलिन, एक और लिख लेते हैं, जोलिन वर्ड इज कमिंग. दीज ड्रग्स आर nasal decongestant. Nasal decongestants are given in the treatment of rhinorrhea. This oxymetazoline is otrivin. Now, if you use these drugs continuously, continuous use of nasal decongestant, it will lead to atrophic rhinitis. बार बार यूज करोगे otrivin, atrophic rhinitis हो जाएगा. And if you suddenly stop taking this drug, sudden stoppage of nasal decongestants will lead to rebound rhinorrhea. दोबारा नाक बहनी शुरू हो जाएगी. This rebound rhinorrhea due to sudden stoppage of nasal decongestant is known as rhinitis medicamentosa. इसे क्या बोलते हैं? Rhinitis medicamentosa. Now tell me, guess what these drugs are? Atosiban, TO word is coming. Ritodrine, TO word is coming. Can you tell me these drugs are? These drugs are TO means they are tocolytic drug. Tocolytic means they relax uterus. They inhibit delivery of a child. Atosiban, it blocks oxytocin receptor. It is an oxytocin blocker. Ritodrine is a beta 2 agonist. ये beta 2 agonist है. These drugs are tocolytic drugs. Now, what is the drug of choice for BPH? BPH means benign prostate hypertrophy. To open sphincter, sphincter बंद हो जाता है. So we give tamsulosin. And the brother silodosin. And to reduce prostate size, अगर prostate का size कम करना है, we give finasteride with or dutasteride. Finasteride and dutasteride. Finasteride and dutasteroids are 5-alpha reductase inhibitor. They inhibit the conversion of testosterone into dihydrotestosterone because dihydrotestosterone increases prostate size. But if this BPH occurs along with hypertension, साथ में hypertension भी आ गया, तब आप tamsulosin नहीं दोगे. In this case you will give prazosin. क्या दोगे? Prazosin दोगे. Fine. And prazosin का side effect? Prazosin side effect is postural hypotension because it dilates blood vessels also. And this postural hypotension due to prazosin is known as first dose effect. इसे हम क्या बोलते हैं? First dose effect बोलते हैं. Now, which drug is given to control hypertension, pulmonary edema in scorpion sting, बिच्छू का काटना? Tell me the answer. Scorpion sting, prazosin. Again, the answer is prazosin. Prazosin is the answer. So, what is a single drug of choice for hemangioma, dilated blood vessel on skin, thyroid storm, migraine prevention, essential tremors? Yes, that is a beta blocker, propranolol. Propranolol is a beta blocker. And remember, beta blockers are contraindicated in asthma patients. Beta blockers are contraindicated in asthma patient. Now, which drug masks the symptoms of hypoglycemia? So we call it as hypoglycemic unawareness. पता ही नहीं होगा कि hypoglycemia हो रहा है in a diabetic patient. Yes, the answer is beta blockers. Now, main side effect of beta blocker is, beta blocker side effect is bradycardia. So if there is bradycardia, what is the treatment? The treatment of bradycardia due to beta blocker toxicity is glucagon hormone, because glucagon causes tachycardia. Glucagon से क्या होता है? Tachycardia होता है. Now let's talk about asthma. So in asthma, first we have is SABA, short acting beta 2 agonist. The drug name is salbutamol. And second drug you have to remember is terbutaline. Terbutaline. LABA, long acting beta 2 agonist, salmeterol. कौन सा याद रखना है? Salmeterol. So it is a very long acting drug. Now the drug which has both SABA plus LABA property, short acting भी है, long acting भी है, that is formoterol. That is formoterol, which is now considered to be the drug of choice for asthma. So what are the main side effects of beta 2 agonist? The side effect of beta 2 agonist is 2T 2H. क्या side effect है? 2T और 2H याद कर लो. First T is tremors. Beta 2 agonist causes tremor. T for tachycardia. In blood, they decrease potassium, hypokalemia, but in blood, they increase glucose. They increase glucose. But they increase glucose, you will write hyperglycemia. They cause hyperglycemia in blood. पोटेशियम कम हो जाता है, ग्लूकोज का लेवल बढ़ जाता है. Which drug for asthma itself can cause bronchoconstriction, paradoxical bronchoconstriction? Tell me, is it ipratropium or tiotropium? What is the correct answer? Ipratropium causes paradoxical bronchoconstriction. Now, what is the action of theophylline in asthma? The main action of theophylline, which is found in tea and coffee. The main action of theophylline in asthma is, it is a phosphodiesterase 4 enzyme inhibitor. And excessive tea and coffee consumption will lead to excessive urination, scissors. So the side effect of theophylline is diuresis and scissor. And why it happens? Because it blocks adenosine receptor. Side effect क्या क्यों आ रहा है? Because it is adenosine A1 receptor blocker. Now, inhalational corticosteroids, which are given for long-term treatment of asthma, like budesonide, they are the drug of choice for chronic asthma, long-term treatment of asthma. Okay. Now, what is the main side effect of inhalational corticosteroid? Inhalational corticosteroid can lead to oral thrush. So oral thrush or candida infection is the side effect of inhalational corticosteroid. Now what is Samter's triad of aspirin? Aspirin से जब asthma होता है and ethmoidal nasal polyp, this triad is known as Samter's triad. This triad is known as Samter's triad. Now other anti-asthma drug, cromolyn, chrome word आ रहा है, nidocromil, chrome word आ रहा है. If chrome word is coming, these drugs are mast cell stabilizer. इनको हम क्या बोलते हैं? Mast cell stabilizers. Leucast word आ रहा है, monteleucast, zafirleucast. These drugs are leukotriene receptor blocker. किसको ब्लॉक करते हैं? ल्यूकोट्रीन के रिसेप्टर को ब्लॉक करते हैं. व्हाट इज जिल्यूटॉन? इनहिबिटिंग ल्यूकोट्रीन प्रोडक्शन. आई ल्यूट वर्ड इज कमिंग. इट इज लाइपोऑक्सीजनेज इनहिबिटर which reduce the production of leukotriene used in asthma. So in asthma, which monoclonal antibody blocks IgE? Answer is omalizumab. Which monoclonal antibody blocks IgE in asthma? Omalizumab. Which monoclonal antibody blocks interleukin 5 IL-5? Mepolizumab and Reslizumab. Recent question of FMGE. Which monoclonal antibody blocks interleukin 5 receptor? That is benralizumab. Benralizumab. Fine, important. So all these monoclonal antibody will have Li word in them. सब में Li word आ रहा है. ठीक है, सब में Li word आ रहा है. आप देख रहे हो, they are used in asthma. Now let's talk about drugs for cough. So first drug is bro, ambroxol. इसका bro क्या है? Bromhexine, bro वाले drug and N-acetylcysteine. They are expectorant drug. They are expectorant drug. Expectorant drug means mucolytic drug. They are mucolytic drug. They are given in the treatment of productive or infective cough. They are given in the treatment of productive or infective cough. While DON, D-O-N, DON, dextromethorphan, opioids like morphine, codeine, folcodeine, levorphenol is important, and noscapine. These drugs are antitussive drug. They are antitussive drug. These drugs are given in the treatment of dry cough. These drugs are given in the treatment of dry cough, and these drugs are absolutely contraindicated in productive cough. Among them, remember these opioid wale drug, they are highly addictive. Which cough syrups are highly addictive? Opioid wale. Tell me the answer of this question. In which disease you give the treatment with continuous nitric oxide inhalation, सिल्डेनाफिल एंड बोसेंटान, ये तीनों ड्रग कौन सी बीमारी में हम यूज करते हैं बेटा? यस, दे आर गिवन इन द ट्रीटमेंट ऑफ PAH, that is pulmonary artery hypertension. Now this sildenafil is also known as Viagra. So sildenafil is given in pulmonary artery hypertension. It is also the drug of choice for impotence. Impotence का भी drug of choice है. What is bosentan? ENTA word is coming. It is endothelin antagonist. It is endothelin antagonist given in the treatment of pulmonary artery hypertension. Now let's mark where these diuretics they work. So the first diuretic we have is carbonic anhydrase inhibitor like acetazolamide. It acts at a level of which nephron? Yes, nephron के कौन से level पे काम करता है? It acts at a level of PCT, proximal convoluted tubule. Then we have is osmotic diuretic like mannitol. किस पे काम करता है? It acts at a level of loop of Henle. Then we have loop diuretics like furosemide, bumetanide, torsemide. They act at a level of TAL. TAL stands for thick ascending limb. In thick ascending limb, remember loop diuretic inhibit one transporter known as sodium potassium 2 chloride transporter. They inhibit sodium chloride potassium 2 chloride transporter. Then we have thiazide diuretic. So thiazide diuretic is chlorthalidone, thali wala drug. Metallozone, metal wala drug. Indapamide, India wala drug. They act at a level of DCT. किस पे काम करते हैं? DCT. And in DCT they inhibit one transporter. Very important MCQ. They inhibit sodium chloride symporter at the level of DCT. Lastly, we have is potassium sparing diuretic. So potassium sparing diuretic are CEAT. कितने ड्रग होते हैं? 4. स्पाइरोनोलेक्टॉन, एप्लिरिनॉन, ऑन वाले ड्रग हो गए. अमाइलोराइड एंड ट्राइमटेरिन, दे एक्ट एट अ लेवल ऑफ कलेक्टिंग डक्ट. किस पे काम करते हैं? कलेक्टिंग डक्ट पे काम करते हैं. एंड दे इनहिबिट द एक्शन ऑफ एल्डोस्टेरोन हार्मोन. They inhibit the action of aldosterone hormone. That is why these diuretic are potassium sparing. They preserve potassium. So let's talk about diuretics are given in edema. So in heart failure, which edema is there? Pulmonary edema is there. Drug of choice is loop diuretic like furosemide. In renal failure, we have periorbital edema. Again, the diuretic of choice is loop diuretic. In liver failure, which edema is there? In liver failure, we have ascites. Here, the diuretic of choice is spironolactone. Now tell me, cerebral edema when it happens? When there is increase in intracranial pressure. Here the diuretic of choice we have is mannitol, osmotic diuretic. So the drug of choice is mannitol. But remember, mannitol is absolutely contraindicated in heart failure and renal failure. We don't give mannitol. Understood this part? So mannitol reduces intracranial pressure. Okay. Now let's talk about drug of choice for mountain sickness, acetazolamide. Drug of choice for mountain sickness is acetazolamide. But remember, don't confuse mountain sickness with morning sickness. Morning sickness is vomiting in pregnancy. If there is morning sickness, then we give doxylamine along with vitamin B6. What is another name of vitamin B6? We know pyridoxine. Motion sickness, we discussed amine wale drug या फिर zine wale drug. So can you tell me any drug ending with the word amine? Scopolamine, diphenhydramine, promethazine, cyclizine, etc. Amine or zine wale drug. So which diuretic preserve calcium? Thiazides. That is why thiazides are given in the treatment of renal stone. कौन से diuretic renal stone के treatment में देते हैं? Thiazide. Which is the most effective diuretic, also known as high ceiling diuretic? Loop. Loop का मतलब भी बड़ा long है ना? Which diuretic causes gynecomastia? Spironolactone. Diuretic in renal failure, we just discussed, loop diuretic. Okay. Now, what is the drug of choice for bleeding esophageal varices? Bleeding esophageal varices, the drug of choice is terlipressin. If terlipressin is not in the option, go with octreotide. Go with octreotide. Drug of choice for nocturnal enuresis or bedwetting in children. So here we can give three drugs: DOI, D for desmopressin, बच्चों में अगर यूरिन पास आउट हो रहा है, oxybutynin, and one antidepressant drug, imipramine. Three drugs which are given in bedwetting in children. Now the drug of choice for neurogenic and nephrogenic diabetes insipidus. In neurogenic, we give desmopressin. In nephrogenic diabetes insipidus, we give thiazide diuretics. We give thiazide diuretic. What is the drug of choice for excessive ADH? Syndrome of inappropriate ADH secretion, which leads to hyponatremia. The answer is tolvaptan. Tolvaptan blocks ADH receptor or vasopressin receptors. Now, which drug increase the amount of bradykinin in the body? The answer is ACE inhibitor, like captopril, lisinopril. कोई भी ड्रग जिसमें प्रिल वर्ड आता है will increase the amount of bradykinin. And remember, increase in bradykinin causes dry cough. कफ होता है and face पे swelling, angioedema होता है. ठीक है. Now tell me, what is the advantage of sartans? Sartans are angiotensin receptor blocker. L-chirin means it inhibits renin. These drugs do not increase bradykinin level. So this is the advantage of sartan. Which ACE inhibitors are not prodrug? They are not inactive drug. Two ACE inhibitor, captopril and lisinopril. Only two ACE inhibitors are not prodrug. Now, which angiotensin receptor blocker has PPAR gamma action, telmisartan. And telmisartan is good for diabetes. Which angiotensin receptor blocker lowers uric acid level? Good for gout. Lowering of uric acid level will be losartan. LO means losartan. Now, ACE inhibitor and ARB, they are contraindicated in pregnancy. हमने पढ़ा था pregnancy में नहीं देना. Now, which drugs protect kidney? Nephroprotective drug in diabetic or hypertensive nephropathy. That nephroprotective drugs are 3. 3 drugs हैं जो किडनी को प्रोटेक्ट करते हैं. Very, very important for you. The first is SGLT2 inhibitor. These drugs, they will end with the word gliflozin. Diabetes में भी देते हैं. Canagliflozin, empagliflozin, dapagliflozin. ACE inhibitor और ARB, प्रिल और साटन वाले ड्रग, and a drug finerenone. These are the 3 drugs which protects kidney in cases of CKD, chronic kidney disease. Now, first line drug for essential hypertension, CAT. We give calcium channel blocker, DHP type. इनके एंड में डिपीन वर्ड आएगा, like amlodipine. If this is not given, go with ACE inhibitor or ARB, pril या sartan वाले drug. And which diuretic is given for essential hypertension? Thiazide diuretic. They are the first drug to be started in essential hypertension. Now, drug which is given for resistant hypertension, spironolactone. The drug which is given for hypertensive emergency, if the blood pressure is more than 180 by 120. Remember, now the drug of choice has become nicardipine. अब क्या बन चुका है drug of choice? Nicardipine. But earlier we used to give nitroprusside. But nitroprusside nowadays we don't give because it leads to cyanide toxicity. We can also give labetalol. Remember, 3 drugs for hypertensive emergency. So how to treat? How to treat cyanide toxicity? Cyanide toxicity is, first treatment is give vitamin B12 hydroxycobalamin. What is the antidote? Hydroxycobalamin. With the hydroxycobalamin, you can give amyl nitrite. Amyl nitrite, how we can give? Inhalational route. So remember these 2 drugs for cyanide toxicity. Now, which drugs are given in pregnancy? So in pregnancy, remember LHMC, Lady Harding Medical College, they are given in pregnancy. So the overall drug of choice for PIH, pregnancy induced hypertension, is labetalol. क्या है drug of choice? Labetalol. In labetalol resistant cases, you can add other drugs like hydralazine, methyl dopa, and calcium channel blocker nifedipine. कौन सा calcium channel blocker? Nifedipine are the drug of choice in pregnancy. So which drug is absolutely contraindicated in pregnancy? We just discussed, beta. Tell me, the drug which are absolutely contraindicated in pregnancy are pril या फिर sartan वाले drug. Pril and sartan वाले drugs are absolutely contraindicated in pregnancy. Pril are ACE inhibitor, sartans are angiotensin receptor blocker. Now, which is the drug of choice for acute attack of angina? Sublingual nitrate. And how nitrates, they are effective in angina? Nitrates are venodilators. Because they are venodilators, very important MCQ, they reduce preload to the heart. Heart पे preload कम हो जाता है. Chronic या फिर vasos chronic stable angina, give beta blocker. Chronic vasospastic angina, give calcium channel blocker. But remember, never combine beta blocker with calcium channel blocker. Why? They both can lead to bradycardia. So never combine beta blocker with calcium channel blocker like verapamil और diltiazem के साथ combine नहीं करना. Never combine nitrates with sildenafil because it can lead to hypotension and sudden death. तो नाइट्रेट को सिल्डेनाफिल के साथ नहीं देना, बीटा ब्लॉकर्स को कैल्शियम चैनल ब्लॉकर्स के साथ नहीं देना. नाउ विच एंजाइना ड्रग is a potassium channel opener. Potassium channel opener is nicorandil. Nicorandil. How we can remember? Nicorandil is a CO-dil. It is a coronary. CO means coronary. Dil means dilator. Where it is used? It is used in the treatment of AN, angina. Which drug produce a side effect of coronary steal syndrome? Now we don't use it in angina. Dipyridamol. Which drug is a funny channel blocker on SA node? The drug name is ivabradine. Drug name is ivabradine. Which drug is a meta? Meta means metabolic shifter. Metabolic shifter means it changes the metabolism of heart from triglycerides to glucose. It will shift the metabolism of a heart from tri means fatty acid, triglyceride to glucose is trimetazidine. Very easy. Tri means triglyceride, metabolize nahi honge, heart will now use glucose, that is trimetazidine. These are anti-anginal drugs. Now chronic heart failure. In chronic heart failure or CHF, which drug has mortality benefit that will reduce death? Remember A, B, S. तीन ड्रग याद कर लो, बहुत है. First is ACE inhibitor, प्रिल वाले ड्रग. Beta blockers, they reduce mortality in CHF. And spironolactone, very important. And a very important class of drug again I am writing is SGLT2 inhibitor like gliflozin, dapagliflozin, empagliflozin. So these drugs, they reduce mortality in CHF. But how many beta blocker can reduce mortality? Remember, only 4 beta blocker can reduce mortality. Not all beta blocker. That is nebivolol, bisoprolol, carvedilol. ये तीन तो याद ही रखने हैं. And also metoprolol. Now, which drug is given in diabetes mellitus, also approved in CHF? That is SGLT2 inhibitor. These drugs are also given in diabetes mellitus, DM. Now, which neprilysin inhibitor is approved for CHF? That is sacubitril. कौन सा ड्रग? Sacubitril. New drug, neprilysin inhibitor. Now tell me, does digoxin reduce mortality in CHF? क्या digoxin से डेथ को हम कम कर सकते हैं? Digoxin has mortality benefit. The answer is no. Digoxin does not reduce mortality in CHF. So digoxin, where it is used? Remember, digoxin is used in CHF. Digoxin is also used in atrial fibrillation, which is also known as SVT, supraventricular tachycardia. So let's talk about digoxin. So digoxin inhibit which transporter on heart? Digoxin inhibit sodium, potassium, ATPase transporter on heart. Very, very important. Recent MCQ. Now, what is the main side effect? Specific visual side effect of digoxin is xanthopsia. Xanthopsia means digoxin से क्या होता है बेटा? Yellow vision होता है. It causes yellow vision. Digoxin can lead to ventricular fibrillation, which is treated with lignocaine. अगर digoxin से VF हो रहा है, give lignocaine. And overall, what is the antidote of digoxin poisoning? Antidote of digoxin poisoning is digibind. क्या है? Digibind. It's an antibody against digoxin, and we have very well discussed Is hemodialysis effective in digoxin toxicity? The answer is no. Digoxin की poisoning में hemodialysis नहीं करते. So let's talk about arrhythmia. In arrhythmia, the class 1 drugs, they are known as sodium channel blocker. इनको हम क्या बोलते हैं? Sodium channel blocker. एक नाम याद कर लो, lignocaine. Lignocaine. Beta blockers are under which class? Beta blocker, they come under class 2. Except which beta blocker? Sotalol. Sotalol is a beta blocker which comes under class 3. So in class 3, which drug we give? In class 3, we give potassium channel blocker. So potassium channel blocker is sotalol, and another drug we have is potassium channel blocker is amiodarone. Amiodarone comes under which class? Class 3. So which antiarrhythmic drug causes vortex keratopathy? Thyroid problem, because it contains iodine. Liver damage, and iodine color is purple. Purple man syndrome. So you can see amiodarone, IOD word is coming. So it contains iodine. So the answer out here is amiodarone. Amiodarone. Now, what is the drug of choice during acute attack of PSVT? Acute attack of PSVT is IV adenosine. IV adenosine. Okay, dose is 6, 12, 12 milligram. So total you can give 3 injection of 30 milligram. Okay. But which drug is given for prevention of PSVT? So you can remember B or C. So PSVT में कितने ड्रग देते हैं? A, B, C. Adenosine for acute attack, B and C for maintenance, B for beta blocker, and C for calcium channel blocker, verapamil. कौन सा ड्रग? Verapamil भी दे सकते हो. Now the drug of choice for long QT syndrome or torsades de pointes is magnesium sulfate. Drug of choice for the treatment of bradycardia and AV node block is atropine. Drug of choice is atropine. Now, what is the mechanism of action of statins? Atorvastatin, rosuvastatin. These drugs, they inhibit one enzyme in liver known as HMG CoA reductase enzyme. Statins, they inhibit which enzyme? HMG CoA reductase, and that is why they decrease LDL cholesterol. And they are given as a drug of choice to reduce LDL cholesterol in blood. The main side effect of statin is myopathy. They causes muscle damage. Now, the drugs which are ending with the word fibrate, fenofibrate, clofibrate, their main mechanism of action is they are PPAR alpha agonist. They are PPAR alpha agonist, and they are given to decrease triglyceride level. Statins किस लिए देते हैं? कोलेस्ट्रॉल को कम करने के लिए. फिब्रेट किस लिए देते हैं? ट्राइग्लिसराइड्स को कम करने के लिए देते हैं. Now, which vitamin is used as a hypolipidemic drug? That is vitamin B3. What is another name of vitamin B3? Niacin. Niacin as a hypolipidemic agent, and niacin is given to increase a good lipid level, that is HDL level. Among these three classes of drug, which hypolipidemic drug causes gout? Gout किससे होता है? Gout होता है niacin का side effect क्या है? Niacin causes gout. Another side effect of niacin is flushing. Niacin causes flushing and gout. And very important MCQ, PCSK9 inhibitor given to reduce cholesterol level is evolocumab, alirocumab. Evolocumab, alirocumab are the two drugs. You just have to identify LOC word इसमें ढूंढना है. They lower cholesterol, so they are PCSK9 inhibitor. Now, mechanism of action of aspirin. Remember, aspirin is an irreversible COX inhibitor. COX inhibitor means cyclooxygenase inhibitor. So when it inhibits COX enzyme in platelet, it decreases the production of thromboxane A2. Because of this reason, remember aspirin has anti-platelet effect. Now understand one point always. Wherever the word irreversible comes, irreversible means hit and run drug. अगर कहीं भी वर्ड आ जाए irreversible मतलब hit and run drug. Third name of irreversible inhibitor is suicide inhibitor, MCQ. Okay, so what is the antiplatelet dose of aspirin? That is 40 to 325 milligram, and aspirin is the drug of choice for MI, stroke and Berger's disease as an antiplatelet drug. Fine. So which of the following antiplatelet drug are pro-drug? Pro-drug कौन से होते हैं? Clopidogrel and prasugrel. You can see grel word आ रहा है, and these drugs are ADP receptor blocker. इनको हम क्या बोलते हैं? ADP receptor blocker बोलते हैं. Now clopidogrel being a prodrug, it is converted into active form by which enzyme? It is converted into active form by CYP2C19 enzyme. I have given you the trick how to remember, and this activation of clopidogrel is inhibited by a proton pump inhibitor omeprazole. So that is why avoid combining omeprazole with clopidogrel. It inhibits the conversion of omeprazole clopidogrel into active form. So which of the following drug inhibit GP2B3A receptor? Just remember one drug. एक ही पूछा जाता है, एप्सिक्सीमैब. एक ही पूछा जाएगा आपसे FMG में. Epsiximab is an antiplatelet drug which block glycoprotein 2B3A receptors. Now, let's talk about after antiplatelet, let's talk about anticoagulant drug. Anticoagulant drug कहाँ देते हैं बेटा? DVT में देते हैं, atrial fibrillation में देते हैं, DIC में देते हैं, disseminated intravascular coagulation. So the first anticoagulant drug we have is warfarin. Warfarin is a vitamin K inhibitor. How? It inhibits a very specific enzyme in liver, VCOR-C1 enzyme. Okay, VCOR-C1 enzyme. So if warfarin bleeding occurs, what is the antidote? Antidote of warfarin bleeding is, logical antidote should be vitamin K. But with vitamin K, if bleeding occurs, we add PCC. क्या add कर देते हैं? PCC. Prothrombin complex conjugate. ये क्या चीज है? You know that vitamin K inhibit 4 factors, 2, 7, 9 and 10. PCC is a mixture of 2, 7, 9 and 10. It is known as prothrombin complex conjugate. Apixaban, rivaroxaban. What these drugs are? These drugs are factor. कौन सा factor होना चाहिए बेटा? XA word is coming. Factor 10A inhibitor. Factor 10A inhibitor. And these drugs, if bleeding occurs, what is the antidote? Antidote is Endexanet. You can see Dexa or XA word is coming. It is nothing. It is synthetic form of factor 10A. Then we have is dabigatran. Dabigatran, TRAN. TRAN means it is a thrombin antagonist. It is a thrombin antagonist or a thrombin inhibitor. And the antidote of dabigatran is idarucizumab. कैसे याद करें? दारू word is coming. Dabi word is coming. दबा के दारू पियो is the antidote of dabigatran. And remember, the first 3 drugs are oral anticoagulant drug. They are oral anticoagulant drug. Let's talk about parenteral or injectable anticoagulant drug. So we have high molecular weight heparin. We have parin wale drug, enoxaparin and dalteparin. They are low molecular weight heparin. Perinux wale drug, they are ultra low molecular weight heparin. And these heparins are indirect thrombin inhibitor. They are indirect thrombin inhibitor. How do they act? Remember, they activate one protein in blood, that is antithrombin 3. ये किसको activate कर देते हैं blood में? They activate antithrombin 3. or antithrombin 3 inhibit thrombin. So what is the antidote of heparin toxicity? Protamine sulfate. But remember, protamine sulfate, it is only given for high molecular weight and low molecular weight heparin. Protamine sulfate is not given for ultra low molecular weight heparin like fondaparinux में effective नहीं है. This year's FMG question, fondaparinux में protamine sulfate is not effective. Now, heridin, lepiridin, riudin wale drug and ergatroban, these drugs are the drug of choice for HIT. HIT क्या होता है? Heparin induced thrombocytopenia, which is a dangerous hypersensitivity reaction to heparin. Then we gave heridin, lepiridin, ergatroban. Now, what is the anticoagulant of choice in pregnancy and postpartum period? You can use any of the following heparin. You can use any of the following heparin, and remember, warfarin is contraindicated up to 12 weeks of pregnancy or first trimester. So when you can start warfarin in a pregnant female? After 12 weeks or after first trimester. Now what is streptokinase, L-tiplase, retiplase, tenectiplase? They are TPA, tissue plasminogen activator, and these drugs are known as fibrinolytic drug. They remove fibrin. They are known as fibrinolytic drug. And fibrinolytic drugs, where they are used, tell me, a quiz type. Streptokinase and L-tiplase, retiplase, N-STEMI में देंगे कि STEMI में देंगे? Tell me the answer. Remember, they are given in ST elevated MI, while in N-STEMI, they are absolutely contraindicated. Similarly, in which stroke you will give streptokinase? Remember, they are given in ischemic stroke, but they are absolutely contraindicated in hemorrhagic stroke because they themselves can cause excessive bleeding. So, कहाँ use करते हैं हम? STEMI में use करते हैं और ischemic stroke में use करते हैं. In other condition like N-STEMI and hemorrhagic stroke, we never give streptokinase, L-tiplase like drug because they can cause bleeding. And if there is bleeding with streptokinase, what is the antidote? The antidote of streptokinase is EACA, that is epsilon aminocaproic acid. You can also use tranexamic acid. These drugs are antifibrinolytic drug. They are antifibrinolytic drugs. Okay. Now, amla and lemon juice, which contains vitamin C, increase or reduce oral iron absorption. They increase oral iron absorption. But tea, coffee and antacids, they reduce oral iron absorption. Now, which iron is given as an injection? Iron dextran is given as an injection. And how it is given? Intramuscular injection. So when you are giving it as an intramuscular injection, give by a technique known as Z technique. कौन सी टेक्निक से देना है? Z technique. Zigzag, skin को pull कर दो. The advantage of Z technique is we can avoid staining of subcutaneous tissue or fat in cases of Z technique. Okay. Now, which chelator is used as an iron poisoning? And you know that iron poisoning occurs in thalassemia patient. So the answer is desferrioxamine. कैसे याद करें? Fe वर्ड आ रहा है. केमिस्ट्री में Fe को क्या बोलते थे? आयरन बोलते थे. Which chelator is given in copper poisoning? And copper poisoning occurs in Wilson's disease. So the answer is penicillamine. Sir, penicillamine तो याद करना ही है. A new drug you have to remember copper chelator में is triantine, which has been asked in your exam. ट्रायंटीन भी याद रखना है आपने. नाउ रिमेंबर बाल, बिस्मथ, आर्सेनिक, लेड, मरकरी. मरकरी वर्ड आ रहा है ना. सो द एंटीडोट चिलेटर इज बाल. British anti-leucite, which is also known as dimer-caprol, Okay, now let's talk about endocrine and let's finish now our session very rapidly also. So which insulin is never mixed with other insulin? The answer is glargine insulin, because glargine is acidic insulin. All other insulins are neutral insulin. Which is the longest acting insulin? That is degludec. If degludec is not given in the option, go with glargine. How to remember? Remember, glargine acts for 24 hours. Make it opposite. 24 का opposite क्या होगा? Degludec acts for 42 hours. And these two insulin, remember, they are such a long acting insulin that we call them as peakless insulin. They keep on acting. They are known as peakless insulin. Now, which insulin is given intravenously? Intravenously we give in emergency, and that emergency is known as diabetic ketoacidosis. That is IV, regular insulin. Fine. Now, insulin is also given in one more emergency. Is it hyperkalemia or hypokalemia? So I'll give you a hint. There is tall T waves. Tell me, tall T waves on ECG occurs in? Yes, insulin is given in the treatment of hyperkalemia. So diabetes drugs which causes hypoglycemia is insulin. Apart from insulin, remember, any drug which starts with the word gly will cause hypoglycemia, like glimepiride, glipizide, gliclazide. ये याद कर लो, बहुत है. So these drugs causes hypoglycemia and diabetes. So GLP-1 agonist, GLP-1 stands for glucagon-like peptide, and this drug has been approved as an anti-obesity drug. So which drug, Karan Johar? Remember, semaglutide and liraglutide. So these drugs are GLP-1 agonist, glucagon-like 1 peptide agonist, and among them, which drug is also available orally? Semaglutide is also available orally nowadays. Liraglutide is available as an injection. Now, what is teduglutide? Teduglutide is not GLP-1, it is GLP-2. 2 for teduglutide. Remember, teduglutide 2 hai. It is not given in diabetes. It is rather given in the treatment of short bowel syndrome. कहाँ देते हैं हम teduglutide? Teduglutide is rather given in short bowel syndrome. Now, let's talk about which drug increase the amount of endogenous GLP-1 in our body. These drugs are gliptin. Gliptin हमारी बॉडी में GLP-1 का लेवल इंक्रीज करते हैं. हाउ वी कैन रिमेंबर? GLP-1 का लेवल इंक्रीज कौन करता है? इनका मतलब इंक्रीज ग्लिप्टिन, लाइक सीटाग्लिप्टिन, लीनाग्लिप्टिन. सो विच ड्रग इज रीनल सेफ? Linagliptin. Which drug is renal safe? Linagliptin. Saxagliptin should be avoided with ketoconazole, because ketoconazole is a CYP inhibitor. Metformin is contraindicated in renal failure. So renal failure में कौन सा ड्रग लेना है? Linagliptin लेना है, metformin नहीं लेना. Which diabetes drug activates PPAR gamma? Pioglitazone. Pioglitazone activate PPAR gamma receptor. Which anti-diabetic drug leads to glucosuria? And glucose excretion in urine can lead to UTI. Yes. कौन सा ड्रग यूरिन का फ्लो बढ़ाता है? SGLT2 inhibitor, These drugs we have just remember फ्लोजिन, फ्लोजिन वाले ड्रग यूरिन का फ्लो बढ़ाते हैं, फ्लो बढ़ेगा तो यूरिनरी ट्रैक्ट इन्फेक्शन होगा. Which drug have renoprotective and cardioprotective drug in CHF and CKD? Most important MCQ is फ्लोजिन. Drug of choice for diabetic neuropathic pain. न्यूरोपैथिक पेन में कौन सा ड्रग? प्रीगाबालिन. Pregabalin is given in diabetic neuropathic pain. Which drug is given for diabetic retinopathy? Because these drugs will inhibit formation of new blood vessels in retina by inhibiting one protein, VEGF protein, vascular endothelial growth factor. So these drugs which inhibit VEGF given in diabetic retinopathy is, remember a mnemonic, बेवफा रामू की रानी. बेवफा रामू की रानी. अरे बच्चों को याद है, वेरी गुड. सो विश्नोई जी, यू ऑलरेडी नो द निमोनिक. दैट्स ग्रेट. इट शोज दैट हाउ गुड यू आर रिमेंबरिंग. बेवाकीज़ुमैब, रामू किरुमैब इस साल का सवाल. अनफॉर्चुनेटली रानी बीज़ुमैब, they are given for diabetic retinopathy. So which drug is the drug of choice for hyperthyroidism during first trimester of pregnancy? प्रेगनेंसी के फर्स्ट ट्राइमेस्टर में ये ड्रग लेना है. ठीक है, प्रेगनेंसी, प्रोपाइल थायोयूरेसिल. But which drug is given in second and third trimester? कार्बी और मेथीमजोल. इंटरचेंज नहीं कर देना, ठीक है. फर्स्ट ट्राइमेस्टर में अलग ड्रग है, सेकंड और थर्ड में अलग ड्रग होता है, ठीक है, सेम ड्रग नहीं होते. तो विच ड्रग इनहिबिट 5-डीआयोडीनेज एंजाइम? 5- का काम क्या होता है? T4 को एक्टिव फॉर्म T3 में कन्वर्ट करना, विच वी कॉल इट एज पेरिफेरल कन्वर्जन. सो द ड्रग इज 2P याद रखने हैं हमें. कौन से ड्रग याद रखने हैं? 2P याद रखने हैं. पहला 1 बीटा ब्लॉकर, प्रोपेनेलॉल. सेकेंड propyl thiouracil. These drugs, they inhibit peripheral conversion of T4 to T3 by inhibiting 5-deiodinase enzyme. Fastest acting anti-thyroid drug, iodides like potassium iodide, Lugol's iodine. Half-life of radioactive iodine 131, 8 days. Radioactive iodine 131 destroy thyroid gland by बीटा रेस. कौन सी रेस? बीटा रेस. बीटा बेटे डिस्ट्रॉय कर देते हैं. नाउ HPA हार्मोन. व्हाट इज द ड्रग ऑफ चॉइस फॉर डॉर्फिज्म? डॉर्फिज्म है, हाइट बढ़ानी है तो क्या दोगे? ग्रोथ हार्मोन. द ड्रग नेम इज सोमाट्रोपिन. व्हाट इज सोमाट्रोपिन? सोमाट्रोपिन इज ग्रोथ हार्मोन. सोमा का मतलब होता है ग्रोथ. ड्रग ऑफ चॉइस फॉर प्रोलैक्टिनोमा, केबरगोलिन. ओके, बट द क्वेश्चन कम्स, प्रोलैक्टिनोमा इन प्रेगनेंसी, देन द आंसर कम्स आउट टू बी ब्रोमोक्रिप्टीन. And both these drugs, they stimulate which receptor? Dopamine D2 receptor, which decrease prolactin production from hypothalamic pituitary axis, and decrease in prolactin production will reduce milk production. So which drug is given to suppress milk production in mother after neonatal death? The answer is same. You can give any of the following drug, either bromocriptine or cabergoline. Now, what is the drug of choice for acromegaly, excess of growth hormone? That is somatostatin hormone. And the drug which are somatostatin hormone, they will end with the word reotide, like lanreotide, octreotide. Lanreotide is longer acting. Now, pegvisomant, it is also used for acromegaly. In resistant cases, we give pegvisomant. Pegvisomant is a, somant word is coming, growth hormone receptor blocker. ये growth hormone के receptor को block कर देता है. Now remember, pulsatile injection of leuprolide. What is leuprolide beta? Gonadotropin, रिलीजिंग हार्मोन। जब हम इसका पल्सेटाइल इंजेक्शन देते हैं, इट इंक्रीज FSH एंड LH लेवल। फाइन। And when we give that same leuprolide as a continuous injection, it decreases FSH and LH. Fine. It decreases FSH and LH. In which condition we want to increase FSH and LH? When the person is having infertility. And when we want to decrease FSH and LH level, when the person is having prostate cancer, because decrease in LH will reduce the production of testosterone hormone. Now, what are relics? Relics वाले ड्रग क्या होते हैं? They are gonadotrophin releasing hormone blocker antagonist. Agreed? And they only decrease FSH and LH level. So can you tell me where these drugs are used? Relics wale drug. Relics wale drugs are also approved in prostate cancer. They are also approved in prostate cancer. So now let's talk about SERM, selective estrogen receptor modulator. They will end with the word phene, like tamoxifen or meloxifene, clomiphene. Phene word आ रहा है. Tamoxifen, it is given in the treatment of breast cancer. कहाँ देते हैं? Breast cancer में देते हैं. But tamoxifen side effect is it increase the risk of which cancer? Tamoxifen increase the risk of endometrial cancer. It increase the risk of endometrial cancer. Or meloxifene, which is also known as centroman. It is used as a contraceptive, which comes with the brand name Saheli. Saheli नाम से आता है. Clomiphene, it is an ovulation inducer given in PCOD, polycystic ovarian disease. What is letrozole? Letrozole is an aromatase inhibitor. एरोमेटेज एंजाइम का काम क्या होता है? टेस्टोस्टेरोन को इस्ट्रोजन में कन्वर्ट करना. लेट्रोजोल इनहिबिट्स द कन्वर्जन ऑफ टेस्टोस्टेरोन इनटू इस्ट्रोजन. इट इज द ड्रग ऑफ चॉइस फॉर पोस्ट मीनोपॉजल ब्रेस्ट कैंसर. कहां देते हैं? पोस्ट मीनोपॉजल ब्रेस्ट कैंसर में देते हैं. फाइन, वेरी गुड. नाउ लेट्स टॉक अबाउट सेडेटिव हिप्नोटिक. थायोपेंटोन is a barbiturate. Why it is a short acting barbiturate? Because it deposit in fats. It shows a property of redistribution into fats. Fine. What is a drug of choice in ECT? Electroconvulsive therapy. One barbiturate known as methohexetone. Methohexetone. What is the treatment of benzodiazepine poisoning? Benzodiazepine like diazepam, lorazepam. The antidote is flumazenil. The antidote is flumazenil. कैसे याद करेंगे? AZ word is coming in all of them. AZ word is coming in flumazenil also. What is the treatment of barbiturate poisoning like thiopentone, phenobarbital? We only do forced alkaline diuresis. And you know how to do forced alkaline diuresis? By sodium bicarbonate. Now, which drug among barbiturate and benzodiazepines are contraindicated in acute intermittent porphyria? Remember, barbiturates are contraindicated in AIP, acute intermittent porphyria. Z drug. You know Z, like Z, है ना? Z का मतलब क्या है? A person will sleep. Remember, they are now considered to be the drug of choice for insomnia. Z drugs are the drug for insomnia like zolpidem and zopiclone, except one insomnia, that is jet lag. In jet lag, we give melatonin wala drug, that is ramelteon. Otherwise, for insomnia, we give Z drugs. Then, antidote of harmful or toxic alcohols like methanol and ethylene glycol poisoning is fomepizole. Don't get confused between fomepizole and flumazenil. fomepizole is an antidote. So let's talk about ethanol. What is the drug of choice for delirium tremens? That is diazepam. Agreed? What is the drug of choice for alcohol withdrawal? To prevent alcohol withdrawal, prevention के लिए तो oral drug दोगे, oral chlordiazepoxide. तो कहीं भी अल्कोहल वर्ड आ जाए, रिमेंबर डाइजी वर्ड वाले आपने ड्रग देने हैं, बट बोथ दीज बेंजोडाइजेपीन्स आर contraindicated in liver failure. So if the patient is having liver disease, then give two drugs, lorazepam for delirium tremens or prevention of withdrawal, or you can give oxazepam. Which drug is an anti-craving drug for alcohol? That is naltrexone, along with a camprosate. इसका combination. Which drug creates fear? Deterrent drug for alcohol. Disulfiram. And which drug causes disulfiram like reaction? I think we have discussed. Metro वाला drug, और मेट्रो में हो तो ओपेरा वाला सॉन्ग सुनोगे और दारू पियोगे. सो विच ड्रग कॉजेज डाइसल्फिराम लाइक रिएक्शन? मेट्रोनिडाजोल and cefoperazone. So these drugs are contraindicated in active drinker. जो अल्कोहल में एक्टिव ड्रिंकर हैं उनमें नहीं देना. Now let's talk about opioid. Morphine is contraindicated in head injury patients. So morphine is opioid. So morphine acts on mu receptor, but which opioid has anticholinergic action along with mu receptor? Pethidine. Which mu agonist has SNRI, serotonin, norepinephrine, reuptake inhibiting action? Last year FMGE question. Tramadol. Which opioid has NMDA antagonist action? Methadone. And because of this reason, which opioid causes QT prolongation? That is methadone MCQ. Fentanyl, which is an opioid, it is not given by which route? It is not given by oral route because it has a very high first pass metabolism in liver. Fine. Antidote of opioid poisoning. IV naloxone. Fine. But what is the drug for opioid withdrawal? For opioid withdrawal, you can give 3 drugs, BMT, bone marrow transplant. So B for buprenorphine, very important. If buprenorphine is not given, go with methadone. But now in India, tramadol has also been approved. तो एक आदमी ने ओपियोइड लेना बंद कर दिया. Which drug is given to prevent relapse in opioid addiction? Oral naltrexone. Now student, I want to ask you one question. Where naloxone is given, where naltrexone is given. Naloxone, antidote of opioid poisoning. Naltrexone, to prevent relapse. A person should not start taking again. So which opioid is given to treat diarrhea? So you must have eaten or prescribed this drug. Loperamide. So what is loperamide? OP word is coming. It is an opioid. And remember why we add small amount of atropine to diphenoxylate. Opioids are addictive. To reduce addiction with the diphenoxylate, we add small amount of atropine. Okay, we add small amount of atropine. So status epilepticus, which is also known as acute attack of seizure, more than 5 minutes. What is the drug of choice? The drug of choice is IV lorazepam. IV lorazepam. Now which drug, anti-epileptic drug, is contraindicated in pregnancy? Because it is the most teratogenic drug. Valproate. Valproate is the most teratogenic drug. And the safest drug will be L, that is levetiracetam. If it is not given, go with lamotrigine. Go with lamotrigine. Child, fever and convulsion. This is known as febrile convulsion. Give diazepam. If diazepam is not given in the option, give midazolam as the treatment. Now, which drug block T type of calcium channel? This year's FMG question. T type of calcium channel, where they are located? Can you tell me any brain structure starting from the word T? T से बताओ कोई brain का structure? Thalamus. T type of calcium channels are located on thalamus. Okay. Now, what is the drug of choice for infantile spasm in tuberous sclerosis? Vigabatrin. Vigabatrin. What is vigabatrin? GABA. TR means transaminase. IN means inhibitor. What is the mechanism? GABA transaminase inhibitor. Side effect of vigabatrin is very important. It causes visual defect. It causes visual defect. Which anti-epileptic drug causes hirsutism, gum hyperplasia, ataxia? That is phenytoin. That is phenytoin. Again, ataxia word is coming, but it also causes Stevens-Johnson syndrome and aplastic anemia. That is carbamazepine. That is carbamazepine. Now, a very important question. Carbamazepine, it has a higher risk of causing Stevens-Johnson syndrome. Stevens-Johnson syndrome. Now we modified carbamazepine into oxcarbazepine. Oxcarbazepine has a higher risk of causing SIADH, syndrome of inappropriate ADH secretion. Excessive ADH causes hyponatremia. तो hyponatremia ज्यादा किससे देखा जाता है? हाइपोनेट्रीमिया ज्यादा किससे देखा जाता है? ऑक्स कार्बाजपीन से. कार्बामाजपीन से क्या देखा जाता है? स्टीवन जॉनसन सिंड्रोम ज्यादा देखा जाता है. नाउ विच ड्रग शुड नॉट बी कंबाइंड विद लीवोडोपा? बताओ. लीवोडोपा के साथ वी ऑलवेज कंबाइंड कार्बिडोपा. एंड विच विटामिन इज एब्सोल्युटली कॉन्ट्राइंडिकेटेड विद लीवोडोपा इज विटामिन B6. सो व्हाई वी गिव कार्बिडोपा? सी, कार्ब वर्ड इज कमिंग, dopa word is coming, I word is coming. So carbidopa is a dopa decarboxylase inhibitor. So its name is telling, because it's a dopa decarboxylase inhibitor, it inhibits peripheral conversion of levodopa into active form. Brain के बाहर levodopa dopamine में convert नहीं होगा. Now levodopa causes vomiting. Treatment, domperidone. Which antiemetic drug? Domperidone. Now levodopa के साथ हम दूसरे ड्रग कंबाइन करते हैं टू प्रोलॉन्ग ऑन फेस. ऑन फेस मींस इंप्रूवमेंट. इंप्रूवमेंट को इंक्रीज करने के लिए वी गिव MAO-B इनहिबिटर, वी गिव COMT इनहिबिटर. विच ड्रग्स आर MAO-B इनहिबिटर? सेलिजिलीन, रासाजिलीन, जिलीन वर्ड आएगा. COMT इनहिबिटर एंटाकेपॉन, tolcapon, capon word आएगा. With levodopa, we combine a patient, we give a drug to rescue from off position. Rescue का मतलब, off का मतलब क्या होता है? आदमी जब rigid होता है, rigidity को suddenly ठीक करने के लिए we give injections of apomorphine. We give injections of apomorphine. Which drug in Parkinson disease is available as a transdermal or transcranial patch? Rotigotin patch. Which antiviral drug is also given in Parkinson disease? The drug name is amantadine. कौन सा एंटीवायरल ड्रग दिया जाता है पार्किंसन में? amantadine. So amantadine is effective in which virus? Influenza virus. And the main side effect of amantadine is livedo reticularis. amantadine का साइड इफेक्ट क्या है? Livedo reticularis. Nobody will ask you the mechanism of action of amantadine. Now mood stabilizer bipolar disorder में देते हैं. Most teratogenic drug for bipolar disorder is again valproate. Valproate is also given in bipolar disorder. It is not lithium, it is rather valproate. It is not lithium, it is rather valproate. So lithium in pregnancy causes Epstein anomaly. This is a cardiac defect. What are the main side effect of lithium? Lithium increases WBC level, leukocytosis. It causes tremor, hypothyroid goiter, and polyuria because of nephrogenic diabetes insipidus is the side effect of lithium. Fine. Now here I want to ask you, lithium increases WBC. Which drug decreases WBC level and causes agranulocytosis? That is neutropenia or leukopenia. बताओ कौन सा एंटी मूड स्टेबलाइजर करता है? दैट इज क्लोजापीन. क्लोजापीन WBC को कम करता है, लिथियम WBC को बढ़ाता है. लिथियम WBC को बढ़ाता है. सो एंटीहिस्टामिनिक ड्रग फर्स्ट जनरेशन क्रॉस ब्लड ब्रेन बैरियर, hence they are sedative drug. How to remember? They will end with the word zine or amine. They will end with the word zine or amine, like promethazine, hydroxyzine, cyclizine, cynarizine, meclizine, pheniramine, chlorpheniramine, doxylamine, diphenhydramine. Easily understand हो गया, याद हो जाएगा. So any drug ending with the word zine or amine is a first generation antihistaminic drug, and we know second generation non-sedative, except one drug, cetrizine. Which second generation is a sedative drug? That is cetrizine. Now terfenadine, estimizole banned. Why? QT prolongation, torsades de pointes. Last year estimizole came. Now can you tell me which second generation antihistaminic drug? No QT prolongation, no sedation. That great drug you have to remember is fexofenadine. The great advantage is no risk of QT prolongation, no sedation. So that is why the most preferred drug is fexofenadine. Comes with the brand name Allegra. It comes with the brand name Allegra. Now tell me, sumatriptan is used in acute attack of migraine and it controls headache. It acts on which receptor? How we can remember? Migraine is a very bad headache. Bad headache हो गया. So it acts on 5-HT1, that is serotonin, bad receptor, B and D receptor. So sumatriptan कौन से receptor पे काम करता है? It is a 5-HT1B 1D receptor agonist. Now another drug which we can use is ergotamine, but ergotamine side effect is ergotism. Ergotism means dry gangrene of fingers. Dry gangrene of fingers. So that is why nowadays less commonly used. What is the drug of choice for prevention of migraine? Remember, triptans are not given for prevention. Triptans are given for acute attack of migraine. I am asking about prevention. For prevention, the drug of choice is propranolol. The drug of choice is propranolol. But propranolol is contraindicated in anyone? Asthma patient, beta blocker. So, which drug we can give? Anti-epileptic drug, topiramate or valproate. Which calcium channel blocker is given in migraine? Flunarizine. Which tricyclic antidepressant is given in migraine? Amitriptyline, nortriptyline. ठीक है? And these drugs are safe in asthma. They are given in safe in prevention of asthma. Which monoclonal antibody is given in asthma? Erinumab. Erinumab. Now Gepant wale drug. Remember this drug? Rimegepant, Ubrogepant, Etigepant. They are CGRP2 blocker. They are CGRP2 blocker. These are the new drugs in migraine. I think we can end our session here. So we have covered more than 80% of the PYQs and topics which are commonly asked. So I know I went a little bit fast because the time allotted to me was very less. Agreed? So just best wishes and enjoy your day. If you have any doubt, you can ask me. PDF will be shared with you. So if you have any doubt, you can ask me here. Chalo. So I went very fast. So this is all in the last minute you can remember. Covering everything will take 1 hour more. Okay. So drug of choice of migraine in pregnancy, just see LRR. LRR देख लो बेटा, उसमें सब चीजें covered है. Paracetamol is the drug of choice. Just see LRR, that will cover everything. And from this marathon, remember, it will cover around 70% of the topics. Okay, it will cover around 70 to 80% of the topic. Okay. So I've covered all the remaining topics which are very less commonly asked in FMG exam. In LRR, I have covered everything. Just see that session. In 5-6 hours, we have covered everything. Okay. Chalo, best wishes. Thank you very much. If you have any question, you can ask me. Okay. Best wishes. Sir, in endemic area, which drug we give, sir, for less than 4 weeks, doxycycline is given. Okay. More than 4 weeks, mefloquine is given. I think 70% of the questions will come from marathon series. I believe, strongly believe. Because I have started antimicrobial first because antimicrobial is more commonly asked. General pharma is very commonly asked. Autonomic nervous system is commonly asked. So the diabetes is commonly asked. So the topics which are very important we have covered in marathon series. Okay. So migraine is very important. Antihistaminic drugs are commonly asked. Asthma is important. So all these topics we have covered in marathon series. Okay. Remaining 30%, yes, you can see from LRR. Okay. So where we have a little bit more time and we have covered whole pharma in LRR. Okay. New drugs are less commonly asked in FMG exam. बहुत ही rarely. New drugs are more important for INI-CET exam. Okay. ठीक है, चलिए, best wishes, enjoy your day. I'll share the PDF with all of you guys. इस सेशन को जरूर देखना, this marathon session. If you have not seen rapid revision or LRR, then see this marathon session. Around 70 to 80% of pharma questions will be covered. If you will see LRR, almost 100% of the questions will be covered. Okay. Almost 100% LRR. So I'll just come back to the first slide where I have told you. ये देखना, LRR देखना बेटा मैंडेटरी है, ठीक है, ये जरूर है. 70% of this LRR is in marathon series I have covered. Okay, best wishes, keep learning. Thank you very much.
Hello dear students, a very good evening to all of you. Welcome to the Pediatrics Marathon for your upcoming FMG exams. So can you please confirm if I'm audible and if my screen is visible so that we can start away with our session? Yes? Can someone please confirm if am I audible or not? Hello? Can someone please confirm if I'm audible or not? Yes? Okay. Thank you so much for the confirmation. I believe I am audible as well as visible. Yes. Okay. So we will be starting with, yes, thank you so much, Nikhil, Medico Traveler, Lahiri, Marvel, MPS. Thank you so much. Okay. So moving ahead with our mega revision marathon session from pediatrics, and as Dr. Ankit sir also mentioned, so we are aiming to cover more than 70% of the topics. So we expect that more than 70% of the questions that you will get in your upcoming FMG exams, you will be able to cover from this session. Okay. So let us start straight away. So it is a revision session. So I want it to be an interactive one. I want all of you to answer. Yes. Still, I can hear some of you saying you cannot hear my voice. Can someone else confirm whether I am audible or not? Can someone please confirm? Is voice coming so that we can start? Can someone confirm whether I am audible or not? Gamis says I'm audible. Yes. Shivangi says I'm audible. Yes. So I can see most of you, yes, answering. Okay. So I am audible, right? Okay. So let us start with the important topics from pediatrics. So the growth pattern of different organ systems. So many times we've got a question on this. So we all know the first picture that you see, A. Here what do you see? So maximum amount of growth is taking place in the first 2 years, and then there's not much growth. So this figure, okay, this figure shows very good. Akhilesh, so this shows CNS or brain growth, right? What about the next figure, B? इसमें क्या दिख रहा है आपको? What do you see? So there is an accelerated phase of growth in the first year, and then the rate of growth slows down, and then there is again an accelerated growth during puberty. So this shows somatic growth. Okay, somatic growth or growth in the stature, right? What about the next one? You see that maximum growth here is in the 4 to 8 years age group. So this shows the lymphoid growth. So figure C shows you the lymphoid growth. So there's a physiological lymphoid hyperplasia in this age group. So this age group may say a 5-year-old child has got enlarged tonsils, but they are not congested. You need not do anything about it. That is physiological lymphoid growth. Okay. And what about the last figure, number D? So here you see that there is hardly any growth taking place up to say 9-10 years of age, and then suddenly, there is a lot of growth taking place. So that shows gonadal growth that happens during puberty, right? So we will be able to identify, if given any of these graphs, that what growth are we talking about. Now these are some important devices. You can get a question like, what is it used to measure? So infantometer, we all know what is infantometer used for. So infantometer used to measure the length of a child. Okay, so till 2 years of age we measure the length. Beyond that we measure the height. Stadiometer, we all know, is used to measure the height of a child. Shakir's tape is a tape we know which has got a red, yellow and green zone. What is it used for? So Shakir's tape is mainly used by the field workers, the health workers, to measure. Yes, very good. Minduk, Nikhil, Sonu. So it is used to measure the mid-arm circumference, also called the mid-upper arm circumference, right? And the mid-arm circumference, red, yellow and green zones. We say it is red when the mid-arm circumference is less than 11.5 centimeters, indicating severe acute malnutrition. 11.5 to 12.5 is borderline. More than 12.5 is green, that is normal. What is Harpenden calipers used for? So Harpenden calipers is used for measuring, yes, skin fold thickness. Okay, just like vernier calipers in physics. Remember, you used to measure it for measuring the thickness of coins and all. So skin fold thickness, which gives you some idea about the subcutaneous fat. What about orchidometer? So orchidometer is a device which has these, ovoid bodies. A string-like structure which has these ovoid bodies, right? What is it used to measure? So this orchidometer looks something like this, and it is used to measure testicular size. Very good. So what is the first sign of puberty in boys? So first sign of puberty in boys is, yes, what is it? Testicular enlargement, right? Testicular enlargement is the first sign of puberty in boys, right? What about girls? In girls, what is the first sign of puberty? So first sign of puberty in girls is thelarche or breast development. Thelarche or breast development is the first sign of puberty in girls, right? Okay, so these have come many a times. Moving ahead, The birth weight of an average Indian baby is around 2.9 kgs. And when does the birth weight double itself? So the weight is going to double itself by around 5 months of age, triple itself. So the weight will become triple of the birth weight by around 1 year of age, and quadruples by around 2 years. Okay, right? What about the length or height of a child? So at birth, what is the length? So at birth, the length of a child is 50 centimeters. Okay, and it increases by 50%. What is 50% of 50? 50% of 50 is 25. So it increases by 50% and becomes 75 centimeters when? So by the end of first year. So increases by 50% at 1 year. And increases by 100% or doubles. That means the height becomes 100 centimeter at around 4.5 years of age. Now this question has also come recently. Height of a child is half of his adult height at around 2 years of age. Okay. At around 2 years, the height of a child is half of the adult height. Okay. Now this has come last year only, mid-parental height. So you may be given that the height of father is so and so, height of mother is so and so. What will be the mid-parental height of their son or daughter? So mid-parental height, we need to remember the formula. Very, very easy. So for boys, it is father's height plus mother's height plus 13 by 2 in centimeters. And for girls, it is father's height plus mother's height minus 13 by 2 centimeters. So if you have the father's height and mother's height, you can very easily take out the mid-parental height. Now, what is short stature? You get a lot of questions, case scenarios related to short stature. So short stature is when the height of a child is less than third percentile, okay, less than third percentile, or less than minus 2 Z score or standard deviations below the median for that age and sex. Okay. Now, short stature is of two types. We know proportionate short stature, where both the upper segment and the lower segment are proportionately short. So, the upper segment is to lower segment ratio remains normal. But in disproportionate short stature, either the limbs are disproportionately short or the trunk is disproportionately short. So, this will change, right? Changes. Okay. Now, what happens in growth hormone deficiency? So, we've got case scenarios in related to this earlier. So, in growth hormone deficiency, okay, we know the child will have short stature. Now, what will be the length at birth? So, at birth, will the baby be short? No, the length at birth will be normal. So, what is important to remember that growth hormone has no effect on the growth of fetus. It is only after the baby is born, growth hormone has some effect. So no effect on the growth of fetus. So that has also been asked previously, that which of these do not have effect on the growth of the fetus. So it is growth hormone. Okay. So length at birth and weight at birth is usually normal. And the upper segment lower segment ratio will remain normal or unchanged. It is not going to change. Okay. Because growth hormone deficiency is a cause of proportionate short stature. Okay. Now how much is the normal upper segment lower segment ratio? At birth, it is 1.7 to 1.9:1. By 3 years, it becomes 1.3:1. And by 7 to 10 years, it becomes 1:1. What about the bone age? So in growth hormone deficiency, skeletal maturation is also lagging behind. So bone age will be less than the chronological age or actual age of the child. Okay, right? So yes, so we all know that insulin, cortisol, thyroid hormone, all these will have effect on the growth of fetus, but growth hormone will have no effect on the growth of fetus. Okay. So how do you distinguish from a given case scenario whether it is familial short stature or it is constitutional delay in growth and puberty? So remember, constitutional delay in growth and puberty is the most common cause of short stature during childhood. Okay, of short stature during childhood. Right? How do you distinguish from a given case scenario? What is it? So in familial short stature, what will happen? The final height of the child will be less. So the child is going to be short even when the child is adult. But it will be normal as per the height of his parents. So as per his mid-parental height, you will see that the height is normal. Even though if you look at the percentile charts, you will find that the height is less than -2 standard deviations. So child is having short stature. Okay. The final height attained will be less, but it will be normal as per height of parents. okay, as per height of parents, because here the parents in familial short stature, the parents are also short, so parents height is also short. What about CDGP or constitutional delay in growth and puberty? So here the key word is there is a delay. Ultimately, der aaye durust aaye. So the child is going to have normal height when the child becomes an adult. But during childhood, there is a delay in growth. So 6 years के बच्चे की height will be say like that of a 4-year-old. 8-year-old child will have height of a 6-year-old and so on. Okay. So there's a delay. So here the final height attained is going to be normal. Okay, so short stature is only during childhood, but the final height attained is normal. And here the parent's height is also normal. But here the name itself is telling you there's constitutional delay in growth and puberty. So you can get a history that age at puberty, so there'll be delayed puberty. Delayed puberty in the child also. And history of delayed puberty in parents. History of delayed puberty in parents as well. Okay. And this puberty goes hand in hand with skeletal maturation. Puberty is also delayed, skeletal maturation is also delayed. So in constitutional delay in growth and puberty, the bone age will be less than the chronological age because skeletal maturation is delayed. But in familial short stature, puberty comes at normal age and bone age is equal to the chronological age. Right? And usually in children, we do X-ray of the left hand and wrist. So for finding the bone age, we do the X-ray of left hand and wrist in children. Okay? Right? In infants, we can do the shoulder X-ray, right? And in infants, we can do the femoral epiphysis X-ray, and in older children, we can do the shoulder X-ray as well. But usually, typically, we use X-ray of the left hand and wrist. Okay? What about achondroplasia? So achondroplasia is a typical example of what kind of inheritance? So waiting for your answers. What kind of inheritance? So many times it has come as a direct question. So achondroplasia is an example of, I'm waiting for your answers. Meanwhile, it is what kind of short stature? So in achondroplasia, it is mainly the limbs are short. Okay. So it is short limb dwarfism. Short limb dwarfism. Okay. So limbs are short. Okay. Limbs are short. That means the lower segment is short. So the upper segment is to lower segment ratio is increased. Okay, the ratio is increased because the limbs are short. Okay, so the ratio is increased, right? So autosomal dominant, very good. I can see Aisha, Afifa, Priya, Twilight, Devli, Namrata. Okay, so it is a typical example of autosomal dominant inheritance and the gene involved is FGFR3 gene. And you see a lot of other abnormalities in achondroplasia, like the head can be large. Okay, so there can be large head. And you can see that the limbs are short. Okay, limbs are short. And you can see that there is trident hand. So this hand abnormality where fingers are all lying oblique to each other. It is called trident hand. You can get this champagne glass pelvis. Okay, you can see this pelvis x-ray. So it is a champagne glass pelvis. Okay. And there can be delayed motor milestones and so on. Right? Okay. Now, rate of increase in head circumference is also asked recently. So, what should be the normal rate of increase? So, in the first 3 months after birth, the head circumference increases at the rate of 2 centimeter per month. Next 3 months, it increases at the rate of 1 centimeter per month. Next 6 months, it increases at the rate of 0.5 centimeters per month. Okay, and then next 2 years at the rate of 0.2 centimeters per month. So never in the life of a child you can see that the head circumference increases by more than 2 centimeter. If in any given month head circumference is increasing by more than 2 centimeters per month, it indicates that there is some underlying pathology. So it is abnormal. So there could be an underlying hydrocephalus, there could be a tumor, there could be intracranial bleed. Okay, so there could be some underlying abnormality which is giving rise to excessive increase in the head size. Okay. Microcephaly क्या होता है? What do you mean by microcephaly? We know micro means small. Though microbiology is a huge subject, but micro means small. So microcephaly is when the head circumference is less than -3 z-score below the median or mean for age and sex. Okay. And macrocephaly किसको बोलते हैं? So macrocephaly is head circumference more than +2 z-score. ठीक है, माइक्रोसेफली के डेफिनेशन में इट इज लेस देन -3 z-score, बट मैक्रोसेफली इज मोर देन +2 z-score फॉर एज एंड सेक्स. ओके, Acquired microcephaly. So microcephaly, we know a lot of causes are there. There are some genetic causes. So microcephaly ke causes ki if we talk about, so there are some genetic causes. Genetic causes jaise Edward syndrome, which is trisomy 18, Patau syndrome, which is trisomy 13, right? And you have a lot of other syndromes as well. So that is genetic cause. Then you have some other causes like maternal. So there can be maternal, maternal radiation exposure, maternal drugs like phenytoin, maternal infections. So congenital infections are a big cause by the TORCH group of organisms. And if the baby has got HIE or hypoxic ischemic encephalopathy or meningoencephalitis during infancy. So these are some causes of microcephaly in the baby. But acquired microcephaly is typically seen in Rett syndrome. What is Rett syndrome? So Rett syndrome is a condition more commonly seen in girls. It has a typical X-linked dominant inheritance. Okay, where the head circumference at birth is normal, but later the baby acquires microcephaly and there are stereotypic hand wringing movements, right? And a new latest drug approved, recently approved drug for the treatment of Rett syndrome is trofinetide. Okay, right? So most common congenital cause of obstructive hydrocephalus in a child. What is the most common congenital cause of obstructive hydrocephalus in a child? So hydrocephalus, of course, will give rise to macrocephaly or large head. So it is aqueductal stenosis. Aqueductal stenosis, right? Okay. And if there is hydrocephalus, what is the shunt surgery of choice? So if there is hydrocephalus, the shunt surgery of choice is the VP shunt. What is VP shunt? It is the ventriculoperitoneal shunt. So you make a connection from the ventricle of the brain to the peritoneal cavity so that excess fluid gets drained there. So ventriculoperitoneal shunt, okay, for decompression. Now, few facts about normal dentition in children. So many times again you get questions related to this. So we know there is a primary dentition, which is also called the milk teeth or temporary teeth, which begins. So when does the first tooth appear in the baby? So the first tooth appears in the baby at around 6 to 7 months of age. Okay, and the first tooth, which is the first tooth to appear? It is the lower central incisor. Lower central incisor. Okay. And the primary dentition usually completes by 2.5 to 3 years. The last milk tooth to come is the second molar. And the total number of teeth in primary dentition is 20. Now, what about secondary dentition or permanent teeth? So you have to read your question very carefully. Whether the question is asking which is the first tooth to appear or it is asking which is the first permanent tooth to appear. Okay? Because the first permanent tooth to appear is the first molar, which appears at around 6 years of age. The secondary dentition or permanent teeth completely appear by 12 years, except the third molar or the wisdom tooth, which come between 18 to 25 years and which may not erupt in some of us. So the last tooth to appear is the third molar or the wisdom tooth. Total number of teeth in permanent dentition is 28 to 32 depending on how many wisdom teeth have erupted. Okay. Now, when do you call it delayed dentition in children? So we call it delayed dentition in children when no teeth has erupted by 13 months age. No teeth by 13 months age, we call it delayed dentition. The causes can be some syndromes like Down syndrome. Okay, Down syndrome. Then there can be some endocrine causes like hypothyroidism, hypopituitarism, hypoparathyroidism. Okay, and it can be familial, it can be due to rickets, okay, and so on. Right? Now, moving ahead to some developmental milestones. So, the very important developmental milestones which you can get again as case scenarios or standalone questions. So, neck control. When does the neck control appear? So, partial neck control usually appears by 3 months of age and complete neck control usually appears by 5 months of age. Okay. Sitting with support. So, everything, remember, it is very, very easy. With support will come first, without support will come later. Okay, and sitting first, then standing, then walking. So sitting with support 6 months, without support 8 months. Standing with support 9 months, without support 12 months. Creeping comes in between 10 to 11 months. Walking with support 12 months, without support 13 months. And rides a tricycle, very, very important milestone, by 3 years. Okay, tricycle, 3 wheels, 3 years. Easy. Important fine motor milestones. There's something called hand regard. That means the child looks at his own hands. So 3 months. Bidextrous grasp, holds with both hands, 4 months. Okay. Palmer, 4 to 5 months. Some books even say 5 months. Okay, 4 months to 5 months. Palmer grasp, 6 months. Transfers objects from one hand to another, 7 months. Immature pencil grasp, 9 months, and mature pencil grasp, 12 months. The child is able to scribble spontaneously at 15 months. Tower of 6 to 7 cubes at 2 years. So number of cubes put in tower is age into 3. Okay, so 2 years tower of 6 cubes, 3 years tower of 9 to 10 cubes. Handedness appears by 2 years and gets established by 3 years. Okay. Now, drawing skills of a child, where the child can copy a straight line. A straight line has got 2 ends, so child is able to copy a straight line at 2 years. Rectangle, 4 vertices, so child is able to copy a rectangle at 4 years. Now, circle is like this round, so 3 number has round, so circle copying at 3 years. Triangle, oblique lines at 5 years. And copying a diamond comes at 6 years, right? So it is very easy to remember. A line has got 2 ends, so 2 years. Rectangle has got 4 vertices, so rectangle or a plus sign at 4 years. Circle has got round, number 3 has got round, so 3 years. Oblique lines 5 years and diamond is 6 years. Okay, ऐसे याद रखना है आपको. सिंपल शेप को देखो, आपको याद आ जाएगा. 2 लाइन में 2 एंड्स है 2 years. रेक्टेंगल 4 वर्टिसेस 4 years. गोल है 3 में. सर्कल 3 years. Oblique lines 5 years. Okay. Social milestones. Social smile usually comes at 2 months. Mirror play. The child smiles and vocalizes at his mirror image 6 months. Stranger anxiety 7 months. Waves bye-bye, important milestone, comes at 9 months. Plays peekaboo 10 months. Plays a simple ball game 12 months. Points to objects. Ye chahiye, wo chahiye, like that. So 15 months. Domestic mimicry and dry during daytime by 18 months. Parallel play 2 years and joins in play 3 years. Parallel play matlab the children will not play with each other. They will keep on playing on their own. Okay. Important language milestone. The child vocalizes by 2 months of age. More musical sound or cooing by 3 months. Monosyllabic babbling like ma, ba, da 6 months. Bisyllabic babbling 9 months. 2 to 3 words with meaning at 1 year. Jargon speech 15 months. 10 words with meaning at 18 months. 2-word sentences 2 years, and 2 years mein the child has a vocabulary of 50 to 100 words. The child knows 50 to 100 words with meaning, right? 3-word sentences at 3 years, and 3 years mein the child knows plurals and past tense, and 4 years pe the child is able to tell a story or a poem or even sing a song, right? Okay. Nocturnal enuresis पे last FMG exam में भी there was a question. So nocturnal enuresis पहले तो when do we call it nocturnal enuresis? Nocturnal means रात में, enuresis means passing of urine. So involuntary urination at night beyond 5 years age. ठीक है, beyond 5 years of age, irrespective of whether it is a boy or girl, the definition remains same. So usually the child becomes dry at night by 3 years. But by 5 years also, if the child continues to void in bed at night, it is called nocturnal enuresis. Males में it is more common than females, and positive family history you can find in more than 50% cases. Okay. अब क्या करना है when there is nocturnal enuresis? The first line of treatment is lifestyle and behavioral motivational therapy. तो क्या करना है आपको? Early dinner, restrict the fluid after evening, restrict sweet food. Motivational therapy, you make a star chart. So every day when the child is staying dry, you give it a star. तो 7 consecutive stars हो जाएंगे तो get a gift for the child. So ऐसे star chart बनाने हैं. So first line of treatment यही होता है, lifestyle changes and motivational therapy. Second line में आप bed and alarm technique use कर सकते हैं. So there you have moisture sensing alarms that are available that can be fitted in the underwear of the child. As soon as the child starts passing urine, the alarm will ring, the child will get up, go to the washroom and void. Third line therapy में आता है drugs. So drugs में you can use like imipramine या oral desmopressin या tricyclic antidepressants. Okay, so desmopressin use कर सकते हैं, but oral nasal desmopressin spray is no longer used because of the side effects. Okay, so that can be used, but it is third line of therapy only. Okay. Now breastfeeding, very very important topic. एक question आता ही आता है. So breastfeeding should be initiated within how much time after our childbirth? So within 1 hour of childbirth. So within 1 hour after childbirth, irrespective of whether it is a cesarean section or vaginal delivery, within 1 hour, breastfeeding should start. Exclusive breastfeeding should be continued for 6 months, first 6 months. Exclusive breastfeeding का क्या मतलब है? So it means that the child should be given only breast milk, nothing else, not even sips of water unless medically indicated. After 6 months क्या देना है? After 6 months you have to start complementary feeding, semi-solid energy dense food in addition to breast milk. Breastfeeding stop नहीं करनी है, that will continue till 2 years of age. What are signs of good positioning while breastfeeding? So body of the baby should be well supported. Okay. So weaning term आजकल use नहीं करते आरुषा. Okay, we do not use the term weaning. It is complementary feeding. Okay, because breastfeeding has to continue. We are not weaning off breastfeeding. Body of the baby should be well supported. Okay, occiput, shoulder and buttocks of the baby should be in a straight line. Baby should be turned towards the mother, and abdomen of the baby should touch the abdomen of mother. Okay, these are signs of good positioning while breastfeeding. And signs of good attachment भी recently आया है, very important. Mouth of the baby should be wide open. Entire areola should be in baby's mouth except a small upper part which may be visible. Lower lip of the baby should be everted or turned out. So inverted नहीं होना चाहिए, it should be everted or turned out. Chin of the baby should touch mother's breast. Okay. So exclusive breastfeeding till 6 months, and breastfeeding can be continued till 2 years age. Okay, 2 years. Okay. So breast milk and cow's milk में क्या, cow milk में क्या differences है, उससे related भी questions come many a time. So we need to know carbohydrate किस में ज़्यादा है. So carbohydrate, lactose is more in breast milk as compared to cow's milk. 7 gram per dl in breast milk, 4.5 gram per dl in cow's milk. Protein is lesser in breast milk. Okay, protein is lesser in breast milk. 1 gram per dl as compared to 3.5 gram per dl in cow's milk. But protein में क्या होता है? The breast milk is richer in whey proteins like lactalbumin, which is more easily digestible. And breast milk contains adequate amount of amino acids like cysteine, taurine, methionine, which are required for the CNS development of the baby. But cow milk has casein, which is not so easily digestible. Breast milk has more of PUFA, polyunsaturated fatty acid, which is beneficial for the baby, and more of DHA. DHA is docosahexaenoic acid, which is again beneficial for the baby. Minerals, the calcium phosphate ratio in the breast milk is such that favors calcium absorption. But cow milk is richer in phosphate. So cow milk fed baby will have hypocalcemia. And breast milk iron is more easily absorbable. More easily absorbable. What about vitamins? So breast milk contains adequate amount of all vitamins except vitamin D and vitamin K are less. While in cow's milk, vitamin C is less. Okay, right? So breast milk contains more what? Breast milk contains more, yes, more lactose and lesser protein as compared to cow's milk. And breast milk contains adequate amount of all vitamins except vitamin D, vitamin K and vitamin B12 and strictly vegan mothers who don't even take cow's milk. Okay. Human colostrum related questions have come recently. So human colostrum, what do you mean by colostrum? So it is the milk produced in the first 72 hours after birth. It is thick and yellowish, richer in immunoglobulin, proteins, macrophages. Because these things are there, it is called the first immunization of the baby. It is called the first immunization of the baby. And it is poor in lactose. So it is not very tasty for the baby, but very beneficial for the baby, should be fed to all the babies. Okay, it is the yellow milk. No, it does not come in the end. End में जो आता है वो hind milk होता है. You are confusing. Okay, Floxy. So the milk that comes at the beginning of a breastfeeding session is called fore milk. It is thin and watery. Milk that comes at the end of a breastfeeding session is hind milk. It is thick and richer in fat. But colostrum अलग है. Colostrum is the milk that is coming in the first 72 hours. Okay. For how long can express breast milk be stored? So at room temperature around 8 hours, in a refrigerator around 24 hours, and in a deep freezer around minus 20 degrees Celsius पे almost 3 months. So human milk banks are there जहाँ पे हम store कर सकते हैं 3 months. Absolute contraindication to breastfeeding. So related to the baby, if we talk about, if the baby is a confirmed case of galactosemia, then it is absolute contraindication, confirmed case of galactosemia. Related to mother, if the mother is on chemotherapy or radiotherapy. Chemotherapy or radiotherapy. So this is absolute contraindication. Okay? Relative contraindication will be some infections in the mother, like maternal HIV, maternal herpes या varicella zoster lesions involving the breast and nipple area, maternal TB जहाँ पे ATT start नहीं हुआ है. What is the recommendation in maternal HIV? So maternal HIV में if you have a safe source of replacement feeding, अगर आपके पास available है, then you can avoid breastfeeding. But in developing countries like India, you have to see the risk versus benefit. If you do not have a safe source of replacement feeding which is affordable, sustainable, feasible, safe, so better to continue breastfeeding. So it is a relative contraindication, not an absolute contraindication. Okay. So signs of adequate breastfeeding. So signs of adequate breastfeeding in a neonate. So baby will sleep for, so adequate breastfeeding hai, so baby will sleep for how many hours after feeding? So if a mother is telling, case scenario aa raha hai, so mother is telling that the baby is not able to sleep. So mother is telling that the baby is not able to, mother is worried कि बच्चे को adequate feed जा रहा है या नहीं. How will you reassure the mother? So you have to tell her that if the baby is sleeping for 2 hours, 1 to 2 hours after feeding, baby is urinating 6 to 7 times per day, and the baby gains weight, then matlab adequate breastfeeding is there for the neonate. You need not worry. Okay? ठीक है? Now WHO classification of malnutrition is very very important because इससे आपको direct questions आते हैं, terminologies. Okay? So if we look at the weight for height, okay, weight for height is between -2 to -3 Z score or between 70 to 79% of expected. तो हम उसको क्या बोलते हैं? What do you call it? Wasting. Decrease in weight for height is called wasting, and wasting is an indicator of क्या? So wasting is an indicator of acute malnutrition. Acute malnutrition. Okay? And decrease in height for age को क्या बोलते हैं? Decrease in height for age is called stunting. है ना? And stunting is an indicator of chronic malnutrition. Chronic malnutrition. Okay? So decrease in weight for height is wasting. And अगर weight for height is less than -3 Z score or less than 70% of expected, it is severe wasting. Severe wasting. Okay? If the height for age is less than -3 Z score or less than 85% of expected, it is severe stunting. Okay? Severe stunting. Right? Now, there is a very, very important terminology. Almost every alternate exam, you get it, severe acute malnutrition. What do you mean by severe acute malnutrition? So, in a child 6 months to 5 years of age, presence of one or more of, क्या चीज़ है? If the weight for height is less than 70% of expected, less than 70% of expected or less than -3 Z score. Okay, less than -3 Z score. Mid arm circumference कितना? So SAM के लिए mid arm circumference less than 11.5 centimeters or symmetric bipedal edema of nutritional origin. Any of these is there, then we call it severe acute malnutrition. So if a child has severe acute malnutrition, you have to admit the child to the hospital. You have to look for the complications and treat. जैसे hypoglycemia, hypothermia, infections, dehydration, all that you have to look for it and treat. Okay? And you have to do nutritional rehabilitation. So जब हम nutritional rehabilitation करते हैं ना, we have to do it very very gradually. So gradual nutritional rehabilitation. Gradual nutritional rehabilitation. Why gradual? To prevent nutritional recovery syndrome. To prevent nutritional recovery syndrome or refeeding syndrome. Nutritional recovery syndrome or refeeding syndrome, you have to prevent it. Okay? Right? Yes. So Aisha, marker for chronic malnutrition is decrease in height for age, that is stunting. Okay? So nutritional recovery syndrome or refeeding syndrome we want to prevent. So if a child with severe acute malnutrition has got diarrhea, we will like to avoid IV fluids. SAM में अगर diarrhea है, this also sometimes comes as a question. If diarrhea है, what is the fluid of choice? We use Resomal. Resomal is rehydration solution for malnourished child. It is different from ORS. It has got lesser sodium, more potassium and some micronutrients as well. And try to avoid IV fluids in a child with SAM because इनमें already edema है, they will straight away go into fluid overload. So unless the child is in shock, we want to avoid IV fluids. Okay? Right? So Resomal is rehydration solution for malnourished child. Rehydration solution for malnourished child. Okay? अब हमने एडमिट तो कर लिया द चाइल्ड विद सिवियर अक्यूट मैलन्यूट्रिशन, व्हेन विल यू डिस्चार्ज फ्रॉम हॉस्पिटल? सो डिस्चार्ज करेंगे व्हेन द चाइल्ड शुड बी एक्सेप्टिंग वेल ओरली, नहीं तो फिर से मैलन्यूट्रिशन हो जाएगा. द चाइल्ड शुड हैव लॉस्ट edema एंड स्टार्टेड गेनिंग वेट. Okay, all infections and micronutrient deficiencies should have been treated and mother should be confident of taking care of the child at home. Okay, so आपको रेजोमाल के बारे में you need not know the exact composition, you need to know the composition of WHO ORS, which we will be talking about कि glucose 75 होना चाहिए and sodium 75 होना चाहिए, total osmolarity is 245. What you need to remember is रेजोमाल का difference from the ORS. So ORS से रेजोमाल, how is it different? So resomal has got lesser sodium and more potassium. Okay, right? Now, इस पे recently question आया in the FMGE exam, when do you call it treatment failure in a child with severe acute malnutrition? So treatment failure हम बोलेंगे if the child has failure to regain appetite poor है by day 4, failure to start losing edema by day 4, and day 10 of treatment में if edema is still present and the child is not able to gain 5 gram per kg per day by day 10, then we say it is failure to treatment. एक secondary failure to treatment भी है कि initially the child was responding, then later on in the rehabilitation phase the child is not gaining 5 gram per kg per day for 3 consecutive days. So treatment failure पे भी recently question आया है. So you have to look at appetite, you have to see edema है या नहीं, and you have to see 5 gram per kg per day gain होना चाहिए weight में. Okay. Now, again you get questions related to kwashiorkor and marasmus, right? Kwashiorkor में क्या होता है? So kwashiorkor is mainly protein deficiency along with of course calorie deficiency. Okay, mainly protein deficiency. But marasmus में it is mainly calorie deficiency. Okay, mainly calorie deficiency, right? So अब kwashiorkor में because it is mainly protein deficiency, edema is present, there is poor appetite and the child has apathy and listlessness. The child is not interested in surroundings. So these 3 are the salient features of kwashiorkor. Edema present, poor appetite, apathy and listlessness. Okay. And marasmus में it is mainly the calorie deficiency. ठीक है, protein deficiency उतना नहीं है, it is mainly the calorie deficiency. So marasmus में if both are the options, we will mark calorie deficiency, not protein. So marasmus में edema is not there. Appetite is good or voracious appetite. The child wants to eat anything that comes in front of him. There is no apathy or listlessness. The child is active, alert. Kwashiorkor में usually there is a fatty hepatomegaly, skin and hair changes are also present. Marasmus में नहीं है. Fatty hepatomegaly, skin and hair changes are not there. Skin में you get flag sign and hair changes. Hair में, so skin में you get flaky paint dermatosis. Okay. And hair में you get flag sign, मतलब alternate bands of pigmented and hypopigmented hairs, right? What are these features? So these are features of, we all know what are these features of vitamin A deficiency. So you know there's a whole WHO staging. So XN है night blindness. Night blindness is the earliest symptom of vitamin A deficiency. Night blindness, right? And earliest sign would be conjunctival xerosis. Earliest sign is conjunctival xerosis. Then you have X1b is Bitot spot. Bitot spot में क्या होता है? So you can get an image based question also. If there's the eye like this, Bitot spot will be triangular like this. You will have pearly white triangular lesions on either side of the cornea involving the sclera. Then there can be corneal xerosis, there can be corneal ulceration and scarring. Okay, right? Treatment of vitamin A deficiency, again very very important. You get questions about the dose as well. Okay? So if the age of the child is less than 6 months, then oral vitamin A dose will be 50,000 international units per dose. 6 to 12 months, 1 lakh international units per dose. More than 1 year will be 2 lakh international units per dose. Okay? So more than 1 year में 2 lakh international units per dose है, but remember, only if the weight of the child is more than 8 kg. अगर weight is less than 8 kg, in say a 15-month-old or 18-month-old child, weight अगर less than 8 kg है, we will give 1 lakh international units. Okay? If less than 8 kg. Right? Good. और treatment of vitamin A deficiency में how many doses you will give? You will give 3 doses. At diagnosis, 24 hours later and 2 weeks later. Okay, 3 doses. Prophylaxis में हम कितना देते हैं? 9 mega doses. The first dose with the measles rubella vaccine. Okay, MR vaccine. So you get features of vitamin deficiency is very very commonly asked in every other exam that you give. So उसमें क्या होता है? बेरी बेरी के अगर if you are getting features, so you are getting irritability, peripheral neuritis या फिर edema, heart failure, history of polished rice intake, we think of berry berry. It is which vitamin deficiency? Thiamine or vitamin B1. Okay. ग्लॉसाइटिस, चिलाइटिस, एंगुलर स्टोमेटाइटिस, केराटाइटिस, ये सब आपको मिलेगा राइबोफ्लेविन डेफिशिएंसी में, राइबोफ्लेविन डेफिशिएंसी और विटामिन B2. ओके, व्हाट अबाउट डर्मेटाइटिस, डिमेंशिया, डायरिया एंड इवन डेथ कैन हैपन. सो 4 Ds. सो ये किस में होता है? सो इट इज इन पेलाग्रा. पेलाग्रा इज विच विटामिन डेफिशिएंसी? नायसिन डेफिशिएंसी. ओके, नायसिन डेफिशिएंसी. एंड फोटोसेंसिटिव रैश होता है. कसाल्स नेकलेस इज व्हाट इज कॉल्ड. ओके. Refractory neonatal seizures, which vitamin deficiency? Yes, refractory neonatal seizures you can get in pyridoxine deficiency or vitamin B6 deficiency. Very good, Nikhil. Okay, so megaloblastic anemia, subacute combined degeneration of spinal cord, ये आपको मिल सकता है vitamin B12 deficiency में, vitamin B12 और cobalamin deficiency. Developmental delay, seizures, skin and hair changes, ये सारा आपको मिल सकता है biotin deficiency. So wherever you are getting CNS involvement and skin or hair involvement, think of biotin deficiency. Diarrhea, rash around the orifices, so it is also known as acrodermatitis enteropathica. Acrodermatitis enteropathica. ठीक है, तो ये this you get in zinc deficiency. Okay, zinc deficiency. So these are some common micronutrient deficiencies from which you can get case scenarios and questions. Now, which vitamin deficiency can you tell me can cause collagen defect? Yes, which vitamin deficiency can cause collagen defect? Waiting for your answers. And the disease that is caused by it, of course, is called scurvy. Very good. I can see almost all of you answering. So vitamin C deficiency will give rise to scurvy. And scurvy, vitamin C is required for collagen synthesis. So collagen defect is there. Collagen is the backbone of blood vessels. So collagen agar defective rahega, what will happen? The blood vessels will be fragile. So scurvy mein what you can get? You can get gum bleeding. You can get subperiosteal hemorrhage involving the long bones. Okay, subperiosteal hemorrhage of long bones. So it is such a painful condition that the child will not want to move the limbs. So it is called painful pseudoparalysis. Painful pseudoparalysis of limbs. Okay, painful pseudoparalysis of limbs. Okay, and you can get scorbutic rosary. Okay, prominence of ribs can be there, right? And you can get a history of cow milk fed baby. Cow milk, we said, is poor in vitamin C, and moreover vitamin C is heat labile. You boil the cow milk, it will go away. Okay. Calculation of maintenance fluid requirement in children. And before that, vitamin C deficiency we said is scurvy, and of course we all know vitamin D deficiency is the most common cause of nutritional rickets. है ना? So rickets again can have this ricketic rosary can be there. There can be wrist widening. There can be frontal bossing, parietal bossing, Harrison sulcus, and so on. And features of hypocalcemia can be there, like seizures, tetany. Okay. Calculation of maintenance fluid requirement in children. You can get a 14 kg child है, उसमें कितना maintenance fluid दोगे? The child is NPO for a surgery. You want to give IV fluids. How much fluid will you give in 24 hours? So we calculate using holiday cigar method. So first 10 kgs के लिए we will give 100 ml per kg. Next 10 kgs के लिए 50 ml per kg. Beyond 20 kg we give 20 ml per kg. So अब बताओ, for 14 kg child how much will we give? So for first 10 kgs we will give 100 into 10, that is 1000. For next 4 kgs we will give 50 into 4, that means 200. So we will give 1200 ml in 24 hours for this child. The fluid of choice in children abhi is, in older children it is DNS. DNS, dextrose normal saline with added potassium, 1 ml KCl per 100 ml. So this is the fluid of choice. We may also use N/2 in 5% dextrose with KCl. Okay. But older children we prefer using DNS, right? Now, antidotes of common poisoning already you've discussed in pharmacology, but the common ones which have been asked recently, paracetamol toxicity. Case scenario, the child, paracetamol ki bottle se, the child has drank the syrup and come to you. So, antidote uska we know is N-acetylcysteine. Okay. बेंजोडायजेपिन सर ने ऑलरेडी बताया आपको, फ्लूमाजेनिल. ओपियोइड, मदर को लेबर के समय मॉर्फिन मिला है, ओपियोइड एनाल्जेसिक्स मिले, द बेबी इज डिप्रेस्ड, व्हाट विल यू गिव? सो यू कैन गिव नेलॉक्सोन टू द बेबी, राइट? नेलॉक्सोन टू द बेबी, राइट? एंड आयरन टॉक्सिसिटी, अ बेबी हैज टेकन अ लॉट ऑफ, अ चाइल्ड हैज ईटन, घर में आयरन के टैबलेट्स पड़े थे, 10 टैबलेट्स खा लिया. सो आयरन के लिए टॉक्सिसिटी वी विल यूज द आयरन चिलेटिंग एजेंट्स विच वी ऑल्सो यूज इन थैलेसेमिया. सो व्हाट इज इट? डेस्फेरिऑक्सामिन. What are the other drugs used in thalassemia for iron chelation? Deferiprone, Deferacirox, okay, right? And heparin के लिए we know it is protamine sulfate, protamine sulfate. कौन से poisoning के लिए you have to tell me? Atropine and pralidoxim is used. Atropine and pralidoxim is used in which poisoning treatment? Yes, वेटिंग फॉर योर आंसर्स. सो एक केस सिनेरियो आता है जिसमें बच्चे को बहुत सारी स्वेटिंग हो रही है, बहुत सारा सलाइवेशन हो रहा है, लॉट ऑफ सिक्रीशंस आर कमिंग. सो एंड देयर इज अ हिस्ट्री ऑफ एक्सपोजर टू इंसेक्टिसाइड, स्प्रे हो रहे थे फील्ड में. सो वेरी गुड ऑल ऑफ यू, अलीशा, शिवांगी, डेवली, आयशा. सो organophosphate poisoning we'll think of in this case scenario, and of course the antidote will be atropine and pralidoxim. अब ये बताओ इन डिजीजेज में क्या कॉमन है? So we know the mode of inheritance for these diseases is autosomal dominant. So straightforward questions भी आते हैं, which of the following has autosomal dominant inheritance? So you have hereditary, so you can remember by the mnemonic heavy dominant. So hereditary spherocytosis, autosomal dominant polycystic kidney disease. Osteogenesis imperfecta में क्या होता है? There is a triad. क्या triad होता है? So it is again a type 1 collagen defect. There is a triad of, so you can get a case scenario blue sclera. जो white part of the eye है, instead of that it is blue. And you have recurrent fractures which lead to bony deformities. Okay, recurrent fractures which lead to bony deformities, and you have deafness. Right? Okay. Then Marfan syndrome. Marfan syndrome में क्या होता है? So Marfan syndrome, there is tall stature, है ना? Fibrillin gene defect. So there is tall stature. There is arachnodactyly. You have pectus carinatum या pectus excavatum हो सकता है. Right? Okay. Intermittent porphyria, neurofibromatosis, we know neurofibromatosis में neurofibromas हो सकते हैं, they can be capiolae spots, okay, freckles can be there, Lish nodules on iris. Achondroplasia we already discussed. Noonan syndrome has some similarities with Turner syndrome, okay, but Noonan syndrome can be seen in both boys and girls. Turner syndrome किस में होता है? सिर्फ females में, right? And tuberous sclerosis again another न्यूरोक्यूटेनियस डिसऑर्डर. ट्यूबरस स्क्लेरोसिस में क्या स्किन लीशंस होते हैं? सो एश लीफ मैक्यूल्स, एश लीफ स्पॉट्स, शैग्रीन पैचेस एंड सो ऑन. ओके, एडेनोमा सिबेशियम, राइट? ओके, अब बताओ ये डिजीजेस का क्या मोड ऑफ इनहेरिटेंस है? सो दीज आर डिजीजेस विच हैव गॉट ऑटोसोमल रिसेसिव इनहेरिटेंस, राइट? So albinism, alkaptonuria is with what deficiency? Homogentisic acid oxidase. फिर beta thalassemia, sickle cell anemia, cystic fibrosis. So these are very important diseases. All of them have autosomal recessive inheritance. Congenital adrenal hyperplasia or CAH, right? Then Gaucher disease, galactosemia, homocystinuria. These are the important ones. Homocystinuria has clinical features similar to Marfan syndrome. Some examples of diseases with X-linked recessive inheritance. Hematological diseases कौन बताएगा? X-linked recessive inheritance का example hemophilia, right? Hemophilia is an example. G6PD deficiency. Okay. IEMs with X-linked inheritance, X-linked recessive inheritance. IEMs, inborn errors of metabolism. So Hunter disease, right? Hunter disease, okay, Hunter disease, Fabry disease have X-linked recessive inheritance. Even Lesch-Nyhan syndrome, okay, Lesch-Nyhan syndrome, right? Immunodeficiency syndromes with X-linked recessive inheritance, बताओ. So Bruton's X-linked A-gamma globulinemia, Bruton's A-gamma globulinemia, okay, जिसमें immunoglobulins are low. Then CGD, chronic granulomatous disease, Wiskott-Aldrich syndrome. ये सब X-linked recessive inheritance है. VASP gene is there. Wiskott-Aldrich syndrome में what is the typical triad that you get? So there is recurrent infections, immunodeficiency है ना? So recurrent infections, and you have thrombocytopenia, and platelets are of small size, and atopic dermatitis like rash. Atopic dermatitis like rash. Okay. Other genetic disorders which have X-linked recessive inheritance, उसमें एक important one is DMD, Duchenne's muscular dystrophy and Becker's muscular dystrophy. So these are some important ones with X-linked recessive inheritance. X-linked dominant inheritance, one or two you need to remember. One we already mentioned is Rett syndrome. Rett syndrome, MECP2 gene is most commonly involved, more common in girls, and one is X-linked hypophosphatemic rickets. Hypophosphatemic rickets. Yes, so very good. Gowers sign किसमें मिलता है? So Gowers sign, Kirtal, Gowers sign we get in this Duchenne muscular dystrophy and Becker muscular dystrophy. You can get this Gowers sign, difficulty in getting up from sitting position, but it is not specific. It can be seen in any disorder where there is proximal muscle weakness. एक pedigree आपको दिया है, उससे how do you identify the type of inheritance? So if all the children of an affected female are diseased, what kind of inheritance it is? We know it is, yes, देखो जैसे इसमें this female is affected, all her children are affected. This. Again, you see this female is affected, all her children are affected. This female is affected, all her children are affected. What kind of inheritance? So it is mitochondrial inheritance. Mitochondrial. Example क्या है? Example है Leber's hereditary optic neuropathy, leg disease, MELAS, MRF. So mitochondrial inheritance. If at least one of the parent is affected, कोई भी बच्चा affected है, at least one parent is affected, then it is dominant inheritance. If males and females are affected with equal frequency, it is autosomal. कोई sex link नहीं है, autosomal inheritance है. ठीक है? And father to son transmission अगर है, it rules out X-linked inheritance. X-linked नहीं होगा, it will be autosomal. क्योंकि father का हमेशा Y chromosome goes to the son. Father का X chromosome never goes to the son. तो father to son transmission will rule out X-linked inheritance. Okay? अब ये बताओ most common chromosomal abnormality in children is Down syndrome. क्या basic defect है Down syndrome में? So there will be 3 copies of chromosome 21, right? Or trisomy 21. Okay? And it is most commonly caused by meiosis में, mother के meiosis में problem हो रही है, maternal meiotic non-disjunction. जैसे जैसे मदर की एज बढ़ती जाती है, रिस्क ऑफ डाउन सिंड्रोम इन द बेबी इंक्रीजेस. सो मैटरनल मियोटिक नॉन डिसजंक्शन. ओके, राइट. सो डाउन सिंड्रोम के डायग्नोसिस के लिए व्हाट इज दिस इन्वेस्टिगेशन? यू मे बी आस्क्ड व्हाट इन्वेस्टिगेशन इज दिस? इट इज अ कैरियोटाइप. कैरियोटाइप जिसमें आप सारे क्रोमोसोम देख रहे हो. एंड दिस क्रोमोसोम 21 देयर आर 3 कॉपीज. ओके, सो दिस इज डाउन सिंड्रोम. एंटीनेटल स्क्रीनिंग ऑफ डाउन सिंड्रोम में क्या करते हैं? सो डाउन सिंड्रोम में नहीं मिलता है. रॉकर बॉटम फुट इज देयर इन एडवर्ड सिंड्रोम. ओके केतन, नॉट इन डाउन सिंड्रोम. सो डाउन सिंड्रोम में यू हैव मोंगोलॉइड स्लैंट ऑफ आईज, डिप्रेस्ड ब्रिज ऑफ नोज, ओके, एंड प्रोट्रूडेड टंग, फ्लैट ऑक्सीपोर्ट एंड सो ऑन. ओके, सो बायोकेमिकल मार्कर्स क्या होते हैं स्क्रीनिंग के लिए डाउन सिंड्रोम के लिए? फर्स्ट ट्राइमेस्टर में यू कैन डू पैप ए, प्रेगनेंसी एसोसिएटेड प्लाज्मा प्रोटीन ए एंड बीटा HCG. ठीक है. एंड आप न्यूकल थिकनेस देख सकते हो ऑन इमेजिंग. न्यूकल थिकनेस, नेक के पीछे का थिकनेस, ओके, ऑन अल्ट्रासाउंड. सेकेंड ट्राइमेस्टर में क्या करते हैं? सेकेंड ट्राइमेस्टर में यू कैन डू आइदर अ ट्रिपल टेस्ट जिसमें बीटा HCG, अनकॉन्जुगेटेड एस्ट्रेरॉल, अल्फा फीटोप्रोटीन है. क्वाड्रुपल टेस्ट इज ट्रिपल टेस्ट प्लस इनहिबिन. एंड एक आप कर सकते हो इंटीग्रेटेड टेस्ट, विच इज़ द बेस्ट स्क्रीनिंग टेस्ट आउट ऑफ दीज. इंटीग्रेटेड टेस्ट इज द बेस्ट वन. उसमें आप मैटरनल एज, फर्स्ट ट्राइमेस्टर की न्यूकल थिकनेस एंड पैप एंड सेकेंड ट्राइमेस्टर क्वाड्रुपल, एवरीथिंग यू आर टेकिंग. ओके, व्हाट इज NIPS? नॉन इन्वेजिव प्रीनेटल स्क्रीनिंग कैन बी डन. उसमें आप सेल फ्री फीटल DNA इन मैटरनल ब्लड. तो मदर के ब्लड का सैंपल लेके यू find out the fetal DNA in that and you analyze it. So cell-free fetal DNA in maternal blood is used for this analysis, and this can be done beyond 10 weeks of gestation. Okay, so this is very, very sensitive screening test for Down syndrome, but the confirmatory test is fetal karyotype. Confirmatory test अगर पूछे, it is fetal karyotype. अब fetus का karyotype करना है तो you have to get the fetal material. कैसे लोगे? If the pregnancy is 11 to 13 weeks, you do a chorionic villus sampling. If it is 14 to 16 weeks, you do a amniocentesis. Okay, if it is 17 to 20 weeks, you can do a chordocentesis. So say take out the fetal material and do a fetal karyotype, but then it carries the risk of abortion. If you're getting a case scenario where there's a short stature in a female with primary amenorrhea, you think of, yes, Turner syndrome. Turner syndrome क्या होता है? 45XO, right? That means one single X chromosome, no Y chromosome, okay? No Y chromosome. So it is always seen in girls, always seen in girls, right? और क्या होता है टर्नर सिंड्रोम में? So most common congenital heart disease in these females is bicuspid aortic valve. If that is not there in your options, then it is coarctation of aorta. Next common is coarctation of aorta. Okay. And इनमें क्या होता है? Webbed neck is there. There is streak ovaries, rudimentary uterus. There is cubitus valgus. Okay. Short stature, but the intelligence is normal. Normal intelligence. Okay. Normal intelligence. Right. Now, you may be given some genetic disorders. Match the following type questions can be there. Ki what is the genetic abnormality? So we all know Edwards syndrome, E for E. Edwards syndrome is trisomy 18. Patau syndrome we know is trisomy 13. Cry-do-chat syndrome is what? It is 5p minus. That means deletion in the short arm of chromosome 5. Fragile X syndrome is kya? Trinucleotide repeat disorder. CGG repeats. Increase in the number of CGG repeats. So it is a trinucleotide repeat disorder. Mostly seen in males, and there is mental retardation, large head, large ears, large jaw, large testis. Okay. So trinucleotide repeat disorder. Prader-Willi syndrome ka there's a unique, there are multiple mechanisms of inheritance. So unique feature hai ki it is a epigenetic imprinting disorder. Okay, disorder of genomic imprinting. Disorder of abnormal genetic imprinting. Okay, imprinting disorder se ye ho sakta hai, and it can also be due to, remember, P for P. So paternal gene deletion. Paternal gene deletion of the UBE3A gene on chromosome 15. तो पैटर्नल डिलीशन से हो सकता है, या फिर मैटर्नल डाइजोमी, मदर की जीन की 2 कॉपीज आ गई, या फादर्स जीन गॉट डिलीटेड. So paternal deletion or maternal disomy can cause it. And yes, there is obesity, there is hypogonadism, okay, and so on, right? Intellectual disability. पाल्स गाइडलाइन के क्वेश्चन आए ए बी सी डी ई क्या होता है उसमें. सो वी नो वेन एवर देर इज अ सिक चाइल्ड, ए इज फॉर यू हैव टू टेक केयर ऑफ द एयरवे, बी इज फॉर ब्रीदिंग, सी इज फॉर सर्कुलेशन, ओके, सर्कुलेशन, डी इज फॉर डिजेबिलिटी, ओके, एंड ई इज फॉर एक्सपोजर. सो ये डी और ई हमें पता होना चाहिए. इज बीन आस्क्ड प्रीवियसली. डी इज फॉर डिजेबिलिटी, ई इज फॉर एक्सपोजर. आइडियली इन अ सिक चाइल्ड यू शुड बी एबल टू गेट IV एक्सेस विद इन 1 minute. अगर 1 minute में नहीं में हो रहा है, इट इज़ रिकमेंडेड दैट यू गो अहेड एंड सिक्योर अ इंट्रा ऑशियस एक्सेस. इंट्रा ऑशियस एक्सेस बच्चों में यूजुअली वी डू इट ऑन द अपर पार्ट ऑफ टिबिया, शिन बोन पे करते हैं. ओके. Now, enzyme deficient in these metabolic disorders. So, Von-Guillain disease, we know what is the enzyme deficient? Glucose 6-phosphatase. So, क्या होता है? Glucose 6-phosphate is not getting converted to glucose. So, क्या होगा? There will be hypoglycemia. Hypoglycemia की वजह से early morning lethargy and seizures can be there. Now, excess of glucose 6-phosphate is accumulating by the glycolytic pathway. It is forming acetyl CoA. Acetyl CoA से आपका triglycerides बन रहे हैं, lipids बन रहे हैं. So there is hyperlipidemia and there is doll-like facies. Doll-like facies. Okay, doll-like facies. Elevated lactates, increased lactate and increased uric acid. Okay. Cori disease में क्या होता है? So Cori disease में there is D-branching enzyme deficiency. So features similar to Von-Guillain disease plus muscle involvement. Okay, plus muscle involvement. Von-Guillain के features plus muscle involvement. Pompe disease, what is the enzyme deficient? Direct question आया है recently. So Pompe disease, the enzyme deficient is acid maltase or alpha glucosidase. McArdle disease, it is M for M, muscle phosphorylase. Muscle phosphorylase. गॉशे डिजीज में क्या होता है? गॉशे डिजीज में गॉशे डिजीज ग्लूकोसेरेब्रोसाइडेज. So glucocerebrosides accumulate and Gaucher's cells बन जाते हैं with crumpled tissue paper appearance of cytoplasm. So the child can have splenohepatomegaly, huge spleen, splenohepatomegaly and pancytopenia. Okay, pancytopenia. Okay, phenylketonuria, phenylalanine hydroxylase deficiency. Phenylalanine hydroxylase deficiency. Hypopigmentation is there, intellectual disability, hypertonia, mousy or musty odor of urine. So this is the क्या है ये? This is the Gaucher cell. देख लो, crumpled tissue paper appearance of the cytoplasm. And it is important because you have enzyme replacement therapy is available. Enzyme replacement therapy is available for Gaucher disease. And और क्या क्या diseases के लिए it is available? So it is available for Gaucher disease, Pompe disease, among the mucopolysaccharidosis type 1, 2 and 6 के लिए it is available, Hurler, Hunter and Matrix-Lamy. Fabry disease, Niemann-Pick recently it has become available. So enzyme replacement therapy is available for these disorders. Okay. Phenylketonuria, हमने बोला already, phenylalanine hydroxylase is deficient. Substances accumulate, phenyl acetate, phenyl pyruvate accumulate हो रहे हैं. Excess of phenylalanine is getting accumulated, which is causing brain damage. Okay, so it leads to brain damage. And here क्या हो रहा है? Tyrosin is not getting synthesized in body. This enzyme is deficient है ना, ये enzyme deficient है, so tyrosin is not getting synthesized in body. So tyrosin becomes essential amino acid, becomes essential. And why hypopigmentation we said? So phenylalanine, say phenylalanine hydroxylase makes tyrosin, dopa and melanin. So tyrosin is not getting formed, dopa is not getting formed, melanin is not getting formed. So hypopigmentation. Okay, right? Bilateral oil drop cataract with jaundice is seen in galactosemia. Galactosemia case scenario has come recently. Galactosemia can be due to deficiency of any of the three enzymes. क्या क्या? GALT. What is GALT? Galactose 1-phosphate uridyl transferase. And remember we said breastfeeding is absolutely contraindicated, है ना? So galactose 1-phosphate uridyl transferase. So GALT enzyme can be deficient, or they can be galactokinase deficiency, or epimerase deficiency. Any of these three enzymes can be, can be deficient. Okay. Urine turns black on standing. Again, it is a very favorite question of the FMG exam. Urine turns black on standing. Batao which disorder? So it is alkaptonuria. What is the enzyme deficient? So alkaptonuria, and what is the enzyme deficiency? So it is homogentisic acid oxidase deficiency. Homogentisic acid oxidase या homogentisate oxidase भी बोलते हैं. Deficiency. So polymers of homogentisic acid accumulate in the urine. So urine turns black on standing. And there is also ochronosis. Ochronosis means black dots on sclera of the eye, ear cartilage and so on. Okay. अब आ जाओ some infective disorders, infectious disorders in children. So measles. What happens in measles? So measles, you have a characteristic erythematous maculopapular rash. Erythematous maculopapular rash, which is confluent at places. Jagah jagah pe they are, getting mixed with each other. Maculopapular rash. And you have coplic spots, which is pathognomonic. Coplic spots, buccal mucosa, conjunctiva, even vagina pe. So there can be, reddish spots with whitish center. So coplic spots are pathognomonic. Iske alawa, there is a wet kind of look in the child. So there is cough or coryza, conjunctivitis. Okay. And unimmunized child. Okay. Chicken pox में क्या होता है? So chicken pox typically has got pleomorphic rash. Pleomorphic rash का क्या मतलब है? So you will get vesicles, pustules and ulcerations, crusting, everything at the same time. So different forms of rash at the same time, it is called pleomorphic rash. Okay. And till when the chicken pox remains infective till all the lesions have crusted. Okay. Till all lesions crusted. All lesions have crusted. So from a case scenario, you can find out whether it is chickenpox or not. Erythema infectiosum, you get typically slapped cheek appearance. Fever to rahega, along with that slapped cheek appearance of rash. Hand foot mouth disease, again low grade fever, and you get blisters or blisters in oral cavity, and you get vesicles on palm, sole, etc. And you need just supportive treatment, and it is caused by enteroviruses, Coxsackie virus. Diphtheria. So diphtheria, again, how do you suspect? So if you're getting an unimmunized child with sore throat, difficulty in swallowing, and आपको grayish white pseudomembrane दिख रहा है in the throat, fever may or may not be present, you think of diphtheria. How do you manage? So the drug of choice for diphtheria, the drug of choice is antidiphtheritic serum. Antidiphtheritic serum or diphtheria antitoxin आपको देना पड़ेगा. Along with that, you have to give antibiotics to halt further toxin production. Third generation cephalosporins, penicillin can be given, right? So, and you have to do isolation of the patients. Isolation and of course supportive care. Okay, supportive care. Contacts को क्या करोगे? Again, contacts को you have to isolate. Isolation of contacts, and you have to, agar if any lesions are appearing, you have to send swabs from them, and you have to give chemoprophylaxis of contacts. Okay, you can use penicillin or erythromycin or azithromycin. So penicillin or erythro or azithromycin can be used for the close contacts. And you have got a question recently on vaccination of contacts of a diphtheria case also. So for all individuals who are close contact and who have not received a booster dose in last 5 years, if less than 7 years, you give a dose of DPT. More than 7 years, you give Tdap. Okay, right? And all children who have received less than 4 doses of diphtheria containing vaccine should be immunized, right? So that is important. Now, congenital infections, again an important topic. From the case scenario, you have to identify which congenital infection. So if there is periventricular calcification with hepatosplenomegaly, thrombocytopenia, sensory neural hearing loss, we think of CMV, congenital CMV. Parenchymal calcification of the brain, chorioretinitis, hydrocephalus. कौन सा congenital infection सोचोगे? Yes. So most of the congenital infections are causing microcephaly. Only one causes large head due to hydrocephalus, and that is congenital. Very good. I can see Nikhil, Abdul, Ujjwal, Ketan, Uttara, Scalpel, Vipul, Midhun. So yes, congenital toxoplasmosis. Okay. PDA and cataract and sensory neural hearing loss, congenital rubella. Microcephaly and cicatrizing skin lesions, limb defects, congenital varicella. Hutchinson's triad किसमें मिलता है? Congenital syphilis. And what is the Hutchinson's triad? What is Hutchinson's triad? So Hutchinson's triad, you have 3 things: Hutchinson's teeth or notched incisors, right? And interstitial keratitis and sensory neural hearing loss. Interstitial keratitis, sensory neural hearing loss, right? Or 8 nerve deafness. ये क्या defect है? So here you can see that there is a sac in which the bowel loops have herniated. So there's a sac जिसके tip पे umbilical cord is attached. So what defect is this? So this is a omphalocele. है ना, इसमें the intestine is covered in a sac and umbilical cord is attached to the tip. If the intestine would have been uncovered, so intestine herniated out, intestine exposed without membrane, what defect would it be called? Without any membrane covering. क्या बोलोगे उसको? Without any membrane covering, then we call it gastroschisis. दोनों में ही surgical treatment, surgical correction would be required. Okay. Chances of congenital abnormalities are more with omphalocele, right? National immunization schedule, again important. Birth vaccines, direct question aate hai. What are the vaccines which are recommended at birth? So you have to give BCG. BCG कैसे देते हैं? Intradermally in the left upper arm. You have to give OPV and you have to give hepatitis B. 6 weeks पे what do you give? OPV1, Rota1, Penta1, FIPV1, pneumococcal conjugate 1. 10 weeks पे what do you give? OPV2, Rota2, Penta2. 14 weeks पे you give all the vaccines that you gave at 6 weeks. 6 weeks वाले vaccines again you have to give at 14 weeks, right? 9 to 12 months में MR1, PCV booster, Japanese encephalitis in endemic areas and fractional dose of IPV third dose. 16 to 24 months MR2, DPT booster 1, OPV booster and Japanese encephalitis second dose. 5 to 6 years DPT booster 2 and 10 and 16 years TD, right? First dose of measles rubella vaccine given on 7 months because एक epidemic था. When will you schedule the next dose? So remember, अगर 9 completed months के पहले if you've given any measles vaccine, it is not counted. So again, you will give first dose at 9 months and second dose at 16 to 24 months, जैसे कि आपने देखा था ये National Immunization Schedule में MR2, right? Management of an infant born to hepatitis B positive mother. Mother is SBS-AG positive. So baby should be given both hepatitis B vaccine plus hepatitis B immunoglobulin within 12 hours of birth using 2 separate syringes to prevent the vertical transmission. Okay. What is open vial policy? Open vial policy will allow reuse of certain vaccines up to 4 weeks of opening, provided expiry date should not have passed. VVM जो है वो दिखाएगा vaccine should be usable. What is VVM? So VVM is vaccine vial monitor, है ना? So VVM is this. This is VVM. VVM is vaccine vial monitor. Vaccine vial monitor, which has got one circle and a square. If the color of the square is lighter than the circle, you can use the vaccine. If it is same or darker, then you cannot use the vaccine. It indicates whether heat damage has been there to the vaccine or not. So, agar expiry date has not passed, VVM shows it is usable, square is lighter in color, aseptic technique used, vaccine vial septum not submerged in water, you can reuse these vaccines up to 4 weeks of opening. But there are some vaccines that do not follow open vial policy like BCG, MR. So, ये vaccines को ना, you have once opened it, you have to use it in that immunization session within 4 hours. Most of the other vaccines will follow the open vial policy. What is enoxaparin purpura? So remember, it is palpable purpura. Palpable purpura with presence of one or more of abdominal pain, joint involvement in the form of either arthritis or arthralgia, renal involvement, so it can be hematuria, proteinuria, and any biopsy showing IgA deposition. Any one of these, if it is present along with palpable purpura, we call it henoch-Schönlein purpura. Very good, Vaibhav. So no thrombocytopenia. Even though it is a purpura, remember there is no thrombocytopenia. So thrombocytopenia is usually absent. Usually no treatment is required, but in severe cases where there is severe GI bleeding, severe abdominal pain, you can use steroids. Now Kawasaki disease, what is Kawasaki disease? We know Kawasaki disease is fever for more than 5 days. So fever for more than 5 days, whereas any 4 out of 5 cream features. What are cream? So C is conjunctivitis, which is non-purulent. R is rash involving the trunk. E is edema and erythema of extremities. A is adenopathy or lymphadenopathy. M is mucosal involvement in the form of strawberry tongue, right? Any 4 out of these 5 features are there along with fever, we call it Kawasaki disease. Drug of choice for Kawasaki disease we know is IVIG. Drug of choice is IVIG, not aspirin. Drug of choice is intravenous immunoglobulin, and along with that we give high dose aspirin therapy. Important complication of untreated Kawasaki disease is coronary artery aneurysm. Coronary artery aneurysm. Now, recently in the FMGE exam, it was a question that a child with untreated Kawasaki disease has developed coronary artery aneurysm. What will we do? So then if coronary artery aneurysm, if small aneurysm has developed, then you have to continue aspirin prophylaxis, continue long-term aspirin prophylaxis. Not prophylaxis, actually it is secondary prophylaxis, treatment ही हो गया एक तरह से. If it is moderate aneurysm, तो आपको 2 drug देना पड़ेगा, aspirin and clopidogrel. And if it is giant aneurysm, more than 8 millimeter, then you might have to give low molecular weight heparin or even warfarin. And agar to there is development of thrombus, then you have to give thrombolytics. Okay, thrombolytics, right? Okay, coming to some topics from neonatology. Term neonate किसको बोलते हैं? Very basics. You get questions sometimes. So term neonate is a baby who is born between 37 completed weeks to less than 42 weeks gestation. Preterm neonate born at less than 37 completed weeks. Post-term greater than equal to 42 weeks. Low birth weight neonate किसको बोलते हैं? Birth weight less than 2500 grams. Yes. Very low birth weight less than 1500 grams. Extremely low birth weight less than 1000 grams. Sorted? Okay. Small for date या small for gestational age किसको बोलते हैं? Baby born at with birth weight whose birth weight is less than 10th percentile of expected. Less than 10th percentile of expected according to the gestational age. ठीक है? And large for date is birth weight more than 90th percentile of expected according to the gestational age. Okay. So aspirin you have to give long term till the coronary artery aneurysms resolve. Till then you have to give. If they do not resolve, you might have to even give it lifelong. So on follow up you decide it. Okay. Right. So the latest neonatal resuscitation protocol 2025 guidelines. So recently, guidelines have been slightly revised. So NRP 2025 guidelines, what have they added? So initiate cord management plan has now been added in the guidelines. Okay, cord management plan. So you have to decide whether you want to do delayed cord clamping. Mostly it is done for, all term and near term babies also. You have to do delayed cord clamping, okay, for at least 60 seconds. With term gestation, good muscle tone, breathing or crying, then the baby gets routine care. If the answer is no, then you have to warm, maintain normal temperature, dry position, clear airway. Routine suction is no longer indicated. ठीक है, फिर what else is the difference? So अभी instead of positive pressure ventilation, अगर apnea, gasping, heart rate less than 100 है, you have to do ventilation. Instead of positive pressure ventilation, they've just mentioned the term ventilate. Okay, ventilate. Okay. फिर और क्या difference है? So now the target oxygen saturation table is now starting from 2 minutes instead of 1 minute. Okay, it is starting from 2 minutes instead of 1 minute. Right? Okay. So, and what else is the difference? So, अब बोल रहे कि instead of intubation, you can use laryngeal mask airway safely. Okay. What else? There is a difference in the use of oxygen. So, use of oxygen में क्या difference है? So, it is now telling that ventilation, whenever you're starting ventilation in positive pressure ventilation, you can start with room air in term and late preterm neonates. Okay. 21 to 30% in babies born between 32 to 35 weeks gestation, and 30 to 100% in very preterm babies born at less than 32 weeks gestation. So this is the latest 2025 guidelines in neonatal resuscitation. If you are starting bag and mask ventilation, start with room air in term and late preterm, 21 to 30% oxygen, 32 to 35 weeks gestation, 30 to 100% oxygen in less than 32 weeks gestation. Okay. और एक चीज़ जो इम्पॉर्टेंट है, रेशियो ऑफ चेस्ट कंप्रेशन इज टू पॉजिटिव प्रेशर वेंटिलेशन. सो इन नियोनेटल रिससिटेशन व्हाट शुड बी द रेशियो ऑफ चेस्ट कंप्रेशन एंड पॉजिटिव प्रेशर वेंटिलेशन? वेरी 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 इंपॉर्टेंट. सो इट शुड बी 3:1 एंड नथिंग एल्स. बट इन ओल्डर चाइल्ड अगर आपके पास 1 रेस्क्यूअर है 30:2 and 2 rescuers 15:2 is the ratio of chest compression and positive pressure ventilation. But in neonates it is 3:1, right? Okay. And delayed cord clamping, we said, should be done for all stable term as well as preterm neonates. Okay. But very extremely preterm less than 28 weeks में नहीं करेंगे. Okay. Not in less than 28 weeks baby. And of course, bag and mask ventilation is absolutely contraindicated. Bag and mask ventilation absolutely contraindicated in congenital diaphragmatic hernia. So AMBU you will do at the rate of 40 to 60 breaths per minute, 30 to 60 breaths per minute. Okay. So congenital diaphragmatic hernia. Right. Components of APGAR score क्या है? So you can remember by the name APGAR. A is for appearance. P is for pulse rate. G is for grimace or response to stimulation by catheter. Another is for activity, and R is for respiratory effort or respiration and not for respiratory rate. Okay. and more than 7 is taken to be normal. Whenever a baby is born, क्या क्या करना है? We have to give essential newborn care. उसमें क्या क्या आता है? Immediate care at birth, we've already discussed the resuscitation guidelines. Thermal care, baby को warm रखना है, just dry up the baby. No baby bath till the cord falls. Baby bath नहीं देना है. तो एक बार option था baby bath in first 24 hours. No, it should not be done. Okay. Resuscitation when needed. Cord care, cord को you have to keep clean and dry. Do not apply anything. आई केयर स्टेराइल स्वैब लेके आपको आई को वाइप करना है. ईयर का नथिंग इज मैंशनड. ओके, नथिंग इज मैंशनड इन द एसेंशियल न्यूबॉर्न केयर. इन्फेक्शन प्रिवेंशन, टेक ऑल एसेप्टिक प्रिकॉशंस. ब्रेस्ट फीडिंग शुड स्टार्ट विद इन 1 hour. एंड कोई और हेल्थ प्रॉब्लम्स है क्या देखना है, डेंजर साइंस देखना है, टाइमली एंड सेफ रेफरल. ओके. कैंगरू मदर केयर किसके लिए करते हैं? सो इट शुड बी डन अगेन फॉर ऑल स्टेबल लो बर्थ वेट बेबीज. ठीक है, क्या कॉम्पोनेंट्स है? So the components are kangaroo position, मतलब baby is kept in skin to skin contact with the mother inside the clothing of mother. So kangaroo position, kangaroo nutrition, मतलब which is exclusive breastfeeding. Okay, exclusive breastfeeding. And early discharge from hospital. Early discharge from hospital. What are the advantages? Why are we saying kangaroo mother care? Improved exclusive breastfeeding rates, better gain in weight, head circumference length, and reduced risk of sepsis, hypothermia, length of hospital stay, mortality is up, will reduce. Okay. How do you calculate how much fluid to give in a neonate? So there was a question related to feeding also. आपको चाहे feeding देनी है, top feeding, or you want to give IV fluids, how much you will give. So if the baby in a neonate or newborn baby on day 1 or first 24 hours of life, if the baby's birth weight is less than 1500 grams, we give 80 ml per kg per day. Okay, and if it is more than 1500 grams, we give 60 ml per kg per day. बस ये याद रखो. And then you can see we go on increasing by 15 ml, 10 to 15 ml per day. ठीक है, उतना आपको याद रखने की ज़रूरत नहीं है. This you need not remember. Just day 1 का याद रखो and day 7 में it becomes 150 ml per kg per day. Right, just remember day 1 and day 7. Okay, right? And you know, depending on the gestation of the baby. So if the baby is less than 28 weeks gestation, you have to give IV fluids only. You can give total parenteral nutrition or TPN. 28 to 31 weeks है तो OG feeding, orogastric tube feeding, OG tube से feeding दोगे. 32 to 34 weeks gestation है, then you will give katori spoon feeding, katori spoon feeding. And beyond 34 weeks gestation, you can do direct breastfeeding. Okay. Initial fluid given is 10% dextrose if you have to give IV fluids. Okay. Sodium and potassium are added later. Now, how do you distinguish एक head swelling है baby को तो cephal hematoma है या capered succedaneum? And you get true and false questions also and questions related to characteristics of these. So, cephal hematoma is basically subperiosteal hemorrhage. Subperiosteal hemorrhage involving cranial bones. So, her bone ka, they have their own periosteum. So, subperiosteal hemorrhage is not going to cross sutures. So, it does not cross sutures. But capered succedaneum is edema in the layers of scalp. Nothing to do with bone or periosteum. So, it can cross sutures. Cephal hematoma takes time to appear also, disappear also. So, appears in 24 to 48 hours, disappears in 5 to 7 weeks. And because it is a collection of blood, it predisposes to jaundice. Capered succedaneum appears immediately present at birth, disappears in 48 to 72 hours, and does not predispose to jaundice. ठीक है? Infant of diabetic mother में what are the problems? So metabolic problems क्या होती है? So first thing is the baby is large for date usually. So metabolic problems, there is hypoglycemia, hypocalcemia, hypomagnesemia, polycythemia, and hyperbilirubinemia. Okay. CVS में क्या होता है? More chances of congenital heart diseases, जिसमें से most common is VSD, most specific is TGA. Respiratory में more chances of respiratory distress syndrome. Neurologic में again most common would be neural tube defects. Most specific would be sacral agenesis or caudal regression syndrome. Sacral agenesis और कॉर्डल रिग्रेशन सिंड्रोम. ओके, कॉर्डल, कंजेंटल रूबेला सिंड्रोम नहीं है ये, कॉर्डल रिग्रेशन सिंड्रोम. ओके, रीनल में बहुत सारा हो सकता है. सो दे कैन बी रीनल एजेनेसिस. ओके, रीनल एजेनेसिस, पिडर्सन हाइपोथेसिस बोलते हैं हाइपोग्लाइसेमिया का, नॉट पेंड्रेट, पिडर्सन्स हाइपोथेसिस. सो रीनल एजेनेसिस कैन बी देयर कैन बी डुप्लीकेशन ऑफ यूरेटर. सो रीनल abnormalities, कंजेंटल abnormalities हो सकते हैं. रीनल वेन थ्रोम्बोसिस कैन बी देयर. GI प्रॉब्लम्स कैन बी देयर, है ना. GI प्रॉब्लम्स लाइक स्मॉल और लेजी लेफ्ट कोलोन सिंड्रोम बोलते हैं. लॉन्ग टर्म प्रॉब्लम्स कैन बी देयर लाइक ब्लाइंडनेस. ओके, लॉन्ग टर्म प्रॉब्लम्स कैन बी देयर लाइक ब्लाइंडनेस, ओबेसिटी एंड डायबिटीज इन द बेबी. ओके, इन्फेंट ऑफ डायबिटिक मदर में. मैनेजमेंट ऑफ नियोनेटल हाइपोग्लाइसेमिया, लास्ट FMGE एग्जाम में देयर वाज अ क्वेश्चन ऑन नियोनेटल हाइपोग्लाइसेमिया. सो नियोनेट्स में व्हेन द ब्लड ग्लूकोज इज लेस देन 45 मिलीग्राम पर DL वी से हाइपोग्लाइसेमिया. अब अगर तो देखो बेबी एसिम्टोमेटिक है, सो यू जस्ट ऑफर अ फीड एंड रीचेक ब्लड ग्लूकोज आफ्टर 30 to 45 मिनट्स. अगर नॉर्मल आ गया तो कुछ नहीं करना है. And if it is still low, then you start IV fluids. But if the baby is symptomatic है, मतलब seizures हो रहे हैं, या फिर the baby is having some other manifestation, increased sweating, apneas, so symptomatic है तो you have to give IV 10% dextrose and start continuous IV fluids. Okay, so start continuous IV fluids and monitoring. Okay, right. Primitive neonatal reflexes, rooting reflex helps a mother in breastfeeding. Appears by 32 weeks gestation, starts disappearing by 1 month postnatal age. Moro's reflex क्या होता है? Embrace equivalent, है ना, ऐसे टाइप का होता है. So Moro's reflex begins to appear by 28 weeks, completely appears by 37 weeks, disappears by 5 to 6 months. Normally it is symmetrical, but अगर asymmetrical है Moro's reflex, it is a problem. Asymmetric Moro's reflex कब मिलता है? When do you get asymmetric Moro's reflex? So asymmetric Moro's reflex can be in some bone problems, some neurological problems. So neurological problems like Erb's palsy, congenital hemiplegia, bone problems like fracture clavicle, and clavicle is the most common bone to fracture in a neonate, and unilateral shoulder joint dislocation. Okay. And agar Moro's reflex does not disappear, if it persists beyond 6 months, it indicates brain damage. Okay. Plantar grasp reflex क्या होता है? 28 weeks gestation में आता है, disappears by 3 months. Plantar grasp also and palmar grasp also. Right? Asymmetric tonic neck reflex, again it comes around 35 weeks gestation, disappears by 5 to 6 months, and when this will disappear, the baby will learn to roll over. Similarly, when palmar grasp reflex disappear, the baby learns voluntary grasp. Symmetric tonic neck reflex again comes at 4 to 6 months postnatal age. So ये appears after birth. Okay, these two reflexes appear after birth, postnatal age, and disappears by 8 to 12 months. Parachute reflex आता है around 7 to 8 months postnatal age, and it never disappears. Never disappears, persists throughout life, making it important. Right? अब ये क्या है बताओ? A neonate presents with respiratory distress, chest X-ray reveals air bubbles in left hemithorax. What is the probable diagnosis? So what can you see here? Bowel loops in the thorax, है ना? Chest में bowel loops आ गए हैं. Mediastinal shift, cardiac shadow, very good. So this is a spotter. It is congenital diaphragmatic hernia. Most common variety of congenital diaphragmatic hernia is posterolateral or Bogdalic variety. Most common cause of death in these babies is pulmonary hypoplasia or pulmonary complications. And we already mentioned bag and mask ventilation is absolutely contraindicated, right? What about how, from a given case scenario, how do you distinguish whether it is physiological jaundice or pathological jaundice? So physiological jaundice may appear in first 24 hours of life. Yeah, pathological jaundice may appear in first 24 hours of life, but physiological jaundice never appears. Never appears in first 24 hours. अगर एक बच्चे में first 24 hours में you can see any jaundice, yellowness, it is pathological. Okay? Physiological jaundice, palms and soles never yellow. Palms and soles never yellow. Okay? Palms and soles will never become yellow in physiological jaundice. Okay? Palms and soles never yellow. but it can be yellow in pathological. Again, physiological jaundice is always unconjugated. Unconjugated bilirubin urine में आता है, नहीं आता है? It does not come in urine. So urine will not be high colored. And physiological jaundice never persists, icterus never persists beyond 3 weeks. But pathological may persist beyond 3 weeks. So from a given case scenario, you can get an idea whether it is physiological jaundice or pathological jaundice. And jaundice has a cephalocaudal progression. Agar only face is yellow, it is only bilirubin is 4 to 6 milligram per dl. Chest yellow, 8 to 10. Abdomen yellow, 10 to 12. And legs yellow, 12 to 14. But agar palms and soles are yellow, bilirubin level is at least 15 milligram per dl, which is abnormal, right? So palms and soles are never yellow in physiological jaundice. ये बताओ ब्रॉन्ज बेबी सिंड्रोम किसका एडवर्स इफेक्ट है? Yes, waiting for your answers. Bronze baby syndrome is an adverse effect of. Yes, so it is an adverse effect of phototherapy. Phototherapy is the treatment of choice for neonatal jaundice. The most effective wavelength is 450 to 460 nanometer. Most important mechanism by which it works is structural isomerization, where bilirubin is converted to lumirubin. Okay, bilirubin is converted to lumirubin, right? And bronze baby syndrome के अलावा और क्या adverse effects है phototherapy के? So adverse effects are like, so there can be retinal toxicity. That is why you cover the eyes of the baby during phototherapy. Okay, gonadal toxicity or mutations. Okay, hypocalcemia, diarrhea, dehydration. Okay, hypocalcemia, diarrhea, dehydration, impaired maternal child bonding. So these are some of the adverse effects of phototherapy, right? Unconjugated hyperbilirubinemia के कुछ examples बताओ. So it can be either due to increased production of bilirubin, जो किस में होगा? Some hemolytic disorders. So chronic hemolytic anemias like thalassemia, hereditary spherocytosis, है ना? फिर आपके erythroblastosis fetalis, जो कि RH इनकम्पैटिबिलिटी और ABO इनकम्पैटिबिलिटी से हो सकती है. ओके, G6PD deficiency, cephal hematoma can predispose to increased production of bilirubin. Decreased conjugation किस में होता है? So decreased conjugation in Crigler-Nazar syndrome where there is a deficiency of UDP glucuronidase transferase enzyme. Type 1 complete deficiency, type 2 is partial deficiency where phenobarbital is effective. Gilbert syndrome is mild deficiency. So these are some causes of unconjugated hyperbilirubinemia. Conjugated कब होता है? So conjugated can be non-obstructive. Non-obstructive हो सकता है conjugated में, right? Conjugated can be non-obstructive. Non-obstructive के कुछ causes बताओ. So it can be due to infections. It can be due to some metabolic causes like galactosemia, hereditary fructose intolerance, mitochondrial disorders, and so on. Right? It can be because of some toxins and it can be idiopathic neonatal hepatitis. Obstructive causes. So obstructive causes में क्या हो सकता है? There can be physical obstruction like biliary atresia. And there can be some conditions जहाँ पे excretion of bilirubin is not happening place properly like Dubin-Johnson syndrome. Okay, Dubin-Johnson syndrome, Rotor syndrome. Okay, congenital hepatic fibrosis, Carli disease and so on. Okay, ये सारे conjugated hyperbilirubinemia है. Okay, screening test for biliary atresia क्या होता है? EHBA is extrahepatic biliary atresia. Screening test is HIDA scan और hepatic scintigraphy, है ना? न्यूक्लियर मेडिसिन का स्कैन है hepatic scintigraphy, जिसमें हम देखते हैं excretion of bilirubin is happening in the intestine or not. Surgery for EHBA, Kasai procedure. Kasai is portoenterostomy. Kasai procedures. इसका we know, this has been asked previously, poor prognosis if done beyond 8 weeks. So आपको 8 weeks of life के अंदर कर देना है. And the most common indication for liver transplantation in children again is biliary atresia. Okay, poor prognosis if done beyond 8 weeks. एंटीनेटल कॉर्टिकोस्टेरॉइड्स पे क्वेश्चंस आते हैं. सो यू कैन यूज आइदर इंजेक्शन बेटामेथासोन और डेक्सामेथासोन. डोजेज इज इंपॉर्टेंट. ठीक है, तो यूजुअली बेटामेथासोन इज बेटर, बट इंडियन गाइडलाइंस में डेक्सामेथासोन इज recommended because it is cheaper and more easily available. But betamethasone has lesser side effects. Okay, betamethasone 12 milligram, 2 doses 24 आवर्स अपार्ट. इंट्रामस्कुलरली देते हैं. द टोटल डोज इज 12 इंटू 2 24. डेक्सामेथासोन का भी टोटल डोज इज 24 मिलीग्राम. कैसे देते हैं? सो डेक्सामेथासोन विल बी 6 milligram, 4 doses, 12 hours apart. So again it became how much? So it became 6 into 4 is equal to 24. क्या advantages है antenatal corticosteroids का? So decreased risk of NEC or necrotizing enterocolitis, decreased risk of intraventricular hemorrhage, decreased risk of respiratory distress syndrome, and decreased neonatal mortality. Decreased neonatal mortality. So antenatal steroids are given to all mothers expected to deliver between 24 to 34 weeks of gestation. ठीक है. कोला कलर्ड यूरिन अलॉन्ग विथ फेशियल पफिनेस एंड हाइपरटेंशन चिल्ड्रन. क्या डिसऑर्डर सोचोगे भाई? एक बच्चा है मान लो 5 ईयर्स का, 5 to 12 ईयर्स ऑफ एज में मोस्ट कॉमनली दिस इज सीन. यू हैव अ कोक के कलर का यूरिन, कोला कलर्ड यूरिन. हीमाचूरिया भी हो सकता है, प्रोटीन यूरिया भी है थोड़ा, फेशियल पफिनेस, इडीमा इज देयर, हाइपरटेंशन इज देयर. सो यू विल थिंक ऑफ वेरी गुड. सो वी विल थिंक ऑफ पोस्ट स्ट्रेप्टोकोकल ग्लोमेरुलोनेफ्राइटिस, और we will think of nephritic syndrome, जिसका most common cause in children of course is post streptococcal glomerulonephritis. Immune mediated होता है, nephritogenic strains of streptococcus cause it, right? And इसमें क्या होगा आपको? nephritic range proteinuria मिलेगा. So if you do a UPUC, urine protein by urine creatinine ratio, it will be between 0.2 to 2, right? C3 levels will be low, right? And but it will return to normal by 6 to 8 weeks. ट्रीटमेंट इज मेनली सपोर्टिव. ओके, अब ये क्या है? अगर आपको जनरलाइज इडीमा मिल रहा है, मैसिव प्रोटीन यूरिया इन अ चाइल्ड इज यूपी इज टू यूसी, मतलब यूरिन प्रोटीन बाय यूरिन क्रिएटिनिन रेशियो मोर देन 2, तो हम बोलते हैं मैसिव प्रोटीन यूरिया. इस कंडीशन में वी विल सस्पेक्ट व्हाट? नेफ्रोटिक सिंड्रोम. ओके, मैसिव प्रोटीन यूरिया, जनरलाइज इडीमा, हाइपोएल्बुमिनेमिया विल ऑल्सो बी देयर. हाइपोएल्बुमिनेमिया, एल्बुमिन लेवल्स विल बी लेस देन 2.5. ठीक है. हाइपरलिपिडेमिया विल बी देयर. व्हाट इज द मोस्ट कॉमन कॉज ऑफ नेफ्रोटिक सिंड्रोम इन चिल्ड्रन? इट इज मिनिमल चेंज डिजीज. मिनिमल चेंज डिजीज को मिनिमल चेंज डिजीज क्यों बोलते हैं? बिकॉज किडनी बायोप्सी अगर आप करोगे, लाइट माइक्रोस्कोपी विल बी एब्सोल्युटली नॉर्मल. ओनली ऑन इलेक्ट्रॉन माइक्रोस्कोपी यू विल गेट इफेसमेंट ऑफ फुटप्लेट ऑफ पोडोसाइट्स, राइट? पोडोसाइट्स का फुटप्लेट्स. What is the drug of choice? Drug of choice for nephrotic syndrome in children is prednisolone. First episode nephrotic syndrome and relapse. First episode and relapse दोनों के लिए prednisolone है. But drug of choice for SRNS, अगर पूछे steroid resistant nephrotic syndrome का drug of choice क्या है? Then it is calcineurin inhibitors. Calcineurin inhibitors क्या क्या है? Yes, cyclosporin and tacrolimus. Cyclosporin या फिर tacrolimus यूज कर सकते हो, right? Okay. Steroid dependent nephrotic syndrome में you can use drugs like low dose alternate day prednisolone, levamisole, cyclophosphamide, mycophenolate mofetil and so on. What is the most common cause of seizure in children less than 5 years? It is febrile seizure. Febrile seizure कब बोलते हैं? When there is seizure along with significant fever. Significant fever कब बोलेंगे? When the temperature is more than 100.4 degrees Fahrenheit. Without any evidence of CNS infection. Okay. So febrile seizure का definition we already done. Types क्या क्या है? Simple febrile seizures are usually generalized tonic-clonic. Complex febrile seizures are focal. Simple febrile seizure lasts less than 15 minutes. Complex febrile seizures last more than 15 minutes. Simple febrile seizure occur only once. Complex febrile seizure में recurrent episodes हो सकते हैं. तो focal 15 minutes or longer and frequent. Treatment of choice क्या है? Simple febrile seizure. Simple febrile seizure में no long-term anti-epileptics are required. No long-term anti-epileptics. Just you lay down the child in recovery position, paracetamol दे दो comfortable बनाने के लिए, but no long-term anti-epileptics. Only if a child is having status epilepticus तो आप उसका management करोगे, lorazepam दोगे abort करने के लिए. Complex febrile seizure में sometimes there is a role of valproate, but simple febrile seizure no anti-epileptics required. What is the mode of inheritance of neural tube defects? Yes. कौन सा mode of inheritance है? It is multifactorial, जहाँ पे host, environment, genetics, everything plays a role. What is the drug used to prevent neural tube defects? तो ये तो बहुत बार पूछा जा चुका है. So it is folic acid. तो मदर को हम folic acid देंगे. कितना देंगे और कब देंगे? So 400 microgram per day to all women, 4000 microgram per day or 4 milligram per day for high risk women, and to be started at least 1 month before conception. At least 1 month before conception. So pregnancy diagnose होने के पहले शुरू करना है, तभी it will help. Okay. And severe neural tube defect क्या होता है? जहाँ पे आपका scalp, cranial bones are absent, brain is exposed to outside, anencephaly. और क्या क्या होता है? So examples of neural tube defects are anencephaly जहाँ brain is exposed to outside, meningomyelocele जो कि आपको lumbosacral region में most commonly, ओके, meningomyelocele और myelomeningocele भी बोलते हैं, lumbosacral region में most commonly seen. Infantile spasms, global developmental delay and hips arrhythmia on EEG. क्या disorder सोचोगे? So if you are getting a triad of infantile spasm, it's also called salam attacks. Global developmental delay or intellectual disability, hips arrhythmia on EEG, West syndrome. Very good user and Uthara. So West syndrome. What is the drug of choice for West syndrome in children? Injection ACTH. Drug of choice for infantile spasms and tuberous sclerosis. So it is vigabatrin. Drug of choice for neonatal seizures. Neonatal seizures के लिए drug of choice है phenobarbital. Drug of choice for absence seizures in children. In India, it is valproate. Okay, right? Drug of choice for status epilepticus. Your first drug to be given in status epilepticus. It is injection lorazepam. Right? If multiple fractures are detected in antenatal ultrasound scan, we will think of osteogenesis imperfecta or brittle bone disease. We already talked about it. It is a type 1 collagen defect. Autosomal dominant inheritance है ना, और ट्रायड होता है, हमने बोला ब्लू स्क्लेरा, राइट, ब्लू स्क्लेरा एंड डेफनेस एंड रेकरेंट फ्रैक्चर्स. अक्यूट रिमेटिक फीवर, अगेन इंपॉर्टेंट टॉपिक. मेजर क्राइटेरिया क्या होते हैं? सो हाई रिस्क कंट्री लाइक इंडिया, मेजर क्राइटेरिया वुड इंक्लूड कार्डाइटिस. इट कुड बी क्लिनिकल, it could even be subclinical carditis as per the latest guidelines. Okay, joint involvement in the form of either polyarthritis or monoarthritis or polyarthralgia. Sydenham chorea, erythema marginatum, subcutaneous nodules. ठीक है. And minor criteria क्या क्या होते हैं? So you can get a question, which of the following are major criteria, which of the following are minor criteria. So these are of course the modified Jones criteria. So minor criteria are like fever, monoarthralgia, elevated ESR, CRP, prolonged PR interval. So you need either one major, two minor. So you need one major plus two minor, or you need two major to diagnose acute rheumatic fever. Recurrent episodes के लिए even two minor criteria will work. 3 minor criteria will also work, right? And of course you need essential criteria. Essential criteria क्या है? Evidence of streptococcal infection. So it can be throat swab में आपको streptococcal infection मिल जाए, या ASO titer मिल जाए. Okay? And prophylaxis के लिए you have to use injection benzathine penicillin. Secondary prophylaxis के लिए you have to use an injection benzathine penicillin. Treatment के लिए of course we use aspirin. Aspirin initially high dose followed by low dose, treatment of heart failure, bed rest if carditis is there and so on. NADA's criteria किसके लिए use करते हैं? So NADA's criteria is used for the assessment of presence of heart disease. So it will just tell you assessment of presence of congenital heart disease, whether a congenital heart disease is present or not. So you need either one major or two minor criteria. मेजर क्राइटेरिया में क्या क्या आता है? एनी डायस्टोलिक मर्मर, सिस्टोलिक मर्मर मोर देन ग्रेड 3, हार्ट फेलियर, साइनोसिस. माइनर क्राइटेरिया में क्या आता है? सो माइनर क्राइटेरिया में सिस्टोलिक मर्मर लेस देन ग्रेड 3, abnormal second heart sound, abnormal BP, abnormal chest x-ray, abnormal ECG. Okay, So 3 things are clinical minor criteria में systolic murmur less than grade 3, abnormal second heart sound, abnormal BP, and 2 things are lab, abnormal chest x-ray, abnormal ECG. ये बताओ 5-year-old child with history of cyanotic spells. Child में cyanotic heart disease most common कौन सा है? So it is tetralogy of Fallot, right? Tetralogy of Fallot. Okay. And आपको क्या मिल रहा है? So cyanotic spells are there, clubbing is there, systolic murmur in the left upper sternal, that means pulmonary area, chest x-ray shown, so you have this boot-shaped heart or core and sabot appearance. Okay, boot-shaped heart or core and sabot appearance, you think of tetralogy of Fallot. What are the 4 components of tetralogy of Fallot? So large VSD, pulmonary stenosis, overriding of aorta and right ventricular hypertrophy. No atrial septal defect. ठीक है? Auscultation में क्या मिलेगा tetralogy of Fallot में? You'll get a ejection systolic murmur in pulmonary area and single second heart sound. Because P2 is soft and inaudible. Right? And severity of tetralogy of Fallot is directly proportional to the severity of cyanosis, inversely proportional to the murmur. Right? और क्या होता है ये coarctation of aorta में आपको notching of inferior margin of ribs मिल जाएगी. Coarctation of aorta. And you will get weak femoral pulses. Lower limb pulses will be weak. This is what? Egg on side appearance. Very important spotters. Egg on side appearance you get in TGA or transposition of great arteries. Point mutation in 6th codon of beta globin chain अगर आपको मिल रहा है. Replacement of glutamate with valine. किस में मिलेगा? So it is sickle cell disease. Sickle cell anemia या sickle cell disease. It is the most common structural hemoglobinopathy. Acute painful crisis can be there. You have to maintain the hydration properly. Increased incidence of osteomyelitis. Most common organism causing osteomyelitis in children is Staph aureus. But sickle cell anemia में it is salmonella. Okay, salmonella. Heterozygous sickle trait protects against malaria. And इसके treatment में hydroxyurea has a role. वो fetal hemoglobin level को बढ़ा देता है and symptoms को कम कर देगा. And you have to maintain hydration. Snowman is TAPVC. Yes, very good. It is supracardiac TAPVC. अगर आपको heme arthrosis मिल रहा है, swelling of a joint with positive family history, so you will think of what? Hemophilia. Hemophilia we said is X-linked recessive inheritance. Increased APTT मिलेगा, normal PT, BT and platelet counts मिलेंगे. So you can get a family history जहाँ पे maternal uncles are affected and males are more commonly affected. Okay, males are more commonly affected. Diagnosis of an infant, incessant crying हो रहा है, रोए जा रहा है, tender palpable mass in abdomen and blood and mucus in stool. Typically we will think of intersusception. Intersusception, red currant jelly stool बोलते हैं, and one part of the intestine is telescoping into the adjacent segment like this. अंदर घुस जा रहा है, intersusception. Okay, so you can get claw sign, coiled spring sign, ठीक है, in radiology. So that can come. Projectile non-bilious recurrent vomiting in an infant with olive-shaped palpable abdominal mass. So many times it has again come as a question. Congenital hypertrophic pyloric stenosis. Okay. So इसमें भी आपको target sign, donut sign, lot of radiological signs that you get here. Okay. Surgery will be the treatment. And you have, hypochloremic metabolic alkalosis with paradoxical aciduria. Fluid of choice, normal saline. Most common cause of diarrhea and dehydration in child less than 5 years of age is rotavirus. Diarrhea वाले बच्चे में assessment of dehydration, how will you do? So there is some dehydration if the child is what? Sensorium में क्या होगा? Irritable. Thirsty, excessive thirst. And skin pinch goes back slowly but less than 2 seconds. Some dehydration. Severe dehydration कब बोलेंगे? So if we will call it severe dehydration if the sensorium is lethargic and comatose, not able to drink and goes back very slowly. Skin pinch goes back taking more than 2 seconds very slowly, then we say severe dehydration. Okay, so from a given case scenario you need to be able to tell. Agar no dehydration hai, then the child is in green category. You give WHO ORS to prevent dehydration. 5 to 10 ml per kg per loose stool. So these are IMNCI categories. Okay, green, yellow and pink. Some dehydration है, क्या करोगे? 75 ml per kg. 75 ml per kg. ORS 75 ml per kg over 4 hours. Severe dehydration 100 ml per kg. And fluid of choice is RL in 5% dextrose IV. Okay? Right? तो सिवियर डिहाइड्रेशन में हमें देना है 100 ml per kg. तो हम देंगे फर्स्ट 30 ml per kg if less than 1 year over 1 hour, next over 5 hours, total over 6 hours. And in more than 1 year of child, we give it in half the time. So over half an hour, 2.5 hour and total over 3 hours. ठीक है? Fluid of choice we said is ringer lactate in 5% dextrose. अगर वो नहीं है तो सिर्फ ringer lactate दे दो. ORS का composition we already discussed. Sodium of 75, glucose of 75, potassium 20, chloride 65, citrate 10. So total osmolarity is 245. And Resomal हमने बोला is more potassium less sodium. Recurrent diarrhea मिल रहा है. In a child, abdominal distension, anemia, short stature, failure to thrive, we think of celiac disease. And उसके लिए screening test होता है anti-TTG IgA. And of course, we have to do upper GI endoscopy, duodenal biopsy. तो anti-TTG IgA and total IgA usually करते हैं हम. And the treatment is lifelong gluten-free diet. तो प्रीवियसली देयर वाज अ क्वेश्चन कि क्या अवॉइड करोगे. सेमोलेना सूजी नहीं दे सकते हो. यू कैन गिव राइस, है ना, राइस दे सकते हो. ब्राओ नहीं देते हम. बार्ली, राई, ओट, व्हीट. सो लाइफ लॉन्ग ग्लूटेन फ्री डाइट इज द ट्रीटमेंट. राइट? ओके. Diagnosis of a newborn with dry, rough skin, big tongue, constipation, umbilical hernia, abdominal distension. Of course, we are dealing with congenital hypothyroidism. And उसके लिए screening test होता है TSH. TSH we can do either a cord blood screening test or you can do a heel prick. Okay, heel prick. Heel prick after 48 hours. Okay, dried blood spot लेते. Most common cause is thyroid dysgenesis. अगर goiter है तो thyroid dyshormonogenesis. What is the most common cause of ambiguous genitalia in a baby? It is congenital adrenal hyperplasia. Most common cause of CAH, 21 hydroxylase deficiency. Okay? And screening for CAH हम करते हैं using 17 hydroxy progesterone levels. Progesterone levels. ठीक है? तो आपको बेबी शॉक में मिल सकता है ambiguous genitalia in a female, think of CAH. CFTR gene mutations किस में मिलते हैं? Cystic fibrosis. So typically you will get recurrent pneumonias and oil in stool. Delta F508 is the most common mutation in India. And you have sweat chloride levels elevated, sweat chloride more than 60 milliequivalents per liter. Think of cystic fibrosis. Okay. Croup and acute epiglottitis. Croup is viral. दोनों में stridor होता है. Right? Croup is viral. Acute so most common cause is parainfluenza virus. And यहाँ पे क्या होता है? The child is less toxic. So low grade fever रहेगा. Okay? Low grade fever and barking cough and so on. X-ray में you get this steeple sign. So croup में you get this steeple sign. Okay? Narrowing of the airway like steeple of church. And treatment में you have to give single dose dexamethasone. Single dose dexamethasone in mild cases and nebulized epinephrine in severe cases. Nebulized epinephrine in severe cases. Okay. Acute epiglottitis क्या होता है? Bacterial illness है. And it is most commonly caused by streptococcus. In immunized population, it is streptococcus. Previously, it was H. influenzae. इसमें the child is more sick looking and toxic. Drooling of saliva हो रहा है. The child is not able to swallow his own saliva. Okay. इसमें you have this thumb sign in acute epiglottitis. Right? And because it is a bacterial illness, IV ceftriaxone along with supportive care is the treatment of choice. Okay? IMNCI, so this is the last topic for the day. IMNCI classification of a child. हम more than 2 months age की बात कर रहे हैं with cough or difficulty in breathing. पहले देखो कि fast breathing है या नहीं. Less than 2 months में we call it fast breathing if respiratory rate is more than 60, 2 to 12 months, more than 50, 1 to 5 years, more than 40 per minute. General danger signs है या नहीं, we will see they are like convulsions, lethargy, inability to feed, okay, inability to feed, persistent vomiting, and so on. Okay. So अब हम देखेंगे क्या? So if general danger signs are present in a child, general danger signs are present, it is very severe disease, severe pneumonia or very severe disease. Severe pneumonia or very severe disease. तो क्या करोगे आप? First dose antibiotic and refer. First dose antibiotic and refer. प्राइमरी PHC की बात कर रहे हैं हम, है ना, व्हेन द चाइल्ड कम्स टू अ PHC. Fast breathing and or chest drawing means pneumonia. So you give oral antibiotics, oral amoxicillin, and reassess after 48 hours. नो जनरल डेंजर साइन ऑफ फास्ट ब्रीथिंग और चेस्ट इन ड्रॉइंग, तो आप क्या करोगे, तो इट इज़ नो निमोनिया, कफ एंड कोल्ड ओनली, नो निमोनिया. सो इसमें आप होम बेस्ड सपोर्टिव केयर करोगे, राइट. एंड ये जो है दिस नो निमोनिया इज यूजुअली रिटन इन अ ग्रीन बैकग्राउंड. ठीक है, नो निमोनिया इज रिटन इन अ ग्रीन बैकग्राउंड, निमोनिया इज रिटन इन अ येलो बैकग्राउंड, एंड general danger signs severe pneumonia, very severe disease in pink background. That is the IMNCI classification. Okay, so I think that is all. We've covered a lot of topics from pediatrics in this short span of time, and I believe it will help you solve more than 70% of questions that you get from pediatrics. If you have any other queries and if you want to ask anything else, feel free to message me now, or you can message me in the social media handles. I hope you have benefited from this session and you have interacted very nicely. Most of you have been able to answer most of the questions that I've asked. And yes, it has been a very high intensity, high speed revision class covering a lot of important topics, but that is what you need before your exam. Just maintain the momentum. You've worked really hard till now. Just give that little bit more extra push. थोड़े से और दिन इसी momentum को continue कर लो, and I am sure you will be able to clear this exam very very easily. Just have faith in yourself, है ना. हर समय एग्जाम के पहले सबको डर लगता है, जो टॉपर है उसको भी एग्जाम के पहले डर लगता है, बट दैट इज़ ओके. आप बस अपना काम करते जाओ. जस्ट पुट इन योर बेस्ट विदाउट थिंकिंग अबाउट द रिजल्ट्स, एंड एवरीथिंग विल बी फाइन, ट्रस्ट मी. All the very best. So if you have any other queries, anything else, any confusion, feel free to message me. I'll end the session here so that, because आपको बाकी सब्जेक्ट के भी और क्लासेस होने हैं. All the very best. Happy Lohri to you as well. So अभी तो हाँ एग्जाम्स है, you'll not be able to enjoy much. थोड़े से दिन और सस्टेन कर लो, एंड उसके बाद यू कैन टेक अ नाइस ब्रेक. ठीक है, ऑल द वेरी बेस्ट. कीप वर्किंग हार्ड, ट्रस्ट योर सेल्फ, एवरीथिंग विल बी फाइन. जस्ट ब्रीथ, कीप ऑन वर्किंग, पुशिंग हार्ड. बस करते जाओ, फल की चिंता अभी मत करो. ऑल द वेरी बेस्ट. गॉड ब्लेस यू.
हाँ स्टार्ट से ही हो गए. एक बार आ जाए यहाँ पे मेरे पास. वेट कर रहा हूँ, वेट कर रहा हूँ, वेट कर रहा हूँ. ठीक. आवाज आ रही है? Start live start.
नहीं लाइव स्टॉप स्ट्रीमिंग स्टार्ट रिकॉर्डिंग
आप ऑन है आप बनाना स्टार्ट करिए.
ठीक है
ओके
थैंक यू हेलो एवरीवन चलो हेलो एवरीवन आर यू गेटिंग माय वॉइस ऑडिबल विजिबल नो यू विल रिमेंबर एवरीथिंग ओके ओके सो हाँ कोई बात नहीं सब याद हो जाएगा अभी पूरा याद हो जाएगा डोंट वरी नमस्ते नमस्ते चलो गुड इवनिंग एवरीवन चलो so we are starting a very important session definition of hurt am I audible and visible to everyone yes definition of hurt is 114 BNS चलो वेरी गुड आवाज फट रही है enlarge the slide wait is it not enlarged आवाज फट रही है ये स्लाइड एनलार्ज क्यों नहीं है कर्सर हटाओ wait बट स्लाइड एनलार्ज क्यों नहीं हो रही है स्लाइड एनलार्ज क्यों नहीं हो रही है ये बड़ा क्यों नहीं हो रहा है ऑन स्क्रीन ओके वेट तो थोड़ा सब लेट हो गए एफएमटी का पेपर लीक कर दूं चलो इज इट क्लियर नाउ ओके चलो सब एवरीथिंग इज फाइन बेटा गॉड ब्लेस यू ऑल ओके अब चलो स्टार्ट करते हैं 114 BNS is a definition of hurt okay choka hurt is choka but grievous hurt is chakka something which is grievous hurt that is chakka okay So 116 is a grievous head. The first grievous head is emasculation, loss of erection of penis. By any mean, if there is a loss of erection of penis, अगर किसी भी problem से आपका erection of penis loss हो गया, that would be a grievous head. The first part of grievous head is loss of erection of penis. Okay, done, sir. Second grievous head is loss of sight of either eye. By any mean, if you are loss of sight of either eye, that would be a grievous head. अगर आपकी आंखों की रोशनी चलेगी, that would be a grievous head. Third, loss of hearing of either ear, that would be a grievous head. Loss of any member of joint. If any member or any joint is lost, that would be a grievous head. Joint is lost, joint is cut, member is lost, that would be a grievous head. तो मैंने तीन बताया, 114 is a hurt and 116 is a grievous head. Okay, is it clear? यहां तक एक बार थम्स अप दे दो बेटा. 114 is a hurt, चौका मारा तो चोट लगी है, चोट चौका, and 116 would be a grievous head. हाँ, आप सबको चो में समझ गया. That would be a grievous head. Okay. Sir, you can. Okay. Destruction or permanent impairing of power. If any power of any member or joint is lost, it's a grievous head. Permanent disfiguration of head and face. अगर आपकी head and face पे there is acid throwing, that would be a grievous head. Okay. Fracture and dislocation of bone and tooth. Remember, my dear friend, fracture and dislocation of bone and tooth would be a grievous head. Not only bone, but tooth also. Any hurt which endangers the life, like dangerous injury, like stab injury, cut injury, firearm injury, that would be a grievous head. Any hurt by which you are in severely body pain, yes, and you cannot follow your routine work for 15 days. So please be careful. Previously it was 20 days, now it is 15 days. Severe body pain for 15 days, you cannot follow your routine activity for 15 days, it would be a grievous hurt. हाँ, अब अपना 15 days हो गया. So this would be grievous. Now I am coming to EDH. अपने को point है ना, 99% मैं कह रहा हूँ LRR और इसमें से ही सवाल आ जाएंगे. EDH is exclusively traumatic. It's a biconvex. In lucid interval of EDH, you are responsible. Medical negligence, you can be charged for medical negligence for EDH. Pterion you are hitting. Doctor साहब, this is EDH above dura. It is rupture of middle meningeal artery. ये पक्का सवाल आएगा. Pterion पे हिट हो, मिडिल मेनिंजियल आर्टरी रप्चर हो और मेडिकल नेग्लिजेंस का चार्ज लगता हो, दैट वुड बी EDH, है ना, इडली शेप. इट इज बाइकॉन्वेक्स. एक लाइन पक्का याद कर लेना दोस्तों. SDH, ABCD you have to remember. Alcohol, A, B boxer, B banana shape, B for bridging vein ruptures, C for child, C for concave or convex, C for it crosses suture. EDH doesn't cross the suture. D for old and E for emissary vein rupture. Yes. A very simple trick is ABCDE for SDH. ABCDE for SDH. Now tell me this one. Thunderclap headache and xanthochromia is which hemorrhage? ये पक्का सवाल आएगा. इस एग्जाम में लिख लो. Thunderclap headache and xanthochromia is which? Yes, will not be vast. It is subarachnoid hemorrhage. It would be subarachnoid hemorrhage. सर ने ही निकाला पेपर. Thunderclap headache and xanthochromia will be SH. पक्का लिख लेना. Sir, ICH is intracerebral and it is also known as interparenchymal. दोनों बातें ध्यान रखना. It is intracerebral or it is also known as interparenchymal. It is most common non-traumatic hemorrhage. Most common traumatic hemorrhage is SH. पक्का ध्यान रखना. It is due to increase in BP, that is hypertension. It is the most common affected structure is putamen. It is putamen. Now, sir, in emergency condition, no consent is required. So very simple. E look like 3. No consent is 0. That would be robo voice. Yes. Double tap on the skin. Is it clear, beta? Okay. So E look like 3. That is 3. And no consent is required in emergency condition. That would be 30 BNS. That is a very important topic, my dear friend. 30 BNS. Yes. We can operate and thus save the patient. Perjury is a false evidence. Definitely. Definition is 227 and punishment is 229. Yes. Definition of perjury is 227. Perjury has 7 letter, beta. कभी गलती मत कर जाना. Perjury has a 7 letter and punishment is 229. Definition of perjury. Now false certificate. Doctor साहब, your true sequence is 1, 2, 3. False certificate, false sequence is 2, 3, 4. है ना? हमें एक को मिस कर देना. We are missing 1. So false sequence, false certificate is 2, 3, 4. Yes, beautifully done. Yes. Doctor, criminal has 8 letter अबॉर्शन एज 8 लेटर, इससे आसान ट्रिक इस दुनिया में ब्रह्मांड में कहीं नहीं हो सकती. Criminal as 8 letter, abortion as 8 letter, criminal abortion BNS would be 88, with mother consent 88, without mother consent 89, death of mother 90. That's the most beautiful trick. Criminal has 8 letter, abortion has 8 letter, with mother consent 88, without mother consent 89, death of mother 90. पुलिस ने मारा चौका, मजिस्ट्रेट ने मारा छक्का. पुलिस इंक्वेस्ट 190. Doctor sir, be careful. It is not BNS, it is BNSS. BNSS. पुलिस ने मारा चौका 194 BNSS. मजिस्ट्रेट ने मारा छक्का, it is 196 BNSS. Now sir, police inquest is 194 BNSS. It's the most common. It is done by senior head constable, the minimum rank. It is done by unnatural death. It is done in, yes, inquest is in BNSS. Senior head constable is the minimum rank of police officer. Magistrate inquest 196. You just remember a very simple trick: A, B, C, D, E. A, mental asylum death. B, yes, very important. B, police beating death. C, police custody death. D, dowry death. E, exhumation death. And F is police firing death. That's a very simple trick, unforgettable trick. Police ne mara chauka, magistrate mara chakka. But this is not BNS, this is BNSS. Okay. Court and death sentence. Doctor Sahab, these are the 4 court. Pakka yaad rakh lena dosto. These are the 4 court which can give you unlimited fine and death sentence. Supreme Court, High Court, Session Court, and additional Session Court. 4 courts: Supreme Court, High Court, Session Court, and additional Session Court. Be careful, sir. These are the 4 court which has very important power. Assistant Session Court 10 year, Chief Judicial Magistrate Court 7 year, First Class Judicial Magistrate Court 3 year, and Second Class Judicial Magistrate Court 1 year. 10-7-3-1. 10-7-3-1. Very simple, sir. Yes, I'll discuss, don't worry. Second Class Judicial Magistrate Court 10,000 rupee fine. First Class Judicial Magistrate 50,000 rupee fine. All remaining are unlimited fine. Pakka yaad rakh lena doston. This is going to be very important. 10-7-3-1. 10-7-3-1. याद कर लोगे? एक बार thumbs up दे दो बेटा. 10-7-3-1. Second class 10,000, first class 50,000. Pakka सवाल. Pakka? Very good beta. Now sir, common witness who see the crime, who observe the crime, it is first hand knowledge rule. Expert witness can go for volunteering of the statement. If I am expert witness, I am a doctor, I can go for volunteering the statement. Pakka. Now sir, A killed the B and C has seen the crime. C is a direct evidence. C is the direct evidence. C told the story to D. It is a hearsay evidence. Okay. A fingerprint found in the crime scene. It's a circumstantial evidence. And A with knife came out and E has seen. That is an indirect evidence or corroborative evidence. That is a indirect evidence or corroborative evidence. A with knife came out and E has seen. That would be a indirect evidence or corroborative evidence. बहुत simple. Sir, public witness, beautifully done, my dear friend. There is a public prosecutor and defense witness. There is a defense lawyer. Okay, same party lawyer. In chief examination, the same party lawyer asks the question. In cross examination, opposite party lawyer asks you a question. Yes. And re-examination, again, same party lawyer asks you a question. Leading question are allowed in cross examination. The question which has answer in yes or no. अपनी भाषा में बोलते हैं ना, तू हाँ कर या ना कर. That is a leading question. This is allowed in cross examination. This is asked by opposite party lawyer. Beautifully done. Sir, dying declaration, which is followed in India, here it can be given by victim, magistrate, or any other person. It is 26 BSA. Bharatiya Sakshi Adhiniyam, beta. Yes, Bharatiya Sakshi Adhiniyam. It is only valid if you die. Oath is not taken. Cross examination. लिख रहा डॉक्टर सालूम के हो. Oath is not taken, cross examination is not done, and leading question is not asked. Dying deposition is practiced in USA. It is done by magistrate. It is oath is taken, cross examination is the best part, and leading question is asked. That would be a dying deposition. Dying deposition. Yes, beautifully done. The better is dying deposition because it's a cross examination is done. Okay. थोड़ा सा याद रख लेना. 26 BSA is dying declaration. Sir, this is none other than Davidson body. D for Davidson body. D for drumstick body, neutrophil seen in female. That would be a Davidson body. That would be it. Everything is a question according to me, okay? Now, study of death is thanatology and study of postmortem change. The changes after death is known as taphonomy. Taphonomy. Study of death is thanatology. Study of postmortem changes is taphonomy. This is Kevorkian sign, my dear friend. My favorite question. It is seen in 1 hour to almost few minutes after death. It's a retinal vessel fragmentation. It's a Kevorkian sign. It is a Kevorkian sign. This is Teklenoir. It is seen in 3 hours after death. It's triangular change. Start as a yellowish change, it becomes brown. That is a Teklenoir. Pakka sawal. Teklenoir railroad sign. Beautifully done, my dear friend. Rigor mortis is due to ATP depletion, my dear friend. First muscle is myocardium. First external muscle, be careful, sir. First overall muscle is myocardium. First external muscle is upper eyelid and start from head and goes to toe. That is a Steinlo. कैसे याद करोगे? ऊपर से नीचे आती है. That is a Steinlo. Yes, that is a Steinlo. This is you can see the rigor mortis begins in 1 to 2 hours after death. The first muscle is myocardium and the first external muscle is upper eyelid. You can see this is rigor mortis. This is rigor mortis. Beautifully done. एक बार थम्स अप दे दो, मेरे अपना आपका प्यार समझ लूंगा और मैं खुश हो लूंगा. थम्स अप दे दो बेटा. Every line is a MCQ according to me. Yes. Yes. Beautifully done. है ना, आपका ज्यादा टाइम खराब नहीं करना है क्योंकि आप सब मेरे प्यारे बच्चे हो. This is the first. This is cadaveric spasm again due to ATP depletion, my dear friend. Yes. Again due to ATP depletion. It is seen just after death. Here primary relaxation is absent because it's just after death. It's an antemortem event. It is seen in drowning. This is a very important question. It is seen in drowning. It is cadaveric spasm. ATP depletion is seen, but just after death. Here primary relaxation is absent. Yes. Beautifully done. Marbling. I am coming to the marbling. The sides are chest, shoulder and abdomen. Start in 24 hours. Very well developed in 36 to 48 hours. Pakka dhyan rakhna. Start in 24 hours. Very well developed in 36 to 48 hours. It is greenish brown in color. And one question you can get, it is due to sulfa hemoglobin. Sulfa hemoglobins. Hostile examination mein leading question can be asked in chief examination also. Okay, beta? So this is marbling. Start in 24 hours and prominent in 36 to 48 hours. Yes, beautifully done. Sulfa hemoglobin pakka yaad rakhna beta. This is lightning. You can see the branching leaf pattern. This is lightning. This is branching leaf pattern. Lightning fall on your body. बिजली आप पे गिरी. Fall को इंग्लिश में बोलते हैं FAL fall. Filigree, arborescent and Lichtenberg burn. Fall as a kiran. बिजली की किरण गिरी. Kiranographic. It doesn't correspond to the vascular channel. Pink erythematous. Air compression always goes in front. Yes. Now, friends, this won't be asked in exam. It starts in 24 hours and it is prominent in 36 to 48 hours. Air compression always in front. Bijli giri, fall as a kiran. Bijli ki kiran aap pe giri. Beautiful question. Fall as a kiran. Okay. Okay. Done, sir. This is branching leaf. बेटा स्लो जाना है तो इसको आप अपनी शॉर्ट छोटा करके देख लेना. ठीक है. Sir, maggots are actually larva of fly seen in 1 to 2 days. In rainy season, it starts early. The study of maggots is known as entomology. Study of maggot is known as entomology. 1 to 2 days. In rainy season, it is early. Every line is an MCQ you will feel in exam. पक्का आप एग्जाम में फील करोगे कि मेरे मुंह से निकला हुआ हर सवाल एक MCQ था. सेंटर पे गिरवा दो इसलिए. Adipocere A for ammonical smell. Adipocere is also known as grey wax or saponification. Seen in warm and humid climate or body in water. कब देखा जाता है? Warm and humid climate or body in water. ये पक्का सवाल आएगा. Bacteria is Clostridium welchi. Lipase is the enzyme. 3 days to 3 months. इसको start होने में it can take 3 days and it can last for 3 months. Yes. Fetus below 7 month adipocere is absent and pseudo smell is present in the clothes of adipocere. छोटी छोटी बातें कई बार इसकी स्मेल कपड़ों में रह जाती है. Pseudo smell present in cloth. Fetus below 7 month it is absent, my dear friend. Beautiful question. Yes. Every line is MCQ. This is adipose here, warm and humid climate, my dear friend, or body present in water. And the bacteria is same Clostridium welchi. The enzyme is lipase. 3 days to 3 months. Pseudo smell on the clothes. Yes, beautifully done. सर मेरे 300 में 300 है तो फिर मैं आपका नाम लगाऊंगी. चलो कोई बात नहीं. This is 3 days to 3 months. I have mentioned mummification. Opposite to adipose here, it is in dry and hot climate. It is also known as desiccation. You can get a question. Odorless is the smell. Arsenic and antimony favors the mummification. Natural feature of the body is preserved. Natural feature of the body are preserved. That is none other than mummification. आर्सेनिक और एंटीमनी आपके अगर सोइल में हो तो ममिफिकेशन को फेवर करते हैं. स्मेल इज ऑर्डरलेस. एडिपोस इट वाज अमोनिकल. टॉर्चर, टी फॉर टोटो. टोटो पूरी दुनिया जानती है टोटो. डिक्लेरेशन ऑफ टॉर्चर, डिक्लेरेशन ऑफ टोक्यो. इस्तांबुल प्रोटोकॉल इज रिलेटेड विद टॉर्चर. बिटिंग ऑन सोल, बिटिंग ऑन सोल. सोल इज ऑन द फूट और ऑन द बूट. दैट इज फेलंगा और बेस्टिनाडो. यस. एब्डोमेन वी हैव क्वाड्रेंट. हमारे एब्डोमेन में बहुत सारे क्वाड्रेंट होते हैं. क्वीराफोना बीटिंग ऑन एब्डोमेन. टेलीफोन, टेलीफोन. ईयर, बीटिंग ऑन ईयर, टेलीफोना. एंड सस्पेंशन ऑन द पोल, पैरेट पर्च. P for pole, P for parrot perch. That's beautifully done. P for pole, P for parrot perch. Electric as IC, electric torch is picana. Now in anus, the chili paste in anal canal. गर्मा गर्म मिर्ची डाल दी. हा हा हा. Bellery, it is bellery. Hot rod in anal canal, black slave. Hot rod in anal canal, black slave. And by crushing and by crushing of the soft tissue and damage to the muscle, this is balena. वैसे we can remember by belen we crush the roti. By belen we crush the roti. That is balena. Yes, yes, it is balena. Now, sir, spinal cord is opened from posterior surface. This is you are going to get the question in exam. Spinal cord is open from posterior surface and stomach is open from greater curvature. Stomach is open from greater curvature. Spinal cord is from posterior surface. Stomach is open from greater curvature. Now postmortem technique, my dear friend. Yes, Kalidas, black slave is a Kalidas. Most common postmortem technique is none other than virtuous method. One by one organ removal. एक organ निकाल लेते. Liver निकाला, lung निकाला, spleen निकाला. We for a very common method, the most common method is virtuous method. Beautifully done. Yes. Rokitansky as IN. It is an in situ method. We don't remove anything. That is an in situ method in HIV or hepatitis. That is a Rokitansky method in transmissible disease. GB. If we remove block one by one, हम एक block निकालते हैं. It's a Gon's method. And L for luteal, L for large mass. If you remove the complete mass, it's a large mass. Luteal method, my dear friend. Luteal method. Yes, beautifully done. Yes. Now, sir, McNaughton rule. McNaughton has U and N. If unsoundness of mind is what is given, you are not responsible. It's a McNaughton rule. C for current, C for mental capacity is lost. That would be Current's rule. And DU for Durham's, it's a product of mental disease. That is a product test or Durham test. So these are 3 questions you can get in your exam. McNaughton, unsoundness of mind. Current's capacity. Durham's is a product test, my dear friend, you can get in your exam. Please be careful. Lovely. Criminal responsibility of insane is 22 BNS, my dear friend. How to remember? आप नोटी कब होते हो? जब आप 21 को क्रॉस कर देते हो. तो मैकनॉटन और इंसेन का प्रोटेक्शन दैट कम्स अंडर 22 BNS. You become naughty at the age of 22. Capgras, apna look like pariah. That is familiar look like stranger. That is a delusion. Capgras syndrome. Apna look like pariah. Fregoli, stranger look like familiar. Opposite of Capgras. Infidelity. अब डॉक्टर साहब, if you have delusion of infidelity, आपको लगता है आपका पार्टनर भरोसेमंद नहीं है, आपका पार्टनर बेवफा है, तो आप अपने पार्टनर से क्या कहोगे? Othello syndrome. Yes, Othello syndrome. Othello, that would be Othello syndrome. And delusion of love, the morbid jealousy is declarambolt. Declarambolt, my dear friend, you feel like Usain Bolt loves me. आपको लगता है Usain Bolt आपसे प्यार करता है, but ऐसा नहीं है. Declarambolt syndrome. Othello syndrome. अपना पराया, Capgras syndrome. पराया अपना, stranger to familiar. That would be Fregoli syndrome. Survivability of fetus is 28 weeks. That is a capability of survival. Yes, beautifully done. Live birth test for respiration. Your first life is your lung. So any lung test for respiration is breast love. आपकी देखो एक बात हो मेरे को बताओ आपकी पहली लाइफ क्या है लंग या स्टमक यस लंग so breast love first life or hydrostatic test is for lung and breast love second life test is for your stomach and intestine air in stomach or intestine is breast love second life test yes 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 आपकी पहली लाइफ आपका लंग है और आपकी सेकंड लाइफ आपका स्टमक इससे कभी जिंदगी में इस जिंदगी में तो भूलोगे नहीं बाकी की मेरे को गारंटी नहीं है फ्रिजिडिटी फीमेल इज रिजिड माय डियर फ्रेंड इफ योर फीमेल रिजिड डॉक्टर साहब योर फीमेल पार्टनर इज रिजिड आपकी फीमेल पार्टनर इज नॉट गेटिंग सेक्सुअल अराउजल और नॉट एबल टू मेंटेन सेक्सुअल अराउजल भाई साहब मजा नहीं आ रहा है स्टार्ट ही नहीं हो पा रहा दैट इज फ्रिजिडिटी that is frigidity yes beautifully done yes now sir child born after death of father is posthumous child any child born after what is post after human की death के बाद child born after death of father is a posthumous child yes affiliation case is a case of disputed paternity and quad if you are important to a particular person if I am important to a particular woman I am a quad and a female is important for a particular man she is a quad अगर आप एक पर्टिकुलर इंसान के लिए आप इंपॉर्टेंट हो नामर्द हो या मजा नहीं आता यू आर ए क्वाड यस यस चलो कोई बात नहीं डॉक्टर साहब इन सुपर फिकंडेशन वी हैव वन टी मींस सेम एमसी साइकिल and 2T in 2 MC cycle. In 1T means same MC cycle, 2 are fertilized, that's a superfecundation. And in 2 MC cycle, 2 ova are fertilized, that would be, yes, I am going for English, whatever you want. In same MC cycle, my dear friend, if 2 ova are fertilized, that is a superfecundation. And in 2 different MC cycle, 2 ova are fertilized, that would be superfetation. Yes, beautifully done. Yes, beautifully done. Same or different means same age. Here same age of fetus. Here 1 month difference of a fetus. That is very important. Sir, supposititious child, fictitious child or substituted child, all are same. Yes, all are same. ये तीनों चीजें एक ही है sir. If you blackmail someone for money that I am pregnant because of you, मैं गर्भवती इसलिए हूं क्योंकि तूने मेरे को बच्चा दिया. If you blackmail someone for the money, that is a supposititious child, fictitious child or fabricated child, substituted child. Yes, बंगाली में कहां से कराऊं यार. चलो, MTP Act, my dear friend, beautiful trick, my dear friend. MTP Act, the consent is given by mother. The age of mother should be above 18 and the mother should be sound mind. It is up to 24 weeks. Up to 20 weeks, we require 1 doctor consent. And 20 to 24 weeks, we require 2 doctor consent. Yes. Nanere kab aa rahe ho? Nanere means borawad. Yes. Okay. So consent is given by mother. Age is more than 18 years of age. Up to 24 weeks. Up to 20 weeks, 1 doctor. Yes. And 20 to 24 weeks, 2 doctor. This is none other than my dear friend MTP. Okay. Now sir, who is a doctor? At least 25 MTP आपने assist की हुई होनी चाहिए. 6 month house job, MD, MS diploma or DNB in Obs Gynae department, and 1 year experience in the Obs Gynae department. That should be MTP. Beautifully done, my dear friend. Okay, up to 20 weeks. अगर आपको MTP कब करवानी होती? When you have contraceptive failure. Up to 24 weeks, rape, incest, vulnerable female or minor. Yes, beautifully done. But more than 24 weeks you can do if you have substantial fetal abnormality. मेरे हिसाब से बोलो तो congenital abnormality. Example, like any eugenic, any teratogenic, you can go for more than 24 weeks also. Okay, but who is the need? We need a medical board. Anxiety बहुत ज़्यादा हो रही है. Okay, no problem. I will tell you the issue also. Don't worry. Medical board is Obs Gynae, gynecologist, pediatrician, radiologist or sonologist or any other member. Who is any other member? And gazetted officer. Any time of MTP, if you want to save the life of female, Dr. Sahab, जिंदगी में be careful. Jaccha bachcha, be careful about the jaccha. Mother is the most important thing in the life. So mother's life is important. You can do MTP at any time, even by 1 doctor. That has to be taken. Yes. Yes. Sir, dead body की language में पढ़ो. Okay, okay, I'll try to that also. Okay, unnatural sexual offense, aprakratik yon aparadh, something which is not natural is unnatural. Okay, so everything is very simple. It is first is anal sex, my dear friend. First is anal sex, beautifully done. Anal sex is a Greek love. G for Greek, you know what is G, and it is B for buggery, B for buttock. Okay, sodomy. Passive agent, C for child, and C for catamite, unforgettable trick. Mouth sex, oral sex, mukh methun, that is a sin of Gomorrah. Sin of Gomorrah. Animal sex is bestiality. Lesbianism is three. Lesbian, लड़कियां स्त्री. As for sapphism and tribadism, मैं जोक नहीं बता रहा हूं बेटा, लड़कियों को स्त्री बोलते हैं. Sapphism and tribadism are other name of lesbianism. Okay, so G for Greek love, B for buggery, sin of Gomorrah is oral sex, animal sex is bestiality. Be careful in the life. डॉक्टर साहब 106 is medical negligence. सर क्वेश्चन, सारे क्वेश्चन है बेटा, बी केयरफुल, ऑल आर द क्वेश्चन. एक डॉक्टर ने जीरो काम किया, पिछवाड़े पे छक्का लगा. दैट इज 106 इज ए BNS section. 106 is a BNS section of medical negligence or any other negligence. Okay. Now, sir, I'm coming to sexual perversion. P for perversion, P for paraphilia. Now, sir, if you are giving pain to the partner, it is sadism or algolagnia. Suffering pain from the partner, you are feeling very good. Marle bhai sab, I'm very happy. That is masochism on passive algolagnia. Sir, trans is opposite and vest is a cloth. If you are wearing clothes of opposite sex, it's a transvestism or eonism. And if you are satisfied with the opposite sex article, like see, I'm a boy and I'm satisfied with girl's panty, that is a fetishism. फटी हुई चीज से मजा लेना, fetishism. Trans opposite vest cloth, beautifully done. Okay, yes, beautifully done. Okay, now sir, F female are rubbing a female in the crowded place, it's a proterism. Obscene video call, अगर आप अपनी गर्लफ्रेंड को कॉल करते हो and you are showing the obscene picture in obscene video, और आप कुछ कहते हो भाई साहब ये obscene picture है, that's a scatologia. Nymphomania is excessive sexual desire in female and satyriasis. अब देखो दोस्तों, satyriasis के नाम में आशीष है, excessive sexual desire in male. दोस्तों हिंदी में दोनों को ठरकी बोलते हैं. D for dipaldism, D for danda. If you are a teacher and you are beating your student by danda and you are feeling very good, that is a dipaldism. Yes, that is a. Sir, सारी नींद उड़ा दी, सारी नींद उड़ा दी. D for dipaldism, D for danda. So that is obscene video call. It's a scatologia. Scatologia. Beautiful. Sir, microchemical test for blood. देखो दोस्तों, मैं आपका टाइम खराब नहीं करना चाहता because it's a very highly rapid fast session. Teachman, man, Teachman, it's a man. Man color is brown, my dear friend. So in Teachman, it's a blood test with a brown rhombic crystal. Takayama, Takatak. Which color is Takatak? Pinkish color is Takatak. If you get something pinkish in your life, अगर आपको गुलाबी चीज मिल जाए, your life will become Takatak, Takatak, Takatak. So pinkish feathery crystal in this blood stain, that would be Takayama test. Takatak, Takatak, Takatak. Okay, so here hemine and hematine crystal, here hemochromogen crystal. So be careful, sir. Takayama, life become Takatak. Life become Takatak by pinkish color. गुलाबी चीज मिल जाए तो लाइफ टकाटक हो जाती है. Teachman man has a brown color, but it's a test for blood stain. It's a test for blood stain. Okay. Now semen, sperm and seminal fluid. Florence has C. It is for choline crystal. कोहली का कलर डार्क ब्राउन. द कोहली इज ए ह्यूमन बीइंग. हमारा विराट कोहली ह्यूमन बीइंग is a dark brown color. It is Florence for choline crystal. Barbados for spermine picrate. It is a yellow needle shaped crystal. Is a Barbados. How to remember? Barbados has S for spermine. Florence has a C for choline. Only in Russia possible. Okay, 7,000. No problem. Florence is C for choline. Choline is a brown rhombic, brown color. Barbados is as spermine picrate is a yellow needle shaped crystal. These are for semen. Sir, this is graze abrasion. It is also known as brush burn. Yes. Yes. Brush burn is a graze abrasion, my dear friend. Sir, tire mark is none other than, my dear friend, very fantastic question. Tire mark is an imprint or pattern abrasion. Tire mark is a imprint or pattern abrasion. Be careful, sir. Tire mark are imprint or pattern abrasion. Sir, battle sign is a contusion. It's not abrasion. It is contusion is in dermis. Battle is always in मैदान. तो सब आपने सुना होगा हल्दी घाटी की बैटल, है ना? आपने कईयों की बैटल सुनी होगी. Battle is always in मैदान. That's a wonderful trick by Jammer sir. M for मैदान, M for middle cranial fossa, M for bruise is at mastoid. Fracture is at middle cranial fossa, bruise is at mastoid. It is ectopic or migratory bruise, my dear friend. Yes, लड़ाई मैदान में होती है. Battle is always in मैदान. So M, everything is M. M for middle cranial fossa, M for none other than, my dear friend, mastoid area. Now, the raccoon sign is also the same ectopic or migratory bruise. Here, fracture at anterior cranial fossa and the bruise is at periorbital area. That is MM. It is also a migratory or ectopic bruise, my dear friend. तो मैंने battle sign और raccoon sign दोनों जो बताए हैं, that is a migratory or ectopic bruise. पक्का याद रख लेना एग्जाम में. देखो दोस्तों, कम पढ़ाता हूं, ढंग का पढ़ा दूंगा. Tramline bruise is caused by lathi on road and it's a patterned bruise, my dear friend. देखो, patterned abrasion or imprint abrasion by tire mark and lathi on road causes patterned bruise. Yes, beautifully done. Yes. Split laceration is also known as inside looking laceration, beta. Why it is known as inside looking laceration? It is on the hard surface by hard weapon. Why it is known as inside looking laceration? Because the margins are regular. Now the area of the hard surface are scalp, forehead, eyebrow, chin, iliac crest, shin and posterior part of elbow. This is split laceration or inside looking laceration. ठोकने वाली भी हार्ड है और जहां पे मारा वो भी हार्ड है. हार्ड सरफेस एंड हार्ड वेपन. द मार्जिन आर रेगुलर, माय डियर फ्रेंड. Yes. Now, sir, self-inflicted injury or suicidal injury, these are known as hesitational cut, tentative cut, trial cut. So what is self-suffered? Self-suffered is different. Self-inflicted means you are hitting on your body. Self-suffered means other is hitting your body with your consent. अगर आप खुद ठोकते हो, that is self-inflicted. किसी और से ठोकवाते हो, भाई ठोक ले, that would be self-suffered. So it's a very important difference. Yes, beautifully done, my dear friend. Love you all. Line of Langers. You can get this question in your exam. Line of Langer correspond to the collagen fiber. These decide the shape of stab injury. These decide the shape of stab injury. That is a line of Langers. These decide the shape of injury. That would be a line of Langer. Sir, swallowtail. Be careful. Swallowtail is seen in laceration and fishtail, that is seen in stab injury. Swallowtail in laceration and fishtail is seen in stab injury. Now, sir, if you see this particular injury, that is clean cut, crushed tissue and fracture of vertebral bone. Now, sir, there are two features, clean cut injury and crushed tissue. That is a chop wound. It is caused by heavy sharp edge weapon. This is caused by axe, kuladi, chopper, gandasa. There are so many things, but there will be three things: clean cut, crushed tissue and fracture of vertebral bone. That would be a chop wound. Beautifully done, my dear friend. Sir, active defense wound. When you grasp the weapon, defense wound का मतलब क्या होता है? जब बचने के लिए करते हो, आपने हथियार ही पकड़ लिया. If you actively grasp the weapon, that's active defense wound in palmar surface. And passive defense wound, don't get confused, my dear friend. Passive defense wound, when you protect yourself, that is a extensor surface of your hand, your forearm and medial surface of your forearm. These are passive defense wound. Yes, beautifully done. Sir, that's a pedestrian injury, not pediatrician injury. Pedestrian injury is the first primary impact injury, the first impact on the leg, that's caused bumper fracture. Bumper fracture is a fracture of tibia bone, my dear friend. First hitting, that is a bumper fracture, primary impact injury. Second is hitting, you are hitting the glass and bonnet, that is a secondary impact injury. And my dear friend, you are hitting the ground. अब आप गिर के ground पे टकरा गए, आप divider पे टकरा गए, that is a tertiary impact, which is also known as secondary injury. First impact, bumper fracture, tibia fracture, primary impact. Second impact, glass and bonnet. Tertiary impact, hitting on the ground, my dear friend. अब आप ground पे टकरा गए, there will be multiple grazed abrasion and tire mark. You can get a question. Multiple grazed abrasion and tire mark, that's a tertiary impact. But tertiary impact is also known as secondary injury. Yes. that is also known as secondary injury. एक बार एग्जाम में ध्यान रखना, tertiary impact is known as secondary injury. Tertiary impact is known as secondary injury. Be careful, you can get a question. Tertiary impact is known as secondary injury. Yes, beautifully done. Okay, अभी आ जाएगा बेटा. Blunt trauma, the most common organ spleen. The penetrating trauma, liver. Blast injury, most common is tympanic membrane. Seat belt, most common is mesentery. Then your hollow viscous like small intestine and spleen. Yes, yes, yes. Sir, seat belt causes chance fracture, fulcrum fracture of lumbar vertebra. Seat belt causes chance fracture and fulcrum fracture of lumbar vertebra. ठीक है, चलो कोई बात नहीं. Yes, tertiary impact is also known as secondary injury. Beautifully done. Okay. Blunt impact spleen, penetrating trauma liver, blast injury tympanic membrane. Seat belt most common is, yes, beautifully done. Seat belt most common is mesentery, then hollow viscous. Seat belt causes chance fracture, fulcrum fracture of lumbar vertebra. Sir, my favorite question of your exam, Marshall triad is seen in secondary blast injury. Marshall triad is seen in secondary blast injury. Okay. Air compression causes primary blast injury, tympanic membrane. Flying missile, Marshall triad, that is punctate abrasion, punctate laceration, that is a, yes, secondary blast. You are hitting the ground, that is a tertiary blast. Burn and flame, quaternary blast. Sir, you can get a question in this exam. Quinary blast. What is quinary blast, my dear friend? Like after effect of the blast. What is after effect? Burn. No, not a burn. After effect is chemical radiation. That is after effect of virus and bacteria. That would be a quinary blast. Burn and flame is a quaternary blast, and after effect are quinary blast. Be careful, my dear friend. Yes, PTSD. Yes, absolutely right. Joy is absolutely right. PTSD will be a quinary blast. Okay, burn and flame will be a quaternary blast. Be careful. This is going to be most wonderful question. Air compression, primary blast. Flying missile, Marshall triad, secondary blast. Hitting the ground, that is tertiary blast. Burn and flame is a quaternary blast, and after effect is quinary blast. Most beautiful question. Yes, done. Every line is MCQ. Antemortem hanging, dribbling of saliva is opposite side of the knot. If I have knot here, dribbling of saliva at the opposite side of knot, because of, you can get this question in exam, because of pterygopalatine ganglion and because of submandibular gland. Okay. Yes, beautiful question. Yes, law faces sympathetic case, same side of the knot, eye remain open and pupil is dilated. Pupil is dilated and eye remain open at the same side of the knot. This is law faces sympathetic case. Cervical sympathetic chain. Cervical sympathetic chain. Okay, I will make it adjusted. Don't worry. Okay, is it clear? Sir, camera disturb हो रहा है, ठीक है? चलो कर दिया मैंने. Okay. So law faces sympathetic is same side of the knot, eye remain open and pupil is dilated. Cervical sympathetic chain, opposite side of the knot, that's a dribbling of saliva. Dribbling of saliva. Sir, आप कहोगे तो कैमरा क्या सब कुछ adjust कर दूं यार. But sir, both are the finding of antemortem hanging. Sir, you can see this is cervical sympathetic chain stimulation. Same side of the knot. You can see the same side of the knot, eye remain open and pupil is dilated. This is law faces sympathetic. This is law faces sympathetic. Okay, that's a very beautiful question. Judicial hanging, hangman knot at angle of mandible. Hangman fracture is C2 vertebra fracture. And in judicial hanging, I expect this question in exam. INICET sign is carotid tear. INICET sign is carotid tear. All three questions: hangman knot, angle of mandible, hangman vertebra fracture, C2 vertebra fracture, and INICET sign is carotid tear. Beautifully done. Yes. Sir, this is none other than garroting, my dear friends. Spanish windlass. It is judicial strangulation. It is not judicial hanging. This is judicial strangulation. This is garroting, Spanish windlass, because it is common in Spain and Turkey. Throttling is this one. This is always homicidal, my dear friend. You can see the fingernail abrasion. You can see the 6 penny bruise. You can see the hyoid bone fracture, most common, but you can get this question in exam. Most specific fracture is a cricoid fracture. Most common fracture hyoid bone, most specific is this, and you can see the hematoma and hemorrhage in this throttling, which is always homicidal. But sir, this is fingernail abrasion, this is throttling, but same fingernail abrasion. My favorite question, my dear friend. perioral abrasion, perioral contusion, perioral multiple bruises, perioral contusion, perioral finger abrasion with asphyxial sign. This is smothering. What is smothering, my dear friend? Smothering is, you can see the picture, my dear friend. Yes, most common is iodine throttling, most specific is cricoid. But if you see all this area, this involved, this is none other than smothering. My dear friend, smothering can be homicidal as well as accidental. It is never suicidal. Smothering can be homicidal as well as accidental. It's never suicidal. Can you see the picture, beta? Yes, beautifully done. So this is smothering. It can be homicidal, it can be accidental, never suicidal. Yes. Now, sir, cafe coronary means you are intoxicated, something chokes. अब आप नशे में थे और कुछ आपकी गले में चल गया. That is cafe coronary. The cause of death is cardiac arrest. You can get this question in exam. The cause of death is cardiac arrest, my dear friend. Mother lie on the baby is a overlaying. Mother lie on the baby is overlaying. But sir, I am expecting this question in your exam, my dear friend. Barking is homicidal, my dear friend. Barking is homicidal. It is smothering plus traumatic asphyxia. You are sitting, that is a traumatic asphyxia, and you are doing smothering. This is homicidal. This combination is known as barking, my dear friend. Love you all, my dear friend. This is barking. This is homicidal. In freshwater drowning, in wet drowning, the cause of death is cardiac arrest. But sir, see the three letter. In freshwater drowning, it would be hemodilution, hyperkalemia, hyponatremia, and ventricular fibrillation. Hemodilution, hyperkalemia, hyponatremia, and ventricular fibrillation. In seawater drowning, it is hemoconcentration, hyponatremia, potassium is normal. Here, bradycardia. Here you will die in 4 to 5 minutes. In seawater, you will die in 8 to 10 minutes. तो आप उल्टा सोच रहे होंगे. In seawater, you die in 8 to 10 minutes, my dear friend. Be careful. You die late in seawater. You die earlier in freshwater. This is going to be the best table of your life. Freshwater and seawater. So diatoms are seen in antemortem drowning. These are unicellular algae covered by silica present in your bones. And my dear friend, we are doing acid digestion. If you get this picture, this is none other than diatom, which is indicative of antemortem drowning. Unicellular covered by silica. It is acid digestion test, my dear friend. It is acid digestion test. So choose fresh water. I won't suggest to choose anything. Postmortem staining in carbon monoxide is cherry red. In cyanide, my dear friend, brick red. Hypothermia, it's a bright pink. Hydrogen sulfide, 2 color. Hydrogen sulfide H2S, 2 color, bluish green. Opium, it is black color. Sir, but when you eat pan, डॉक्टर साहब जब आप पान खाते हो, your mouth become chocolate brown. जब आप पान खाते हो ना, पान खाते हो तो आपका मुंह chocolate brown हो जाता है. What is pan? Phosphorus and potassium chlorate, A for aniline and N for nitrate or nitro compound. It will become chocolate brown color. So this is a very, sir, आपने कोनी लगे कहीं. No problem at all, my dear friend. I love you all. But this is postmortem staining. पान खाते हो तो chocolate brown color हो जाता है. P for phosphorus, P for potassium nitrate, A for aniline and N for nitrate or nitro compound. This is pan. Chaliana. Chalo. For race, we use a cephalic index beta. RAC. Race cephalic index is C. It is breadth of skull divided by length of skull into 100. Sir, you can remember by a Hindi trick, Doodh Mishtan Bhandar. And you can remember by English trick also, dumb. Dolichocephalic, 70 to 74.9. Meseticephalic, 75 to 79.9. And brachycephalic, it is 80 to 84.9. Yes, Doodh Mishtan Bhandar. And the trick in English is, it is dumb. सर डोले शोले किसके फेमस है? निग्रो की और प्योर आर्यन के. डोलिकोसेफलिक एंड निग्रो एंड प्योर आर्यन. मस्ती की पाठशाला, हु इज मस्ती? MICE. इंडिया वाले लोग मस्ती करते हैं तो मेसेटिसेफलिक, MICE. चाइनीज एंड यूरोपियन ऑल्सो एज मस्तीसेफलिक एंड ब्रेकिसेफलिक इज इन मंगोल. सो डोले शोले, निग्रो एंड प्योर आर्यन. प्योर लोगों में डोले शोले होते हैं. मस्ती की पाठशाला, इंडिया की पाठशाला, मस्ती की पाठशाला. वेरी ब्यूटीफुल माय डियर फ्रेंड. It is very beautiful. MICE, mice. That is cephalic index. Sir, for sex, Ashley rule. For Ashley rule, it is done for sternum bone. Sir, all bony prominence are more prominent in male In female, frontal and parietal eminence. Preauricular sulcus is present in female. O for obturator foramen, O for oval in male and triangular in female. Best index is sciatic notch index. Pelvic inlet is heart shape in male and round shape in female. तो सब फीमेल में सारी चीजें गोल गोल होती है, गोल गोल माहौल. But only one thing which is not round in female, that's the obturator foramen. Okay, be careful. I for ischial tuberosity, I for inverted in male and inverted in female, and angle are V shape or less in male and U shape or more in female. That's a beautiful trick, unforgettable trick of your life. Okay, so that's a very simple trick. सारी चीजें फीमेल में गोल होती है एक्सेप्ट ऑब्चुरेटर फोरामेन. और सब मेल और हार्टलेस, हम कहते हैं ना मेल में दिल नहीं होता, बिकॉज आवर हार्ट इज एट द पेल्विक इनलेट. हमारा हार्ट थोड़ा नीचे है, दैट इज एट द पेल्विक इनलेट. सो बी केयरफुल. This is a heart shaped pelvic inlet. Yes or no, my dear friend? Okay, I am asking about all the question. So that's the most beautiful trick. Okay, okay, done, sir. Sciatic notch index is the best index. Okay. Sir, civil negligence. Okay, beautifully done. Civil negligence is none other than tort. Criminal negligence, I'll discuss. Civil negligence is a mild negligence. Criminal negligence is a gross negligence. In civil negligence, the burden of proof कौन करेगा? The patient has to prove. But in criminal, doctor has to prove. Civil negligence in civil or consumer court, it is done by money. It is compensated by money. Criminal negligence by money and 106 BNS. Civil negligence in civil court or consumer court like overdose causing drug side effect. है ना, अगर आपने overdose कर दिया और drug के side effect हो गए. But criminal negligence, a surgeon forgot the swab in the body, that would be criminal negligence. Beautiful question. Okay, civil negligence is not. अरे एक बार नीट पीजी में क्वेश्चन आया हुआ है. Civil negligence burden of proof is patient and criminal negligence burden of proof is towards doctor. चलो बच्चों, कोई बात नहीं. डॉक्टर साहब, these are gunshot injury. You can get a question in exam. Sir, in contact shot, yes, res ipsa loquitur is thing, or yes, surgeon forgot the instrument in the body, that is a res ipsa loquitur. In contact shot, it is muzzle impression present. In all remaining shot, muzzle impression absent, without any doubt. Sir, stellate shape, it is contact shot. All remaining, it's a circular shot. अगर आपका star shape, it's a contact shot. All remaining circular. Sir, burning is produced by flame, blackening is produced by smoke, and tattooing is because of gunpowder. So no burning, no blackening, and no tattooing. That means it's a contact shot. If all burning, blackening, and tattooing present, that would be a close shot. Only blackening and tattooing, it will be a near shot, and all are absent, it will be a distant shot. Be careful, है ना. सारे ट्रैक में चले गए, nothing is present, contact shot. Then BBT present, close shot. Only BT or TT present, near shot, and all are absent, it's a distant shot. Sir, abrasion or grease color present in all shot. Sir, abrasion and grease color present in all shot. Be careful in your exam. Okay, beautiful question. Yes. Sir, upper limb fusion and lower limb fusion. देखो डॉक्टर साहब, upper limb ऊपर होता है, you will start with 18. Lower limb नीचे होता है, you will start with 17. 18, 16, 18. Upper limb fusion. 18, 16, 18. Upper limb fusion. And 17, 18, 17 lower limb fusion. In female, the fusion is seen 1 to 2 years earlier. In female, the fusion is seen 1 to 2 years earlier. That's a very beautiful trick. Okay, done. Upper limb में ऊपर से start हो. Sir, toxicological analysis and chemical analysis. The most commonly used is common salt, but ideal is rectified spirit. देखो दोनों बातें अलग है. Most क्योंकि सस्ती चीज क्या है, नमक. Most commonly used is common salt, but ideal is rectified spirit. For blood, the best preservative is sodium fluoride and potassium oxalate. Beautiful question, my dear friend. Yes. Urine, toluene. Toluene and thymol are the preservative for urine. Histopath, the best preservative is formalin. Virology, it's a glycerin. Virology, it is a glycerin. Beautiful question. Yes or no, my dear friend? Virology, it is a glycerin or glycerol. Sir, special smell of a poison. Fruity smell, ethanol. A for acrid smell, A for aldehyde. Beautiful question. Rotten egg smell, ये एग्जाम में आपके क्वेश्चन आया हुआ बेटा, गड़बड़ाने की जरूरत नहीं है. रोटन एग स्मेल, अंडे दो ही अच्छे, H2S. Fish smell, नीली फिश, aniline. Kerosene smell, I expect this question in exam, organophosphate. Kerosene smell, organophosphate. Fishy smell, zinc phosphide. डॉक्टर साहब, बी केयरफुल, BC वैसे बहुत फेमस वर्ड है BC. Bitter almond, cyanide. burnt rope cannabis. Bitter almond cyanide, burnt rope cannabis. Beautiful question in exam. Shoe polish, shoe कौन से पसंद है? Nike, nitrobenzene. Garlic, AR, arsenic. Garlic pizza, garlic smell in phosphorus. In थाली, thallium. So these are the question you can get in exam. है ना? सारी की ट्रिक भी बता दी. BC बहुत लोग फेमस है, हालांकि BC गलत वर्ड होता है, बट BC आप burnt rope, cannabis, bitter almond साइनाइड, है ना? BC गलत है, बट हमें शू किसके फेमस है? नाइकी के, नाइट्रोबेंजीन. गार्लिक, आर्सेनिक, फास्फोरस एंड हीलियम. थाली में गार्लिक पिज्जा खाते हैं. सर एंटीडोट, वैसे तो फार्मा में आपको पढ़ा देते हैं, बट जामर सर के साथ बैठे हो. पैरासीटामोल, एनेसिटाइलसिस्टीन, मिथेनॉल, फोमिपाजोल, कार्बन मोनोऑक्साइड, ऑक्सीजन, बेंजोडाइजेपिन. आई एक्सपेक्ट दिस क्वेश्चन. फ्लूमाजीवी. ओपिएट, डॉक्टर साहब ओपिएट से कंफ्यूज मत होना, हेरोइन इज आल्सो सेम. नलोक्सोन, यस माय डियर फ्रेंड. ऑर्गेनोफॉस्फेट, एट्रोपिन एंड ऑक्साइन, प्रिलिडोक्साइन. साइनाइड, विटामिन B12 is best antidote, but sir, amyl nitrite, sodium nitrite and sodium thiosulfate, this is Lilly antidote or triple antidote. थाली में पिज्जा, थेलियम, प्रूशियन ब्लू एंड मिथाइल, मैथ हीमोग्लोबिनीमिया, मिथाइलिन ब्लू. मोस्ट ब्यूटीफुल ट्रिक. मैथ थाली में पिज्जा, थालियम, दैट्स अ प्रूशियन ब्लू. साइनाइड की बेस्ट एंटीडोट विटामिन B12, बट वी यूज ट्रिपल एंटीडोट. एक बार थम्स अप कर दो तो मजा आ जाएगा, मैं भी मजे से आपका ध्यान आकर्षित कर सकता हूं. बोलो गोलगप्पो, छोटी छोटी बातें, है ना? चलो आगे, चलो डन. थैंक यू वेरी मच. थम्स अप हो गया भाई साहब. चलो सर, एल्ड्रिच मीज लाइन इन आर्सेनिक पॉइजनिंग, ए और आर्सेनिक ए. एल्ड्रिच मीज लाइन, आर रेड वेलवेटी म्यूकोसा, यस. आर रेंड्रो पिगमेंटेशन, ए आर. आई ब्यूटीफुल ट्रिक, आयरन इज एंटीडोट, फेरिक ऑक्साइड इज एंटीडोट, एंड सी cholera, it mimics acute arsenic poisoning, mimics cholera poisoning. Acute arsenic poisoning mimics cholera poisoning. Beautifully done. This is Eldridge Mees line. Sir, this is none other than basophilic stippling, which is seen in RBC. Beautifully done. Seen in lead poisoning. It is known as saturnism or plumbism. It is also known as saturnism or plumbism. Sir, this is root of aconite. It is also known as blue rocket, meetha zehar. Yes, root, yeah, that is a basophilic stippling seen in RBC. Root of aconite, blue rocket or meetha zehar. Sir, there is a classical sign, Hippus sign. It's a cardiac poison, contraction and dilatation of pupil. And there is one thing which is known as xanthopsia, yellow halo. It is causing hyperkalemia. It is causing hyperkalemia. Yes, beautiful. Aconite. This is yellow oleander, but आपके एग्जाम में नाम आएगा इसका cerebra thivacea. All parts are poisonous. Yes, my dear friend. In aconites, all parts are poisonous. It's aconite, blue rocket, meetha zehar, Hippus sign, hyperkalemia, xanthopsia. ये सारे क्वेश्चन आ सकते हैं. This is yellow oleander. Yes, this is yellow oleander, cerebra thivacea. कहते हैं ना हाथ पीले करना, मतलब सेलिब्रेट करना. कहते हैं ना लड़की के हाथ पीले करना, सेलिब्रेट, cerebra thivacea. कनेर, पीला कनेर. सर कोकेन के क्या क्या नाम है? सी कोकेन, सी क्रैक, सी कोक, सी शी. शी इज अ व्हाइट लेडी, व्हाइट मतलब स्नो. सर देयर इज अ मैग्नान सिम्पटम, टैक्टाइल हेलुसिनेशन, फॉर्मिकेशन और कोकेन बग. एंटीडोट इज अमाइल नाइट्राइट. BP, heart rate and respiratory rate are increased. Nasal swab is the best sample. Heroin plus cocaine, he plus she. ओह भाई साहब मजा आ गया. जब he she के साथ मिल जाती है तो आपकी गेंदों की स्पीड बढ़ जाती है. स्पीड बॉल. He combines with she. Heroin combines with she. She is a cocaine. Your speed ball is there. The speed ball. That combination is known as speed ball. ये पक्का आएगा. Sympathomimetic is cocaine. Sympathomimetic is cocaine. Beautifully done. Sir, poppy fruit is a theme. Pinpoint pupil, coma and respiratory depression. अगर pinpoint pupil दिए हुए हो, coma और respiratory depression दिया हो, this is none other than अफीम. सर ओवर थिंकिंग को कम कैसे करें? अच्छी अच्छी बातें सोचो, जो तुम्हारे साथ जिंदगी में अच्छी अच्छी हुई है उसके बारे में सोचो. जिंदगी में भगवान ने बहुत अच्छी चीजें दी है. डोंट गो फॉर दैट विच आर वेरी बैड. ओके, चलो. पिन पॉइंट प्यूपिल, कोमा एंड रेस्पिरेटरी डिप्रेशन. इट इज पोपी फ्रूट और अफीम. वी गिव द वर्टिकल इंसिजन, माय डियर फ्रेंड, एंड वी गेट दिस पोपी फ्रूट, दैट इज अफीम, माय डियर फ्रेंड. कुछ हुआ ही नहीं है. दैट्स ऑल. दैट मीन्स यू आर वेरी लकी. हेरोइन इज ए सेमी सिंथेटिक. The antidote, the heroin is also known as diacetylmorphine. The antidote is naloxone, and smoking the heroin is known as chasing the dragon. You can get this question. जैसे ना एक पत्ती पे लेके smoking of heroin करते हैं. This is chasing the dragon. This is chasing the dragon, my dear. So sweating is absent in one condition that is known as heat stroke. अभी का सेशन देखो. दिल से ओवर थिंकिंग कम हो जाए, मस्त रहो, खुश रहो बेटा, भगवान ने जो डिसाइड कर रखा है वो होगा, डेस्टिनी इज द बेस्ट, खुश रहो हमेशा, है ना। चलो, सो दैट इज वेरी इंपॉर्टेंट। यस 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 यस, आप सच्ची बहुत अच्छा, भगवान करो सब पास हो जाओ, मेरे दिल से दुआ है, सब पास आके मेरे से जोधपुर आके मिलो, मेरे दिल से दुआ। चलो, स्वेटिंग इज एब्सेंट इन हीट स्ट्रोक, स्वेटिंग एब्सेंट होती है हीट स्ट्रोक के अंदर, ब्यूटीफुली डन। सर स्कैल्ड इज ए मॉइस्ट बर्न, there's a liquid or steam above 60 degree, and here you can see the two findings, soldering and bleaching. हंसते हंसते कट जाए रस्ते, that is a scald is a liquid and steam above 60 degree, ये भी क्वेश्चन आता है, soldering and bleaching is seen, my dear friend. Yes, flame is a dry burn, you can feel the burn at 44 degree, and there is a blackening and burning, there is a blackening. सर बोतल लेके आएंगे जोधपुर, बेटा पढ़ाई में ध्यान दो, पढ़ाई में ध्यान दो। Yes, yes, your anxiety is released. Soldering and bleaching in scald, and blackening and burning is seen in flame or dry burn. Okay, so this is scald and this is flame. Yes, beautifully done. This is flame. Flame is a blackening and burning. Okay, so rule of 9 and rule of Wallace, there are 11 into 9, 90%. Head and neck 9%. Right upper limb 9, left upper limb 9. Anterior chest 9, posterior chest 9, abdomen 9, posterior abdomen, part of the abdomen 9. Right lower limb, right is 9. Okay. Posterior part of the right lower limb is 9. And left lower limb anterior 9, posterior 9. 1% is for your genitalia. Yes, my dear friend. Yes. In chemical burn, the blisters or red lines are not seen. Okay. Sir, if you see the lower limb, thigh 10%, leg 5%, foot 3%, because one lower limb, that is 18%. So if you see the head and neck, head 7% and neck 2%, and if you see the upper limb, 4, 3, 2. Yes, beautifully done. Yes, yes. ये सारे PYQ हैं. All are the PYQ, my dear friend. Whatever I'm asking, whatever I'm going through, that is a PYQ only. Okay. Sir, crocodile burn are high voltage and loose contact burn. These are multiple pitted burn. No. Yes. FMT medicose, fit medicose, adipose here, it is a lipase, not lecithinase. In normal decomposition, it is lecithinase. High voltage and loose contact, my dear friend, it is crocodile burn. Beautifully done. Yes. Strychnine, Dr. Saab, there are two names of the strychnine, Nux vomica, Cuchilla, dog button. Fatal dose कितनी होती है बेटा? 1 crushed seed, एक पिसा हुआ बीज. The seed are concavo-convex. There is opisthotonus, hyperextension of the back. And Dr. Saab, it causes postsynaptic. Be careful in your exam. पक्का इस exam में आ सकता है. There is a postsynaptic inhibition of glycine, that is a spinal cord anterior horn cell. It mimics a disease that is tetanus. Strychnine tetanus को mimic करता है, arsenic cholera को mimic करता है. Nux vomica, Cuchilla, 1 crushed seed, dog button, concavo convex होता है. इस सीड को अपनी आंखों में बसा लेना दोस्तों, एग्जाम में आ सकता है. Spinal cord poison, anterior horn cell, postsynaptic inhibition. Sir, this is Ratti, Abrus or rosary bead, lal beej दोस्तों. The abrine is a toxin which act like a viper venom. It's an ideal cattle poison. Yes, Nux vomica is a medicine in homeopathy. It's an ideal cattle poison. It's Abrus precatorius. It's Abrus, rosary bead or Ratti. Sir, Semicarpus anacardium. Yes, my dear friend. Semicarpus anacardium. It is also known as marking nut or bilava. It is also known as marking nut or bilava. Anacardium. Here seed are heart shape. Here seed are heart shape. Yes, beautifully done. Beautiful question. Seed are heart shape. बिलावा पे भी क्वेश्चन आया हुआ, सेमीकार्पोल पे भी क्वेश्चन आया हुआ, बिलावा नोल और सेमीकार्पोल. ब्यूटीफुली डन. मैं 1 घंटे में इतना पढ़ा जाऊंगा कि इतना आपका काम एग्जाम में हो जाएगा. कैलोट्रोपिस, यस माय डियर फ्रेंड, आंकड़ो, मदार, रबर बुश, चारों एक ही चीज है. रबर बुश, उश्चरीन इज ए टॉक्सिक प्रिंसिपल. यस, उश्चरीन इज ए टॉक्सिक प्रिंसिपल. आंकड़ो जिसको हम बोलते हैं सेमिकार, this semicarpole is a marking nut. Calotropis, आंकड़ो, मदार और रबर बुश, it is also a cattle poison. Ushari, yes. Sir, thorn apple, dhatura, it is an anticholinergic. Fatal dose 100 seed. देखो सब H400 seed, कभी गलती होता है. H4 hyoscine is an active principle. आंकड़ा पेड़ जोधपुर में गणा है, सही बात है. It is hyoscine. It's a deliriant poison. It's a 9D poison. इट इज अ आइडियल रेलवे रोड साइड और डिलीरियंट पॉइजन. कहते हैं ना किसी हाथ का दिया हुआ कुछ मत खाओ, अजनबी के हाथ का. इट इज अ डिलीरियंट पॉइजन, रेलवे पॉइजन, रोड साइड पॉइजन. हायोसिन. एंटीडोट इज फाइसोस्टिग्मिन. क्यों लगता है मेरे को इस एग्जाम में क्वेश्चन आएगा एंटीडोट इज फाइसोस्टिग्मिन? यस यस. Doctor sir, if you get this question in exam, that blind as a bat, hot as a hair, dry as a bone, red as a beet, mad as a wet hen, it means we are talking about the Datura. It means we are talking about the Datura. अगर ये चारों चीजें पांचों चीजें दे रखी हो, this is Datura, anticholinergic, hyoseed, 100 seed, everything is very important. Deliriant poison. Sir, huge tragedy is because of methanol poisoning. It is caused by illicit liquor, illegal liquor. कच्ची शराब, मतलब शराब पूरी बनी हुई नहीं है. दिस इज मेथनॉल पॉइजनिंग. यस, ब्यूटीफुल. दिस इज ह्यूज ट्रेजेडी. दैट इज ह्यूज ट्रेजेडी. सर, न्यूरोटॉक्सिक स्नेक कम्स अंडर, मैं थोड़ा इसको अलग कलर दे देता हूं, मजा आएगा. इट इज इलेपेडी फैमिली. यस, न्यूरोटॉक्सिक स्नेक आर इलेपेडी फैमिली. किंग कोबरा, ऊफियोफेगस, कोबरा, नाजा नाजा. डॉक्टर साहब, आप सबको मालूम है कोबरा को हम क्या बोलते हैं? नाग. नाग, नाजा नाजा. Both king cobra and cobra are neurotoxic, my dear friend. The cause of death is respiratory muscle paralysis. Yes, देसी दारू नहीं बेटा, नकली दारू थी. Whose tragedy was नकली दारू, not देसी दारू, नकली दारू. Sir, if you have hood and spectacle, in the hood that is a cobra. The big one is king cobra, Ophiophagus. Yes, Ophiophagus. Yes, antidote is ethanol for methanol and as well as fomepizole. As well as fomepizole. Beautifully done, my dear. चलो, न्यूरोटॉक्सिक स्नेक इलेपेडी. सर, दिस इज बंगारूस. सर, मिथेनॉल होगा. सर, कॉमन करेत इज बंगारूस. कॉज ऑफ डेथ इज अगेन इट्स ए न्यूरोटॉक्सिक, माय डियर फ्रेंड. इट इज ब्रेथ काउंट टेस्ट इज डन फॉर ऑल न्यूरोटॉक्सिक स्नेक. तो मैंने 3 न्यूरोटॉक्सिक स्नेक बताए, किंग कोबरा, कोबरा, कॉमन करेत. ऑल आर न्यूरोटॉक्सिक स्नेक, माय डियर फ्रेंड. यस, ब्यूटीफुली डन. लव यू ऑल, माय डियर फ्रेंड. सारा पढ़ा के जा रहा हूं बेटा, गलती मत करना. V for vasculotoxic, V for viper, 3 rows of brown scale. This is Russell viper. 3 rows of brown scale. अगर 3 बुरी बुरी स्केल दिखाई दे रही है तो ये रसल वाइपर है बेटा. V for vasculotoxic and V for viper. आप इसके लिए क्लॉट टेस्ट करोगे, होल ब्लड क्लॉट टेस्ट. वहां पे हमने किया था ब्रेथ काउंट टेस्ट, यहाँ पे करोगे होल ब्लड क्लॉट टेस्ट. होल ब्लड क्लॉट टेस्ट, क्योंकि ये vasculotoxic है. सर, ट्रीटमेंट फॉर कोबरा. कोबरा इज ए नाग. ASV, anti-snake venom, neostigmine plus atropine plus mechanical ventilation. Yes, yes. Sir, viper is a vasculotoxic, so it is ASV, fresh frozen plasma और surgical debridement. क्यों? क्योंकि bleeding करता है तो आप इसको necrosis हो गया तो एरिया surgical debridement कर दो. करेत no atropine, no neostigmine. करेत only ASV and mechanical ventilation. Yes. So neostigmine and atropine in cobra, fresh frozen plasma and that is surgical debridement in viper, only ASV in mechanical ventilation in करेत. But एक बात ध्यान रखना, in करेत we don't use neostigmine and atropine because करेत का काम होता है प्री सिनेप्टिक पे और cobra is at post synaptic. Now sir, एक एग्जाम में राइट स्ट्रेटेजी पूछी जा सकती है. What is right? RIGST, right. Okay. फोमीपेजोल मार्क कर देना बेटा. बेटर इज फॉर्मूला. R, reassure the patient. पहला. I, immobilize. G, go to hospital. T, treatment and history giving. That is a very important right strategy. Reassure, immobilization, go to the hospital, history and treatment given. That is a very important for. Yes, yes, beautifully done. Love you all बेटा. मैं तो भगवान कहता हूँ आप सबका सिलेक्शन हो जाए, आप बड़े डॉक्टर बन जाओ और बोलो कि सर मजे आ गए. ठीक है ना. As for sea snake, as for skeletal muscle, that is a myotoxic. Renal failure is the cause of death. Sir, gastric lavage is contraindicated in strychnine poisoning or hydrocarbon. Strychnine causes convulsion, that's why it's a contraindicated. And hydrocarbon, it is contraindicated because one of the example of hydrocarbon is kerosene. That can cause aspiration. Both are the right answer, but you can pick hydrocarbon as a better answer. Okay. So flat tail is there. Yes, flat tail is there. That causes paddling. It's a myotoxic. As for sea snake, as for skeletal muscle, myotoxic. Renal failure is the cause of death. Yes, renal failure. Sir, cold बहुत है भाई साहब. ठंड में तो मजा है भाई, सब खाने का, पीने का, सोने का, सब मजा ठंड में. इट इज अ सी स्नेक skeletal muscle. Myotoxin. It is renal failure. It is causing renal failure. Beautifully done. Yes. Sir, blister beetle is a Spanish fly. It causes cantharidic poisoning, and there is a very important symptom, priapism. Priapism, painful erection of penis. दर्द के साथ इरेक्शन होना. That is priapism. Beautifully done. Blister beetle, BB. BB, आपकी BB स्पेन की है, कैंथराइड पॉइजनिंग कर देती है और दर्द के साथ खड़ा करती है. That's beautifully done. Yes. Sir, in dental charting, the first is Palmer notation. My dear friend, Palmer notation is none other than Zygmundi method. Here you write down the teeth 1 to 8 and 1 to 8. You can see 1 to 8, 1 to 8, 1 to 8, 1 to 8. It's a Palmer notation. Ames wali story. No need to get that story. But Palmer notation is 1 to 8, 1 to 8, 1 to 8. It's a dental charting. It's a Palmer notation or Zygmundi method. Beta, Ames में हमने तो मजे में Ames कर लिया, but now the things are getting difficult. Okay, so be careful in your life. Okay. Palmer notation or Zygmundi method. 1 to 8, 1 to 8, 1 to 8. If you write down the teeth in this manner, this is a dental charting. Palmer. आज बहुत खुश लग रहे हो. चलो ठीक है. Sir, Hadrup method. Along with upper teeth, plus is written. Along with lower teeth, minus is written. So plus 1 to plus 8, plus 1 to plus 8, minus 1 to minus 8, minus 1 to minus 1 8. एग्जाम जीटी जैसे ही आता है, एग्जाम बहुत इजी आएगा, बहुत मस्त रहना. दिस इज Hadrup method. This is Hadrup method. Very beautifully done. Plus, so upper teeth plus is given and lower teeth minus is given. That would be Hadrup method. Sir, if the teeth are written 1 to 32, that would be a universal or Cunningham method. Means 1 to 16 and 17 to 32, that will be a universal and Cunningham method. Again, I am telling you, 1 to 8, Palmer notation or Zygmundi method. Plus 1 to plus 8, minus 1 to minus 8, Hadrup method. 1 to 16 and 17 to 32, that is a universal or Zygmundi method. बेटा है ना, ध्यान रखना, गलती मत करना. अगर ऐसी फोटो आ जाए तो ध्यान रखना. Fingerprint is best for criminal identification. DNA fingerprint is best for decompose. In superimposition, we use skull for photograph, and cilioscopy is the best method for lip print. Cilioscopy is the best method for lip print. Fingerprint best for criminal, DNA for decompose, superimposition for skull, cilioscopy for lip print identification method. So this is most common variety. Listen, my dear friend, most common variety of fingerprint is loop variety. In loop we have O, 1 delta and 1 core, O for 1, 1 delta and 1 core. Arch, that is like a mountain, no core, no delta. No core, no delta, that's an arch. Whorl is like a circle, that is 1 to 2 core and 2 delta. 1 to 2 core and 2 delta. Be careful, my dear friend. Again, I am telling you, the most common fingerprint is loop, 1 core and 1 delta. Arch, no O, no core and no delta, just like a mountain. Loop is this. This is loop. Arch is just like a mountain. And whorl is just like a circle, 1 to 2 core and 2 delta. 1 to 2 core and 2 delta. So this is going to be almost the last slide, my dear friend. Sir, in ethanol, there may be a vitamin B1 deficiency, that is thiamine deficiency. Beautiful question. And in thiamine deficiency, we have two things. One is Wernicke's encephalopathy, Goa. तो सब हम दारू पीने के लिए कहाँ जाते हैं? गोवा. G for global confusion, O for ophthalmoplegia, A for ataxia. और वहां पे आप बेवड़ा नंबर 1 हो जाते हो तो B1 की deficiency हो जाती है. That's a very beautiful thing. So for drinking daru, you go to Goa. You become Bevda number 1, B1 deficiency, thiamine deficiency, yes. Global confusion, ophthalmoplegia, yes. And ataxia. And Dr. in Goa you use cap. Goa में जाके आप cap use करते हो. That's a Korsakoff psychosis. Whatever cap you use, you in sunlight or whatever light you use, है ना? तो आप चाहो तो sunlight में जाओ तो भी cap use करते हो और अगर दूसरे light area में जाओ तो भी cap use करते हो. What is cap? C for confabulation, A for amnesia, P for polyneuropathy. चलो एक बार डेंटल चार्टिंग वापस बता दूंगा. व्हाट इज कन्फाबुलेशन? इट्स अ फॉल्स स्टोरी. सो इट इज अगेन ड्यू टू विटामिन B1 डेफिशिएंसी. तो याद करने की ट्रिक क्या है? गोवा और गोवा में जाके कैप पहनते हो एंड यू बिकम बेवड़ा नंबर 1. यू बिकम बेवड़ा नंबर 1. व्हाट इज CAP? confabulation, amnesia, polyneuropathy. What is confabulation? Making false story. Okay, that is making false story. Okay, so ethanol, Wernicke's encephalopathy, Goa, global confusion, ophthalmoplegia and ataxia, B1. Korsakoff psychosis, गोवा में जाके आप कैप पहनते हो, confabulation, amnesia and polyneuropathy. चलो एक बार डेंटल चार्टिंग वापस पढ़ा देता हूं बेटा. चलो देख लो, ये देखो. If you write down 1 to 8, 1 to 8, 1 to 8, 1 to 8, it's a Palmer notation or Zygmundi method, है ना. अगर 1 से 8, 1 से 8, 1 से 8, 1 से 8 लिखा हो, it's a Palmer notation or Zygmundi method. Beautifully done. Okay, beautifully done. सर ये +1 to 8, +1 to 8 ऊपर वाले के साथ प्लस, -1 to 8, -1 to 8, it is a Hadruff formula. Beautifully done. But if the number of teeth, अब ध्यान से सुनना बेटा, है ना. If the number of teeth are written 1 to 32, 1 to 16, 70, 32, 17 to 32, it is Hadruff. No, it's not Hadruff. It's a universal or Cunningham method. It is universal. It is universal or Cunningham method. 1 to 8, 1 to 8, Palmer notation Zygmundi. +1 to +8, -1 to -8, Hadruff. 1 to 16, 17 to 32, it's a universal और Cunningham method. और दोस्तों आपके लिए बहुत बहुत बधाई हो. आप सब जब पास हो जाओ तो आपको गोवा जाना है और आपको कैप पहन के जाना है. गोवा इज Wernicke's encephalopathy and Korsakoff psychosis cap. What is cap? Confabulation, amnesia and polyneuropathy. सर हाँ, modified Palmer notation नहीं है बेटा. Modified Palmer notation नहीं है. That is FDI and modified FDI. But how to remember FDI? We use the number of quadrant. 1, 2, 3, 4. If I'm using the number 1 quadrant, it will be 1, 1, 2, 1, 8. 2 quadrant, 2, 1, 2, 2, 8. 3 quadrant, 3, 1, 2, 3, 8. 4 quadrant, 4, 1, 2, 4, 8. But if I'm using modified, 1, 1, 2, 1, 8, 2, 1, 2, 2, 8, 4 और 3 को exchange कर दो. It is 4, 1, 2, 4, 8. It is 3, 1, 2, 3, 8. That is a FDI and modified FDI, which I didn't discuss here. So गोवा में भैया भगवान करे आप कैप पहन के जाओ. God bless you all. Thanks and best of luck for your exam, my dear friend. Love you all. भगवान करे आप सब पास हो जाओ. खुश रहो बेटा. जिंदगी में खुश रहना सबसे इंपॉर्टेंट है. पास तो आप हो ही जाओगे, है ना. पक्का. चलो मैं FMT मैराथन, स्ट्रेस बस्टर, कॉन्सेप्ट, एवरीथिंग. लव यू ऑल बेटा. भगवान करे आप सब पास हो जाओ और हमसे आके जोधपुर में मिलो. खम्मा गणी आप लोग राजस्थान. गॉड ब्लेस यू ऑल. लव यू ऑल. लव यू. लव यू.